That is truly intercontinental.
Intercontinental, yes. I've been in London for last, 36 years.
Oh, wonderful. I
Yeah.
thought you are in India at the moment. Okay.
I'm coming in India next week, hopefully,
Oh,
if the
all
Indian
right.
government doesn't impose any restrictions.
Oh my God, that's dangerous. I mean, there will be venturesome in a way.
Yeah. And where are you based?
I'm in Germany. I'm in Lübeck.
Yes, yes, that's right. You are in Germany. Yeah, yeah,
Yeah.
yeah. But you won't be able to return back to Germany. Oh, you are in Germany at the moment?
I'm in Germany, yes.
Okay, okay. Yeah, because German government has imposed restrictions for foreign nationals.
Correct. Where is my 1 second? I'm
Sure,
trying
sure.
to. Yeah. All right. Okay. Yes. Can you see my screen? Yes. No. You
I can see your screen. Yes, I
Wonderful.
can.
Wonderful. Wonderful.
Dr. Jain, I stopped the screen sharing from my end because the event hadn't started yet. Let
Okay.
Dr.
Wonderful.
Khanna come in, announce the speakers, and then we'll start.
Absolutely fine.
Thank you, sir.
Absolutely fine.
Good morning. Can you hear me, Dr. Henry?
Yes, Dr. Khanna, we can hear you. I can hear you. Good
Okay,
afternoon.
Good afternoon. So we are back to the third day of the conference. Good morning to all of you. It could be good afternoon. And in Singapore, we are going to have now the day 3 and the 10 today would be new topics in vascular medicine. And then this will be followed by recent trends in vascular imaging. This is a wonderful workshop on non-invasive imaging for coronary and vascular disease. Then we have a workshop on vascular robotics, followed by interventional nephrology course, which is the Asia Pacific Vascular Interventional Nephrology course, which we have started this year. And this will be followed by Gopi Devi oration. And then we have inter-society sessions, the sections of Asia Pacific Vascular Society, sessions of Southeast Asian countries, and Women Crusaders of APVIC, Congestive Heart Failure, Middle East section of APVIC, and Nigerian and South African section of APVIC. So APVIC has really grown. It has actually grown to many continents now, and it has subsections. And yesterday, when we were counting, I think we have put it on the group, up till now we had 7,300 plus registrations and people who were online till day 2. So with this, let me invite our expert panel, Dr. Saroj Das, who is a professor of vascular surgery. He works in London at the Imperial College of London. Dr. Michel Henry from Luxembourg, who was initially in France. He is my mentor and course co-chairman, and nobody needs to introduce him because he himself is a legend in vascular interventions, and he's the one who started and trained not only cardiologists, but also radiologists and vascular surgeons from all over the world. We also have Dr. Rajiv Parak, who is a chief of vascular surgery in Medanta, and Dr. Deepak Jain, who is my colleague. We studied our cardiology together, and we did our DM together. Now he is the director of Cath Lab in Germany. Dr. Tulio Navarro from Brazil, Dr. Ajay Yadav from India, and Dr. Nanda Kumar. Now, with me, I have a course co-chairperson, Dr. P.K. Asokan, and let's start the proceeding. I'll hand over, after I introduce Dr. Deepak Jain, I'll hand over the mic to Dr. Henry and Dr. Saroj Das. Dr. Deepak Jain is a very well-known interventional cardiologist. He practices in Germany. We were very fortunate to work together in our training time, and then he was also part of the faculty in Indraprastha Apollo Hospital before he moved to Germany. As we know that the complications, we are all interventional cardiologists, the complications of interventions are related to similar problems. It could be dissections, thrombosis, perforations, and groin issues, and many a times arrhythmias in cardiac arrest and bleeding issues. And Dr. Jain is the right person to talk about it. He would be talking for the next 20 minutes on complications in cath lab, their management and prevention. So over to you, Dr. Deepak Jain.
Thank you, Narendra. Thank you for the general. Could you hear me?
We can hear you, and we can also see you.
Thank you, Narendra. How can I see my PowerPoint?
You need to share your screen.
That's already shared, but let me see.
So the screen sharing was stopped during the inauguration, so you have to share it again.
Oh, okay. I'll have to share it again. So, screen sharing. 1 second. Bear with me. Okay. Screen sharing. Your screen. All right. Can you see now?
Yes.
Yeah, of course. We can see your slide in full screen.
Okay. Okay. Good afternoon, ladies and gentlemen. After a liberal dose of peripheral interventions, this might be a welcome change. We are going to talk about coronary interventions, their complications, their management and prevention, particularly the prevention part. Let's start with coronary perforations. This is the most feared complication of coronary interventions. It has a very high mortality, and therefore I'm going to talk in details about coronary perforation, and then as the time permits, we'll talk about other complications. This is a very celebrated classification, the Ellis classification. It's from type 1 to type 3. Type 1 coronary perforation is an extraluminal crater here. You can see, and this is without extravasation. Type 2 coronary perforations are pericardial or myocardial blush without contrast jet extravasation. Type 3 perforation is a frank perforation through a 1 millimeter or more perforation aperture there, and you have a jet of contrast jutting out of the coronary artery. This is type 3 perforation. Type 3 perforation spilling type is a so-called fortunate perforation, if you may, because it drains into a cavity and does not normally lead to a pericardial tamponade. Here in this case, there's a perforation of the LAD draining into the left ventricle. It could drain into the coronary sinus, left ventricle, right ventricle, but normally it does not lead to tamponade. Talking about causes of perforation, guide wire, balloon, and rotablator atherectomy. These are the three commonest causes of perforation. Atheroablative procedures do have a high complication rate. Not only the high perforation rate, not only the perforations are more, but type 3 perforations are also more, and this is obviously leading to a higher mortality with this with the atheroablative procedures. One example of rotablator induced perforation here: eccentric plaque in the LAD, very calcified, bud impaction, perforation, tamponade, pericardiocentesis was needed. This is an interesting slide which shows that almost half of the perforations do not lead to tamponade in the cath lab. So tamponade can happen when the patient goes out of the cath lab, and the mortality is almost 50% when tamponade develops. So if you suspect perforation and tamponade, keep the patient under intense observation for at least 12 hours. This is very important because the tamponade may not happen in the cath lab itself. You do an echo, there's a mild pericardial effusion, you don't feel rest assured, and don't send the patient to a normal ward. Send the patient to coronary care unit so that the observation could be done, because the tamponade can definitely develop later on. And the best is to act fast and treat the perforation before tamponade develops. Now, this is an example of out of the cath lab perforation, distal L6 wire-induced perforation here. Did an echo, there was mild pericardial effusion, no tamponade, but 2 hours later, there was tamponade and pericardiocentesis had to be done. How to diagnose perforation? Well, angiographic, you have blush, jet, coronary sinus compression, increased cardiac silhouette. Echocardiography is the gold standard. You can very nicely see pericardial tamponade or pericardial effusion in the echo. Plus, you have a contrast jutting out of the coronary artery, so both of them together leads to the diagnosis of pericardial effusion and tamponade. Management is don't panic, don't hesitate in seeking help. No awards for being a Hercules in the cath lab. Volumes and isotopes, prolonged balloon inflation, pericardiocentesis, covered stent, embolization like coils, gel foam, platelet infusion, FFP directly into the coronary vessels, surgery. Follow-up echo is very important. Now, an example of covered stent in a perforation here. There's a perforation, you can see the stent already placed near that, inflation of the stent, stent deployment, and the perforation sealed. Again, a peripheral perforation, wire-induced coil occlusion, and the perforation sealed. Now, this is a strange case of LAD occlusion where I was doing retrograde LED recanalization by classic reverse cart technique. And here in this case, there were multiple perforations, and both coils and covered stents were used. So a retrograde passage of the wire through the collaterals. The left side is diseased, the left main is diseased. Antegrade passage, kissing of the two wires, balloon dilatation for reverse cart technique. Patient became unstable. There's some kind of haziness in the left main, so stenting of the left main first, and then externalization of the wire, balloon dilatation for preparation of the stent placement. So far, so good. But you can see here already perforation happening. This is where the microcatheter was all the time there. And with time, this perforation became massive. So coil occlusion there. But unfortunately, where the balloon was inflated to stop the perforation while the coil was being deployed, there was perforation again. So a second site of perforation. A covered stent placement there. Deployment of the covered stent. But unfortunately, by that time, the distal perforation was activated again. So we inflated a balloon here to put in another coil. But unfortunately, the perforation happened here. So this is the third site of perforation. Another covered stent here. Between the first covered stent and the coil, as you can see here, this is the first covered stent, this is the coil. Deployment of the second covered stent, and luckily after that we could salvage the case and we could salvage the patient. Pericardial, mind you, pericardial centesis was not needed, so it is very important to definitely treat the perforation before anything else. So quickly treat the perforation before tamponade develops. This is the most important point. But covered stents have their own problems. They are no panacea. They are very stiff. They may be difficult to deliver. They have a high thrombosis rate, high restenosis rate. They are expensive. You need a large inventory for them. And most important is very calcified lesions may fail to seal with perforation. This is an example where multiple perforations fail to seal the perforation. LED, highly calcified, long segment, rotablator done. Distal rotablator, balloon dilatations of the whole length, stenting, conventional stenting, nothing extraordinary about it. And this is where the left main LED stent was being deployed, 3.5 stent. After I was control of the size deployment of the stent there, and a massive perforation. So pericardial centesis done. First covered stent. The perforation did not seal completely. Here you can see some perforation. So high pressure balloon dilatation. Unfortunately, the perforation did not seal with the So second covered stent. Then there was a left main dissection, partially extending into the aorta. So a covered stent into the left main, and then a fourth covered stent here because the perforation did not seal. So a fourth covered stent there. It looked like the perforation is sealed. We sent the patient to the intensive care unit, but 3 hours later, again, there was collection of blood into the pericardial space, and we had to send the patient for urgent surgery. So even multiple covered stent did not prevent pericardial tamponade to develop in a patient with a highly calcified. So sometimes covered stents may also fail. Coils have their own problems. Recanalization of the LED, wire-induced perforation here, coiling, and next day there was a post-PCI myocardial infarction CK elevation of 2000. Whatever you do, the best way is to do a mechanical treatment by mechanical treatment of perforation by coils or covered stent, but don't give protamine. This could be disastrous for two reasons. One, it can occlude the stent, and second, it can lead to clotting of the blood in the pericardial space, which may then not be amenable to aspiration. One example of how protamine could be disastrous: left main dilatation, then a conventional stenting crush technique of the LCX, left main dilatation, left main stenting, and a perforation here. So a covered stent did not seal perforation, pericardiocentesis was done, second covered stent, high pressure dilatation, and at this point the covered stent could seal the perforation, but unfortunately the colleague from the intensive care unit who was attending the case gave protamine, and 15 minutes later, see the disaster, complete occlusion of the left vein. The patient could not be salvaged. So if you really want to have a smooth sailing, best is to sneak away from doing complex cases. But if not, the second option is to avoid perforation. Some pearls to avoid perforation. Important is to confirm the guide wire location if it is in the true lumen in orthogonal views. One very good example of this is this case where you have an LED occlusion, acute myocardial infarction, anterior wall. The wire is clearly out of the artery, but the colleague did not try to confirm it in the lateral view, inflated at the exit point, and a massive perforation. Another very good example of what can happen if the wire lie is not looked at properly, LCX dilatation, perforation happening here, wire passage, and unfortunately the wire passed into the track which was caused by the perforation. But the colleague, he was, mind you, was a very experienced colleague, but this is lack of concentration. He thought he is in the true lumen. He forgot that this is a track caused by the perforation. So the wire in the perforation track, stenting, dilatation, and a complete disaster there, connection to the pericardial space, a free connection to the pericardial space. So a coil occlusion was attempted. Again, this was out of the vessel. Pericardiocentesis, you can see the catheter lying into the pericardial space. Left main became unstable, so left main dilatation there, stenting, and then we realized the problem. So we thought we should exclude this artery by putting in a covered stent from the LCX ostium to the marginal artery. That's what we did. This is a covered stent in the marginal artery. We excluded the LCX and did a kissing technique, and finally we could salvage the case. So it is very important to see the wire position before dilating it with a balloon, otherwise it could be disastrous. Avoid stiffer hydrophilic wires very peripherally into the vessel. This is an anterior wall myocardial infarction, LED occlusion, wire passage too deep into the artery, as you can see here, dilatation and a perforation distally into the LED. So the first thing to do is coil occlusion before anything else. Before the tamponade develops, do a definitive treatment of the perforation, and then do whatever one wants to do. So stenting of the LED, and this is the end result. So the perforation is sealed completely. Avoid overinflation with oversized hardware, LED stenting, LED after the diagonal. So a balloon dilatation.
Dr. Jain, kindly conclude your slides. We're running, it's already past the 12 minutes allotted.
Okay, but I've been allotted 20 minutes. So balloon dilatation, type 2 perforation. Look for guide wire bias in rotablator atherectomies. So ostial diagonal rotablator. This is a guide wire bias. Clearly, it's an eccentric stenosis and a perforation there. So a covered stent, and this is the end result. So it is very important to do a definitive treatment, a mechanical treatment by covered stent or coil or whatever before tamponade develops. When a perforation happens, paradoxically, the balloon which causes perforation is the best to seal it. So anterior infarction, dilatation, post-dilatation after stenting, and a massive perforation. So the same balloon which caused a perforation is the best to seal it, proximal to the stent, dilatation for 10 minutes, and the perforation sealed. Avoid putting conventional stent immediately after you see a perforation after balloon dilatation. So intermediates, type 2 perforation here, a conventional stent, and the perforation became massive. So avoid putting in a conventional stent. Best is to wait or put in a covered stent. And never be assured by prior stenting. Perforation can happen through multiple layers of stent. This is the case previous to the index case, which I'm going to show you quickly. Dilatations, stenting, and this stent near the septal perforator. There are 2 stent layers already. As you can see here, this is the end result of the first case. Now, presentation again, few months later with instant restenosis, angina. You can see instant restenosis. So, conventional high pressure balloon dilatation, but the result was not satisfactory. So, a third stent. There are already 2 stent layers. A stent was put within the 2 stents. Stent dilatation, post-stent dilatation, and a massive perforation. So this perforation could occur despite 3 layers of stent. So don't be assured by multiple layers of stent. Don't be too aggressive in dilatation. Perforations can still happen through multiple layers of stent. Graft anastomosis may be particularly vulnerable to perforations. This is an L6 occlusion here. The graft to L6 is occluded. So retrograde recanalization of the graft recanalization, and then a retrograde recanalization of the L6. So we attempted the entry of the wire passage and entry retrogradely. Finally, we could have the access to the L6, as you can see here. Anastomotic point is still not dilated properly. Aggressive dilatation of the anastomotic point, and a massive perforation, as you will see here. So, covered stents, and then a conventional proximal stenting, and the result was good. Microcatheters in antegrade CTO recanalizations, wire can induce perforations. They are normally not so dangerous. As you can see here, recanalization attempted. The wire seems to have gone into the through lumen, but unfortunately, no, it wasn't. And you see a perforation. So balloon dilatation and perforation sealed after 5 minutes, continuation, and then recanalization of the L6 and stenting. And this is the end result. Not only the coronaries can perforate, in the era of tower, even the LVs can perforate. This is an example of straight Terumo causing a perforation of the left ventricle. So be very cautious, don't push the straight Terumo too deep into the left ventricle. Again, a perforation of the LV, as you can see here. After perforations, let's talk about dissections. NHLBI grades of dissection. Type A dissection, you have radiolucent haziness here. This is type A dissection. Type B dissection, you have a parallel tract. Here, it's known as type B dissection. Type C dissection is where you have an extraluminal cap. This is a type D spiral dissection. And type E is new persistent filling defect, as you can see here. Type F is any dissection which leads to impair or occlusion of the artery or impair flow. So there's no flow. This is type F dissection. Mechanisms: plaque fracture, guide catheter trauma, balloon rupture. The risk factors for ischemic complications. This is most important. When should you treat a dissection? So a dissection length more than 15 millimeters, type C to type F, residual stenosis more than 30%, cross-sectional area less than 2 millimeters, transient in-cap occlusion, unstable angina, and CTO. Predictors: calcified lesions, eccentric lesions, long lesions, diffuse disease. As dissections after the stenting do not have any bearing most of the time all tears are healed. So these edge dissections should not be treated unless you have the risk factors, as I told you before, for occlusion of the artery. Not only the coronary arteries can dissect, retrograde aortic dissections can happen, like in this case, severely diseased vessel dilatation and a retrograde aortic dissection. Unfortunately, the operator kept on injecting. You can see free flow of the contrast into the subintimal space of the aorta. You can see the aortic dissection. You can see an aortic regurgitation happening, acute AR, aortic dissection there. So if you have aortic dissection, retrograde aortic dissection, how to manage it? Do not inject, early stenting, covered stent, hemodynamic stability and instability, ST elevation in the contralateral territory, tamponade, acute AR, length more than 40 millimeters. Send the patient for urgent surgery. Do not meddle with the patient. Follow-up TE is very important. And prevention, take a guide catheter with side holes, less aggressive guide catheters like JR, and minimal hardware manipulation. This is an example of preemptive stenting of the ostium when perforation when retrograde aortic dissection happens. So the aortic dissection is about to happen here. Stenting of the ostium, then do whatever you like, and this is then the end result, the perforation. The retrograde aortic dissection could be arrested. Another example of preemptive stenting, left main dissection, as you can see here, leading to retrograde aortic dissection, stenting of the ostium, and then after high pressure dilatation, we could do the LED, and this is the end result. So the third or the fourth complication that can happen is abrupt vessel closure. Quickly going through it, abrupt closure, the treatment is stent in most of the cases. This is an example of abrupt closure after balloon dilatation, the vessel occluded, stenting, and it was all right. Factors associated with abrupt closure, the unstable angina, females, AMI, intranumeral thrombus, angulation more than 45 degrees and a higher AJ score. Predictors of mortality, obviously the percentage of myocardium at risk, left main and multi-vessel disease. Stenting is the ultimate therapy. This is an example where abrupt closure happened twice. Stenting of the RCA, abrupt closure in the due to proximal dissection, stenting. It was all right. 20 minutes later, abrupt closure in the mid segment, distal to the stent, multiple dilatations and stenting, quickly going through it. And the case was salvaged, and this is the end result. Hardware entrapment, embolization, peripheral complications next year. Thank you very much.
Exhaustive and extensive, and it's very, very important for the newcomers, and a lot of young interventional cardiologists who are watching you must be more than 4,000 or 5,000 right now. And this is where they need to learn how to preempt problems, and when you get into problems, how to arrest them and act fast, otherwise they lose the patient and learn it the hard way. So thank you so much, and we move to, we'll have discussion in the end. We move to the next talk. It is by Dr. Ivo Petrov from Bulgaria, and he's going to be talking about resurrection of renal denervation based on latest trial results. And Dr. Jan, I want you to be there because this technology, I believe, was originally started in Germany, and it had a lot of proponents, especially Dr. Horst Siewert is one of the big proponents of this technology and this way of therapy for renal denervation for hypertension. And it went into some problems because of the Medtronic catheter, but it's coming back again, and we have no better person than Dr. Ivo Petrov, who is the president of the Bulgarian Society of Cardiology, to actually speak about it. Dr. Petrov.
Dear Professor Khanna, dear colleagues, thank you once again for your kind invitation for this meeting. I will speak about the renal denervation and the resurrection of the renal denervation. In fact, nothing to disclose regarding this presentation. We know that approximately 2 months ago, we had a new paper from the European Society of Hypertension regarding the renal denervation indication. And during the years, there is a move from the 2018 guidelines of the European Society of Cardiology, upgrade of the indication for renal denervation procedure. And this was based on several trials, very important trials. So let's speak about the hypertension and the resistant hypertension. Definitely the so-called polypill and multiple medication is not the right decision to control hypertension. And we see into the trials and to the registry, for example, like in this Italian registry from Pisa, that put together the uncontrolled and resistant hypertension is reaching more than 55% of the population in target. So definitely this is a huge medical problem for the worldwide population. And in many of these cases, we have as a resource, as a source of the hypertension that is not controlled, this is the greater 24-hour urinary norepinephrine levels, increased arterial stiffness, higher heart rate, higher systemic vascular resistance. That all of these mechanisms are related to higher sympathetic tone. And it's true also the opposite, that reducing the sympathetic tone by renal denervation, shown first in animal trials, and after that in human trials, have shown that the reduction of renin, angiotensin, aldosterone activation, and the afferent nerve activation is decreasing the nervous system activation as well. So on such a way, we can achieve a reduction of arterial hypertension as well. We know very well the results of Simplicity 3 trial that was not exactly negative. It considered negative, but I would say it's neutral. And the Simplicity 3 trial, that was some kind of disappointment for all of us, the enthusiasts, was due mainly to the escape of the sham control group from the control. So, and this led to a difference between the treatment group and the sham control group was not significant. And after that appeared 5 consecutive trials, both with radio frequency and ultrasound ablation that showed different results. And the reason for that was the better control of the sham group and better performance into the treatment group. I mean, better execution of the renal denervation itself. And this was, in fact, these trials, the consecutive trials, have shown much better results. Let's speak about the procedure itself. So the procedure has to be done properly. And we have learned a lot from the Simplicity 3 trial. We have learned first that into the Simplicity 3 trial, 60% of the patients didn't receive, in fact, exact treatment. They received between 0 and 1 denervation points. And of course, they were, in fact, not treated. And the post hoc analysis have shown that there is a definite relationship, gradual relationship between the number of renal denervation points and the antihypertensive effect. And the second most important, very important fact was that the density of the renal denervation terminations is increasing distally. So the initial strategy to treat mainly the proximal and only the main vessel of the renal artery was wrong. So we have to treat also the distal part of the vessel and circular quadrant of the renal artery. So on such a way, in case of treating 2-4 quadrant ablations, at least per artery, we have increase of the renal denervation effect. And we, in fact, named this strategy the so-called Y pattern. It means radio frequency treatment of not only of the main artery, but also the branches in multiple points. And our proper study that was published in 2018 was shown that both the sympathetic and the average systolic and average 24 hours hypertension is better controlled compared to the, let's say, the standard group, only treating the main vessel. It resulted that is better controlled both for systolic and 24 hours ambulatory blood pressure when the application of Y pattern. Just showing a simple case, a 53-year-old male on chronic hemodialysis. We know that these patients are really a very big treatment problem because their arterial pressure is reaching very high level, even like in this case with 6 medications in this young patient. And despite of the 6 medication, especially during the hemodialysis sessions, his arterial pressure reached as high as 193 millimeters of mercury. Of course, this is dangerous. So nothing else to mention regarding his echocardiography or his renal arteries. And after the application of the Y pattern, so treatment of not only the main vessel, but also the distal and the branches, like shown here, both left and right side, and reaching more than 11 points per renal artery with good reduction of the resistance. That is also more than 10% reduction of the resistance of the points is one of the predictors of good success. We have reached extremely good control of the arterial pressure, and even we started with the reduction of the medication on such a way. This strategy is applied by the Simplicity spiral catheter because the Simplicity spiral catheter has 4 ablation points in one catheter. So this is the strategy to treat more points and also into the branch vessels, because the new version of the Simplicity spiral catheter is on wire. So it's very easily to selectively enter into the branches as well and to ablate more than 12 points per renal artery. With the application both of radio frequency and ultrasound, we have more than 1,100 patients included into the sham-controlled trial that are the best trials to show the results of a device, medical device system. So this meta-analysis, please note, including the Simplicity trial, despite of the inclusion of the Simplicity trial, these meta-analyses have shown better results with the renal denervation, both for the systolic and the diastolic blood pressure results. And these results were also confirmed by the Japanese registry, the Simplicity Hypertension Japanese trial, showing huge, in fact, statistically significant difference between the renal denervation and only medication group. And this was very important to see the 24 hours control. We know that the night hours and morning hours are very important to be well controlled in this patient because they are the most risky by clinical point of view. So in such a way, the new statement into the European Society of Hypertension is that, in summary, in light of second generation sham control trials, it's now established that the renal denervation reduces consistently the blood pressure across a variety of hypertensive patients with mild to moderate hypertension. there is a question about the effect. Is durable the effect of the renal denervation? This trial very well showing that in swine model, in fact, there is no regrowth of the renal denervated terminations. So it resulted that not only on the day 7, but also on the day 180. So it's more than 6 months after the renal denervation. Not that there is no regrowth. There is in fact distal atrophy during the time, and it's very well matching the clinical results. So the clinical results that during the time, in fact, the effect of the renal denervation or on the arterial hypertension is not
Dr.
reduced,
Petrov,
but,
you have a
but
minute
it's
left.
improved. Yes, absolutely. I'm finishing with that, with the durability of the renal denervation and the safety. All these results were achieved without any signal regarding the safety. So there were no dissections, no complication. They are very close to zero. And in fact, this is these are the results, and the results are very important that are translated into the clinical result with reduction of the risk of this very high risk of group of patients with resistant hypertension. And we now, after the disappointment of the simplistic hypertension 3, now we are on the reality. The enthusiastic phase is gone, the disappointment phase is gone, and now we are on the reality. And the reality is advising us to use this data in order the heart team to decide which are the patients that can benefit the most from the renal denervation. And these are the patients, maybe the patient with increased sympathetic resistance and increased variability with also rhythm disorders. So these are probably the main treatment groups in which we have to apply this strategy after the decision of the heart team in order to have better control of the hypertension of these patients. And thank you very much for your kind attention.
Thank you, Dr. Pedro. That was excellent, and we'll have the discussion after 2 more talks. Next, we go to Dr. Saroj Das, who is from Imperial College of London. He's going to be talking about a very pertinent thing in present times, microcirculatory changes and activation of thrombosis in COVID-19 infection and its impact on venous and arterial thrombosis. We have all seen this in our practice during the COVID time this year, that we lost many patients, we had to treat many patients of acute MI, DVT, strokes, just because of hypercoagulable state which was induced by the COVID infection and after the COVID infection because of the systemic response of the body and the vessel wall. So none other than a prolific researcher, Dr. Saroj Das, would be talking about it.
Dr. Khanna, you have my video presentation, or you want me to give the real life talk?
Once you're here, it's a real life talk, which is better if you have it. Otherwise.
Okay. Okay. I will share my screen now. Can you see my slide?
Yes, we can see your slides very well.
Okay. Okay, thank you very much. As Dr. Khanna alluded to the fact that we are all immersed with the uncertainty of this COVID-19 infection. And I don't think we still know where is the end in sight. Is it too distant, as some say, 10 years or more, or it may be sooner? I think we are all impatient to see the end of this problem. And but the reason for discussion or this presentation this afternoon is different. Now, let's look at what this pandemic has done to us. there has been over 267 million people who have suffered from this pandemic. Almost 5 million, in excess of 5 million people have lost their life. In the United States, the death rate is approaching to about 1 million. In India alone, there has been over 5 million deaths, 500,000 deaths from this pandemic. Interestingly, Pfizer claimed that they have saved the world several $1 trillion. But if you look at the real figure, it has affected the global economy. The direct cost of treating this pandemic has been in excess of $11 trillion to the global economy. And furthermore, the indirect cost, which has been calculated over $10 trillion, and the cost is rising. So let's put it aside, because this effect, we will never be able to calculate it properly, because as we do not know when is the end of this problem. So the reason for presentation this afternoon was that I was actually asked to address two important problems that is seen with COVID-19 infection. That what are the significance of the microcirculatory changes that is being seen in COVID-19 infection? And the second question that was asked to me was, what is the magnitude or the severity of arterial and venous thromboembolism in COVID-19 infection? So I did a review, and this has been published in one of the British Hospital journal, and I'm just presenting you some of my outcome of this review that I did. So before we try to address those two questions, we must understand that what are the reasons of the COVID-19 infection? How does it affect the body, and where does it start? And as we all know, that the COVID-19 infection, firstly, it affects the upper respiratory tract, where there are a lot of ACE2 receptors are distributed in the respiratory tract, in the endothelium, in the kidneys, and this virus binds to the ACE2 receptors, and then it infects the body. When the infection becomes severe, it then infects the type 2 pneumocytes, which are located in the lower respiratory tract, and gradually destroys these type 2 pneumocytes, which are not only responsible to maintain the gas exchange, but also they are responsible to the release of the surfactants, which are important for the gas exchange in the lungs. And when this process continues, and it leads on to the pulmonary edema, or what is called ARDS. And together with this, what triggers this process is what is called the cytokine storm, which is the hallmark of the COVID-19 infection. Now, what is the cytokine storm? The cytokine storm involves the release of various cytokines, various interleukins, various chemokines, including the granulocyte stimulating factors, the tumor necrosis factors, VEGF, and so on and so forth. And together with that, there is activation of the reactive oxygen species, reduction of the protective function of oxygen-free radicals. And both the mitochondria and endoplasmic reticulum, they also release a lot of proteins together with hypoxia-inducible factor. And these all lead to the damage or apoptosis of the type 2 pneumocytes more and more. And ultimately, this leads on to the lack of gas exchange at the lungs level, and that leads on to the hypoxia, and so on and so forth. And this ultimately results in the ARDS. Now then what happens, there is activation of the endothelial cells with endothelial injury. Now this then activates the von Willebrand factor, the platelets, and the various adhesion molecules which are released together with the activation of the collagen. That leads on to development of the thrombus plaque. And together with the activation of the various coagulation proteins and inactivation of the various natural anticoagulants, this leads on to the irreversible phase of activation of the coagulation in these patients. So this leads on to the what is called development of thrombosis, capillary clogging, And we assume this is the way how activation of thrombosis takes place in COVID-19 infection. Fortunately, it does not happen to every patient. Those patients who are severely affected by this problem, and most of these patients are seen in the acute therapeutic unit situation, environment. And this leads on to various other complications. And this is why we see development of venous as well as arterial thrombosis. So let's look at the first question that I was asked. Are there any microcirculatory changes that happen in COVID-19 infection, and what is the significance of it? Yes, there does happen some microcirculatory changes, but the fact is, these are the changes that is seen not only in COVID-19 infection, in many patients who are being treated in the intensive therapeutic environment. They all have some microcirculatory changes in their system. Now, what is their significance? The microcirculatory changes signify the severity of the COVID-19 infection, number one, and how this affects the outcome of this patient from this severe infection. And thirdly, it also helps the intensive care personnel how to manage these patients appropriately so that they can recover from this severe COVID-19 infection. Now, there are many ways of assessing the microcirculatory changes in these patients. Like indirectly, you can do pulse oximetry, you can do lactic dehydrogenase, or you can do what is called infrared spectroscopy. But these are not accurate and they do not reflect the exact changes that takes place in the microcirculation. And particularly to do this assessment at the bedside in the intensive care unit for our patient, we need different portable, which are reliable and which will be reproducible devices such as handheld video assisted microscopy or skin fluorescence study. And these are reliable, and this helps the intensivist to, first of all, to see the severity of the problem and assess and monitor their progress with treatment. So with this, there are several changes that is being assessed in the sublingual blood flow to see the microcirculatory changes that I described in my slides. So these microcirculatory changes do help in monitoring the patient and outcome of this patient suffering from severe COVID infection. Let's move on to the next question that I was asked with regard to the activation of thrombosis. We have several reports. Many of these are anecdotal reports, and one such report from Japan, hospital records from Tokyo. And they looked at 516 patients admitted to the hospital, and this is a retrospective observation. And they found equal incidence of arterial as well as venous thrombosis. And as you will see from this slide, that most of these patients have got quite severe arterial thrombosis, suggesting that these were the group of patients who were being managed in intensive care unit environment. But this does not reflect in the real life scenario as to how many patients do really suffer from deep vein thrombosis or acute arterial thrombosis. So therefore, we looked at a larger evidence, and these are the couple of evidences which are something around 65,000 patients, where they looked at the frequency of venous and arterial thrombosis, and this was published this year, in fact earlier this year. And there was another study by Malas who looked at the composite outcomes of venous alone in excess of 8,000 patients. And the overall venous thromboembolism rate was 21%, DVT 20%, pulmonary embolism 13%. But the acute thromboembolism in the arterial system was only 2%. But these results were higher in the intensive therapeutic unit environment as we expected, as you will see in this slide. But the unfortunate thing is that in this meta-analysis and reviews, there were high heterogeneity in the studies related to bias, the population type, the settings, and the prevalence of venous and arterial thromboembolism in this population. So this is not reliable. So let's look at individually about microthrombosis. Microthrombosis has been discussed previously. It's a widespread thrombotic process of microthrombosis has not been observed. There is only one report that was seen in 3 patients where skin biopsies were done, and they showed some few thrombi in the skin. But apart from that, microthrombosis has not been reported widely. As regard to the incidence of thrombosis in the community, this is again is not seen as it is seen as frequently as it is in the ITU environment. Patients, as we said, that the difference between non-ITU patient and ITU patient is this: most of the thrombotic events are seen patients who are recovering from severe infection in the ITU environment. And another thing which was also concluded from this study, from this observation, that most patients who are suffering from severe infection, they should be protected with extended thromoprophylaxis, as there is a risk which is transmitted to the community. So therefore, the risk at discharge in these patients who have already suffered from ATVT or PE in the hospital, in the ITU setting, does exist, and they do benefit from extended thromoprophylaxis. So this is just to finish my presentation. I just thought that this is a slide worth presenting. One study that was recently published from Italy suggests—
Dr. Das, kindly conclude your slides.
Yeah, this is my last slide. Either single or double antiplatelet agent does reduce the mortality from COVID-19 infection. As you will see, this is with single antiplatelet and this is with double antiplatelets. So there is some evidence to suggest that antiplatelet might help in reducing the thrombotic burden in this patient. So the key points in this study was that the severity of the COVID-19 infection is related to the cytokine storm, hypoxic insult, and activation of thrombosis. Patients with serious COVID-19 infections are mostly seen in the intensive care units settings. Assessment of sublingual microcirculatory changes enables monitoring response to predict prognosis. There is evidence to suggest that there is an increased incidence of venous thromboembolism, but not so with arterial thromboembolism. And most of these patients are seen in the intensive care units. Thank you.
Thank you, Dr. Das. That was really wonderful. So now we have Dr. Michelle Henry, who would be speaking on drug-coated balloons for FEMPOP occlusive diseases.
Do you hear me?
Yes, we can hear you, and we can also see your slide.
Okay, thank you. Thank you again, Dr. Khanna. So I would like to speak on drug-eluting balloon. We have problem.
Ujjwal, can you help Dr. Henry? Yeah, it moves now.
Okay, so drug-eluting balloon have potential benefit, leave nothing behind strategy. That's an argument to use this technique. Allows for future intervention, stent, repeat PTA, and it's particularly attractive in some locations where stents are undesirable. You know that there are a lot of, there are a lot of drug-eluting balloon with paclitaxel or now sirolimus. And we can use drug-coating balloon alone. And if you look at this technique, drug-eluting balloon alone versus plain balloon. For short lesion, you see a lot of trials showing the superiority of drug-coating balloon versus PTA alone. But this trial are with very short lesion and not long-term follow-up. If you look at long-term follow-up with the Stellarex, for example, at 3 years, you see a superiority of drug-coating balloon versus plain balloon alone. And at 4-year follow-up also, you see a superiority of this drug-coating balloon, but it's for short lesion. This impact SFA study, more than 300 patients, also at 5 years, you see superiority of drug-coated balloon, however, a modest TLR difference. So, drug-coating balloon is the first-line strategy for the treatment of short femoropopliteal disease. In this impact SFA study at 5-year follow-up, there is no difference between diabetic and non-diabetic patients. Impact Global Study, 4-year follow-up, more than 1,500 patients, and you see also durable result indicating this drug-coating balloon as viable solution for the treatment of femoropopliteal disease, better result with claudicants. And in this ACO-ART-1 study, at 5-year follow-up, also you see a better result if you compare with PTA alone, but always with not very long lesion. So, two main problems remains: long lesion, calcified lesion, long complex lesion. In this Impact Global study, you see that for long lesion, you see that the results are not excellent. It's better when you treat shorter lesion. In this real-world registry reported by Schmidt, you see a drop between 1 year and 2 years, 4. So for Schmidt, there is maybe a late catch-up phenomenon. And at 5 years, recently published at Viva meeting this year, you see for TAPE, good, better result in CTO, long lesion, instant restenosis. So at 5-year follow-up, you can say, even with long lesion, greater than 20 centimeters, the results are favorable. Rosenfield also, using Lutonix, reported favorable result at 2 years. But very interesting, this report by Alburama 2 years ago with Lutonix, 200 lesion, mean lesion length, 20 centimeter, complex lesion. And you can see that the primary patency is poor for all lesion with this all long lesion. And for limb salvage also we have a better result for claudicants. If you compare task A, C, and task CD, we have poor result with task D lesion. So maybe this Lutonix balloon or maybe all drug-coated balloon are not the best for very long lesion. So when you treat long lesion, you have to stent sometimes a lot of patients, between 2 and 50% of these patients. That's the problem of treating long lesion with drug-coating balloon. But in fact, if you place stent, we have similar TLR stented versus non-stented lesion. Calcified lesion. Calcium has been demonstrated to reduce drug-coating balloon efficacy. Calcium is the enemy of all endovascular procedure. And if you look at this slide, you see that for very calcified lesion, the results are less good. But for the 2-year primary patency rate in calcification subgroup, you can see that drug-coating balloon is superior to POBA, but better result in non-severe calcification. However, for Fanelli, you may have good result if you perform longer and stronger inflation. You can use drug-coated balloon with other treatment modality, with BMS, for example. We can predilate before placing drug-coating balloon. And if in this debate, SFA, we predilate before with drug-coated balloon, and you can see that we have better results, drug-coating balloon and BMS versus PTA and BMS for short lesion. Also in this Biolux trial. You can post-dilate with a drug-coating balloon, and also in this DEBA study, when you post-dilate, you have good result, drug-coating balloon and BMS at 2-year follow-up for long lesion. But if you use a thick strut stent like Supera, the results are less favorable. So you can use also drug-coating balloon plus atherectomy. And what is important is a vessel preparation. And you did something else in as many as 50% of the cases. That means you have to prepare the vessel. Prepare the vessel with different modalities. Angioscope, laser, rotational, directional atherectomy, lithotripsy, thrombectomy device. In this definitive study, you see that you have good result, good long-term result when you use atherectomy device plus drug-coating balloons. The results are not bad, even in severe calcification. You can also use Oak-1 directional atherectomy, and recently published at this meeting, 102 patients with this technique in the reality trial. You see that the procedure is safe and effective, but you have only short-term result and some concern about complication like perforation, embolization. If you can use laser atherectomy plus drug-coating balloon, laser plus drug-coating balloon gives better outcomes than drug-coating balloon alone. You can use that stream, but the results are satisfactory, but you may have also some complication. Problem of dissection is interesting. You know that when you use drug-coating balloon with any balloon, you may have dissection, and dissection divided in type A, B, 3. And if you look at treatment for lesion less than 10 centimeters, you see that for dissection group C, the restenosis rate is higher. And for long lesion, you can see that when you have dissection, the results are not very good. So problem of dissection. Problem of instant restenosis, I spoke on that yesterday, so I don't want to insist. Just to remind you that we have a late catch-up at 3-year follow-up. So if you just drug-coating balloon for instant restenosis, is not the best solution, and you have to add something, atherectomy device plus drug-coating balloon. You can compare drug-coating balloon and other technology, for example, BMS, and in this meta-analysis, 1-year follow-up, not too long follow-up, BMS are better than drug-coating balloon. In this study, also reported by Steiner, drug-coated BMS after 3 years seems better. Supera seems better than BMS. You can compare also with drug-eluting stent. Drug-eluting stent in this meta-analysis seems better. And if you compare drug-coating balloon DS for Zeller, similar result, and also similar result for long lesion in this publication. But if you use another drug-coating balloon like Lutonix, there is no difference between drug-coating balloon and DES. In this drastically interesting study, there is no difference between drug-coating balloon and DES. It's recently published at this meeting by Listro. And if you compare Task E, A, B, C, D lesions. There is no difference in terms of primary patency and freedom from restenosis, TLR. So interesting study. This real study also is very interesting. And if you compare, in this study, we had a stratification in short, middle, long lesion. And if you compare this lesion, we have comparable result, drug-eluting stent versus drug-coating balloon at 1 year, but a trend in favor of DS at 3 years. And if you compare also these three short lesion, middle lesion, and long lesion, drug-eluting stent is superior to drug-coating balloon for middle and long lesion, and drug-eluting stent is superior to drug-coating balloon for long lesion. So also DES superior to drug-coating balloon only or drug-coating balloon plus 10. So maybe drug-coating balloon in this study, drug-eluting stent in this study could be superior to drug-coating balloon, at least for long lesion. So, to conclude, drug-coating balloon efficacy has been proven in short, non-calcified de novo lesion. Drug-coating balloon could be the first-line strategy for a wide area of indication in the favorable orbital segment, thus A, B, and C short de novo lesion. However, important open questions still exist with drug-coating balloon, the treatment of long complex calcified lesion. Drug-coating balloon alone seems not enough. We have to prepare the vessel and use atherectomy device plus drug-coated balloon, laser, and maybe BMS. Drug-eluting stent seems better for long lesion. Drug-eluting balloon is disappointing for the treatment of East-end restenosis with a late catch-up at 2-3 years. Are all drug-coated balloon equivalent? In this comparison trial, yes. There is no significant detectable difference between low dose and higher dose drug-coating balloon. In this Transcend study, also no difference between low dose and higher dose. Just to finish, you know there is a controversy, paclitaxel controversy. And Katsanos, 3 years ago, published a report showing a higher risk of death at 2 years. In fact, now we know that we can use this drug-coating balloon. There is no difference in terms of mortality when you use drug-coated device if you compare with PROBA. And you have a lot of trials showing that this meta-analysis.
Dr. Henry, can you conclude the slides?
I finish. Impact 5-year mortality, no difference, and also a cohort. You see a lot of trials showing no difference, Voyager, sweet spot, etc. So you can close the door on the paclitaxel controversy. I think Luckstein said, I think we are really starting to close the door on the paclitaxel controversy. But is this controversy really finished? Maybe not, because at this symposium this year, there is a new concern reported by Katsanos, an increased amputation rate after drug-coating device. But no pertinent data. We have to wait for this controversy. Thank you for your attention.
Thank you very much, Dr. Henry. That was very intuitive and very informative. So then after this, we move to something interesting about shockwave lithotripsy, because this session is on new topics in vascular medicine. So with your permission, can I present this? Okay, so we have 2 lectures here. I would be talking about the concepts, and then Dr. Raj Pratap is going to be showing his case about EVL in peripheral vascular disease. So this is shockwave lithotripsy is a new tool in our armamentarium. the presence of calcium indicates worse prognosis. We have seen Dr. Deepak Jain actually presenting a lot of complications, how to deal with a lot of complications of coronary perforations. And many a times in coronaries and also more in peripheries, this calcification indicates worse prognosis because this has been experienced by most of the vascular interventionalists. The intra-arterial calcium is associated with higher rates of angiographic complications like dissections, perforations, slow flow, no flow, distal embolization, and recoil. And especially now, like Dr. Henry said, gave a lecture on DEBs, and DEBs also require, the calcium is not a great, welcome thing there, and we need to really dilate these vessels well and prepare the vascular bed to actually deliver the drug. Heavily calcified arteries are difficult to dilate with conventional balloon, and they often require mechanical debulking or plug modification with atherectomies, which could be laser atherectomies or rotational atherectomies or directional atherectomies, and sometimes rotational atherectomies or orbital atherectomies. They do provide acute gain by affecting superficial calcium, but again, the deeper calcium is not affected by these atherectomy devices. So there was a need that we have a different tool to actually take care of both superficial and deeper calcium. And we all knew that lithotripsy for last 30 years has been working on very calcified stones in the urinary tract. And that technique was miniaturized on a catheter-based system. And this has a miniaturized and arrayed lithotripsy emitters for localized lithotripsy at the site of vascular calcium. So it took about 2 decades to actually miniaturize the same technology. And then we came up with catheters, both for coronary and peripheral use for tackling difficult calcium in these vascular beds. So if you look at the machine, it has 3 components. It has a console, which is battery operated. Then it has a sort of a catheter, which delivers and it has a switch for giving lithotripsy. And then we have a catheter, which is dedicated for coronary or peripheral use, depending on where we are using. It comes in different sizes. These are the OCT pictures in coronary and peripheral arteries, which shows that this disrupts the calcium in not only the superficial calcium, but also the medial and the deeper calcium. Now, we have 2 sets of catheters for use in peripheral arteries. I'm not talking of coronaries. For peripheral arteries, we have a set of catheter which is used basically for below knee lesions. That comes in 3.5 to 4 millimeter in diameter. And for popliteal, we have diameters from 3.5 to 6. And for iliacs, we have diameters from 6.5 to 7. The lengths of catheter which we have, I'm talking of the balloon which has emitters for lithotripsy, are 60 millimeter in larger diameters and 40 millimeter in lower diameters. The maximum pulse count is 300 in larger catheters and longer catheters, and 160 in the shorter catheters. They all go through 014 wire, and they are the smaller ones are compatible with 5 French system, and the larger ones are compatible with 6 and 7 French system, and they have a working length between 110 to 135 centimeter. Now, how it works, it's a novel calcium modification tool that uses sonic energy waves to modify both intimal and medial calcium. And the calcium modification by shockwave lithotripsy actually leads to miniaturized, it generates shock waves characterized by short durations of 5 microseconds and positive peaks of about 50 atmosphere and negative troughs of the same magnitude. A contrast-filled balloon is inflated just to oppose at suboptimal pressures to just oppose these emitters to the vessel wall. and there is an axial splitting of compressive circumferential forces. It generates violent collapse of cavitation bubbles by shock wave inside the saline-filled balloon which impact the surface of the calcium. And there is a fatigue mechanism involving the progressive expansion of microfractures into macrofractures, and this leads to fragmentation and fracture of the calcium. Now, this hypothesis was tested in the lab and then on the animal models and then in the human trials. And we had 4 trials, the Disrupt PAD 1 and 2 trials, Disrupt PAD 3 trial, and then we have an observational study of Disrupt PAD 3 registry, which is a multicentric registry, and it's a single-arm registry. The initial trials and even all the Disrupt trials actually included patients with heavy calcification, more than 50% of circumference, and mostly the lesions were in long lengths, and often they were also eccentric or concentric, both. Initial studies were of 35 and 60 patients, then PAD 3 had 200 patients, and PAD 3 observational study has 118 patients. And if you look at the acute gain, there was an acute gain of 3.4 millimeter in PAD 3 study, and 30-day major adverse events was 0% in PAD 1, 1.7% in PAD 2, and 6 months major adverse events was 0% in PAD 1 and 1.7% in PAD 2. Now, if you look at the Disrupt PAD 1 and 2 and Disrupt PAD 3 studies, what we see here that in Disrupt PAD 1, we had majority, 3/4 were SFA lesions and 25% were popliteal lesions. While in Disrupt PAD 3, we also included iliac lesions and common femoral artery lesions. And you see here, varying complexity of lesions were used, long lengths, heavy calcification was enrolled in these studies, but there was some limitation of the trials. The biggest limitation is that it's an observational single-arm study without a control group, and there is no definitive comparison that can be made to other interventional devices in terms of safety and effectiveness, especially atherectomies. Only acute procedure results are reported in this study, and PAD 3 RCT will follow subjects to 2 years, and this will provide data on long-term safety and effectiveness of IVL. Infrapopliteal lesions treated in this cohort were too few to analyze, so the study did not have power to analyze and come out with an effective conclusion. Now, let me show you this case. This was the first case of peripheral EVL done in our country. A 70-year-old male who had a bypass in the past, had unstable angina, and this patient had left ventricular dysfunction, also had severe buttock claudication. His venous grafts were occluded and had a native triple vessel disease. So this patient actually required, and was also in LVF, required a balloon pump to support the angioplasty of this procedure. And when we did the angio, he had a very bad calcified aorta, and especially the iliac arteries, and we had to then resort to dilating this lesion and putting in a balloon pump, but this lesion was not amenable was not giving way on high pressure balloon dilatation. So what we did was we got this IVL catheter. This was a 7 millimeter IVL catheter which we used, and here what we do is we just expand the balloon to a size which just is occlusive to the lumen, and then the shock waves are given in multiple cycles, and slowly the balloon expands and this calcium sort of fractures, and then this was amenable to balloon dilatation and putting in a stent, as you can see on the next picture, and we were able to put in a stent and secure an access, put a balloon pump, and complete our angioplasty procedure. If you look at it, this is how it looks like. You need to press the button and there is a shock wave which comes. This actually is very hard on the hard surfaces and very soft on the soft surfaces. If you see, I put my hand there, and once we emit this, It does not injure anything, but if you keep a chalk or if you keep it in the calcium, it just disrupts and cracks that calcium. So this is a safe device. So in conclusion, it's an attractive modality for treatment of severely calcified lesions, combining calcium disrupting capability of lithotripsy with familiarity of balloon catheters. Clinical studies support the effectiveness of IVL in inducing circumferential fractures in calcific plaques, and this leads to significant luminal gain, and it facilitates optimal stent expansion. And this may also be a good tool to treat vessels, especially long lesions in infrapopliteal, popliteal, and SFA lesions, where we are trying to do good dilatation atherectomy and follow it up with drug delivery by drug-coated balloon. Ongoing clinical studies will add further insights into the safety and effectiveness of these techniques, but it does help in acute situation, and there are some unique applications where it can be used. It is a good tool and maybe a good tool to use in no stent zones. That means the flexing areas of the lower limb vessels, which could be popliteal or iliac bifurcation, femoral bifurcation, or popliteal bifurcation. It could be used in high-risk situations like bifurcation, where the runoff is only single vessel, where we are, even when we are doing a subintimal angioplasty, it has proved to be very good, and in failed peripheral angioplasty. Now, patients who are not appropriate for surgery, IVL may provide a safe, effective, non-surgical option for such patients to facilitate angioplasty and
Dr. Khanna, you got muted somehow.
Am I audible?
Yes, sir. Now you are.
Okay. Okay, so I was almost finishing, I think it ran out of the battery. So IVL has a proven role in treating calcific iliofemoral disease. It has a proven role now in facilitating vascular access for large bore devices, both for transcatheter aortic valve replacement and even larger bore devices for doing EVARs and TVARs in heavily calcified prohibitive transfemoral access. So this is one of the star indications where we are using, but it can also be used in no stent zones, in long lesions, calcified undilatable lesions, and in lesions where we want to do drug-coated balloon therapy and the lesions are not giving way and the vessels are not being prepped up properly with conventional balloons. So I'll end here, and I'll invite the next speaker, Dr. Raj Pratap, to show his case, and then we can have a discussion in the end. Is Dr. Raj Pratap here?
Here, and it's cold these days, but it's hard for me to see all these stalwarts and listen to some great presentations today. So I'll be presenting a case of peripheral IVL for common iliac CTO. Professor N.N. Khanna sir has already told in detail about the merits of IVL for peripheral arterial disease. So this is my case. The patient was 59 years male. He was hypertensive, diabetic, presented 2 years back with the history of acute limb ischemia on right side. So was diagnosed as having acute right common iliac thrombosis. Patient underwent surgical embolectomy. Did fine for around 1.5 years. Then presented with intermittent claudications, right limb, for 3 months, and the distance to claudications was less than 50 meters, so Fontaine 2B. So we did a Doppler study for this patient, It showed reduced velocities on the left side as well as very much reduced velocities, and suspicion of total block in the right angiogram, which revealed around 40% stenosis, atherosclerotic narrowing of the infrarenal aorta. Left common iliac was around 50% occluded, and there was common total occlusion of the right common iliac. So these are the CT images. As is, you can see on this, there are huge chunks of calcium at the aortic bifurcation site and the common iliac site also. The common iliac is being it's reformed, not common iliac, but the external iliac is being reformed through collaterals from the left side. So we took up this patient for PTA. So this is the, when we took up this patient for angiogram, so this was like it. So you can see there were multiple collaterals which were filling up this vessel retrogradely. The good thing was that we had a antegrade approach. So whenever things go right, it is much easier to work our way through. So we took a 7 French sheath in both the RT femorals, and we had a straight way. The measurements on CT were around 7 millimeters in the proximal portion of the common iliac and around 6 to 6.5 in the distal portion that was being reformed. We initially tried with a 035 Terumo wire, it won't cross. We upgraded to a PTCA wire, Whisper, didn't cross. Then we took a Fielder XT wire, and still we were not able to make it through. So we decided to give this wire support. So we took a 212 balloon, and with the help of this balloon support, we were able to cross into the aorta. So then the whole length of the occlusion was dilated with 2.5 into 15 mm semi-compliant balloon, but it did not result in much gain or flow in the vessel. Was then further dilated with 4 into 12 mm NC balloon. So these are the data. We had hoped that probably after that we will get some good flow, but it was not there. And in view of heavy calcium and a history of prior vascular intervention, surgical one, we had to think that this calcium needs to be broken. If it is there, probably the even if we receive some acute success, I don't know what would be the long-term result for this patient. So we decided to subject this patient to peripheral IVL shockwave lithotripsy. As we say that one should take around 10% higher size of balloon for getting the optimal technique for IVL. So the distal size on CT was around 6.5. So we took a 6.5 by 60 mm peripheral IVL balloon. We inserted it, and as you can see in the second frame, that even when we had inflated the balloon to 4 ATMs, the middle portion was it was a tight stenosis because of calcium. The balloon was not opening up. So we gave this patient 25 pulses, 2 cycles. One can give a maximum of around 30 pulses in 1 cycle. This catheter has around 300 pulses. So with ongoing pulses, one can see that this balloon suddenly it inflated well enough. So that is where it helped. Probably if we would have not used it or have gone to other balloons, such good expansion, it would have been difficult to achieve. Another thing is that for achieving such expansions, generally when we go for high dilatation, there are chances of injury to the vessel and perforation, especially if there is a lot of calcium involved. Now, this is a sort of non-traumatic sort of thing. We just inflated at 4 ATM and the shockwave did the rest of the part for this patient. So that is how it looked after the shockwave, and then we decided to put a balloon, so balloon mounted stent. This was a 8 into 40 mm balloon mounted stent, which was deployed from the ostia of the common iliac, and we could receive a very good result out of it. As you can see, that stent is well in the middle portion, it is slight under, otherwise it is well expanded at both the ends. So we decided to post dilate it. And after post dilatation, we proceeded because the CT as well as Doppler has shown reduced velocities on the left side also. And in CT, it was mentioned that left common iliac has somewhere around 50% of stenosis with some mild calcium. So we decided to give a try on the other side also with the same catheter. We had a lot of pulses remaining. Now this is the safety that one can go with these balloons, with the shock wave balloon, because it is essentially a non-traumatic procedure. As Dr. Khanna just said, it is hard on hard and soft on soft. So we decided it probably does not carry much risk to dilate the other side with this balloon. So we gave 2 pulses, 2 cycles of 20 pulses on the other side also. And this is the final result that we could achieve. Initially, there was a difference of around 50 mmHg in the aorta and the right side in mean pressures, and around 20 on the aorta and the left femoral. But post procedure, there was equalization of the aortic and the femoral mean pressures. So we could receive this wonderful result, all thanks to the shockwave. And as sir had already mentioned about the Disrupt PAD trials, trial 2 and the third one that has recently come up. And these trials have repeatedly, although the population is low, but the results that these trials have gone are phenomenal. And that is why even at around 12 months, the primary patency rate is much higher than that would have been without using this. So in Disrupt PAD 3 trial also, the procedure success has been much higher than PTA alone. So there is good treatment effect and there is good final angiographic outcomes also. So we all know that bed preparation is essential. And when there is heavy calcium, and it is difficult to prepare the bed in a good manner. And if there is so much of calcium, especially in those patients who have had earlier interventions for that artery, and you decide to put a stent in such patients or do a balloon dilatation, often your stent may be malapposed or it may be underexpanded, and that will result to abnormal hemodynamics at that patient point, and which will certainly going to compromise your long-term results. So take-home message from this case, as for me, would be that shockwave IVL is an efficient method to fracture calcium and provide injury-free acute gain to the vessels, and it allows for a better stent deployment and expansion, leading to improved local hemodynamics, which may translate to lesser repeat procedures and better TLR rates in future. So thank you so much, and that's all I had to share in my brief experience of this IVL in peripheral.
Thank you so much, Dr. Raj Pratap. We'll have discussion after Dr. Rajiv Parak's talk. Ujjwal, I think you have the slides to play for Dr. Rajiv Parak. And we know that Dr. Rajiv is the chairman of the Division of Peripheral Vascular and Endovascular Services at Medanta at Gurgaon. He is one of the most renowned and senior most vascular surgeon of the city. And he specializes both in open vascular surgeries and endovascular procedures, and has been attending and is a part of APVIC right from its inception for the last 12 years. He's going to be talking about a very pertinent and topic as in the last 1 year, which is role of low-dose rivaroxaban in critical limb ischemia. And after the COMPASS PAD trial, the role has really become very significant, and we are actually now moving from DAPT to this, one antiplatelet therapy or no antiplatelet therapy and rivaroxaban. So over to you, Dr. Rajiv Parak.
Thank you, Dr. Khanna. Am I audible?
Yes, you are very clearly audible.
Thank you. Thank you very much for hosting this absolutely phenomenal meeting year after year for the last 13 years. I actually salute your enthusiasm, especially in these unfortunate COVID times. You've managed to pull off such a fantastic collection of speakers and topics. So without much ado, I will talk about this, as you say, a very pertinent topic, which is rivaroxaban, which has recently been included in the medical armamentarium of peripheral arterial disease. So can we have the next slide, please? So PAD, as it is, that is peripheral arterial disease, as you know, affects millions of patients worldwide, but only 5% of these patients have classical symptoms of intermittent claudication. Most of the symptoms, almost 90-95% of them, either asymptomatic or have no classical symptoms, which amounts to, in 2015, a huge number of 236 million adults in 2015 were the number of patients who were affected with peripheral arterial disease. Next, please. Now, there are huge. Next, please. Yeah. So there are huge unanswered questions in the treatment of peripheral arterial disease, because they continue to remain at a very high risk of adverse cardiac events and adverse limb events. And despite the current therapy, which is as we know, either whether it is single antiplatelet therapy or dual antiplatelet therapy, or even in combination with warfarin, the risk of adverse cardiac as well as limb events remains high. This is the REACH registry, in which the 2-year outcomes have been mentioned. And I'll just bring your attention to the worsening of claudication, which is seen prior to revascularization in almost about 108 patients. And even after, the risk actually continues, and in fact increases after any interventional peripheral intervention, whether it is angioplasty or stenting, as is seen by 149 patients who have undergone peripheral angioplasty out of a total of 692. So these patients have actually worsened, because the risk continues despite the current anti-platelet therapy. So next, please. So after peripheral revascularization, the risk of major adverse limb events is substantially increased. Limb events increase rapidly post-procedure, then more slowly after the first year, whereas MI and stroke events increase steadily over the follow-up period. So essentially, immediately after a limb intervention, the risk of adverse limb events is much more than it would be otherwise. Next, please. So there's obviously a huge unmet clinical need for acute limb ischemia, because it occurs, as I said, frequently after revascularization, and can be life-changing because it can lead to hospitalization and even amputation. About 15% of these patients who had acute limb ischemia, even after revascularization, actually unfortunately died or were unable to go home after hospital discharge, because they were either left with amputations, disabling amputations, and they found it difficult to manage at home. And you can see here that the ALI event rate, that is the rate patient years per 100, goes up almost 10 times from before vascularization as after vascularization, as from 0.42 to 4.41. Next, please. So no antithrombotic therapy has demonstrated efficacy for reducing these adverse cardiac or limb events after peripheral revascularization. As you can see with the CASPER trial, in which DAPT or dual antiplatelets along with aspirin and clopidogrel after surgical revascularization, there is a significant increase in patients who have events, post-operative events, and even adding warfarin after surgical revascularization, as the Dutch BOA trial, and you can see that there isn't any significant improvement in reduction of the adverse cardiac or limb events. Next, please. So in chronic PAD also, intensified antiplatelet trials did not report and did not even demonstrate significant reduction in limb events. Unfortunately, they weren't up till now any trials which were specifically looking at adverse limb events, apart from the Euclid trial, the one in the center, which tested ticagrelor as well as versus clopidogrel, which showed that there was no reduction in acute limb ischemia or peripheral revascularization when you used either ticagrelor or aspirin clopidogrel. And the clopidogrel versus aspirin in the Capri trial actually did not measure any limb outcomes, neither did in the Charisma trial with clopidogrel plus aspirin. They only measured the adverse cardiac events which reduced by 24% and 17% in the Charisma trial. Next, please. So there is a huge unmet clinical need in peripheral arterial disease because the evidence and or guideline perspectives, there is lack of class 1 evidence for antiplatelet or antithrombotics post revascularization, and the majority of these anticoagulant and antiplatelet recommendations are actually derived from extrapolation of coronary artery disease studies. So there's obviously was a huge unmet need for research, newer approaches, and inclusive evidence for issuing strong guideline recommendations for antithrombotic therapy. So this is where we stand last year. Next, please. And this is where rivaroxaban came in. Next, please. Next, please. Yeah, next, please. Yeah, so rivaroxaban came in, and this showed that there was a huge vascular protection which rivaroxaban offered by prevention of disruption of the aerobic mitochondrial metabolism, reduction of arterial stiffness, reduction of endothelial cell senescence, and anti-inflammatory properties. And this, in association with aspirin, actually has changed the management of peripheral arterial disease. Next, please. The landmark trial, which was the COMPASS trial, which Dr. Khanna alluded to, was a dual pathway inhibition. This is the new novel approach, which is called DPI, or dual pathway inhibition. The objective of the COMPASS trial was to determine the efficacy and safety of rivaroxaban, low-dose rivaroxaban plus ASA, or ASA alone. And here about 27,000 patients were tested in these three arms, and the anti-thrombotic investigations were stopped 1 year ahead of expectations in February 2017 due to an overwhelming efficacy in the rivaroxaban, low-dose rivaroxaban arm along with aspirin. So this actually shows that there was a huge reduction in the adverse cardiac and limb events when we combined low-dose rivaroxaban along with aspirin. Next, please. So rivaroxaban, the vascular dose of ASA provides superior cardiovascular limb protection, as was shown by the COMPASS trial, because of the reduced adverse cardiac and limb endpoints. The combination of cardiovascular deaths, MI and stroke reduced significantly by nearly 28%, that is a third. Rivaroxaban low dose plus aspirin prevented 1 out of every 2 major adverse limb events, 46% reduction in limb events, including major amputations. This was a huge paradigm shift which occurred and actually gave us a huge ammunition in our fight towards trying to reduce adverse limb and cardiac events. And the consistent results of COMPASS in reducing adverse limb events and vascular interventions, and including total peripheral interventions among individuals who had lower peripheral arterial disease. This was actually then extended to include patients who had actually undergone limb revascularization. So this is, as I said, a continuum, chronic arterial disease continuing to have limb interventions and then continuing thereafter. So the next study, which again changed the complete outlook and actually completed the outlook, next please, is the Voyager trial. The Voyager study was to evaluate the efficacy and safety of rivaroxaban low dose 2.5 twice a day plus aspirin compared with aspirin alone to reduce the risk of thrombotic vascular events in patients with arterial disease, peripheral arterial disease, undergoing peripheral vascular revascularizations, whether endovascular or surgical. These patients underwent a randomized double-blind phase 3 control trial, and the symptomatic patients who underwent surgery were included in this. And this, the results, the completion was December 19, and the results were given out in March 2020. So this actually has really revolutionized our treatment and management of peripheral arterial disease. Next, please. So the key takeaways, next, please. The key takeaways from the Voyager PAD primary results was that in patients undergoing lower limb extravasations for ischemic symptoms, rivaroxaban 2.5 twice a day with aspirin compared to aspirin alone significantly reduced limb outcomes, including acute limb ischemia, reduced cardiac events up to 28%, reduced limb outcomes up to 46%, and the benefits which were early, which were even consistent over a period of time. And this stretched across major subgroups, including those with critical limb-threatening ischemia. And even it reduced the unplanned limb interventions, which means reduced the emergencies that these patients would have been subjected to had they not been on this combination therapy. And of course, even though rivaroxaban has been added to aspirin, the TIMI major bleeding had no apparent increase, and there was no significant increase in any severe bleeding, such as intracranial hemorrhage or fatal bleeding. So you will agree that both the Compass and the Voyager trial have given us a significant information about how to treat these major, this limb-threatening ischemia with reduction of limb events as well as cardiac events. So thank you very much for your patient hearing. If there are any questions, I'll be very happy to answer. Thank you, Dr. Khanna.
Thank you very much, Dr. Rajiv Parekh. Now the session is open for discussion, and I would request you to stay back. And among the panelists and chairperson, we have you along with Dr. Saroj Das, Dr. Michelle Henry, and we have panelists Dr. Deepak Jain, Dr. Tulio Navarro, and Dr. Nanda Kumar. So I leave it to you, Dr. Parekh, to start the discussion.
So, sorry, can you hear me?
Yeah, we can hear you.
Yeah. Okay. So, I can talk about the role of the anticoagulants, which is the rivaroxaban in chronic limb ischemia. This is something which has actually, as I said, changed our practice and thinking, and significantly, because we've been using this dual the aspirin along with low dose rivaroxaban now for almost about 1.5 years, almost 2 years, with significant improvement. So there is in the real world a real place for this therapy. So of course we also had another study which was called the Lighthouse. Basically it wasn't a study, it was just basically a post-marketing surveillance study which is called the Lighthouse project, and that actually had almost about over 1,100 patients enrolled in this, with a significant reduction in the limb events. So both these trials have actually, for peripheral interventionalists, given us a huge fillip to our effort to try and reduce limb events. So if there is anything else which anybody would like to add, I'll be happy to continue to talk about it.
I have a question, and I need a comment from Dr. Saroj Das. He talked very elegantly about the microcirculatory changes after leading to activation of thrombosis after COVID-19 and its impact on venous and arterial system. I wanted his comments and what are the British guidelines for use of this low-dose rivaroxaban, and in patients, especially in patients who underwent peripheral revascularization during this time. You're muted, Dr. Saroj Das.
Thank you, Dr. Khanna. As I said in my presentation, that fortunately, the risk of arterial thrombosis is not as frequent as it is with the venous thromboembolism with COVID-19 infection. That's number one. The second thing is that most of the complications of thromboembolism is seen with severe infection. And most of these patients are being managed in the intensive therapeutic unit environment. Apart from this evidence, the so-called recommendation which has been developed is that there is no role for treating these patients aggressively with antithrombotic agents or anticoagulation agents. But what is important in this patient, prophylaxis should remain the mainstay of treatment, and this prophylaxis should be extended to the community environment. If they have developed already, spent some time in the ITU, and subsequently if they have developed any thrombotic episodes. Obviously, if there is a need for limb salvage or there is a need for other rescuing other arterial thrombosis, that should be done as necessary. But most of the recommendation from all the evidence that we have so far is prophylaxis is better, and we should aim at prophylaxis and treat. If the thrombotic episode has caused any significant problem, then we must treat it with therapeutic anticoagulation.
With your permission, can I say something, Dr. Khanna?
Sure, sir.
Yeah. I think I wouldn't agree more. I think Dr. Das has actually put everything in the right perspective. I think it's extremely important to understand the difference between treatment and prophylaxis. I mean, if somebody actually has an event and there's a thrombotic event, then you treat it just as you would treat any other thrombotic event. I mean, whether you start off with in the ITU setting, you probably start off with subcutaneous enoxaparin or low molecular weight heparin, whichever one you want to use. So you continue with that, and then absolutely right. I think this should be continuing in the community setting once these patients are discharged home. We are talking about patients who have severe disease, who did not suffer from any major thrombotic episode, but these patients also, because of the microcirculatory involvement, as Dr. Das said, these patients also need to be prophylaxed, and this also needs to be continuing into for at least about 6 to 8 weeks in the post-discharge period, because there is definitely a risk which continues, which really needs to be mitigated. I know there isn't any evidence to suggest that this should be done, and I know our friend from King's College, Dr. Arya, he, I think, did a study at the King's College Hospital, and they said that there was no real need to extend the prophylaxis beyond hospital discharge. But I think in our practice at the Medanta Hospital in Delhi, and I think major hospitals across Delhi and India, I think there is most of these patients are being discharged on either rivaroxaban 2.5 BD or on Eliquis, which is a Pixaban 2.5 BD, for a period of at least about 2 to 3 months, if they have had extensive intensive care therapy and have spent significant time in the intensive care unit because of serious COVID disease.
Thank you very much, and that brings it to the right perspective. Dr. Deepak, we had a question from you because you have an extensive experience in your lab dealing with complications like perforations, which I think are mostly related to undetected calcium or high pressure balloons or maybe oversized balloons. Do you think that IVL, which is intravascular lithotripsy, may be minimizing this sort of complication in very severely calcified lesions and angulated lesions?
Actually, to be honest, I have always relied on rotablator, and since we have been doing rotablators for the last 20 years, I do not feel need, at least in my setting, for anything else to treat calcium except rotablator. But yes, I have seen operators using lithotripsy. We have used lithotripsy in 1 or 2 cases. We had found problems like delivery of the balloon. This was one problem which we found because we are a referral center. We are a tertiary care referral center. We do not have patients walk in. We only have referred patients. So we have a difficult subset of patients. And in those patients, tortuous arteries, severe calcification, the balloon delivery becomes difficult. And for delivery of the lithotripsy balloon, we had to dilate it. And this dilatation was not successful. So ultimately, we come back to the same point. To deliver things, we need to do something. And for that matter, we use rotablator very frequently. So for us, rotablator is the ultimate thing for treating calcified arteries. And we have a very low threshold of doing rotablator atherectomy. In fact, we are doing around 200 rotablators a year. So we have a very low threshold of doing rotablator. So straight away, we go for rotablator right away, electively, and not as a bailout strategy.
Okay, I take your point.
Dr. Khanna, if you allow me, Ivo Petrov speaking. Hello,
yeah, sure.
Hello again.
Yeah, Dr. Petrov, please.
Definitely, for me and for my team, the topic about the lithotripsy, both peripheral and coronary, is extremely interesting. Congratulations for your result that you have shown. I would like to add just detail. So, for example, in very complex lesions in which the so-called non-dilatable lesions, we have seen some stents not dilated in the proper extent, both in peripheral and coronary artery disease. And all we know in such a situation, it's a huge problem for the operator and for the patient. And in this situation, as probably off-label, but it's doable, to put just a non-compliant low-profile balloon in advance, and after that with the lithotripsy balloon, the shockwave balloon, it's possible to disrupt the calcium in order to expand the stent on the proper extent. So we had done 5 cases like this, 2 coronary and 3 non-coronary. One of them was dramatic, carotid intervention on a doctor, on a physician. He had total occlusion of the other side, contralateral, and he had critical in-stent calcific in-stent restenosis on the other side. And we succeeded, fortunately, as a final option with the shockwave balloon, and it was a really very, very interesting case, checked by IBUS as well. So it's definitely a new technology that is giving us chance for complex calcific lesions. Thank you.
Yes, definitely, I agree. It's a very good tool, but it has 2 major disadvantages as of now. One, that it is very costly. I mean, the cost of a balloon as of now probably exceeds the cost of the whole angioplasty procedure with the stent. And it's not reusable, and it has just a life of about 3 hours. You can use it in the same patient and the same size. Otherwise, the chip is so made that you can't use it at a later date. The second thing is in peripheral applications, especially, we deal with heavily calcified aortoiliac lesions. And that place, the maximum diameter of the lithotripsy balloon, which we have, is only 7 millimeter. And many a times this becomes undersized, and we are not able to actually break enough calcium or a deep calcium. And we are limited, in aortoiliac lesions, and aorta, you are definitely limited because you can't use this unless you are putting 2 lithotripsy balloons, which becomes very costly, and then, sort of trying to break the calcium. So a better strategy, which at our place, a more practical strategy, which we use is we endoline first with a covered stent and then dilate at high pressure balloon. And this gives us a much better practical result than using lithotripsy balloons, which are undersized and not getting into the right results which we want.
Totally agree.
Can I ask some questions?
Yeah, Dr. Das, please.
Thank you. This question for Dr. Petrov. Hi, Petrov. Now, in your presentation, you talked about multiple sites radiofrequency ablation of the denervation of the renal artery. Does it have any consequence as regard to the compliance of the renal artery? Does it have a long-term effect with regard to management of hypertension?
Very good question, very important question. In fact, this was the main concern before the widespread use of the renal denervation. In fact, like shown into the multiple trials and also in our experience, we had only one short dissection of the renal artery that was extremely easy piece of cake to be stented. Otherwise, we didn't see any long-term consequence that was unfavorable. As I mentioned, there are some special tiny notches on the X-ray to see in fact, the efficiently treated points. And it resulted, these notches, they don't have any further non-beneficial result on the renal artery, and even checked by ultrasound Doppler. Our extremely experienced angiology team is checking every single renal artery after the renal denervation intervention, and we didn't have no one case up to date. And even more, with the new version, the spiral version, I mentioned it's a lower profile on wire on-wire system that is absolutely predictable, where the catheter and the delivery of the renal frequency ablation is delivered. So in fact, it's a really very, very safe system.
Thank you. Can I ask another question to Dr. Pratap? I saw that was very interesting, what you presented. Dr. Pratap, I'm talking to Dr. Pratap.
Yes, sir, I'm here.
Yeah. So, did you think of putting another stent on the left iliac?
Not really. Actually, we had done a pressure study prior to that, and the pressure difference on the left side was around 18 mean pressure difference was around 18 between the aorta and the left femoral. So we had not thought of putting a stent out there, and it was just out of curiosity that okay, the balloon is pretty much a non-traumatic one, so and we had a lot of pulses remaining, so we tried, okay, let's see whatever we could make out of it.
Yeah, that's true. But the fact is that your right iliac stent has crossed into the aorta, and there is always a risk that this will definitely compress on the left iliac artery, left common iliac artery. If it hasn't happened now, it will happen very soon. So usually we tend to put as you know, the kissing stents in this situation. And so something that is what maybe you have to put this patient under surveillance. He might need this in future.
Yeah, I'll keep that thing in mind. And the patient is being followed up. It's been around 3 months. He's doing fine, and let's see. Hopefully, he does well in future. If some.
Thank you.
Thank you, sir. Thanks for the.
Thank you.
One question, if I may. Naren, can I ask a question?
Yeah, sure. Go ahead. That would be the last question.
Dr. Petrov, what's your experience with alcohol ablation and ultrasound? Because in our center, we have been increasingly relying on alcohol ablation.
To be fair, we don't have any experience with this kind of renal denervation. I have heard only, and I would be curious to listen to your experience. It really sounds interesting.
Yes, it is. It is very effective, and the best part is it is much less time consuming than radio frequency ablation.
But do you have a special device, or it's
yes, there is a special device for it. Yes, that is true.
Deepak, may I ask you how, just in the last 15-20 seconds, how do we do it? I mean, and how do we avoid injury to the endothelium and the media? I mean, alcohol ablation just to the superficial nerves, how do you achieve that, and how do you do it? Is it through a drug delivery balloon or something?
Yes, exactly. It's not a drug delivery balloon, but a drug delivery device. It's not a balloon, but a device there which delivers drug, and it has to be given in very small amounts, depending on the response. And the patient has to be anesthetized because it's very painful.
And it doesn't lead to any stenosis or stricture in the renal arteries?
At least for the small follow-up that we have, it didn't. But I do not know. We don't have a longer follow-up.
Because that sounds interesting, and that may be having much wider application than these dedicated, sophisticated devices.
Correct. Yes.
Thank you so much.
In fact, just a detail, we have to know that into the European statement, the two systems that are approved is the the radio frequency and the ultrasound. Unfortunately, so in our environment, the alcohol would be off-label. So it's probably in the future we are going to see more results, and it can be included. So thank you for sharing.
Actually, we are doing under a registry, and it's a phase 3 trial that we are doing.
So thank you, Deepak. Thank you all, Dr. Ivo Petrov, Dr. Raj Pratap, Dr. Das, Dr. Michelle Henry, Dr. Rajiv Parak. Thank you for this, deliberation in this interesting session on newer topics in vascular medicine. Let's now move to the second session, which is on recent trends in vascular imaging. And today we have the doyen of imaging in the country to be conducting this session. Let me invite Let me invite Dr. K.K. Kapoor, Dr. G.N. Mahapatra to start with. He is the Director and Chairman of the World College of Clinical Cardiology and Imaging. He would be presiding over the ceremony of and conducting this session. We have good speakers like Dr. Kapoor, who works with us. He's a chief of non-invasive cardiology at Indraprastha Apollo Hospital. Dr. Jonan Christopher, Dr. Parul Garde, Dr. Megha Seth, and Dr. Suman Singhal. He and Dr. Kapoor would be conducting this session. And may I invite Dr. G.N. Mahapatra to take over and start the proceedings. Dr. Mahapatra, you are not audible, you are muted.
Thank you, Professor Dr. Khanna, for really giving us a 1 hour session on imaging, role of imaging in vascular system. So in this connection, I would like to invite two of our eminent chairpersons who are in the panel, Dr. E. Prabhu. He is a senior consultant, nuclear medicine physician and head of the department from Chennai, from Global Hospital Chennai, and Dr. Mahesh Banur is also from the southern part, this thing. So now I would hand over all the proceedings, all the presentations to Dr. Prabhu and Dr. Mahesh Banur. He is an imaging person. So over to Dr. E. Prabhu and Dr. Banur.
Thank you, Dr. Mahapatra, for this wonderful introduction. And good afternoon, good evening, ladies and gentlemen. In fact, we have very interesting topics lined up by eminent speakers like Dr. K.K. Kapoor, my great friend, Dr. John Christopher, Dr. Parul, Dr. Megha Seth, and of course, Dr. Suman Singhal is there. Dr. Mahapatra himself will be presenting a topic on PET in evaluation and coronary and carotid plaques. With this few words, I would like to invite the first speaker, Dr. K.K. Kapoor, to give his thought process about understanding duplex scans for peripheral vascular disease.
Thank you very much. I would like to share the screen. Hello, so can you see my slides? Can you see my slides?
Yes, we are seeing your slides. Yes. Dr. Kapoor, please proceed.
Am I audible?
Yes.
And you can see my slides?
Yes.
Okay, thank you. So I would like to, at the outset, thank Dr. N.N. Khanna for giving me an opportunity to speak on this topic of duplex ultrasound in the evaluation of arterial diseases. So the disadvantages of Doppler ultrasound over the other non-invasive techniques is that the invasive diagnostic evaluation is obviated. There are no ionizing radiation. Equipment cost and flow space is 1/6 to 1/8. There is very little manpower requirement. Hardly one person or two persons are required, but one person should be highly trained. And the results are instantaneous and no offline analysis. So when you look at the arterial Doppler, as a screening technique, we have used ankle brachial index. And if you have a normal ankle brachial index of 0.9, but on post exercises, it becomes less than 0.85, but a critical ankle brachial index is less than 0.60. Then it is consistent with the peripheral arterial disease and is an independent predictor of mortality. However, this is a non-imaging technique. So imaging is then needed to confirm the location and degree of the narrowing before revascularization, or if the diagnosis of this PAD is uncertain. So duplex scans helps to identify these these pathological lesions like stenosis, thrombus, aneurysms, fistula, and collaterals. Thus, the duplex scanning provides a combination of anatomical and physiological information that other imaging or physiological testing modalities cannot offer. Now, how is it done? Typically, this vessel is viewed in short axis with a linear transducer of a frequency of 8 to 15 megahertz. And then after doing the short axis, we go to the long axis by rotating the transducer to 90 degrees. And then we add the color flow, and then we can track the artery. Now, this is the Doppler spectral waveform in a normal patient. It has got a classical triphasic pattern. So if you look at this triphasic flow, you can see that it is a non-turbulent flow. This flow is a non-turbulent flow when you look at this. And this non-turbulent flow is indicated by the fact that there is a clear space within the Doppler spectrum. And the flow is triphasic. So this is when you add the color, then you can see that the color fills the entire vessel and you get a color flow, this triphasic pattern. And then this peak velocity in the proximal arteries of the lower limbs, like the iliac arteries or the common femoral artery or the SFA, is in the range up to a maximum of 150 centimeters per second. So when you diagnose arterial obstruction, that is, first of all, you have to understand that when there is a narrowing up to 45 to 50%, there is no alteration in the Doppler waveform. The Doppler spectrum remains narrow, normal velocity, and triphasic. The normal flow reversal can be observed at arterial bifurcations or major branching, and the spectral broadening can occur as an artifact if the sample volume size is too large, that is more than 2 millimeters. Now, this is an example of a high velocity and turbulent flow across the narrowing, and you can see that there is a complete loss of the clear space of the Doppler spectrum. So when you assess the Doppler for the peak flows, then you look at the normal peak velocity in the proximal limb arteries. It varies from this 40 to 90 centimeters per second. More than 2 times increase in the peak velocity or more than 120 centimeters per second is equivalent to 50 to 70% narrowing. More than 3 times increase in the peak velocity or more than, although is actually equal to 90% narrowing, or approximately 180 to 200 centimeters per second. And more than 4 times increase in the peak velocity is equal to 95% narrowing, and which is generally more than 300 centimeters per second. So what are the characteristics of the Doppler patterns in arterial obstruction? When you put the sample volume just proximal to the high-grade narrowing, then you get a low velocity, high resistance flow. We call it a pre-stenotic damping. At the site of the high-grade narrowing, there will be a high velocity spectral broadening and aliasing, and distal to the arterial obstruction, there will be a post-stenotic flow damping, which is characterized by low velocity, reduced acceleration, and a low resistance flow. So you can see that you have on the top panel a mild flow damping. On the middle panel, you have a moderate flow damping, and on the lower panel, you have got a marked flow damping. So what is this minimal stenosis? The minimal stenosis is there is no significant change in the color flow pattern. There could be a minimal spectral broadening, but it may not be there. there is a 1 to 29% increase in the peak systolic velocity, and the velocity ratio is 1 to 1.5, and the waveform is normal triphasic. When you get a moderate occlusion, then there is a spectral broadening, as you can see in this trace, that there is a loss of the clear space inside the Doppler spectrum, and this is the spectral broadening. This velocity ratio is 1.5 to 2, but the reverse component could still be present. And this is to show it diagrammatically that there is a complete fill of the Doppler spectrum with the Doppler flow signals, and therefore you don't have any clear space. When you have severe occlusion, then there is a easily visible narrowing, there is a color aliasing, there is a loss of the reverse component, marked spectral broadening, and there is more than 100% increase in the peak systolic flow. When you have a velocity ratio, we call it VR, if it is 2.0 to 4.0, it is less than 75% narrowing. When it is 4.0 plus or more than that, it is more than 75% narrowing, and you get a monophasic waveform with post-stenotic turbulence as indicated. And when you have this, you have a monophasic flow. So you can see that there is a near total occlusion, and the flow is occurring through the collateral channels, and distal to the obstruction, you'll get a monophasic damped flow. Now, the other thing that you look at it, that you get a distal flow beyond the obstruction will be low resistant with a power Stardust pattern, and this is due to the collateral flow. And when you again see this post-obstructive phenomena diagrammatically, you see that the systolic and diastolic velocities are very close to each other, and you are having a highly damped pattern. The collateral flow is a low velocity monophasic flow. There is a loss of the triphasic character. There is a TARDIS power appearance and low resistance, which is related to the degree of ischemia. This is an example of an infrarenal abdominal aortic block. As you can see very clearly that this is an infrarenal abdominal aortic block, but the flow is occurring into the common femoral artery, SFA, and the profunda artery via the collateral channels. And the flow is then occurring into the PTA also. And what you also get is a slanted appearance, that is a slow acceleration, with the acceleration time being more than 100 milliseconds as compared to the brisk acceleration that you get in non-critical blocks. And other finding could include a color aliasing, which is a focal narrowing, but sometimes due to the vibration of the soft tissue due to turbulence, you can get a color bruit. So when you look at the stenosis, this is an example of a pre-stenotic high resistant flow on the left, and on the right you get a high velocity flow with a velocity ratio of 7.0, indicating more than 90% narrowing. Now, this is a case study of a 66-year-old female patient with complaints of pain in the right leg after walking. And you can see that there is a normal flow in the left SFA. But when you look at the right SFA, you get a monophasic damp pattern, indicating that there is some problem proximal to the artery. And when you look at this popliteal artery, the right popliteal artery shows highly damped flow, while the left popliteal artery is normal. When you look at the anterior tibial artery, you get the same findings. So when you look at the actual site of the lesion, that you do abdominal scanning, and you look at the right common iliac artery, you see a critical narrowing at the right common iliac artery with a high velocity flow of more than 4 meters per second, which indicates more than 95% narrowing. And you see a partial damping of flow in the distal right common iliac artery on the right side. Now, there are some applications of Doppler in graphs. You have this peroneal artery graph showing stenosis, and this graft is of the saphenous graft, and you see high velocities indicating that there is a narrowing at the site of this anastomosis with the peroneal artery. And when you do a revision of this anastomosis, then these peak velocities, they fall to 100 centimeters per second from an earlier one of 200 centimeters per second. Now, this is a pseudoaneurysm. This is due to a rent in the artery, which occurs generally due to iatrogenic procedures or could be due to trauma. And you can see that this is surrounded by clot. The wall of the pseudoaneurysm is surrounded by clots, and there is a small rent. And you can see you can get a classical to and fro pattern, the flow occurring from the rent into the pseudoaneurysm and from the pseudoaneurysm back into the artery. And this also shows you a narrow rent that is seen just at the mouth of the pseudoaneurysm. Now, this is to differentiate between a hematoma and a pseudoaneurysm. You can see that there is an excess graft, and in the process of placement of the excess graft, there was bleeding, but this is a hematoma. There is no flow into the hematoma, so this is not a pseudoaneurysm, and you can see the flow in the excess graft channel. You have a power Doppler mode, which is used when you have low flow states or when aliasing causes problems and you cannot view these background structures, and where optimal angles are not available. Then this is a non-angle dependent power Doppler, which you can see on the right hand side, and you see that the quality of the image is better as compared to on the regular Doppler on the left hand side.
Dr. Kapoor, kindly conclude your slides.
Just give me another half a minute, please. Just, or you can say 10 seconds. The limitations of the Doppler ultrasound in the evaluation of vascular pathologies is that it is highly operator dependent. If you may not always have a good acoustic access, there is angle, because it's a Doppler technique, it is angle dependent, and there is non-visualized flows may not be always equivalent to absent flows. That is the first axiom in Doppler that we teach our students, that the non-visualized flows are not equal to absent flows in every case. And the other limitation is that the disease may be underestimated in the presence of a long, smooth plaque that does not have the accelerated turbulent flow patterns associated with hemodynamically significant lesions. High and low cardiac output can affect the peak systolic velocity. Therefore, in the setting of a markedly high or a markedly low cardiac output, the peak systolic velocity ratio should be the primary diagnostic criteria for diagnosing this obstruction. Thank you very much. Thank you.
Thank you, Dr. Kapoor. We will have the discussion toward the end of the session. May I request my co-chair, Dr. Magesh Banur, to introduce Dr. John Christopher. There cannot be a cardiac imaging session and without John Christopher's participation. And
thank you, sir, for your invitation, and I thank Dr. Mahapatra as well as Dr. Khanna for giving me this opportunity. Now I invite my close friend John Christopher to discuss on coronary calcium scoring, how it is advantage or how it evaluates the coronary artery disease. Sir, Dr. Christopher, please go ahead.
Good afternoon, ladies and gentlemen, respected chairpersons, Dr. Khanna and Dr. Mahapatra. Are my slides visible?
Yeah.
Okay, sir. So I'll be talking about coronary calcium scoring. We know that the prognosis in coronary artery disease long ago was dependent on whether you had a single vessel disease or a double vessel disease, or if you had a heart failure or not. Soon, the prognosis was dependent on whether you had an LAD disease or a non-LAD disease. So thankfully, we have come far, and then we moved into the clinical subsets of patients who had heart failure, and those patients who had a high blood pressure, and those were the patients who had a poor survival curve. But we have moved on and we have come to more clinically relevant tools. And one of the most important and widely used is the Framingham Risk Score, which looks at a number of clinical parameters to judge the patient's risk of developing heart disease over a 10-year period. And it was in 2009 by Dr. Philip Greenland's group in the Northwestern University and his little editorial in the Time magazine, which just exploded calcium coronary scoring into the mainstream cardiac practice. The MESA trial also, for the first time in their clinical scoring, added an Agatston score in their scoreboard. And what it showed in this patient was that with only the clinical parameters, the score was 4.7, which is low risk. But with the addition of 175, which was the patient's calcium score, the risk just boomeranged to 7.6%, which is an intermediate risk, and therefore the prognosis completely changed. What is calcium scoring? Coronary calcium score is a part of the development of atherosclerosis. It is found exclusively in atherosclerotic arteries in the heart. It's obviously seen more in advanced lesions and in elderly age. However, we don't have a linear relationship between calcium score, percentage stenosis, and vulnerable plaques. In the 1980s, calcium scoring was done by the EBCT machines. The three scores that were common were the Agatston's, volume, and calcium. We moved on in the early part of the millennium when the GE company actually took over and bought out the EBCT and stopped its production. And therefore, only multi-slice CT scanners have been used ever since with an excellent temporal and very good spatial resolution. What is very good with the top-end scanners is that you can see in this patient with a BMI of about 24, the dose is about 0.4 millisieverts, and a slightly heavier patient with a BMI of 30, the expected dose goes up to about 0.7 or 0.8, well within the 1 millisievert margin. The scan is done by using a what we call a helical mode in the CT. It's a non-contrast scan. You don't need to use contrast. It is an ECG gated scan, and the scan happens in about 5 seconds. The total procedure is about 5 minutes. So patients walk in and walk out with absolutely no preparation. Now, we've talked about the various scores, the Agatston, volume, and the density. There is some small body of data which suggests that the density factor is also important. And with the same Agatston and volume score, a lower density seems to give a higher cardiovascular risk to that patient, but it is not very well known, nor is it done widely. Now, how are we interpreting calcium score? A 0 score means you have no identified plaque. The risk of heart disease and heart attack is extremely low. Anything less than 10 is a minimally identified plaque with, again, a low risk of heart disease and MI. When you touch 100, it's called as mild, and there is a moderate risk of heart disease. And when you cross 400, it is a moderate to high or high risk. And in our series at our institution, we found that when you cross 400, 50% of our patients had a positive stress maybe scan on the nuclear imaging. Now, this is a 45-year-old gentleman. He's a businessman who had atypical chest pain. We did his calcium score 0. We did the CT immediately afterwards, and pristine coronary arteries, LAD, L6, and RCA. We gave him a clean bill of health and actually stopped the aspirin for him and made sure that his lifestyle factors were well controlled. This is another 65-year-old lady with atypical chest pain, and our calcium score was 1609. And no surprises when we did the CT, multiple lesions in all the 3 territories of intermediate to high region. And this lady actually required an angiogram and a subsequent bypass surgery. Now, who are we going to use a calcium score? It is reasonable with a level of evidence B by the American College in a patient with an intermediate risk, 10 to 20% 10-year risk score, or may be reasonable for someone with a low to intermediate risk, 6 to 10% score. Definitely not recommended for a patient of less than 6% intermediate score. And the way we go about it is this very nice flow chart, which was published in the Journal of Nuclear Medicine, where if the 10-year risk is low, then primary prevention is what is offered. If the patient has a high risk on the clinical parameters of more than 20%, he straight gets a a nuclear scan, a SPECT scan. If there's extensive ischemia, he gets to go directly to the cath lab. If it is mild to moderate, he's on medical management for secondary prevention. And if this patient has an intermediate score, and that's the kind of score and patient we're looking at, he gets a calcium score. And if it is between 100 and 400, he gets secondary prevention. Less than 100, he gets primary prevention. And more than 400, he gets a stress scan. And this is the general way we would be using the calcium score in this kind of population. And where does our recommendations come from? It started from the 2006 American Heart Association on the assessment of coronary heart disease, the 2007 American College Guideline, and the combined American College and Heart Association in 2010 gave us some very, very robust evidence in favor of calcium scores. So the 2007 guideline, the 2013 guideline, and here the recommendation clearly showed that when a clinical risk model is uncertain, then you could either use a family history, a HSCRP, a calcium score, or an ABI. And so therefore calcium score has a fairly good recommendation of 2B with the level of evidence B, and that's the data that we are working at. Now, what is the difference between calcium scoring and CIMT? Now, calcium scoring has a high predictability in patients with cardiovascular disease or coronary disease. The predictability is low in patients with CVA, while a CIMT has a lower predictability in coronary disease, but a higher predictability in stroke patients. This is just to set matters right for which is better for which. Now, sensitivity is high for calcium score in the presence of 50% angiographic stenosis, but the specificity is only moderate, and the sensitivity ranges between 90 to 92% with only a 50% specificity. However, we must see that the absence of calcium is highly predictive of the absence of significant coronary artery disease. There are obviously patients who cannot have it, and those patients are those who are pregnant, patients who have already had an MI, angioplasty, bypass surgery, whose resting heart rates are very high, and those who have intracardiac pacemakers, wires, or stents or valves, which will obscure the calcium scoring. Now, the accuracy trial clearly showed the very high sensitivity of calcium scoring, especially if it was 0, but it also displayed the lower specificity of the calcium score. Looking at the ethnicity, it is seen that the whites have the highest calcium scores, both male and female, compared to the Chinese, Hispanic, and Black, but the predictive value of calcium score still remains the same. Now, when you talk about the relative risk for coronary disease in the elderly, it is seen that the tertile of calcium scores starting from 0 to more than 1,000 has a significant bearing on the cardiovascular risk prediction of these patients. Within the same FRS score of 10 to 20%, we can divide our patients into 3 tertiles based on the calcium score, with very low disease of annual coronary events in the first tertile less than 100, and very high incidence of coronary MACE in patients with more than 400 score. And also the NEGM study clearly showed that if you have a high score of more than 300, you have a significant coronary event of almost 10% plus over a 5-year period. And also we have seen the data that in elderly patients, especially when you cross 55, the chance of you having a significant lesion if you are male is high if you have a higher calcium, and also if you are female with a higher calcium score compared to those patients who have lower calcium score have a lower incidence of significant lesions. What is the effect of using calcium score? Well, it has a possible therapy for primary prevention and helps us to add aspirin and hike up the dose of statin in those patients who have a higher calcium score compared to their clinical risk score. We have looked at statins and other therapies, and it is actually found paradoxically that the use of statins increases calcium scores over a period of time. And just a week ago, I saw an article which says in a Korean database that patients who did excessive exercise actually had a faster calcium progression. Not sure what that means. So calcium progression has been conflicting, and we are really not sure what it really means. But in terms of prognosis, if you're asymptomatic and have a calcium score of 0, you have an excellent prognosis compared to somebody who has a calcium score of more than 0. It's not very true for symptomatic patients. The same doesn't hold true, and symptomatic patients don't get the same kind of benefit. Again, it's clearly noted that in patients with a lower FRS score, the calcium scores are generally less than 400 compared to patients with higher FRS score, where this calcium scores of more than 400 are more common. And again, if you're looking at 5-year mortality and we're looking at the FRS division, you can see in patients with low calcium scores, the FRS scores by themselves do not really tell us about the prognosis compared to patients with a higher calcium score than the FRS score is able to divide the 3 tertiles. Now, what is very important is that in smokers, be aware that a lot of patients have a calcium score of less than 10 and they're still vulnerable to myocardial ischemia. The same thing has been noted in the emergency room, where we find that even with a calcium score of 0, there is significant atherosclerosis and stenosis, possibly due to the presence of significant non-calcified lipid-rich plaques. When we look at the endothelial physiology, also we can see in those patients with ischemia, they have higher calcium scores, both more than 100 and more than 400, compared to those with no ischemia, who have a higher proportion of patients with calcium score more than 0. In this very interesting article, it was shown that if you add the peripheral artery disease detection, calcium scoring, and nephropathy, you can actually uptitrate the risk of diabetes mellitus in these patients. When you talk about the warranty of calcium scores, it is as high as 15% for those with a calcium score of 0. However, diabetics, the warranty drops down to less than 5 years, showing that if you're a diabetic, a calcium score of 0 may not protect you. Repeat calcium score at this time is not recommended. There's no clinical algorithm to look at repeated calciums, although people say after 3 years you can have a look at it. But also we must remember that statins actually increase the calcium score. What it really does is the presence of calcium helps the compliance to various drugs in patients. Once they know they have a higher calcium score, their compliance seems to improve. And the big trial, which was done fairly recently, the Eisner trial, which was headed by Dr. Dan Berman, looked at coronary artery calcium score in the Sinai Institute.
Johan, kindly conclude your slides, please.
Yes, that patients who had a normal calcium score had fewer tests and procedures in the subsequent 4 years, although the drug cost went up because they were aggressively managed. Now we have AI and machine learning coming, and even in the non-gated scans, we're able to pick up the calcium scores, and we are going to get some very good models in the years to come. I will end my talk with this very, very interesting statement by Dr. Dan Berman, who's also my mentor. And what he said was the recommendation by major professional organizations in cardiology that coronary calcium be measured is likely to have as great an impact on saving lives as a recommendation that cholesterol be measured and controlled. Very, very interesting science. And thank you very much for that opportunity. And thank you very much once again. Thank you.
Yeah, that was the nice presentation. Now I call Dr. Parul Garedi to present her talk on role of MRI in aortic and carotid plaque assessment. Dr. Parul, please. Yeah, slides are on.
You all can see my screen?
Yeah.
Okay. At the outset, I would like to thank the dignitaries of Asia Pacific Vascular Intervention Society for having given me this opportunity. So these are the questions that we are going to address today in this next 10 to 12 minutes. So what are the characteristics of vulnerable plaque? We all are aware of the process of atherosclerosis, which begins with deposition of lipid as an early atheroma in the intimal layer of the vessel, which, if uncontrolled, incites an inflammatory reaction and leads to formation of what is known as the vulnerable plaque, which has a large lipid pool, a thin fibrous cap, and lot of inflammatory cells around it. This is typically what we label as the vulnerable plaque. If it remains uncontrolled, there can be rupture of the thin fibrous cap, which can lead to an embolic phenomenon. So having said this, this is what we look at when we are looking at vulnerable plaques. So we look at presence of intraplaque hemorrhage, lipid-rich necrotic core, thin fibrous cap, enhancing vessel wall around the plaque and surface conditions of the plaque, whether or not we are able to see ulcerations over the plaque. Now going on to the next question, that why and how does MR imaging aids in detection of these plaques? Now why MRI? MRI because it has an inherent high soft tissue contrast. The lumen as well as the wall of the vessel can be imaged in a single study, that too non-invasively. High resolution imaging is possible using surface coils and sub-millimeter acquisition, and of course there is lack of ionizing radiation. So over the last 2 decades, there have been several studies which have looked into the role of MRI for detecting these vulnerable plaques and finding the risk assessments for stroke using this technique. This is a systematic review or a meta-analysis which was published way back in 2013 in the Journal of Stroke, which said that presence of intraplaque hemorrhage, lipid-rich necrotic core, and thinning and rupture of the fibrous cap on MRI of carotid plaque is associated with increased risk of future stroke or TIA. And this, they have further asserted, is the stroke risk information that MRI gives is beyond what luminal stenosis is there at that point in the vessel. So having said this, how do we incorporate vessel wall imaging in our routine protocol? Routinely, what we can do is in patients where we are imaging patients with stroke, we can just add 2 techniques, simple techniques, that is fat suppressed Stephen weighted black blood imaging and a post gadolinium fat suppressed Stephen weighted black blood imaging for evaluation of these plaques. Now, why Stephen weighted image? A Stephen weighted image is because the blood degradation products in the early and late subacute stage cause Stephen shortening. Hence, they look bright on Stephen weighted sequence. Why black blood? Why black blood is, it's a flow suppressing sequence. So the lumen becomes black, and fat suppressed is that the fat around the wall gets suppressed. So the wall of the vessel is much better appreciated using this sequence. Why do we need to use contrast? Because we want to look at inflammation and we want to differentiate the necrotic lipid core, which will not enhance, as against the fibrous cap, which would enhance. So this is an example of an intraplaque hemorrhage. By the rule of thumb, most of the time, whenever you see a bright signal on Stephen weighted sequence within the plaque, one has to think of intraplaque hemorrhage. So here, this is the vessel lumen and this is the plaque, which is showing a bright signal on T1. It is hypo on T2 and not really enhancing on the contrast enhanced Stephen scan. This is typical example of an intraplaque hemorrhage. Yet another example. Here we have the sternocleidomastoid muscle. So normally we compare the signal intensity of the plaque with the sternocleidomastoid muscle. And if it is bright, we know that it is bright on T1. And again, by the rule of thumb, we would think of intraplaque hemorrhage. This is an example of a lipid-rich necrotic core. So lipid-rich core actually would be slightly bright on T2, but would be iso to slightly hypo-intense on T1. But what would be diagnostic would be on the contrast enhanced scan, the lipid core would not enhance. However, the fibrous cap would be seen enhancing. So this is typical example of a lipid-rich plaque. Now, how do you identify the fibrous cap on MRI? A thick fibrous cap would be seen as a dark band between the white lumen and the gray wall, whereas a thin fibrous cap would not be seen at all. If there is a cap rupture, we would see a bright gray region near the lumen with or without irregular surface of the plaque. So let's see an example of a thick fibrous cap. So you're seeing a dark band, that's the lumen, this is the plaque, this is a thick fibrous cap. As against that, there is absence of that band here, which indicates that it's a thin fibrous cap. To look for rupture, you look at loss of signal, loss of the dark signal in the dark band, and it is replaced by a hyperintense signal. So you know that this is the site of rupture from the plaque. Now, having said this, let's look at the modified American Heart Association classification for these plaques based on the MRI findings. So they are classically divided into type 1 to 2, which is almost near normal, type 3, which indicates diffuse internal thickening or a small eccentric plaque, type 4-5, wherein there is presence of lipid or necrotic core within the plaque surrounded by fibrous tissue. Type 6 is a complex plaque, which would have hemorrhage, would have surface defect or thrombus within it. And type 7 is a calcified plaque, whereas type 8 would indicate a fibrous plaque. So let's try and look at the examples of each of them. This is a normal vessel wall. You see normal uniform wall thickness. So this is example of type 1 to 2. This is a typical example of a type 3 plaque, wherein you're seeing eccentric wall thickening with some signal changes within. In this case, as you see, there is no even bright signal within the plaque, and this is a typical example of a necrotic core and a type 4-5 plaque. Next is a complex plaque which is bright on T1 again, so intraplaque hemorrhage. There is thinning of the cap and probably some ulceration, so this is a complex ulcerated type 6 plaque. And lastly, we have a plaque which is hypointense on all the sequences, and it is the calcified plaque. Now, going on to our next question, what is the clinical impact of this technique? Why do we need vessel wall imaging? In patients who have been labeled as cryptogenic stroke, where no cause has been found, there have been several studies that have been done to look at the carotid bifurcation particularly, and to detect the culprit lesion. And it has been really very promising. I will show you in the next slide. Then in patients who are at high risk of stroke, selecting the patient for carotid revascularization versus medical therapy, again, is a question which can be solved by using vessel wall imaging and looking at the plaque burden and the presence of vulnerable plaques in those set of plaques. Next, decision between carotid endarterectomy and carotid stenting is again based on the presence of a rupture-prone plaque, which has a tendency to dislodge while going in for a carotid stenting. So again, whether a carotid stent should be done or whether the patient should undergo a surgery, or maybe other methods like flow diverters or covered stent should be used, is based on this imaging. Lastly, to monitor treatment response, yes, MRI is definitely promising, but to look at the total plaque burden, the plaque volume, as well as the characteristics of the plaques, whether or not the therapy has changed them. So this is the clinical utility of MR imaging. Now, this is a very interesting article which was published in 2012, wherein they had studied the patients with cryptogenic stroke, and they had studied the prevalence of non-stenosing complicated atherosclerotic plaques using MRI. And it was found that arterioarterial embolism from complicated non-stenotic carotid plaques may play an important role in a subgroup of patients which were previously diagnosed with cryptogenic stroke. So here we are trying to assess the culprit lesion using MRI. Now, last segment is the role of MR in aortic wall imaging. So traditionally, actually, transesophageal ultrasound has been used very, very commonly to look for mobile plaques in the patients who are suspected of having stroke due to embolization from the aortic plaques. Now, I would like to share this nice research article published in the Journal of Cardiovascular MR in 2017, wherein aortic atheroma has been studied as a source of stroke to assess the embolization risk in stroke patients and controls using 3D CMR technique. So here they've used simple PD weighted, T2 weighted and T1 weighted sequences and have tried to study the aortic wall, particularly the aortic arch and descending thoracic aorta. And they have found that the significance of more than 4 mm thick intima and presence of vulnerable plaques in the aortic arch and descending aorta are a relevant etiology of stroke. So this is just an image from this article wherein we see the normal aortic wall. This is an image wherein there is an eccentric thickening here, but it is less than 4 mm. Now, here is an example of a stable plaque. If you see, it is hypointense on all 3 sequences, PD, T2 and T1, which indicates that it's a calcified plaque. So it's a stable plaque. As against that, if you look at this image, there is a bulge in the wall of aorta. It is bright on PD, on T2 images, and it is heterogeneous on T1 weighted sequence, which indicates that it is probably a complex plaque and has been labeled as AHA grade 6. So based on these MR findings, even the aortic plaques have been classified like the carotid MRI plaques into type 1 to type 8 on the similar grounds as the carotid plaques. Having said this, yes, there is still certain limitation in MRI vessel wall imaging for aorta. It has a limited utility in assessing mobile thrombi unless Cine techniques are used to image the aorta. It overestimates the plaque thickness as compared with transesophageal ultrasound. The technique takes longer scan times and it's less cost effective. But I'm sure in future with better techniques that are coming up, imaging of aorta would definitely be the way forward. So as we look at future of vessel wall imaging, there are several new techniques that are coming up each day. I would not want to go into the detail of all this, but yes, a special mention to phase sensitive image reconstruction, which has improved the contrast between the lumen of the artery and the wall of the artery. I'll just give you an example of that. So this is a snap technique that has come up, which is a PSIR technique, wherein the lumen has become totally black. And now if you look at the wall, and if there is presence of hemorrhage in the wall, it can be very, very easily appreciated. So this is an example of the snap technique in cross-section with hemorrhage in the plaque, and this is the lumen. So having said this, I would like to conclude my talk by saying that definitely vessel wall imaging with MRI is the way forward. Eventually, it will be like a one-stop stop for a patient with stroke, wherein the entire stroke protocol would be done to first look at the diffusion-weighted images, to look for acute infarcts, which would be the effect of the plaque, and then to look for the cause of stroke by imaging the vessel wall, and by characterizing, not only characterizing the tissue composition of the plaque, but also by looking at the plaque burden and the presence of acute inflammation of the plaque. Having said this, I would like to thank all of you for your kind attention. Thank you.
Thank you, Dr. Parul. We'll have the discussion towards the end of the session. And I'd like to invite the next speaker, Dr. Megha Sheth. Dr. Megha Sheth to start the presentation, please.
Thank you very much. So my presentation is on role of CT and MRI in Takayasu arteritis. Okay, so today I'm going to present images of how to do cross-sectional imaging of Takayasu arteritis using CT and MRI. We will not focus on other imaging modalities like ultrasound and nuclear medicine. We'll discuss today in detail how to do CT and MRI, how they are useful for diagnosis as well as follow-up. So as we know, Takayasu arteritis, also known as pulseless disease or occlusive thromboaortopathy or Martorell syndrome. Basically, it is a chronic, progressive, inflammatory and obliterative disease of the large vessels. Large vessels is important. Okay, the process, apart from aorta, it may also involve the coronary and the pulmonary arteries. And it was first described in 1908 by Japanese ophthalmologist Mikito Takayasu. Okay, the disease primarily affects young women in the second and third decades of life. No specific causes yet been identified. Autoimmune etiology has been proposed. Otherwise, there are infections like tuberculosis, some viral and streptococcal infections also likely. Now, what is the importance of cross-sectional imaging? See, Takayasu arteritis has very non-specific clinical symptoms. So it is very important to diagnose it in the early systemic phase, where the imaging specialist is often the first person to identify it. So our aim is to identify it in the early systemic phase. Now, there are 5 varieties of Takayasu arteritis. The classification: type 1 involves only the aortic arch vessels. Type 2A involves ascending aorta, arch and arch vessels. Type 2B involves, apart from type A, descending thoracic aorta is also involved. Type 3 involves descending thoracic aorta, abdominal aorta with or without abdominal aorta branches. Type 4 involves abdominal aorta and or its branches. And type 5 can be a combination of anything, means from ascending aorta to abdominal aorta with branches. Okay, so this is again, see, this is again the classification of all the varieties. Type 5 variety is the most common, and coronary and pulmonary involvement is indicated as C+ or P+ respectively. This is the Sharma criteria for diagnosis of Takayasu arthritis, which combines all clinical history, pathological, radiological, and if there are two major, one major, two minor, or four minor criteria, then there is a high probability of Takayasu arthritis. So now what do we see on imaging? First of all, we'll discuss CT angiography. The protocol is you have to scan the entire aorta from arch vessels to common femoral artery, and you have to take a delayed phase because that better demonstrates the mural thickening that is seen in Takayasu arthritis. So first feature of Takayasu arthritis is the mural thickening, as you can see here. See, this is the vessel lumen and this is the wall. We can see this intimo-medial thickening. Here also very nicely you can see the thickening around the right brachiocephalic trunk, left common carotid artery. And on venous face you can see a double ring enhancement pattern. Means a poorly enhancing inside ring and then obviously enhanced outside ring is observed frequently. Then the second change is the luminal changes, stenosis or occlusion, that is generally observed in delayed stage of the disease, and you can very nicely see here the left subclavian artery is occluded. So this is how the luminal changes will be seen. The next feature is collateral vessels. See, you can see here none of the abdominal aortic vessels are seen. Only this inferior mesenteric artery is seen, which is dilated, and this it is giving off collateral, or what we call the arc of Riolan, to supply all the abdominal organs. So this is an example of collateral vessels. This was another case where pulmonary artery was also involved. The right pulmonary artery upper lobe branches were occluded, and the patient has multiple aortopulmonary collaterals that supply the lung field. So this is an example of pulmonary involvement also, and example of collateral vessels. What are other findings? As I said, high involvement of coronary and pulmonary involvement. Pulmonary 63% and coronary could be as high as 44%. So this is an example of Takayasu arthritis. You can see here intimo-medial thickening with calcified plaques, and here the right coronary artery also very nicely seen thickening as well as occlusion. Pulmonary artery involvement I already showed. So now I'll show you the different types of Takayasu arthritis. This is type 1 Takayasu arthritis. Here the left common carotid, and here as you can see in this image, the right common carotid, both are significantly chronically narrowed, and as you can see the ascending aorta arch are normal. So this is type 1. This is another patient, 24-year-old young female who had occlusion of right subclavian as well as right common carotid artery. You can see here also the involvement of right subclavian and common carotid artery. This patient in addition had significant stenosis at origin of left main coronary artery as well as right coronary artery. So coronary involvement in this image I already showed you. So the patient already had the coronary, now pulmonary involvement also. This is just an image to show you that, see, the right subclavian was occluded, so right internal memory artery or rima is hypoplastic, whereas lima is normal. This was another patient, again, long segment occlusion of common carotid artery. In this volume rendered image, you can see the occlusion of both common carotid arteries. The patient had involvement of ascending aorta and also involvement of coronary artery, RCA involvement, and left main involvement. This was a patient of type 3 Takayasu aortitis, involvement of descending thoracic aorta, as can be seen here. This was another patient. Apart from stenosis, ectasia and dilatation can also occur. So this is an example of type 5 Takayasu arthritis. Another case, we can see here multiple stenosis in descending thoracic abdominal aorta, celiac trunk. The patient also had stenosis in the left subclavian artery, involvement of bilateral renal arteries, involvement of left subclavian artery. Another patient, again stenosis in celiac artery. involvement of renal artery, stenosis in pre-bifurcation aorta, and this is again a VRT image showing stenosis in pre-bifurcation aorta. So these are different examples of how Takayasu arteritis will look. Now we come to MR angiography technique. Again, the entire aorta is imaged. These are the different sequences that can be used for MR angiography. To sum up, if you want to see stenosis and dilatation, go for 3D MR angiography. If you are looking for thickening of vascular wall, then TE1 and T2 weighted multiplanar images are good. Enhancement of vascular wall, then you need contrast enhancement, and edema of vascular wall, then you need a PET suppressed T2 weighted imaging. So again, MR acute phase, late phase, the findings are similar to CT coronary angiography, but as I said, wall thickening very nicely seen on post-contrast gadolinium enhanced images. I'll show you the examples of all these. Again, in late phase, we'll come across stenotic lesions. Most commonly involve stenotic vessel in aortic branches subclavian, whereas in abdominal aorta, it is the renal arteries. So this was an 8-year-old female patient, development delay in childhood migraine. You can see here very nicely that the left internal carotid artery is occluded. Okay, another patient, this is again an MR angiography image. We can see here that the right internal carotid artery and here the left subclavian artery as compared to right. See, right side is normal, left side is irregular with focal areas of stenosis. So this is how you can appreciate. This was another patient, 11-year-old child, history of claudication, difference in blood pressure, means absent pulses in left upper limb. And you can very nicely see that the left subclavian artery, axillary artery, part of proximal brachial artery are significantly narrowed. Okay, so this is how you can diagnose. This was another case. Here you can see significant narrowing in descending thoracic aorta. This was a 10-year-old child who had chronic complaints since 1 year and the dyspnea on doing little work. I will show you this 3D MR angiography. See, you can see this right subclavian artery stenosis, left common carotid artery is occluded, left subclavian artery we cannot see, areas of significant stenosis in descending thoracic abdominal aorta. So this is how an MR angiography image will look. This is how you can see the vessel wall in axial MR images. Here you can see the vessel wall thickening. Okay. Here also, if you can appreciate, this is the lumen and there is significant arterial wall thickening. So this is how vessel wall thickening and stenotic lesions will appear on MR angiography. Now, what are the differential diagnoses? Atherosclerosis, major ones are atherosclerosis, giant cell arteritis, polyarteritis nodosa. Atherosclerotic, generally they are in elderly patients and usually associated with long segment luminal stenosis. Giant cell arteritis, I will also show you an example. It more commonly affects the branches of internal and external carotid arteries. Polyarteritis nodosa, disease of medium and small size arteries, and more commonly there are pseudoaneurysms. See, this we had a case of giant cell arteritis. This is this blush that you can see is actually dilated right temporal artery with periarterial inflammatory thickening. So this we had diagnosed as a case of giant cell arteritis. Now, as we all know, the management is mainly medical therapy, high dose steroids or cytotoxic drugs. For complications, stenosis or occlusion, we go for stenting, means angioplasty or surgical. Now, this was a 27-year-old patient, known case of Takayasu arteritis, came to us for follow-up. We can see mild kinking of stent with peristent leak, very nicely seen here also in axial images. This was another patient on follow-up. We can see the stent is there, but there is this dissection, flap is there. You can appreciate the involvement of arch vessels, ongoing involvement, and here the stent lumen is in the true lumen of the dissection. This was another patient who had coronary involvement. Patient had undergone bypass and both the grafts, bypass grafts from aorta, SVG grafts are blocked. So this is how we see the presentation of Takayasu arthritis and how CT and MR can both effectively and provide excellent anatomic information as well as useful for follow-up and management. And MRI has the added advantage that there is no nephrotoxic contrast media or ionizing radiation. Thank you. Thank you very much.
Thank you, Dr. Megha. It was a nice presentation. Our next speaker is Dr. Suman Singhal. I request her to present on role of CTA in vulnerable plaque assessment. Dr. Suman Singhal, please. Dr. Suman.
Good afternoon, everyone. Am I audible now?
Yes.
Yeah. Good afternoon, everyone. First of all, I would like to thank the organizers and the dignitaries of this conference to giving me the opportunity to be part of this imaging part of the conference. I will be speaking on role of CT coronary angiography in vulnerable plaque assessment. As we all know, rupture of a vulnerable atherosclerotic plaque, which has a thin fibrous cap and a large lipid core, is the most common cause of acute coronary syndrome. So by CT coronary angiography, by early detecting these vulnerable plaques, which are going to rupture and cause the ACS, is where we are today. So as we are discussing in this forum, the plaque imaging mainly, Dr. Parul has also shown that a vulnerable plaque has a thin fibrous cap, a large lipid core, and spotty calcification. There can be positive remodeling, which can happen in these plaques. We have different imaging modalities to diagnose these vulnerable plaques. MR she is already covered, and we have PET, and by SPECT also we can see these plaques. Different people have used OCT, IVUS, NIRS to diagnose these vulnerable plaques. But everything has a pros and cons. Like OCT cannot assess the plaque burden, though it has a very good characterization of plaque and thrombus. The grayscale IVUS has a poor sensitivity for the thrombus, though it can identify the plaque burden very well. Similarly, the other techniques are there. And in CT is very good to diagnose vulnerable plaque features like large lipid core, the spotty calcification, positive remodeling. But the spatial resolution of CT is less, and there where the limitation is that it cannot diagnose the thin fibrous cap. So the vulnerable plaque features on CT are low attenuation plaque, that is less than 30 HU, positive remodeling, the spotty calcification, and napkin ring sign. So we will cover one by one. Low attenuation plaque is a plaque which has a density less than 30 HU. So any low density plaque, if you see, you put the cursor and you get it less than 30 HU, that is a low attenuation plaque or a lab, what we call it. Then second thing is the positive remodeling, which is based on the Glasgow phenomenon, where whenever there is a plaque which has started occurring and increasing in size, there is a compensatory expansion by the artery so that the lumen is not narrow. So that happens for some time, and later there is a limit to that, and then the stenosis starts occurring. So positive remodeling is a phase where we can actually see the wall by CT, and we can diagnose positive remodeling. Like here we take the lumen diameter, the full diameter at the point of the lesion and the reference vessel, and we calculate the remodeling ratio. If that is more than 1, that is a positive remodeling, and if it's less than 0.9, that is negative remodeling. So whenever you see a positive remodeling, that is again a feature of a vulnerable plaque. This is how you take it. This is a plaque, low density plaque, which is there, and you calculate the distance at the proximal to it, and then at the point of the lesion. And if it's more than 10% of the reference vessel, that is positive remodeling. Now the second thing is, the third thing is, spotty calcification. So any calcification which is less than 3 millimeter in diameter is a spotty calcification. So that is how you differentiate it from the large chunky calcifications which you normally get in a CTCA. So which can be again small spotty, intermediate spotty, or a large spotty calcification depending on the size. So if you see small calcific foci surrounded by this low attenuation plaque. These are the spotty calcification. Napkin ring sign. This is a very, very important sign. And if you see this in a plaque in a coronary CT, this is or this tells us that this plaque is vulnerable, unstable, can rupture. So whenever you see this low density area within the hyperdense plaque, this is the lumen here, this is calcification, this is the plaque, and if you see this low density area, that is a napkin ring sign which is present, which is an independent precursor for a vulnerable plaque and an acute coronary syndrome. If you see a plaque like this, but no hypodense area in between, that is without a napkin ring sign. So they actually compared the low attenuation plaque and the napkin ring sign in CTCA, which is seen here, along with the OCT, and it actually compared to OCT, it was section to section, similar findings were found in a CT coronary angiography. So nowadays, plaque imaging, which is a very hot topic in CTCA, and one should include this in your routine CT reporting, you should see when you see the plaques, either the plaque is non-calcified, partially calcified, or a calcified plaque. Then you look at the high-risk plaque features, whether they are there or not, like low attenuation, spotty calcification, or positive remodeling. And then you say whether the napkin ring sign is present or not, and a plaque is heterogeneous or a homogeneous plaque. Now, relative there, whenever if you get any plaque feature, the relative risk increases to 32. And per each plaque, each feature also has a different relative risk, which can be seen in this JACC article of 2014. This is the image taken from JACC Imaging 2013, where they showed the importance of diagnosing these vulnerable plaques. This patient had undergone a CT before, and he had features of vulnerable plaque in his LAD, and he did not get anything done later. And 10 months later, the patient presented with an acute MI, and the same plaque was if we see these vulnerable plaque features, we should report them, because this will help the clinician to diagnose that yes, this is a plaque, this should be treated before it actually ruptures. Williams et al. Also by JACC 2019 article demonstrated that if an obstructive disease is there and one or more of these high-risk plaque features are there, it increases the 10-fold increase of having the myocardial infarction. In cataracts also, vulnerable plaque has been included as a modifier. So whenever in cataracts you are reporting a CTCA, if you see this feature, use the cataract higher stenosis and then the slash, and whether this vulnerable plaque like this is here. So you put it as cataracts 2, 3 or a slash V. So that is telling them that this is a vulnerable plaque which is present. We have got this new CT machine with AI, which gives us nicely all the plaque features in this color coding with this IVUS images, where we can actually see a calcification, the lipid core, the positive remodeling, and the lumen very well. This was a patient who had come to us just in a atypical chest pain and no definite cause of acute coronary syndrome. And when we did the CTCA, the calcium score was 0, but there was a significant plaque, almost 90% stenosis with these vulnerable plaque features. Positive remodeling was there. There was a napkin ring sign. So this is really helpful in diagnosing it further. This patient had undergone a coronary cath angio and a plasty later. By these semi-automated plaque quantification techniques are also there with certain vendors, where they can actually see the plaque burden also they can calculate by the CTCA. The plaque progression, again CTCA is a non-invasive modality, which is a very definitive one to monitor whether the plaque is progressing or not. It also helps us, like it is not just the luminography, it is much more than that. We can see the wall, we can see the heart as a whole, we can see the positive remodeling, and it really helps us to diagnose further, not just the anatomical imaging. But the recent Scott Hart article also It is an important prognostic indicator, CTCA, for diagnosing the vulnerable plaque as well as the stenosis. Radiomics is something which can be applied, which can be applied to different imaging modalities, and depending on the data algorithms, it can be used in future to diagnose these vulnerable plaques and plaques with napkin ring sign. So to conclude, MDCT is a really good modality, non-invasive, to look at the plaque vulnerability with all the vulnerable plaque features. And in patients with ACS, the combined presence of these three features identifies the unstable region with a positive predictive value of almost 95%, negative predictive value of 60%, and an accuracy of 70%. It is currently a very important modality to diagnose vulnerable plaques. According to this JAC 2020 article, we have come a long way from just illuminography to functional imaging by CT-FFR. We can diagnose the inflamed coronary plaques by the perivascular fat attenuation index, the vulnerable plaque features, the assessment of the coronary stenosis, and the functional implication also by the CT-FFR. So we are here with coronary stenosis, atherosclerotic burden, plaque vulnerability, and doing the asymptomatic risk stratification for the patients. So there in the future, according to Jack recent intervention article, the CTCA will be used for planning PCI probably in future. And this is kind of one-stop shop, tells us calcium score, CAD-RADS, morphology, plaque analysis, CT FFR, myocardial perfusion, and it is really helpful from anatomical to functional imaging. These are our articles in different books. So thank you so much. Welcome to any questions if they're there.
Thank you, madam. We will take the questions to the end of the session. I now take the pleasure of inviting my great friend, Dr. G.N. Mahapatra, who is a very dedicated nuclear cardiac imager. And he is known for his leadership skills in World Affairs, and he founded the World Federation of Cardiac Imaging and Clinical Cardiology. He is also in the editorial board of JAC Cardiac Imaging. Over to Dr. Mahapatra. You can carry on, please.
Ujjwal, can you help me out to share the screen, please?
You're able to see your screen.
The screen is on, sir. Slides are on. Yeah.
So I'll go to the slideshow.
Yes, sir. Go to the slide.
Right side, sir. Right down. Hourglass is then down.
You come to the bottommost the frame, and to the 75% you have put magnification. Near the 75, there's an icon. You just click that.
Hourglass is there.
Come down, please. Come down.
So any
lower panel.
Mahapatra, you can do it like you did in the morning. You can do it from the bottom right corner or the slideshow option at the top bar.
I know that, but it is covering my thing. I think that's a
you minimize the frame. You minimize the frame here.
Mute, stop video. Yeah, I don't know why it is come up. Now, yeah. Okay, sign. Good. Slideshow. Okay, are you seeing my slide?
Yes.
Okay, Prabhu, Dr. Prabhu. Okay. Okay.
So we can't see them in full screen yet.
There is the same thing. You just come to the setup slideshow.
Okay, then I'll do. Ujjwal, you want me to again share it or?
You share. There is a third or fourth icon to the right. We said there is this icon called a setup slideshow. Top panel.
Okay. I'm just.
Or you can share again. I'll just stop the screen sharing from my end. 1 second.
Please stop that.
Yeah, you can start the screen sharing again.
Okay. Okay, are you seeing now?
Yes, sir.
Okay, fine. Sorry for the inconvenience. Now, next 12 minutes, I will be speaking on role of PET in evaluation of coronary and carotid plaques. We'll start with coronary, and later on, I'll show you the carotid plaques also. Why it is not moving? Why it is not moving?
You tell next slide. It is being projected from a different end.
Just press enter. Okay.
Okay. Okay. All our present understanding of major cardiovascular events is centered around the atherosclerotic plaque and the process that leads to acute plaque rupture producing myocardial infarction. Atherosclerosis is characterized by lipid deposition within the arterial intima, represents a nidus for inflammation. This lipid becomes oxidized, triggers an inflammatory response constituting a macrophage. These macrophages engulf lipid particles to form foam cells. So these foam cells induces pro-inflammatory cellular phenotype, promote ongoing inflammation, cell death, and potentially leading to acute plaque rupture and atherosclerosis leading to acute event. So nuclear cardiology procedures has distinct advantages over other diagnostic imaging modalities, such as having a low radiation risk because of low amount of radioactive traces are used. It is being relatively painless and non-invasive and provides both structural and functional information superior to other non-invasive invasive tests like MDCT, MRI, OCT, and IVUS with a 93% sensitivity and all. So new innovations such as molecular imaging now offers an array of tools to develop advanced diagnostic approaches. Understanding the pathophysiology of atheroma makes it possible to identify vulnerable plaque based on its metabolic signature or the presence of excessive apoptosis. Because of its large metabolic and apoptotic signals, even the small lesions can be visible. Recent advances in hybrid imaging, particularly PET-CT or PET-MR, that increases the high spatial resolution and anatomical detail with molecular assessment of disease activity. This provides the ability to identify vulnerable plaque characteristics, which I'll be speaking one by one, and differentiate active, hot, unstable plaque from a quiescent, stable disease activity to improve the patient stratification. Inflammation within the plaque has been extensively documented, and imaging with F18 FDG has been in different vascular territories with limited success with the physiological uptake of FDG. So, who are the patients to be benefited in this plaque imaging? Acute coronary syndrome in MI group, continuous chest pain lasted for more than 30 minutes, new left bundle branch block, elevated cardiac troponin T, chronic stable angina with positive treadmill test, and abnormal myocardial perfusion scan. So what are the exclusion criteria? Patient with pregnancy, of course, history of allergy to iodinated contrast material, history of renal dysfunction in post-MI with serum creatinine more than 1.5 mg per deciliter, inability to hold breath, patients with arrhythmia, particularly of post-MI and hemodynamically unstable patients. So what are the PET radio tracers available in plaque imaging? You know very well, for last 2 decades, we have been using F18 FDG for oncology imaging or neurology imaging that can be used. I'll tell you in what condition and where. Then the second one is really the molecule of the millennium, that is called F18 sodium chloride. Then third one, again, it is a very good for neuroreceptor imaging, that is called neuroendocrine imaging, gallium-68 dotactate or copper-64 dotactate or C11 PK triple 195, then fluoromisinazole, fluorocholine, gallium-68 nota RGD, gallium-68 pentaxifor. And what are the characteristics of unstable and ruptured culprit plaques? Extensive inflammation, a large necrotic core, as Dr. Suman has just mentioned, a thin fibrous cap. In inflamed lesions, this cap becomes thinned and weakened by the action of matrix metalloproteinase, predisposing to rupture. Then positive remodeling with a large plaque volume. Then microcalcification, then neovascularization in atherosclerosis lesion, a major role in plaque growth. So this is the vulnerable plaque which Dr. Suman has already shown. So this is a small, big necrotic core. This one is I'll just a pointer. I'll take the previous pointer. So this is the necrotic, big necrotic core. These are the neoangiogenesis things, and this is the spotty calcification, and these are the macrophages, which is small lumen. Then this is a stable plaque and an unstable plaque. Unstable plaque in the right-hand side, you can see the left-hand side is the stable plaque. So you can differentiate how unstable is it. So this is a molecular target, how different radioisotopes they work. In macrophage level, the FDG worked, F18 FDG, and also the gallium-60 dotated, because that expresses the somatotropin receptor on the macrophages. Then we have got microcalcification, the right-hand side corner, sodium chloride, there are microcalcifications, then NOTA and RGD for remodeling imaging, then the hypoxia imaging, FFIC imaging. So starting with 18-fluorodeoxyglucose, PET F18 FDG, as I have told you, it has been used in oncology for many years and was first utilized to image atherosclerosis in the cardiac artery. It accumulates intracellularly in tissues with high metabolic activity and does not have any affiliation with the microcalcification, F18 FDG. FDG affiliation due to macrophage infiltration as a part of inflammation and therefore been used as a non-specific marker of vascular inflammation in aorta, carotid, and femoral. So, but coronary artery uptake is often obscured when you use F18 FDG because of the myocardial uptake. So, therefore, quantifying the vulnerable plaque in smaller coronary arteries remains a challenge when we are using previously F18 FDG, because the spatial resolution is limited to 6 mm. But significant cardiac and respiratory motion that further degrade the PET signal, complicating assessing of mid to distal coronary artery. So now this is the molecule F18 sodium chloride. It has been used as a bone tracer and for the detection of bony metastasis for many decades, but has now found a potential application in hybrid cardiac imaging. The ligand F18 sodium chloride is a hydroxyapatite key component of early vascular microcalcification, as it binds to micro rather than macro calcification due to the higher exposed surface area of hydroxyapatite. So microcalcification is thought to be an early healing response to cell necrosis and inflammation that precedes the development of larger macroscopic deposits of calcium, which can be converted to a stable plaque. So we can detect with the microcalcification in fibrous cap may also increase local stress and destabilize the plaque, leading to rupture. So sodium chloride, F18 sodium chloride, appears to have low uptake in the adjacent myocardium and a very high affinity of the tracer to the microcalcification in the plaque, in the unstable plaque. So what is the mechanism of action? An event-prone coronary plaque has a thin cap, as you know all, with a necrotic core, but the initial phase of inflammation sets off within the plaque due to multiple underlying risk factors leading to microcalcific foci, which tend to have a higher risk of rupture. So fluoride uptake is an indicator of calcification within the plaque. In that active phase, calcification leading to penetration of the tracer F18 sodium chloride to the ruptured plaque and gets tagged. So here you can see there is a totally a subtotal or a complete total lesion of the LAD artery in the left-hand side of the angiogram, and here you can see the intense uptake of the sodium chloride and the proximal region of the LAD, which you can see over here. So this is the same thing where the graphical representation were to show that the culprit plaque has got a very good tissue background ratio of accumulating sodium chloride as compared to non-culprit. So then the next comes the gallium-60 dotated, the other target receptor that expressed onto the macrophage. Then it has been demonstrated exclusively expression of somatic receptor in macrophages within the atherosclerotic plaque, showing improved discrimination of culprit and high-risk plaque in both coronary and cardiac. See one slide. One patient underwent a sodium chloride PET CT, demonstrated 3 discrete regions of focal uptake in the proximal, mid, and distal RCA. The highest uptake is CMLE. So you can see here there are multiple lesions of the the gallium-68 dotted and showing multiple areas of intense uptake. But as compared to here in the lower images, there is this is called a stable plaque. So hardly there is any uptake in the proximal LAD in the lower side. But upper side, there are multiple 3 lesions which shows that gallium, that the A18 sodium chloride has got a beautiful uptake. So now from coronary to move to the vessels, A18 FDG PET CT in the evaluation of vascularity. So I will show you a very good case of Takaisu in the stage of vasculitis, not at the level of not at the level of stenosis. So it may be Takaisu or it may be Janssen arthritis, but I'll show you a very beautiful case. Vasculitis is defined as an inflammation and necrosis with the leukocytic infiltration of the blood vessel. Takaisu arthritis is a chronic inflammatory arthritis that primarily involves the aorta and its main branches, which Dr. Megha showed that lesion is stenosed and this thing. But I will show you at the level of arthritis how F18 FDG has picked up those things much early from the stenosis. So F18 FDG PET metabolic imaging is nowadays used in the investigation of patients with large vessel vasculitis. So it reveals the extent of the disease and is highly effective in detecting large vessel vasculitis anywhere in the body and has a high sensitivity specificity. It can be monitored, particularly of large vessel inflammatory and disease activity after you see that and find out and then put the patient on immunosuppressive therapy. That also I'll show you, such as prednisolone and cyclophosphamide 110 mg per day. Following 2 months, we repeated again the PET CT. Now have a look. Here,
Dr. Mahapatra, kindly conclude your
yeah,
slides.
it will about 2-3 minutes. So it is showing the whole abdominal aorta is showing increased uptake among and also the both subclavian artery is showing the increased uptake of F18 FDG. After putting the patient on prednisolone and cyclophosphamide after 2 months, we repeated. Then he saw that they're totally gone and totally cured, and there is no vasculitis either there in the aorta, abdominal aorta, or in the subclavian arteries. So this is another case of vasculitis which shows multiple intense uptake is shown in all the abdominal aorta. That is called a vasculitis. Here, the interesting case, the PET CT shows multiple lesions of intense uptake in the aorta, and the CT calcium shows nothing, and fuse image shows there are multiple increased FDG uptake in the arteries, so that this is more sensitive than the calcium score. So concluding, nuclear cardiology procedures are no doubt the state-of-the-art procedures in the present day clinical practice in diagnosis, prognosis, and guidance of therapy in CAD and non-CAD patients. The field of cardiovascular atherosclerosis imaging is burgeoning with increasing availability and uptake of CT PET. Hybrid imaging platforms combine these modalities with PET, which together provide detailed information about coronary anatomy, flow, plaque morphology, and disease activity, expanding our pathophysiological understanding of atherosclerosis and improving restratification. Further, what I showed you, sodium F18 sodium chloride uptake value in magnitude can be used as a criterion to differentiate between culprit and non-culprit plaques in MI patients' usefulness in cases of multivessel disease. Thank you very much for your attention. I would like to invite to come as a attendee or as a faculty for our 3rd World Congress in Cardiac Imaging and Clinical Cardiology at Tajlands Hotel in Bandstand, Mumbai, Bandra West from 28th to 30th October 2022. Hopefully, the corona should settle down. Thank you very much for giving me an opportunity to speak. Thank you.
Thank you, Dr. Mahapatra. Then the floor is open for discussions. We will take a couple of questions for a few minutes.
It was a very nice lecture from all the faculty. Congratulations. And I have one question to Dr. John Christopher, that when you recommend now at present, in the present scenario, the calcium scoring study, isolated calcium scoring study, when we are going to recommend? Dr. John is there?
So Dr. Johan had to leave for an emergency angiography.
Okay.
So maybe I could take that.
Yeah, please.
So basically, as Johan rightly pointed out, in cases where the primary risk is moderate, um, in cases where the primary risk is moderate, we could take up calcium scoring, and that would allow us to classify them further into various groups, either bringing their risk up or less. So the calcium score would be a game changer in those cases, and that would allow us to aggressively treat or take the patient off the treatment. I hope.
Basically asymptomatic patients.
Asymptomatic patients, but which fall in that intermediate category of risk based on the clinical picture or based on the clinical criteria.
Mahesh, I would like to add here, calcium scoring should be ordered as only a screening procedure to initially, suppose if you see calcium scoring 10, 100, 200, risk style modification is the choice. But if it is more than 300, more than 400, a stress-packed myocardial perfusion scan to be undertaken to find out a hemodynamically significant perfusion defect, which needs a treatment. That is ischemia. No, I have two questions. One for Dr. Parul. Parul, you showed in MRI there is a thick fibrous cap, thin fibrous cap, rupture, but you did not show us any features of unstable hot plaque detected by MRI. Dr. Parul.
Yes, sir. So, sir, I did show the type 6 plaque, which is an unstable complex plaque, which contains multiple components like hemorrhage. There would be calcification in it. So I showed that as an example. Yes, there are these partially calcified unstable plaques, which we end up seeing in vessel wall imaging for carotid. Unfortunately, I didn't have an image to show for that.
No, that means MRI cannot diagnose instability or unstable hot plaques.
Yes, sir. Means for that, an associated, as you rightly showed, sir, the functional imaging, like that is imaging with PET is definitely necessary. To an extent, it can show by just if we do a contrast enhanced T1 weighted imaging and we look at the wall and the wall enhances or the plaque enhances, to an extent, yes, we can call it an inflamed plaque.
Contrast is must.
Yeah, contrast is must for that, sir.
And then, sir, Mahapatra sir, can you predict the time of plaque rupture by doing any investigation? Because in CT, if there's an abdominal aortic aneurysm, we can tell more than 5.5, this percentage is going to rupture. But can we predict the plaque rupture like that? Because it is going to give a very good treatment strategy.
Dr. Mahesh, only we can diagnose hot instability plaque. When it will rupture and how it will rupture, it is very difficult to tell. But we can differentiate between a stable plaque and an unstable hot plaque. That's there. I have another question to Dr. Megha. Dr. Megha, I saw a lot of your slides in Takaisu, grade 1, type 1, type 2, type 3, type 4. What I showed you a Takaisu arthritis. So you tell me, all these lesions, stenotic lesions, yes, definitely stenting and other things, you have to do that. But can your CT scan or can your modality diagnose Takaisu at the level of arthritis?
Yes, sir, it can. I will answer for that one, because by looking at zooming the images, we'll see the stranding. Whenever we see the stranding, that is the earliest sign of inflammation. Afterwards only we are going to get the wall thickening. So CT, plain as well as contrast, and after 2 minutes of delay study, definitely it can detect the early phase of arthritis.
Okay, that means CT can pick up the disease process in very early also.
Yes, sir.
But CT cannot say, Dr. Mahesh, whether it's an active arthritis or it is just a stable or something like that.
No, sir. By giving contrast, if anything is enhances, we will tell enhances, not the opacification. If anything is enhances, it is an active lesion on CT.
Okay.
Dr. Mahapatra, so we need to move on to the next session.
Yeah. Oh, thank you very much.
Thank you.
I think the chairperson should wrap up the
Yes.
session. Please, Dr. Prabhu.
Yes, sir. Actually, thank you, Dr. Mahapatra. In fact, we had a exciting feast of lectures to sum up the various imaging options in cardiac imaging and vascular imaging. To begin with, we had a beautiful lecture about use of echo and ultrasound. And it all depends upon the skill of the operator. Many times we may have a good ultrasound machine, the operator may not be as good. And of course, there are each and every technique, like an ultrasound, has its own drawbacks. And many times in a given institution, all these modalities may not be available. And so it all depends upon how we optimize to determine what is best for the patient in a given clinical situation. And I would like to congratulate all the speakers for doing a wonderful job. And thank you very much. I think we are move on to the next.
Over to Professor Dr. N.N. Khanna.
Thank you.
Professor N.N. Khanna, organizing.
This was indeed a wonderful session, a lot of learning. I was quietly sitting back and learning a lot. And we can see how the imaging technology, especially the non-invasive imaging technology, has changed the way we think about coronary artery disease and arthritis and vascular disease, and how we can now proactively treat these diseases much early and almost arrest their progression, and so that they don't go to the stage of intervention or surgery. And even if we are in that stage, it gives us so much of value to actually plan our procedures very well, to anticipate problems, and to get the most optimal results. So this session was wonderful. And yesterday we had an invasive imaging session. It combined, both of them combined. It was actually a big feast and a learning experience for all of us. Just to let you know, we have about 4,800 people right now hooked up who were watching this program. And thank you very much, Dr. Mahapatra, for a joint collaborative session with your society, and also for bringing in such good speakers, and also yourself to actually enlighten the cardiology community. Thank you so much.
Thank you, Dr. Khanna, for giving us an opportunity to collaborate with your Asia Pacific Society. And really, I'm grateful to you. And thank you for all the chairmen and all the speakers who had taken active participation to make it a big show. And it was really a great show. Thank you all.
Thank you.
Thank you. And we will be getting the recordings and sending it to you for circulation. Thank you.
Sure. Thank you.
So, ladies and gentlemen, we now move on to the next session, which is equally interesting. This is on current trends in medical therapy for peripheral arterial disease and atherosclerotic heart disease. The first speaker here would be Dr. Jack Tan. He's from Singapore. He's a well-known figure, a very good researcher, and a very good interventional cardiologist. This will be followed by a talk on NOAC's recent advances in ACS, then by Dr. Anupam Goyal. Then this will be followed by options for stroke prevention in atrial fibrillation, NOACs or warfarin, with the focus on dabigatran. Dr. Satbir Singh would be talking about it. And then Dr. C.K. Ponde is going to talk about the significance of two-light study in clinical practice. And then Dr. Iyengar would talk about lipid lowering in peripheral arterial disease. May I request the chairpersons, Dr. R.J. Manjuran, Dr. P.C. Manoria, Dr. Vinay Krishnan, Dr. Yashpal Sharma, Dr. S.S. Iyengar, Dr. Tamkeen Kina, and B.H. Natesh to join me to conduct this session. So I think Dr. Jack Tan has a recorded talk. He's just sent me a recorded talk. So Ujjwal, can we have Dr. Jack Tan's talk?
Thank you, Prof. Kannan, my good friends in India, for allowing me to speak briefly at the 13th APVIC meeting this year. So my topic given is balancing bleeding and ischemic risk for the high-risk patient, the APSC consensus statement. My name is Jack Tan, the immediate past president for the Asian Pacific Society of Cardiology. These are some of my conflicts of interest. From 2019 until now, the APSC has developed 10 consensus statements, and I'll emphasize 4 of them in relation to this topic. So what are the antiplatelet options for CCS, ACS, or PAD? Firstly, there's SAPT, cilostazol, oral anticoagulant, DAPT, 2B3A, IV cangrelor, subcutaneous salotogrel, or triple therapy. But as we know, if we use more and more potent or combination therapy, the bleeding risk rapidly increases. There are really a lot of antithrombotic targets from VKA interacting in the coagulation cascade to a factor 10A NOAC inhibitors, low molecular weight heparin, unfractionated heparin, bivalirudin, and direct thrombin inhibitors orally to target fibrinogen and clot formation, together with aspirin that targets thromboxane A2, as well as a variety of CYP2 P12Y19 inhibitors, 2B3A inhibitors that target platelets. So there are really multi-pronged targets that we can use nowadays for the anticoagulation cascade. It's actually surprising that patients don't bleed as much as they don't. So what's the determinant of successful antithrombotic therapy? Really is how hard you want to drive the antithrombotic therapy, and predominantly is based on the presentation mode, especially acute coronary syndrome. But you do need to start thinking of de-escalation, and the de-escalation or the bleeding risk assessment is predominantly the level of comorbidities and demographic that determine the bleeding risk. So it's always a tug of war between bleeding and anti-ischemic risk assessments. So what are the factors that increase risk of bleeding? We know that age, low body weight, CKD, prior history of bleeding, abnormal liver organ function, excessive alcohol intake, concomitant steroidal NSAID long-term use are all factors that increase bleeding. We do recognize them easily. The factors that increase ischemic risk is even clearer to recognize. Some form of diabetes, current smoking, CKD, prior acute coronary syndrome, stent thrombosis, acute coronary syndromes, multivessel disease, implantation of multiple stents in vulnerable locations, all ischemic risk predominance. So, but the confusion comes for a lot of folks is when we say it's ischemic risk factors, people confuse ischemic risk factors for bleeding risk factors and bleeding risk factors for ischemic risk factors because commonly there's an overlap. But what's not so commonly recognized is that the overlap is not one for one. The bleeding risk factors commonly come under the subset of ischemic risk factors. And what we do not want to do is firstly say that high bleeding risk is equivalent to high ischemic risk. Is not the same. And likewise, high ischemic risk is not necessarily equivalent to high bleeding risk. And if you do shorten your antithrombotic, antiplatelet effects early, the patient will suffer the risk of ischemic risk. But if you do unnecessarily prolong in the high bleeding risk patient, the antithrombotic anticoagulant use, then they're subject to catastrophic bleeding that can cause morbidity and significant mortality. So the scope today, I just want to quickly set the stage for defining bleeding risk. What does the major guideline tell us? What are the strategies to reduce bleeding without excessively exposing patient to increased ischemic risk? So what are the high ischemic risks? I think in a lot of these trials like COMPASS, DAP, Global Leaders, TIMIS, Twilight, or Pegasus, the ischemic risk factors are pretty well known. Age, CKD, type 2 diabetes, prior history of vascularization, or MI, or some form of peripheral arterial disease, which is always in there. In Asia, there are some differences. Maybe in some groups of Asian countries, age is higher, CKD, diabetes prevalence is higher, recurrent MI incidence is higher, particularly in that of India. The prevalence of multivessel disease may be less, and the prevalence of peripheral arterial disease may be less in Asia compared to the Western population. In APSC consensus, we use a CVD algorithm to define ischemic risk. C stands for prior coronary event, high-risk coronary anatomy, documented multivessel disease, whether through CT or CAP. V for established cerebral vascular disease, established peripheral arterial disease. D for any form of disease like diabetes on treatment, regardless of duration. eGFR less than 60 or some form of albuminuria, or heart failure due to coronary artery disease. For bleeding risk, in the stent bleeding risk truncation, DAP truncation trials, a lot of the factors are quite common across this series of trials like advanced age, concurrent OAC use, baseline anemia, thrombocytopenia, previous GI or intracranial bleed, hospitalization for bleeding or end organ dysfunction. But you see in all these trials, a lot of the trials are openly represented in that subgroup of advanced age with use of anticoagulants at the same time. In the risk scoring calculators like REACH, Dutch AS, SAW, DEP 41, Paris 38, Precise DEP 32 trials, firstly, a lot of the trials bleeding risk criteria are all over the place. The proportion of true high bleeding risk patients are at best 25% of the cohort. And lastly, the AUC adjudication for this group of patients is less than 0.7. So they are not very well correlated with bleeding. And more importantly, they are not validated in our Asian population. Be that as may, the ARC Bleeding Risk Consortium is quite well recognized and endorsed. Is defining a high bleeding risk as a buck 3 or 5 bleeding risk or more than 4%, or 1 year bleeding risk intracranially or more than 1%. And this is arbitrary, but this is defined high bleeding risk criteria. And if they meet 1 major or 2 minor out of this 20 major, 20 minor criteria that we will go through. In the APSC consensus, we form a simpler algorithm, just the ABO algorithm, to highlight to folks there are some cases that you need to think of high bleeding risk. A for age or frail above 75 or advanced age above 85 or minimum life expectancy. This age cannot be by itself. It needs to combine with either B or O. B, a spontaneous intracranial bleed before, or some form of recurrent GI bleed that cannot be correctable, or hemoglobin less than 9. O for organ dysfunction like end-stage renal failure requiring dialysis, liver dysfunction with liver cirrhosis, bone marrow failure or thrombocytopenia less than 50,000, or prior stroke in the last 6 months. And the other part about bleeding is that the bleeding risk definition and the risk of bleeding, there are 4 major bleeding risk definitions: ISTH, TIMI major, Gasto, Bach bleeding risk, but they are not the same actually. And you can see that the Bach 3 or 5 favored by the ARC criteria is quite significant. Bach 5 of fatal bleeding, Bach 3 or some form of intracranial bleed in 3C, as well as hemoglobin drop of more than 5. In the ISTH major, it combines every one of this, including a fatal bleed. So if you look at the studies, like in this case, the Engage AF TIMI 48 trial, if you classify bleeding into different categories, the percentage of severe versus minor bleed changes. So I think in most bleeding criteria is either the Bach bleeding criteria nowadays or the ISTH bleeding criteria. In the APSC consensus 2020, when you look at it, some of the guidance given, for example, to mitigate bleeding risk is to use some more imaging guidance while doing PCI, to use a 3rd generation drug-eluting stents. Bleeding risk and thrombotic risk should be assessed, but we don't endorse any specific form of risk calculator because it is not proven in Asians. Gender alone should not be considered when assessing bleeding or ischemic risk calculators. So if you look at this, ESC in 2020 came out with some guidance on how to mitigate bleeding risk. For example, before ACS, if your early invasive approach is being used, you do not need to load the P2Y12 inhibitor. 2B3A use could only be considered in bailout situation. And this outcome was predominantly driven from the ISA REACT 5 study. The ARC HBR bleeding risk criteria is also officially endorsed by the ESC in 2020. And these are some of the PCI risk mitigators, for example, appropriately dose adjusting by body weight, anticoagulation, taking into account renal function, default radial approach, default PPI use in cases where it's deemed to be high risk of bleeding. In patients on oral anticoagulation, PCI is performed without interruption of VKA or NOAC, and patients on VKA don't further use unfractionated heparin if the INR is already more than 2.5. In patients with NOAC, regardless of timing, use a lower dose unfractionated heparin of between 50 to 60 units per kilogram body weight. Consider aspirin use, but do not consider pre-treatment of P2Y12 inhibitor and 2B3A inhibitors only for bailout. And some of the other strategies like shortened depth can only be considered, either dropping aspirin or P2Y12 inhibitors after 3 months, de-escalation of 3rd generation to clopidogrel with reloading, bleeding versus ischemic risk assessment upfront before any procedures, and between 3 to 6 months, you can consider this truncation for patients. A point of care testing platelet function of SIT2C19 genotyping can be considered to further refine your 2B3A use. In the ESC guidelines, they also talked about in patients with AF and the requirement for stents, you can consider a triple therapy of just up to a week and then stopping after based on ischemic and bleeding risk assessment. In the ACS and STEMI subgroup, the main grounds is to assess bleeding risk. If the bleeding risk is deemed to be very high, consider aspirin clopidogrel approach and shorten to 1 month. If the bleeding risk is just high, the aspirin clopidogrel can be lengthened and then subsequently just aspirin alone. If the bleeding risk is very high, then it's not aspirin but in preference to clopidogrel. If the bleeding risk is low, there's a lot of choices out there for a higher ischemic risk patient. The aspirin can be combined with ticagrelor with 3 months in the 12-light regime or 12-light ticagrelor monotherapy after that, or aspirin, prasugrel, aspirin, ticagrelor, aspirin, clopidogrel up to 12 months, and extended DAPT if warranted, or dual pathway inhibition as indicated. Some other strategies include the FIRE trial, which showed that rivaroxaban monotherapy was non-inferior to combination therapy with an antiplatelet single agent with respect to bleeding risk, superiority, as well as reduction of ischemic events. So you can use just NOAC alone for stable CAD. There's also a strategy for acute PCI to consider a CYP2C19 genotype guided strategy to use aspirin clopidogrel in compared to a third generation P2Y12 inhibitor. At 12 months, is shown to have same thrombotic event but less incidence of bleeding. So the APSC consensus statement advocate using the algorithm of CVD to look at ischemic risk assessment and ABO algorithm to look at the bleeding risk guidance to come up with this flow chart whenever you transit from a position of DAPT or considering long-term management for CCS and you are dropping or considering dropping or extending, think about the CVD risk first. If they have any of the CVD risk factors, for example, you have a CKD patients who's diabetic, who's had multi-vessel stenting, then by all means, this is a high risk CVD risk. If there are none of the above, or CVD risk, they are low risk, you can go to single antiplatelet. If they are high risk, then assess their ABO algorithm. If the ABO has, for example, concomitant the patient is end-stage renal failure, hemoglobin is actually baseline 8, then they are with high-risk excessive bleeding. Then consider early truncation to SAPT. If, for example, they do have high CVD risk factors, but no ABO markers of risk for bleeding, you can consider 3 options. 1, if they have complex PCI, consider DAPT extended pathway, extend out your DAPT regime. Or if they have prior multivessel disease, multivate disease, post-bypass, post-ACS, post-PCI, PAD, cerebrovascular disease, consider a dual pathway inhibition with aspirin, low-dose rivaroxaban 2.5 BD. If they have complex PCI and they have tolerated 3 months of aspirin ticagrelor without any major thrombotic or bleeding risk, then you can consider a trial regime or ticagrelor monotherapy. So with that, I'd like to thank my stakeholders for the APSC consensus statements, and thanks to the audience for allowing me to present this short communication. And I'll welcome any discussion and question. Thank you very much for your time.
Dr. Khanna, you aren't audible.
Thank you, Jack. We will just go to the next talk and we'll have discussion in the end. Dr. Anupam Goel is the next speaker. She's going to be speaking about NOAC's recent advances in acute coronary syndrome.
Hello, good afternoon, friends. Thank you, Dr. Khanna, for organizing this beautiful conference and giving us all this opportunity. Let me see, is my screen visible?
No, your screen is not visible. You need to go to the slide share.
Yeah, I did that. That's what, just give me a moment.
Yes, I can see your computer screen now.
I had to minimize my presentation to reach there. I hope now you can see the presentation.
Yes, we can see it.
What is this? These are not my... Oh my, how? Is it my screen? I don't believe it.
Okay, we also have a backup of your slides. If you don't mind, we can play it from here.
Oh, that should be all right, because, but there's no reason it shouldn't. I understand we are already late on the time. Can you see my slides?
Yeah, now we can see it.
Right.
Good.
Hi.
You're all good.
Hi, good afternoon, everybody. My topic for today is DOAC, recent advances in acute coronary syndrome and chronic coronary syndrome, with a focus on rivaroxaban. Coronary artery disease encompasses a wide range of phenotype with varying risk and prognosis, as we all understand. As per 2020 ESC and ACS guidelines, ACS consists of STEMI, NSTEMI, and unstable angina. And as per 2019 ESC guidelines, chronic coronary syndrome has patients with stable angina or dyspnea, new onset heart failure and suspected CAD, stabilized patients less than 1 year or more than 1 year after initial diagnosis or revascularization, patient with angina and suspected vasospastic angina, or those patients who have been diagnosed to have CAD incidentally while having their screening done. Stable CAD actually is a misnomer, and it's a heterogeneous group which covers patients with prior MI or ACS, patients who have had prior revascularization, with angina with evidence of ischemia, or silent MI, patient with significant and not significant coronary artery disease. Pillars for treatment of cardiovascular prevention are mainly in the form of lifestyle modification with smoking cessation, healthy nutrition, regular physical exercise, weight control, and psychosocial support. Medical management in the form of lipid, blood pressure, and glucose lowering, ACE inhibitor, beta blockers, and anti-inflammatory, and aspirin, clopidogrel, and ticagrelor therapy to take care of the acute events. But unfortunately, despite guideline recommended therapy, there is still a very high risk of cardiovascular events, as was shown in this study published in JAMA in 2010, where 96% patients were on aspirin, 88% on P2Y12 receptor inhibitors, more than 90% on statin, more than 80% on beta blockers, ACE inhibitors, or ARB, and still over the next 3 years, there was a 15% cardiovascular risk and MI of stroke, which is a very high risk. So we need something better than guideline-mediated therapy. Chronic coronary artery disease is characterized basically by platelet activation, and in the chronic phase as persistent thrombin generation as well. After an arterial thrombotic event, for the initial stages, there is platelet activation, which is strongest in acute phase, where DAPT are very effective. But as the time goes on, there is prolonged thrombin generation, which leads to cumulative risk of secondary events, and we need a therapy for this phase of management. When we apply dual pathway inhibition with rivaroxaban 2.5 twice a day with aspirin, we are able to target both platelet activation and thrombin generation to take care of our patients with chronic coronary artery disease and peripheral artery disease. Novel oral anticoagulants are easier to administer, have a predictable dose, have less drug and dietary interaction, and have a favorable safety and efficacy profile. Unlike warfarin, which affects factors in extrinsic or intrinsic pathway, they inhibit both factor 10A and thrombin inhibition, and key step in coagulation pathway, which mitigates the propagation of thrombin. Rivaroxaban is a direct oral factor 10A inhibitor, which has been used in wide range of indications, starting from stroke prevention in non-valvular AF, then venous protection in patients with deep vein thrombosis, we know thromboembolism, pulmonary embolism, and now latest in patients with acute coronary syndrome and CAD and peripheral artery disease patients. COMPASS is a very interesting trial which determined the efficacy and safety of rivaroxaban low-dose rivaroxaban plus aspirin or aspirin alone for reducing the risk of MI, stroke, and cardiovascular death. COMPASS included more than 27,000 patients, out of which 91 patients had coronary artery disease and 27% patients had peripheral artery disease. After a run-in period of 30 days, patients were randomized to rivaroxaban 2.5 twice a day with aspirin 100 mg, or rivaroxaban alone 5 mg twice a day, or aspirin 100 mg once a day. It was to be stopped 1 year ahead of expectations because of overwhelming efficacy in rivaroxaban 2.5 twice a day with aspirin arm, with an average follow-up of 23 months. COMPASS had CAD patients with high-risk comorbidities, which are our general routine OPD patients as well. 20% patients had both CAD and PAD. Around 70% patients had previous MIs, 37% patient had diabetes, and around 22% patients had renal impairment and heart failure. So they were definitely high-risk patients which were included, and dual pathway inhibition in these patients had significantly reduced cardiovascular death, stroke, and MI with the relative risk reduction, significant relative risk reduction of 24%. Also, the risk of cardiovascular death was reduced by 22%, stroke by almost half, 42% reduction, and non-fatal MIs by 14%. So the combined effect of rivaroxaban and aspirin was found to be very efficient. And with the subgroup analysis which we did, who are the patients who get the most benefit? As the cardiovascular risk increases in the subgroup, like for overall population of the patient, 23 events were prevented in 1,000 patients over 30 months. But then diabetic patients, 31 events were prevented, patients who had renal impairment, 36 events, and those patients who have both CAD and peripheral artery disease, the polyvascular disease patients, the maximum number of events were prevented for these patients. Not only rivaroxaban and aspirin was very effective in preventing event in these patients, also the serious bleeds caused were lesser in these patients. Against a backdrop of 2 events per 1,000 in full COMPASS population, when there were more than 2 vascular beds involved, there was almost no significant vascular event in these patients, also in heart failure patients. So this is not only an effective management, it is also safe management. To summarize from COMPASS, in patients with chronic CAD, the addition of rivaroxaban to aspirin reduces cardiovascular death, stroke, and MI by about 1/4 on top of guideline-mediated therapy, reduces ischemic stroke by around half, and mortality by around 1/5. And net benefits continue to happen during long-term treatment. Those who derive the greatest benefits are the patients who are at maximum risk, like patients with polyvascular disease, heart failure, CKD, and diabetic patients. And dual pathway therapy provides a highly attractive option for management of chronic coronary syndrome patients. What is the role of DOAC in ACS? Prevalence of ischemic events remains high despite using effective management. Usually DAPT are used for ACS, but when we add thrombin DOAC to it, which inhibits thrombin generation, reduction of thrombus formation happens, and we expect better event control in these patients. ATLAS ACS TIMI 15 studied the randomized double-blind placebo-controlled study, which evaluated the efficacy and safety of rivaroxaban in aspirin in patients with ACS. Patients of STEMI, NSTEMI, and unstable angina were enrolled. Those patients who had increased bleeding risk, warfarin use, or had earlier ICH were excluded. All the patients received aspirin, and use of thienopyridine was as per the physician discretion. They were randomized for placebo, rivaroxaban 2.5 twice a day, and rivaroxaban 5 twice a day. This was an event-driven trial with target of around 1,000 primary events rate, with the primary safety endpoints of TIMI major bleed, non-CABG, and efficacy endpoints of cardiovascular death, MI, and stroke. What it showed it that in ACS, the addition of rivaroxaban to an antiplatelet background reduced the relative risk of cardiovascular death, stroke, or MI by 16%, and the twice daily 2.5 mg dose resulted in fewer fatal bleeding events as compared to 5 mg twice a day doses. So what seems is rivaroxaban 2.5 twice daily is the best balance of safety and efficacy when added to aspirin or dual antiplatelet therapy in our acute coronary syndrome patients. as was shown in Atlas ACS TIMI-46 study, which was the safest dose of rivaroxaban with aspirin of DAPT was 5 mg per day, and also emphasized in Atlas ACS TIMI-15 that 2.5 twice daily is the best balance. Whenever we have to use the rivaroxaban dose of 10 mg or less, we need twice a daily dosing as opposed to once a day to have a 24 hours minimum coverage. Another trial which studied rivaroxaban in ACS is H-replace. Those were the ACS patients, and all eligible patients received a background dose of aspirin plus clopidogrel or ticagrelor, and they were randomized to rivaroxaban 2.5 BD, 5 mg rivaroxaban, or enoxaparin in dose of 1 mg per kg twice a day dosing. More than 2,000 patients enrolled across 21 sites. The major inclusion criteria were hospitalized patients who missed the emergency PCI time window and who had an indication for short-term combination use of DAPT with enoxaparin. Those patients who already received thrombolytic therapy or revascularization or needed urgent revascularization were excluded from the trial. And what we realized from it is, in the primary endpoint, the low-dose rivaroxaban was associated with lower incidence of events in this subgroup of the patient. Even in the primary endpoint of pooled analysis, the risk profile of rivaroxaban was very good and there were a lower number of risk. Even the safety endpoints, the ISTH definition of bleeding events were similar in both the subgroups of rivaroxaban and enoxaparin. So what we can conclude from these trials is that low-dose rivaroxaban, when administered during the acute phase of ACS in those patients who have missed the primary perfusion window and before planned revascularization, is at least as safe as enoxaparin for treatment, and there is a reduced event in MACE compared with enoxaparin when these patients are followed in 6 months follow-up period. Where do guidelines stand in this regard? As per 2019 guidelines for management of CCS, adding a second antithrombotic drug to aspirin is recommended in those patients with high risk of ischemic events who are not at high bleeding risk with a class 2A indication, and those patients who are moderately increased risk with a 2B indication with level of evidence A. High ischemic risk is defined as diffuse multivessel coronary artery disease with at least one of the diabetes, recurring MI, peripheral artery disease, or CKD. Moderate ischemic risk is defined as presence of one of these, multivessel or diffuse CAD, diabetes, recurrent MI, peripheral artery disease, heart failure, or CKD. What are our antithrombotic options for chronic coronary syndrome patients? Either continue with clopidogrel or prasugrel with 10 mg once a day, or use ticagrelor in 60 mg twice a day as shown in Twilight, or use rivaroxaban in dose of 2.5 mg twice a day, especially recommended in patients who have post-MI 1 year or have multivessel CAD along with aspirin to reduce their risk of recurrent ischemic evidence. Rivaroxaban is the only DOAC which is indicated in chronic CAD and PAD patients and only DOAC recommended in ESC guidelines for treatment of chronic CAD. Thank you so much.
Thank you, Dr. Anupam. We'll have the questions in the end. So we move to the third speaker, Dr. Satbir Singh, who is going to speak about options for stroke prevention in atrial fibrillation, NOACs or warfarin.
Good evening, everybody. So, are my slides visible, sir?
It's visible.
May I start now, sir?
Yeah, sure. Please
Good evening, sir, and thanks to Professor Dr. Khanna for giving me an opportunity to speak on this topic. So today I am going to discuss the option for stroke prevention in atrial fibrillation, particularly more stress on the DOACs. They are not to be called now as NOACs because they are almost more than 1 decades. They are no more novel anymore.
Dr. Singh, can you make the presentation full screen, please?
My presentation is full screen here on my screen.
No, we can only see the first slide.
Let me make it full screen again. Is it full screen now?
Not yet.
Okay.
Can I stop the screen sharing once? You can share it again. Yeah, please.
Okay.
Or Ujjwal, we can play from, you have the slides now, you can play.
Is it full screen now?
No. So you must have, no.
So we can play Ujjwal, there's
play
no
it from
problem.
my end, sir.
We'll play it from our end, you can speak. Is that okay, Dr. Sadbir?
Yes, sir. It's fine.
I think from the next talk onwards, we should be ready with our backups. Okay, so we have a full screen of your presentation. You can go ahead.
So it's not visible to me at my end.
We have the first slide. You can start speaking and just keep saying next. So we will change the slide.
Dr. Singh, you can minimize the presentation on your screen. Go back to the Zoom screen because we are sharing from our end.
Okay, fine.
And you can command us to go next or previous and we do that.
Okay, fine. So may I start now?
Yes, you can.
So today we are going to discuss the options in stroke prevention in atrial fibrillation, more focus on DOACs. Why on the atrial fibrillation? As we all know, over the last 2 decades, that atrial fibrillation is one of the common cardiovascular disorder, and it has led to a lot of comorbidities. And it is with the advancing aging population in our country also and all over the world. We have seen that the incidence of atrial fibrillation has increased, and atrial fibrillation has shown to be an important cause of stroke. And it is seen that that every 2 seconds someone is having stroke, and every 5 seconds in the world someone is dying from stroke, and is the second most common cause of death after ischemic heart disease. And up to 80% of the strokes can be avoided, as there are lot of modifiable risk factors like we can control hypertension, we can control weight, the smoking is to be quitted, and definitely the oral anticoagulants. Next slide, please. Next slide, please. I think the slides are different, the slides which I'm having. Can we go to the previous slide, please? So as we know that the 2% of the world population of less than 65 year and 9% of the population more than 65 year of age has AF, and the AF prevalence is very high all over world. Though we don't have any hardcore data from India, but from US it is seen that lot more. It is estimated that that 12.1 million people will be suffering from AF with the prevalence in 2030 in US, and extrapolating that particular thing into Indian population, the numbers will be much more in Indian population by that year. And also the control of atrial fibrillation and the control of other risk factors is also much less in Indian population. So the risks are going to be much high in Indian population. And also in patients of AF, the mortality with associated comorbidities is very high if the person is having AF, for example, coronary artery disease or peripheral vascular disease. Next slide, please. So as per the guidelines, the AF has been divided broadly into the AF of valvular origin or non-valvular AF. To cut short, the latest guidelines have shown that in non-valvular AF, the only 2 valvular conditions, that is moderate to severe MS and mechanical heart valve, are the 2 conditions in which are considered as AF of valvular origin. In all others, the AF is not considered to be of valvular origin.
Dr. Sadbir is not audible. Ujjwal?
Dr. Satvir, your audio is not coming. Hello? Yeah.
Yes, sir.
Yeah. Now, sir. Okay.
Yeah. So now in next slide, please.
Ujjwal?
Yeah. So in this management of atrial fibrillation, it is now clearly seen that the role of antithrombotic is very much high, and it is seen that there are two risk scores which has been given in the management of atrial fibrillation, that whether we have to start the patient on anticoagulant and how much aggressive treatment is to be done. The CHADS2 score and Hasbled score, as the earlier speakers have already discussed, that these two things, the risk factors of these two particular criteria, these two particular scores are very much overlapping, though they are not overlapping one by one. But as we can see in both these scores, that age and hypertension and the risk of stroke has been considered in both the varieties, in both the scores. So if the person is having a high CHADVASC score, there is more importance of giving antithrombotic therapy, and if the person is having a Hasbled score high, then there are more risks of bleeding. So one has to be weighing the balance of one particular score against the another. Next slide, please. So as we know that there are a number of oral DOACs have been available now, the dabigatran, rivaroxaban and apixaban. And out of these, the dabigatran for management of AF is to be given twice daily, rivaroxaban to be given once daily, and apixaban again twice daily. The difference in all these three is that the apixaban, the renal clearance is 25%, whereas in 2/3 of the clearance of rivaroxaban is renal, and 80% of dabigatran is renal clearance. And one more important difference is that the cytochrome 3A4 interaction is not there with dabigatran, whereas it is there with the rivaroxaban and apixaban. As we know that there are a number of drugs which get metabolized by the cytochrome 3A4 system. So the drug-drug interaction of those particular drugs are not there with the dabigatran as compared to with the rivaroxaban and apixaban. The next slide, please. So the prophylaxis against the stroke in these patients of atrial fibrillation and venous thromboembolism is very important. Next slide. And the NOACs, as we know, has been discussed that they are into the categories which act on the mainly on the factor 10A or the direct thrombin inhibitors, that is dabigatran. Next slide. So for us, so the NOACs as per guidelines have shown, as per the guidelines have shown that the NOACs are indicated over warfarin in NOAC eligible patients with AF, except in moderate to severe mitral stenosis and mechanical heart valves. So it is clear that except these two valvular AF conditions, in all other conditions, these oral anticoagulants can be used, and with evidence of level A and class of evidence 1. Next slide, please. So as per the guidelines for the stroke prevention in AF, patients who are eligible for oral anticoagulants, NOACs are recommended in preference to vitamin K antagonists, excluding the patients with mechanical heart valves, and oral anticoagulants are recommended in stroke prevention in AF with patients, male patients with CHADVASC score more than equal to 2 and females more than equal to 3. Next slide, please. So OX, the oral anticoagulants have to be considered in stroke prevention, as has already been discussed. and the risk score assessment has to be done particularly. And in the risk score assessment with Hasblad score should be considered to help address the modifiable bleeding risk factors and identify the patient with high risk for bleeding, and for early and frequent clinical review at follow-up. As in the Hasblad score, it has been clearly shown that the time in the therapeutic range with WARF is to be considered. And if the time to therapeutic range with the WARF is decreasing decreasing with time, then these patients are to be considered for NOACs. And also, if the patient is not having a frequent access to the INR values or INR test, as the patient might be living in a rural area or suburban area, in those patients also the NOACs are to be considered as the first choice. Next slide, please. So as per 2020 guidelines in AF, now it has been stressed very clearly that the weight reduction should be considered as the primary lifestyle modification management, as it has been seen that is a major risk factor for the AF and recurrence of AF. Next slide, please. In these guidelines, also the new thing what has been advocated, that in a patient with AF of less than 24 hours and very low risk of stroke, post cardioversion, anticoagulation, which was earlier recommended for 4 weeks following the cardioversion of AF, it can be omitted in a patient in which the duration of AF is less than 24 hours. And also in patients of pericatheter with the catheter ablation for the AF, the stoppage of oral anticoagulation has not been recommended in patients who are undergoing the catheter ablation. Next slide. So as we have already discussed that the dabigatran is a direct thrombin inhibitor, and it binds to the active site and thereby inactivating both fibrin bound and unbound sites of the thrombin. Next slide. And as we have already discussed that there is no mediation of metabolism of dabigatran through cytochrome 3A4. Hence, the dabigatran has no drug-drug interactions with the drugs which are having cytochrome 3A4 metabolism. Next slide, please. So, keeping in view the data on various therapy alternatives benefits, one can really jumble up the thought process like this. Now let's try to figure out the things relatively easy. Next slide. Next slide. So to sum up, the patients with the antithrombotic therapy, in which the antithrombotic therapy is to be used, if the Chadwick score is 0 in males and 1 in female, no antithrombotic therapy is required. In females, however, aspirin monotherapy may be considered. But as compared to patients who are having more than 2 in males or more than 3 in females, oral anticoagulation should be considered, and the DOAC therapy is recommended over warfarin, except in valvular AF, as has already been discussed. Next slide. So the various dosages which are recommended for the atrial fibrillation in a patient with a normal hemodynamics and normal renal function are 150 for dabigatran, 20 milligram daily for rivaroxaban, apixaban 5 milligram PD. Next slide, please. However, the dose modifications are to be done in patients in whom there is a decreased renal clearance. Next slide. And among the DOACs, there are a number of trials. So in view of the time constraint, I'll sum up the trial summaries. Next slide. Next slide, please. So in patients of elderly patients with AF, which is a most common subset of AF in our population also. Next slide. The problem with the elderly population is that they have a decreased GFR, number one, they have more bleeding risk, and they are non-adherence. And also in view of this pandemic-like situations now, the access to frequent access to INR is not that common with the elderly population. Next slide. So the Geriatric Society has recommended the dabigatran and rivaroxaban to be used cautiously. However, in real-world data, the rivaroxaban has been shown to have a higher risk of GI bleeding, and in patients of creatinine clearance of less than 30, dabigatran has some lack of safety data. However, with the modified dosages, we can use in the geriatric population. Next slide. So this is a real-world study from Europe, in which the risk of the stroke and systemic embolism with oral anticoagulation has been shown in the patients with AF. Next slide. And this has been recently published, in which even with the modified dose, the risk assessment has been done, and it is seen that the oral anticoagulants, they are acting better with the stroke, for the stroke and for the major bleed in patients not in the standard dose but also in the modified dose. Next slide, please. The cumulative incidence, in this particular study, the comparison has been done with the standard dose and with the modified dose for the stroke, and the various comparisons from the real world has been shown that the dabigatran has performed better in patients with the elderly population with dabigatran as compared to rivaroxaban, not only for the stroke but also for the major bleed and all-cause mortality. They are all better. The dabigatran has performed better as compared to rivaroxaban and as compared to apixaban. Next slide, please. So in the real world study, the patients of more than 75 years initiating oral anticoagulation for AF with standard or reduced dose NOAC has been associated with similar risk of stroke with warfarin and the lower risk for the bleeding. So the NOAC can be considered as a safer option in patients of elderly age group. Next slide, please. So in this particular study, the dabigatran of 110 and 150 has been compared with the matched warfarin users, and in this study the patients were mainly, the primary outcome was the first hospital admission or emergency room visit. Next slide. And if we see in this particular slide that even in the patient of less than 75 or more than 75 with the modified dose, the risks are similar and benefits are similar, and it has been seen the GI bleed is a little higher in the elderly population. Next slide.
So can we conclude the slides?
Yes, sir. Next slide, please. So from this study, it has been concluded that the older patients treated mainly with 110 milligram dabigatran dose experience less intracranial bleed and events under dabigatran treatment when compared to warfarin, but are at higher risk of cardiovascular bleeding events. Next slide, please. This has the ACS cases has already been discussed by the previous speaker, so I will skip on to these slides in the interest of time. Next slide, please. Next slide, please. So in the valvular AF cases, particularly in the TAVR cases, there is a case series. Next slide. In which the newer oral anticoagulants have been used in view of the various risk factors, like the patient has refused warfarin or there was a history of GI bleed. So in this case series, now this has been considered as a feasible option even in patients post TAVR also. Next slide. Next slide, please. In this meta-analysis, which has been shown that in the valvular AF, the patients which were enrolled in various trials have been shown that it is a feasible option with the similar mortality, and there is less risk as compared to vitamin K antagonists. So in particular, though as of now in valvular AF, the in valvular AF, however, it is not indicated to have a to prescribe DOAC, but now the literature is moving toward the fact that in near future, yes, the DOACs will be available and recommended even in this particular scenario. Next slide. So NOACs have been shown to be superior in reducing the stroke and systemic embolism even in valvular heart disease, but not major bleeding and all-cause mortality. So in future, yes, definitely the things are going into that direction. With more data, we may be having data in this particular scenario also. And except in patients of post-TAVI as of now, in which it is clearly recommended to not to use DOACs in this particular scenario. And next slide. Thanks for your patient hearing and a little glitches because of the technical issues in between.
That was very good, Dr. Sadbir. Sorry, there were some issues with your, the computer with the slide, and we thought we had a backup. Anyway, we'll go to the next session, next topic. This is significance of twilight study in clinical practice, a very important topic, and no other person could do justice to this except Dr. Ponde. So is Dr. Ponde online?
Yes, sir. Yes, sir.
Okay. So,
I'll share my slides, sir.
Yes, please go ahead.
Can you see the slides, sir?
No, we don't. Yes, now we can see your slide. Yes, just go to the full slide.
My topic today is the significance of twilight study in clinical practice. We know that the frequency and prognostic implications of bleeding events after PCI has always been underestimated. In the past 2 decades, the ischemic events have become half because of aggressive antiplatelet therapy, aggressive antithrombotic therapy, routine use of primary angioplasties, and rescue angioplasties and pharmacoinvasive therapy. However, the hospital bleeding has doubled, and that is again because of more potent P2Y12 inhibitors, more aggressive antithrombotic therapy, including GP2B3 antagonists used in the cath lab, followed by the low molecular weight heparin in the ICU post-PCI. In the ADAPT-DAY study, the out-of-hospital bleeding mainly occurred in the GI tract. Almost 2/3 of these events were in the GI tract. And we know that BARC2, BARC3, and BARC5, these are the bleedings with which we are always worried that a clinically overt sign of hemorrhage, which is actionable, significant drop in hemoglobin or need for inotropes, etc. And last, a fatal bleeding. We are always worried and afraid of these kind of bleedings. And if you look at the outcome, a comprehensive evaluation of prognostic impact of GI bleeding was performed in the ACUITY trial. And the GI bleeding is a significant independent predictor of outcomes at 30 days with a hazard ratio of 4.8, almost 5 times more mortality than those patients who don't bleed, 2 times more non-fatal MI, and 2 times more composite ischemic outcomes. Similar data has also been shown from the burn PCR registry. The moment you have GI bleed in the hospital or within 30 days of the PCI, it is indeed a bad news. And therefore, we have been focusing on how to reduce the bleeding episodes before procedure, during procedure, and after procedure. But my today's topic is on after the procedure. And here, the choice of DAPT, the duration of DAPT, and modulation of DAPT is extremely important. Modulation meaning cutting off the aspirin as quickly as possible after PCI within 1 week, 1 month, or 3 months, depending on the patient, whether you are doing a stable subset with a drug, a bare metal stent, drug-eluting stent with a which is a polymer-free or degradable polymer stent, and so on. So it is very important that somebody need to address this. And Twilight was the largest study done to date to specifically design the demonstration of the reduction in bleeding with ticagrelor monotherapy versus ticagrelor plus aspirin beyond 3 months in high-risk patients treated with PCI. So the study design is known to all of you, and the primary composite endpoint was the time to the first occurrence of clinically relevant bleeding. Secondary endpoint was all-cause death, non-fatal MI and stroke. And of course, there were some exploratory endpoints which I would not really focus. If you look at the baseline characteristics of this study, almost 1/3 of the patients were, 1/4 were males, 1/3 were 40% were diabetic, and almost 20% patients had chronic kidney disease. And what did it show? The major bleeds with which you are worried about, BARC type 2, type 3, and type 5 bleeds, came down by almost 45% without significant increase in any ischemic outcomes, including all-cause mortality, non-fatal MI, and non-fatal stroke. So the Twilight study among high-risk patients who underwent and completed 3 months of dual antiplatelet therapy, ticagrelor monotherapy was associated with a lower incidence of clinically relevant bleeding than when it was combined with aspirin beyond 3 months without significant increase in the risk of death, MI, or stroke. Then Twilight ACS study, patients of ACS who were treated in a similar manner, and you can see here that in the aspirin ticagrelor DAPT arm, the bleeding was almost double as compared to the monotherapy arm. So therefore, this study again concluded that in patients with or without non-ST elevation ACS who have completed initial 3 months course of DAPT following PCI, ticagrelor monotherapy showed clinically meaningful reduction in bleeding events without any increasing in the ischemic events. Then what about complex PCI? Complex PCI means multi-vessels treated, 3 lesions treated, multiple stents, total stent length more than 60 millimeter, bifurcation, use of atherectomy, CTOs, and bypass graft PCI. As interventionalists, we are always worried of stopping DAPT prematurely in these patients. But look at this. Even in this group of patients, the risk of adverse events 12 months after randomization, BARC bleeding significantly reduced, BARC 3 or 5 bleeding significantly reduced, and death, MI, or stroke, no significant difference at all. So again, complex PCI Twilight highlight says that after 3 months of aspirin, ticagrelor, DAPT, de-escalating to ticagrelor monotherapy reduces significant bleeding without any risk of increasing the ischemic events with continued DAPT. What about CKD? Here there was a bad news. In CKD, bleeding events definitely by de-escalation decreased, but there was a significant increase in the ischemic events and myocardial infarction. So the conclusion was there was no net clinical benefit of de-escalating the DAPT beyond 3 months in patients with CKD, particularly when the GFR was less than 50. So about diabetes, again, significant benefit. So diabetic patients again benefited significantly with this kind of therapy, de-escalation of therapy beyond 3 months to ticagrelor monotherapy. So in patients with diabetes undergoing PCI, de-escalation beyond 3 months works in favor in getting net clinical benefit by reducing major bleeds, particularly GI bleeds, access site bleeds, and even bleeds because of hidden cancers in diabetic patients. So what about high bleeding risk patients? We know age more than 75, previous bleeding diathesis, patients who are on concomitant therapy with steroids, NSAIDs, etc., recent trauma, chronic liver disease, chronic kidney disease, and active cancer. These are the patients with high bleeding risk. So in patients with high bleeding risk, again, the net clinical benefit was even higher than in patients with average or low bleeding risk by de-escalation of DAPT beyond 3 months to ticagrelor monotherapy. In my center, which is Hinduja Satellite Center and our principal hospital, we have started de-escalating the therapy beyond 3 months in all stable subsets. In patients with ACS, where only a single stent is used, and in all high bleeding risk subset of patients. And when we analyze our data, which is at the moment in being considered for publication, this data shows close to around 700 patients, shows that only 2 subgroups, patients with multiple stents, which are non-biodegradable polymer, and patients with CKD, no other subset showed increase in the ischemic events. The Twilight Synergy study, where stents were compared with the biodegradable polymer and non-biodegradable polymer, again, it showed no significant difference in ischemic events. So guidelines also have changed. Guidelines have been reducing the length of DAPT progressively over the last 6 years. And we all know that if the patient is stable angina, you undergo PCI, you can de-escalate DAPT as early as 1 month. So 2017 ESC guidelines, if you see the duration of DAPT in PCI, it all depends upon whether it's a stable subset or acute coronary syndrome. With acute coronary syndrome with high bleeding risk, you can still discontinue at 3 months. In stable subsets, certainly at 3 months. And in stable subset with high bleeding risk, as early as even 1 month. So, my friends, DAPT was an old era. All trials of use of NOACs in atrial fibrillation patients undergoing a PCI for acute coronary syndrome like New Dual PCI, Pioneer AF and Augustus, all the trials have shown us only one single truth. Aspirin, when is an integral part of DAPT or triple therapy, is the culprit of bleeding. And sooner you omit aspirin, the better you are in terms of bleeding risk. And these are the 3 trials which have shown the same thing. So the highlights of these are ticagrelor monotherapy associated with lower bleeding or ischemic events, patients with or without NST elevation in MI, patients undergoing complex PCI, patients with or without diabetes undergoing PCI, patients with CKD, yes, ischemic events increased, but there was no net clinical benefit, but it was not terribly inferior. Patients with high bleeding risk, certainly. Elderly patients, frail patients, certainly, and irrespective of whether you use stent which are with biodegradable polymer or not. So I conclude my talk here and thank you very much for patient listening. I hope I finished in time. Thank you.
Thank you, Dr. Ponde. That was wonderful. And now we have the last talk by Dr. Iyengar. Is Dr. Iyengar there? Yes.
Sir, you are muted, sir. Sir, you are muted.
Thank you. Yeah. Good evening, everyone. Kindly permit me to share my screen.
Yes, you can. Please share your screen. We can see you on the panel.
Can see the slides?
No, we can't. Yes, now we can see your slides.
Yeah, good evening, ladies and gentlemen. After that talk on Twilight trial, let us turn and take a look at lipid lowering in atherosclerotic peripheral artery disease. Now, when we say peripheral artery disease, it encompasses the lower limb, upper limb, mesenteric, renal, and cerebrovascular territory. Now, when you see patient with lower extremity arterial disease, please remember some of them may be harboring coronary artery disease and few of them harboring carotid stenosis or renal artery stenosis. Now, let us look at benefits of lipid lowering in peripheral artery disease. Now, this is the heart protection study where there were 6,700 patients with peripheral artery disease and 13,000 patients without diagnosis of PAD. Now, 40 milligram of simvastatin daily reduced the rate of first major vascular events by about 1/4, and that of peripheral vascular events by 1/6, and at a large absolute benefit because of the high vascular risk. So statin therapy should be considered routinely for all patients with peripheral artery disease. because that had the strongest evidence base for ASCVD risk reduction. For those not achieving LDL goal on statin monotherapy, ezetimibe is considered the first add-on therapy. If they don't meet the goal even then, one should add PCSK9 inhibitor, that is evolocumab, which is available with us now, because this will produce marked additional LDL cholesterol lowering, and apart from that, it has got anti-thrombotic effects, giving us additional ASCVD risk reduction benefit. Looking at the Fourier trial, which had 27,000 patients of atherosclerosis, 3,000 of them had symptomatic lower extremity peripheral artery disease, and out of these 3,600, 2,000 patients had concomitant prior MI or prior stroke, whereas 1,500 of them had no prior MI or stroke. So when you look at the primary endpoint of death, MI, stroke, unstable angina, and coronary revascularization, patients with PAD had definitely higher risk, but they also derived greater benefit as compared to the patients who had no peripheral artery disease. Number needed to treat here being 29, and here it is 63. When you looked at the major adverse limb events, patients with PAD again had significant benefit, risk reduction by nearly 37%. But interestingly, even those patients without non-PAD had major adverse limb events, and they also showed benefit with use of lipid-lowering therapy. Now, this benefit in patients without non-PAD reflects two things. One is the heightened risk of peripheral artery disease in patients with coronary or cerebrovascular disease. And the second one is the underdiagnosis in populations where systematic screening is not conducted. Now, this is the relation between LDL cholesterol achieved at 1 month with the adverse limb events. Now, lower the LDL cholesterol and lower the risk of adverse limb events. This goes down up to the 10 milligram of LDL cholesterol per deciliter. So lowering LDL cholesterol to very low levels, that was median was 30 milligram in the Fourier study, with evolocumab in patients with symptomatic lower extremity artery disease, significantly reduces MACE as well as major adverse limb events. These benefits come with no offsetting side effects. When looking at the composite of MACE and major adverse limb events in patients with symptomatic lower extremity artery disease and no prior MI or stroke, evolocumab resulted in an absolute risk reduction of 6.3% at 2.5 years, yielding a number needed to treat of 16. So the clinical implication is that reducing LDL cholesterol levels to a very low target should be a core focus of preventive therapy in patients with symptomatic lower extremity peripheral artery disease, including those patients who have no concomitant coronary or cerebrovascular disease. Now, what's happening in reality out in the field there? There is a therapeutic gap in patients with ACS versus stroke versus critical limb ischemia. In these 10,000 patients from Hong Kong study, 2.5% of them had critical limb ischemia. Now, only 29% of critical limb ischemia patients achieved the target LDL cholesterol less than 70 milligram per deciliter at month 12, significantly less than stroke patients and ACS patients. And use of statin therapy also was lowest in critical limb ischemia patients, 52.6% versus 88.4% in acute coronary syndrome patients. When it comes to use of high potency statin, again, only 2% of critical limb ischemia received high statin therapy as compared to 21% in acute coronary syndrome patients. Topping all that, at 12 months, 51% of critical limb ischemia patients were not on lipid-lowering therapy as compared to only 28% of ACS patients. What this demonstrated is that there is significant therapeutic gaps in lipid-lowering management in high-risk patients. Critical limb ischemia patients in particular were less aggressively treated with lipid-lowering therapy. This is coming to a study in US where they looked at 125,000 patients. Though the statin prescription rate improved from 75% in 2014 to 87% in 2019, only 30% of patients not on statin at the time of intervention were discharged with statin. New statin prescriptions rates were lower in women, showing the gender bias. Statin use was lower after endovascular intervention, only 26% receiving statin, compared to the surgical patients who received 41% of receiving statins. So in this cross-sectional study, although statin use was associated with substantial improvement of lower extremity revascularization, more than 2/3 of patients not already taking a statin pre-procedure remained not taking a statin at discharge. It's very disheartening. Now, what is the way to go to reduce this gap? Once you see a patient of peripheral artery disease, you must assess his atherosclerotic cardiovascular disease risk. The intensity of lipid lowering should match the risk. Now, put the patient into one of these risk categories based on the major risk factors, non-conventional risk factors, into either low risk, moderate risk, high risk, or very high risk. Now, all peripheral artery disease patients, since they have atherosclerotic cardiovascular disease, they come into high risk. Now, if this patient has one of these high-risk features, he goes into extreme risk category BA. And if he has one of these additional very high-risk features, he goes into extreme category B. Then you have the LDL cholesterol goes laid down for these risk categories. If he belongs to extreme risk category B, his LDL cholesterol should be 30 milligram per deciliter or less. If it is BA, it should be 50 milligram per deciliter or less. The core primary target is non-agitated cholesterol, so that it takes care of triglycerides. Now, how do we achieve these goals? We must reinforce the lifestyle interventions, take optimal control of diabetes and hypertension, use high-intensity statin. If not at goal, use ezetimibe. If not at goal, use PCSK9 inhibitor. Hyperglycemia is another risk factor for atherosclerotic cardiovascular disease. And as shown in the REDUCE trial, compared with placebo, icosapent ethyl 4 grams per day significantly reduced total cardiovascular events by 30% in those patients who were on maximally tolerated statin therapy and had achieved an LDL goal of less than 70 milligrams per deciliter. Now, analysis of first, recurrent, and total events demonstrates the large burden of ischemic events in statin-treated patients with baseline triglyceride more than 100 milligrams per deciliter, and the potential role and benefit of use of icosapent ethyl in this particular group. Lipoprotein(a) is another frontier to take care of because analysis in 3 independent population studies and the genetic study has shown a causal relationship between LPA and peripheral artery disease. And elevated LPA also has shown a heightened risk of ischemic stroke in this study of nearly 50,000 individuals from Copenhagen General Population Study. So Lipid Association of India recommends that one should estimate LPA in all at least once in their lifetime, and definitely in patients with premature atherosclerotic cardiovascular disease, FH, family history of premature coronary disease, poor response to maximal lipid loading therapy, ischemic stroke of uncertain etiology, and calcific aortic valve stenosis. So in conclusion, Chairman, ladies and gentlemen, atherosclerosis is a systemic disease affecting multiple vascular beds, and peripheral artery disease is an indicator of an advanced atherosclerotic process and is frequently associated with preclinical or clinical atherosclerosis in other territories, which imparts very high negative prognosis. All too often, patients with peripheral artery disease and polyvascular disease receive less aggressive secondary prevention therapy and risk factor modification than patients with coronary artery disease alone, although the benefits of guideline-based treatment have been proved. Thank you for your time.
Thank you, Dr. Iyengar. That was indeed wonderful. And I must say the Lipid Association of India has actually come out with very, very provocative and very required and necessary and apt guidelines. And the good thing is that these things are being acknowledged all over the world. People are accepting lower the better, and there is a lot of data now which proves that lower the LDL, the better you are, and what is the advantage of aggressive lipid lowering. And you have been pioneering this work, and this, it's like a crusade for you. And Dr. Puri at our place, and we can see it happening and revolutionizing the care, the adherence to lipid lowering agents, the knowledge of hyperlipidemia, the potential benefits of lowering it to a particular level. And that has really changed the way physicians now are thinking and practicing medicine and cardiology and diabetology. And I must salute your effort and the efforts of Lipid Association of India and Dr. Puri's work that you have gone. The amount of work, I know that how much of effort and work you have done, and actually gone from places to places to educate the physicians, to educate the clinicians about this, the epidemic of coronary artery disease and peripheral arterial disease, and how lipids are important and what is the rationale of lowering it to that level, and making them accept this fact that lower the better. Otherwise, as you said, very, very poor percentage of patients, very low percentage of patients actually were on optimal level of drugs and actually were achieving the target levels. So with this, I will, ask you to, being a panelist and the chairperson, to conduct the discussion. We just have 5 minutes for the discussion because we are a little late, and we have another 2 talks coming from United States on vascular robotics.
Thank you, Dr. Khanna, for those kind words. I have one question for Dr. Pandey, my good friend. Dr. Pandey, do you have any data on the gender, the women patients within this Twilight trial?
No, sir, I don't think there is a women analysis population. In that, there is a difference between males and males and females, and there was no significant difference there. So the females also tended, usually females are considered to have a little higher bleeding risk. So the net clinical benefit in elderly females were higher than elderly males. But overall males and females, I don't have that data, sir. Yes, sir. Can you hear, sir?
Dr. Iyengar, I think you are muted.
No, sir, I think he has been disconnected.
Maybe.
Yeah.
Okay, Dr. Pandey, you really highlighted it very well that it is aspirin alone, or singularly it's the aspirin which is the cause of bleeding, and we have seen it now. It's very difficult for us as physicians or clinicians all over the world to actually, sink to this idea that you can do without aspirin. There are better drugs than aspirin and more potent drugs and safer drugs. And if alone one has to be used, then it's better to choose the other rather than aspirin. So this you have highlighted very clearly, and that is the message I think we should go to a lot of attendees here. There are about more than 5,000. And this, you have made it very clear with the significance of two-light study. I think Dr. Iyengar is back.
Yeah, I think there was some problem with the audio. Dr. Natish, can you hear Dr. Natish, my co-chairman? Do you have any questions or comments?
I think I have a small question for Dr. Anupam Goel regarding DOACs and recent advances. DOACs are efficacious in secondary prevention of ACS. Is there any data recent from the North Indian part? Dr. Anupam Goel?
Dr. Anupam left. Can the other panelists take up the question?
Is Dr. Anupam not there?
No, sir.
Okay.
Dr. Sarbir, do you have anything to say, Dr. Sarbir?
Dr. Sadbir left as well.
Oh.
Okay. So would you like to respond, Dr. Iyengar or Dr. Pandey?
Sir, what was the question? I didn't get that. Data on what?
No, DOACs and recent advances in ACS.
Yes.
regarding secondary prevention of ACS.
Yeah.
Comparison between rivaroxaban and apixaban. Any personal experience or data?
No, I don't have any personal experience of use of apixaban, at least in ACS. But we have used in patients with who have recurrent ischemic events, rivaroxaban 2.5 BID after de-escalating the DAPT after 3 months to TICA. And that we have used, but only in an exceptional anecdotal patient. I can't be generalizing here. Thank you.
We have used in patients only with AF, because ACS and AF, there we have some experience with apixaban, not with rivaroxaban.
Okay, so if there are no other questions, we'll probably want to close this session. I thank Dr. Iyengar, Dr. Ponde to chair this session. I also thank Dr. Jack Tan from Singapore and Dr. Anupam Goel and Satbir Singh and Dr. Natesh to be chairing this session. And thank you all very much. Let's move on to the next session. We are a little late, and the next session would be on vascular robotics. It's a very interesting session. And as we know that vascular robotics is the in thing now. The surgeons have been using robotics for a long time. And now it's the chance of cardiologists and interventionalists to start using these robots. They were initially crude, and then they have been sort of refined. And they are now being used for coronary applications. But apart from coronary, now the use has started in endovascular arena as well. We have two systems right now, and one of the system is Corindus, which is now taken over by Siemens, and this is the robot which now we are going to acquire. We already have one in Apollo family, and we are going to have the second one in probably in our institute in Delhi very soon. And tomorrow we have 2 days of ICE endovascular workshop where we are getting simulators of vascular robotics, and there are about 25 doctors flying in from different parts of the country, about a senior level interventional cardiologist who would be trying out and doing hands-on experience on these vascular and coronary robots for PCI and peripheral angioplasties. Also, we had a full dedicated session on the first day on vascular robotics, AI, machine learning, and telemedicine, which went on very well, and we had a lot of international speakers, the who's and who's of AI in the world, and they were all deliberated on this topic, and there are some live case as well. So with this background, I'm going to move to vascular robotics. The first presenter would be Dr. Ryan Madder from US. He's going to be speaking on vascular robotics, current and future applications. Can we have the presentation of Dr. Ryan Madder?
To start today just with an overview of the robotic system for people who may be less familiar with it. And so it basically consists of two components. There's a bedside robotic arm on top of which you set a sterile cassette, and into that the technician or bedside operator is going to load the interventional devices. And then there's an interventional workstation that consists of the robotic controls as well as a large flat screen monitor. And it's important to think about when you're considering robotic PCI, both the current and future applications of robotics. And so the first generation robotic system was cleared for clinical use in the US in 2012. The current CorePath GRX became available in 2016, and it's been used for both simple and complex PCIs, and over 7,000 robotic PCIs have been performed worldwide to date. It's also cleared for use in peripheral interventions with a focus really on below-the-knee work. It has now received CE mark for some neuro interventions, and currently in development are both further developments in the neuro space as well as the ability to do remote interventions, and that's something that we'll talk about a little bit later. So this is a schematic just showing what the robotic cassette looks like. And so you use a sterile cassette for each case. You set this on top of the robotic arm. And you can see the dotted line here represents the location of your interventional wire. And on the bottom, you can see there's an RX device track. So this is where your rapid exchange, either balloon or stent catheter goes. And then there's an auxiliary track that you can place additional wires for use in bifurcation lesions. And then the controls are relatively simple to use. There's a green joystick on the right that allows you to control your guide catheter. So this is for both advancing, retracting, and torquing the guide catheter. There's a joystick in the middle that allows you to control your wire. So again, advance, retract, and torque. And then there's a controller on the left that allows you to advance and retract your either balloon or stent catheter. And then there are a series of touchscreen buttons that really allow you to maximize the precision of your movement. So using these touchscreen buttons, you can move any of your devices by 1 millimeter increments, and it's a really useful tool to have, again, to increase precision. And so what are the physician benefits of robotic PCI? And I think it really, for the physician, comes down to minimizing the occupational risks that we all face in the cath lab. And I think, as everybody in the audience probably recognizes, these risks really stem from radiation exposure as well as wearing lead chronically. And to optimally reduce the occupational risk in the cath labs, we really need to address both of these issues. And when it comes to wearing lead, we know that about half of interventional cardiologists will report having some form of orthopedic injury during their career. Many of these tend to be spinal injuries. Work-related pain is extremely common in our profession. Just under 50% of physicians in the cath lab having some work-related pain related, again, to wearing chronic lead. And one of the beautiful things about robotic PCI is you don't need lead to do these procedures. You can sit in the safety of the cockpit without lead, and I often say you don't know what you're missing until you're doing your procedures without wearing lead. So the other occupational risks, as we mentioned before, really relate to radiation exposure. And so there's an increased incidence, or maybe an increased incidence, of carotid disease amongst interventionalists. There's about a threefold risk of cataracts that we face compared to people who are not exposed. And then there's some concern that we may be at an increased risk of left-sided brain malignancies, all of which are concerning. I found this study, actually published by El Sayed in 2017, to be quite provocative with respect to radiation risks that we all face. What they did in this study is they actually measured two markers that serve as markers of radiation-induced DNA damage. And so these are biomarkers that can indicate that. And they drew blood samples on vascular surgeons both before and after the procedures that they were doing. And when they looked at vascular surgeons doing open AAA repair, as shown by the brown boxes, they saw no increase in these DNA damage biomarkers before and after the procedure. But interestingly, after a single endovascular AAA procedure, where of course fluoroscopy is used, in these physicians, they were able to measure a rise and fall in DNA damage biomarkers from just a single procedure. And so this is really evidence that even a single procedure, and the radiation doses in this in the procedures in the study, very similar to what we typically would get doing a manual PCI, but these can result in evidence of DNA damage. So I think, again, very provocative findings. And the other thing as it relates to occupational radiation safety in the cath lab is, not only are procedures becoming more complex as time goes on, but our patients, unfortunately, are getting more and more obese. And these are data that we published in 2019 in Circ Interventions, showing that as patient BMI increases, going from left to right in the figure on the left, that you see this stepwise increase in the patient radiation dose, which makes sense. Bigger patients, you have to, supply more radiation to generate the images. But what many may not recognize is that as patient BMI increases, as shown in the figure on the right, there's also a stepwise increase in physician radiation doses. And so the ongoing obesity epidemic, which really continues to grow, may be having an adverse impact on our radiation doses in the cath lab, and it's something we need to be thinking about how to decrease those that risk to us. And I think robotics is a nice way to do that. And so these are data from the PRECISE study showing that for a manual PCI at the table, the average radiation dose was about 20 microgray in this study, whereas in the robotic cockpit, it was less than 1 microgray. And so this represented robotics being associated with a 95% reduction in physician radiation exposure. And just to put this into perspective, I like to show this kind of quick back-of-the-envelope calculation. If we take two operators who both finish their fellowship at the same time, and operator A decides he or she is going to do all of their procedures manually, and operator B decides that they are going to do all of their procedures robotically throughout their career, and just for the sake of making this calculation simple, we'll plug in these radiation doses per procedure from the PRECISE study and just say that each of these operators is going to do 100 PCIs per year, you can see their annual exposures down at the bottom there. And then if we multiply this out over a 20-year career, you can see that with robotics, after 20 years in the cath lab of doing PCI, that the robotics operator actually has less radiation exposure after 20 years than operator A had in their first year of practice. And this is really where these decreases in radiation exposure per case can really be amplified over the course of one's career. And I think we need to be thinking more about the risk over our careers rather than just single cases. So the other thing that has come of interest of late is just the ability to potentially reduce risk in the during the COVID pandemic. And this was originally tweeted out by John George at Einstein in Philadelphia about the possibility of using robotics to decrease the physician's risk of contracting COVID by increasing the distance between the physician and the patient in these cases. And I think this is something that is very interesting and probably requires additional research, but I think an idea worth pursuing. So what are the potential patient benefits of robotic PCI? Well, one of the things that I think robotics is very helpful for is to measure lesion length. And so you can use the touchscreen buttons to actually measure the length of your lesion down to the fraction of a millimeter, and this seems to be an extremely accurate way to assess lesion length. These are data from Paul Campbell in 2015, where they compared visual estimates of lesion length to those obtained with direct measurements by the robotic system. And what they found were that the visual estimates were accurate only about a third of the time. A third of the time they were too long, and another third of the time they were too short. And this, of course, has implications on stent length selection. And in this study, they did suggest that using robotics would result in a significant decrease in the need for two stent procedures by accurately measuring lesions. And then these are data from Aaron Becerra in 2015 as well, showing that compared to historical controls, the use of robotic PCI is associated with a reduction in longitudinal geographic miss. So again, important implications on measuring lesion length and not missing your lesion. So I think one of the most interesting things, which really was just published last month by Tejas Patel, was that robotic PCI seems to be associated with a reduction in patient rating. And so in this study, they did a propensity score matched analysis of robotic PCI versus traditional manual PCI. And these were patients treated at the Apex Heart Institute between December of 2017 and March of 2019. All the PCIs in this were robotically were performed by two highly experienced operators. And interestingly, the data here include the initial robotics learning curve at this center. And what you can see in this propensity matched analysis was that patient radiation doses, both measured by air kerma and by the dose area product, were about 20% lower in the robotic arm. And so again, this was the first evidence that robotic PCI may be associated with a reduction in patient radiation doses. And so I think, again, very, very interesting results. And the authors provided two potential mechanisms by which robotics may reduce patient radiation exposure. One was by improved visualization. And so I think, as shown by this figure on the lower left of this slide, we've all done this when we're doing manual PCIs. The monitors are, of course, several feet away from us across the table, and we lean across the table to try to get a better view. And not only is this not good for our spinal health, but we're also putting our head closer to the source of scatter radiation. So this is a very unhealthy practice. Whereas in robotic PCI, you literally can put your nose up against the screen. And so the operators in Tejas' study suggested that the improved visualization with robotics may be leading to fewer cineangiograms. They actually demonstrated that the number of cineangiograms in the unmatched group was lower with robotic PCI. The other interesting thing that may have driven this reduction in patient radiation doses was table height. And so at this center, they have gotten into the habit of raising the table height during their robotics cases. And of course, when you're doing cases manually, there's a certain table height that is going to be comfortable. And when you go above that, it becomes, not great for operating at very, high table levels. Whereas when you're sitting in the cockpit, you can put the table as high as it goes, thereby reducing patient radiation dose, but yet having no impact on your ability to do the procedure. And so I think this is also something that requires additional study to show how we can optimally use this to reduce patient radiation doses during robotic PCI. So what are the studies that support robotic PCI in clinical use? So I mentioned the PRECISE study earlier. This was a prospective observational study. 20 physicians, 9 different sites, and 164 patients in this study underwent attempted robotic PCI. They had no device-related complications, and in this study they showed extremely high technical and procedural success rates. However, one of the limitations of this study is it was the majority of lesions in this were type A and type B lesions, and so definitely simpler robot or PCI procedures. This has been studied, however, in more complex PCI procedures. These are results from the Cora PCI study that Shami Mahmood did in 2017, showing that in a cohort of patients where the majority of lesions were type B2 or C, they were able to complete these procedures robotically, either with complete robotic, doing them completely robotically, or with partial manual assistance in over 90% of the procedures. They required manual conversion in only a little more than 7% of procedures. So again, really the first evidence that you can do complex PCIs using the robotic system. So this is something that particularly interests me about robotics is really the future of robotic PCI, and I think this lies in the potential for automation and the ability to do remote procedures. And so why would we want to explore automated robotic procedures? Well, one of the things to recognize is in the United States that the operator procedural volumes per year are relatively low. And so the average interventionalist in the United States only does roughly 50 PCIs per year. And you can see on this figure the number of interventionalists that do fewer than 50 PCIs per year is quite high. Well, with automation, you have the ability for the robotic system to actually provide low volume operators with high volume skills. And that is something that I think we should explore as a way to potentially make procedures safer. And I think the airline industry provides a very good example for the potential of this. The majority of flights around the world, commercial flights, it's only the takeoff and landing that are flown by the pilots. Everything in between is really flown by computers. And you see the quote in the middle there that it took us a while to admit it, but computers fly airplanes much more precisely than humans. And I wonder if the same could be true with PCI, that computers and robotics could do PCI more precisely than the average interventional operator. And that's something I think that we should explore as a way to potentially improve both the efficiency of procedures as well as the safety of procedures. And so one of the first automated maneuvers that became available on the robotic system, and this is something that's clinically available now, is called rotate on retract, or ROR. These were data that we put together back in 2017 and published in abstract form, showing that with using ROR and very experienced operators, there was a reduction in wiring time compared to doing robotic procedures without the automated maneuvers. And so again, very, I think, helpful data showing that there might be benefits to using this on efficiently wiring vessels. Very excited to report that there'll be several additional automated wiring maneuvers that are going to become available later this year. These automated maneuvers, again, I think are going to be potentially, change the game as far as efficiency of wiring, particularly difficult lesions or getting into difficult side branches. And these two videos will show kind of the potential of automation. So you can see on the video on the left that this is a vessel that's being wired robotically, but without automated features. And as that video plays, you can see they have trouble getting the wire across that difficult bend in that vessel. And it just highlights that, I think in my experience, when you have difficulty crossing vessels robotically, often when you convert to a manual procedure, those lesions are the same ones that are difficult to wire manually. However, automation, when you watch the video on the right, you can see how efficiently using this spin technique, this automated spin maneuver, how efficiently that wire just slips down the vessel. And so again, I think that automation really has the ability to potentially improve our ability to wire vessels in a more efficient manner. So something I think that requires additional study. So looking at the evolution of robotic PCI, the original robotic systems were really intended to have the cockpit positioned in the corner of the room as kind of shown on the image on the left. And in this scenario, the robotic controls and the robotic arm are hardwired to each other. This has evolved now where many hospital systems are placing the robotic controls in the cath lab control room. And so again, this is a hardwired connection, but does provide you the ability to eventually, not wear scrubs during these procedures, as shown on the second image from the left. On the third image from the left is something that there has been an interest in at multiple hospital systems around the world, which is having a central control room that is connected to multiple different cath labs within your hospital, so that you could potentially have a central operating station that controls multiple different robots in multiple different rooms. I think that's something that we will see evolve further in the future. And then all the way on the right, I think, is something that we hope to develop further, which is really the ability to do robotic procedures remotely from one institution to another. And I think there are multiple different reasons why we'd want to pursue this. And so several problems that remote robotics could address. We know that emergent procedures, that time to treatment is critical. And when it comes to time to treatment, often that time is delayed because of the need to transfer patients from one institution to another. You could deploy remote robotics to overcome that. Access to expertise and treatment is geographically limited. So there are regions both in the United States and around the world where patients can't get to interventional operators. You could deploy robotics to overcome that issue. We have a shortage of skilled specialists. I'll talk a little bit more about that in a few minutes. And the incidence of STEMI and stroke are, of course, on the rise due to both the aging patient population as well as the obesity epidemic. And it's something that we could use remote robotics to address further. So what we're talking about here, again, with remote robotics is this idea of telestenting, where we have a physician in one location with the robotic controls. We have a patient in a separate location with the robotic arm. And over that geographic distance, you perform PCI. And, why do we want to develop this? Well, we have a lot of geographic barriers to PCI that still exist. These are data from 2012, so a little bit dated, but showing the areas of the United States where patients can get to a PCI-capable hospital within an hour. And so those dark spots on the map there show you where patients living in those regions can get to a PCI-capable center within an hour. And it's only about 80% of the U.S. population that can do that. When you go to more rural states like West Virginia, Alaska, and Wyoming, less than 50% of the population in those states can actually reach a PCI-capable hospital in under an hour, and that creates problems particularly with respect to STEMI care. And so remote robotics could potentially address this. We're also facing a shortage of interventional cardiologists in the U.S. These are data from MedAxiom showing that about 25% of the current interventional workforce are over the age of 60. So as these individuals retire in the next 5 to 10 years, we do anticipate there's going to be a shortage. And so again, you could use robotics to potentially overcome that shortage by disseminating interventional expertise. And then I think there is opportunity to do remote robotics in peripheral interventions. When we look in the United States regarding the rates of amputation for critical limb ischemia, you can see there's a lot of disparity as shown on the map on the left. And there are centers or geographic regions in the United States where the first approach to treating a patient with critical limb ischemia, unfortunately, is still amputation. And again, we could use remote robotics to reach those locations and at least make attempts at doing peripheral interventions. We know from the RAPID trial, as shown on the right, that it is both safe and feasible to do robotic peripheral interventions, particularly for stuff below the knee using the current generation system. And then I think an area that's very exciting is the potential to use robotics for remote stroke care. We now know that mechanical thrombectomy is associated with superior outcomes compared to thrombolytic therapy. And the issue that we have, though, in the United States is that we don't have enough comprehensive stroke centers. Of the more than 5,000 hospitals in the United States, less than 5% of them actually are comprehensive stroke centers capable of performing endovascular thrombectomy on a 24/7 basis. And so you could use remote robotics to disseminate the expertise of these stroke interventionalists to get to more centers, potentially reach more patients. So the studies that have looked at this, the first study to evaluate the ability to do remote was something that we published in 2017, this remote PCI study, where we simply asked the question, is it feasible for a physician to perform PCI from outside the procedure room housing the patient? And as shown on the left, the conventional configuration in the cath lab is, of course, to have the robotic controls in the same room as the patient with this hardwire connection. For this remote PCI study, we took the approach as shown on the right, which was simply to move the robotic controls down the hallway into an adjacent cath lab, close both doors, and then from that location, the physician had no direct line of audio or visual communication with the patient or the cath lab staff except using telecommunications devices. And so in this fashion, with the physician outside the procedure room housing the patient, we demonstrated that it was both technically and procedurally feasible to do these procedures. However, the limitation was that the robotic drive and the controls, as I showed, were hardwired in this study to each other. And so in order to be able to do remote procedures over much longer distances, we had to develop the ability for these, the robotic arm and the robotic controls to connect to each other over an internet network. And that's something that we have been experimenting on the last several years. These were data that we published in Neurointervention in 2019, where we developed both an ex vivo simulator model as well as an in vivo porcine model of remote telestenting, where in these we had a cardiology fellow and a scrub tech as the individuals in the room with either the simulated patient or with the live pigs. They obtained vascular access, they seated the guide catheter, they performed contrast injections, loaded all the devices on and off the robot, and performed the balloon inflations, but the rest of the PCIs were performed off-site by me. I was sitting miles away from the either simulated patient or the living pigs. And at the site where I was located, we have live fluoroscopy images piped in, we had live telecommunications brought in, as well as the hemodynamics and robotic controls. And so in this in these models, we had, we did them over miles ranging from about 4 miles up to about 103 miles. And interestingly, the stuff that we did over the very long distances was done over partially over just commercial internet. And so this culminated in procedures that we did where I was in Ludington, Michigan, which has a population of about 8,000. And the animal lab was in Grand Rapids, as shown on the map. And again, this distance was 103 driving miles. And over this distance, we showed that we were able to successfully do PCI procedures on these living pigs without any procedural complications. And so the next step of this was something that Tejas Patel did in 2018, published in 2019, where he performed telestenting on 5 humans in India in December 2018 over a distance of about 20 miles. All 5 cases were successful. There were no complications in any of these cases. So again, showing for the first time that this is feasible in humans. And so one of the questions that has come up is, what is the potential impact of network delays? You can imagine that if your internet signal was poor, and what you were seeing as you were doing a robotics procedure was several milliseconds or seconds behind what was actually taking place in the cath lab with the patient, that delay or that latency would become problematic. And so we started asking questions about what is the latency or delay at which it becomes perceptible to the interventional operator. So these were data that we just published earlier this year, showing that as latency increases from left to right on the x-axis on the figure on the left, that you don't really see a perceived latency until you get up to about 400 milliseconds. And so this is really kind of the benchmark that we need to be thinking about as we further explore the ability to do remote PCI procedures, is that we should be looking to do these over networks that have latencies of less than 400 if our goal is for the operator to be able to do these without having to battle perceived latency. And we asked the question here just late last year, is geographic distance a barrier to telestenting? And so we set up 2 ex vivo models, and each of the models I was sitting in Boston at Robotic Controls. And in the first model, we did a regional model where the robotic arm was in New York City. And so over that distance of 206 miles, we demonstrated that we were able to do simulated PCI procedures without any problems whatsoever. And then we developed a transcontinental model where I, again, was sitting at Robotic Controls in Boston, and I was controlling a robotic arm in San Francisco. And over that distance, again, over 3,000 miles, we demonstrated that it is feasible to control a robotic system in a manner necessary to perform PCI, despite the fact that you're on opposite sides of the country. And so something that we definitely want to explore further. The other thing that was interesting about this is we studied the latencies in each of these models. And so we did these over both wired networks as well as 5G wireless networks. And in this, all the latencies in all of the models, regardless of whether these were done in the regional model or in the transcontinental model, regardless of whether the connections were hardwired, over a wired network or over a 5G wireless network, the latencies in this study were all under that 400 milliseconds. And so as I was controlling these procedures, I did not perceive any latency in any of the models that we studied. And I'm happy to report that this paper was actually just accepted for publication 2 days ago, so this will be available in the very near future. So I think there are some barriers that need to be considered as we continue to explore telestenting. This need for a second operator is something that is still an issue, and I still think we need to figure out, who that individual needs to be in these procedures. But they have to be able to obtain vascular access, perform angiography. I think engaging the guide catheter can be done now robotically, so I don't know that that's absolutely necessary for the person in the room to do that. Managing complications is a big deal, so that operator in the room needs to be able to manage complications. I still think there's opportunity for us to study how we could manage complications robotically from a remote distance. Network performance is still something else that we want to study. We're uncertain of the impact of network traffic on telestenting performance. The latency issue, I think we have good preliminary data that have given us some guidance on that. And then I think there are a whole bunch of interesting questions about licensure, credentialing, liability when you're doing this either across state lines or from one country to another, and these are other issues that need to be addressed. So I just wanted to finish with, I think Siemens really has a visionary approach to what the cath lab of the future looks like, and this really is going to be a combination of state-of-the-art image guidance that makes things that were formerly unseeable visible. And I think also that combined with robotics, the ability to do procedures very precisely, the addition of automation and the ability to do things remotely, I think really is going to transform, PCI procedures here over the next decade. And it's something that we're very excited to continue to work on. So just in summary, robotic PCI is associated with significant reductions in physician radiation dose and does not require the physician to wear lead. It's recently been shown that robotic PCI is associated with reductions in patient radiation doses. Automation in robotic PCI has the potential to standardize care, minimize human error, and potentially augment procedural safety. And then there's current geographic disparity to access to PCI as well as other endovascular procedures, and telestenting or remote robotics is being explored as a potential means to improve access to these procedures. And then I think there's potential to adapt telestenting technology to provide remote endovascular treatment of both stroke and peripheral arterial disease, particularly critical in ischemia. Thank you.
Thank you very much. And I think Dr. Jack Buske would agree, he's a co-chair on this session. This has been a wonderful exposition of this technology. And if he sort of permits, we can have a live case from United States, and Dr. Aaron Grantham is going to be showing a live case of complex multivessel robotic PCI. It's actually a live inbox, and then we can have question and answers too after this, or maybe comments after this.
This first case is a 74-year-old man referred for second opinion for revascularization. He lives about 100 miles west of Kansas City. His relevant past history includes a stroke, which left him with a Parkinson-like syndrome, an unsteady gait, and he has to use a cane or walker. He does have diabetes mellitus type 2. He had an ischemic workup that included an echocardiogram. The echo showed a normal ejection fraction of 55% with no wall motion abnormalities or valvular heart disease. A stress test was done with nuclear imaging that showed transient ischemic dilatation with stress, ischemia in the LAD and circumflex distribution, and 28% of the LV mass was ischemic. He underwent cardiac catheterization in Scottsdale, and he was found to have a left dominant system with a 90% lesion of his major OM2, and a lot of diffuse disease in the LAD with a couple of focal 80% lesions in the proximal and mid portion. So our plan then is to, after having a long conversation with him in the office about these two options of medical therapy versus PCI, he was strongly in favor of PCI. Our plan is to do robotically assisted PCI of the OM2 branch and of the LAD, and we'll perform imaging as well to determine where our stents go and then optimally how well they're deployed. So circumflex OM branch is our first target. We'll get an ariocaudal view of that. AP caudal view of that. All right. Inject. Good. All right. So our plan here is to hook up the robot, and then when we'll show that in detail on video. And then we're going to take a couple cyan blue wires. We're going to put one down the main branch of the AV groove circumflex, and then we'll preload a balloon with a wire that we'll use to get into this large OM branch. At this point in the case, I would be breaking scrub and going over to the robot, but in this instance, Spencer Gaskin, one of our fellows, our interventional fellows, who's done about 25 robotic cases, is going to be doing the driving for us. And so we'll leave him there, and I'll stay scrubbed in case we need to do any manual interruption.
All right, coming toward you.
And we'll feature Tina LaPerry, who's going to be doing the robotics for us with great efficiency.
I always start with the arrow pointed towards the patient. Open it up. Go towards the opposite end and take all the brown stickers off of the plastic shield that sits on the robot. And then open the arrow towards you. Grab the plastic piece and open it up. Put your arms in there so you don't have to worry about sterility. And then your assistant will pull the robot out for you. And your main goal is to get the monitor. White piece goes to the top of the monitor. Pull as much towards the circulator as you can. This plastic piece has preset holes in it. These are not sterile, the wheels, so do not touch them. And then you open this little piece up, go underneath the lock. And then you're pretty much set for the cassette. All right. So, the main target is this communications box. And you want to get underneath the lip here, hold on to it, and just lock it in place. And you have to look, connect track clamp. That's done. We open the drive cover and pull out the key.
Get to the gym.
And our drive is good and straight. I didn't eat my Wheaties this morning. Pressing cassette. And we are ready to tilt the robotic drive. And you just do that gently. All right.
Okay, bring it over and I'll hook it up. So you can see the cockpit setup. We've got a multifunctional display screen, our power vision monitor. It's got multiple configurations. This is a configuration I use most of the time. So we've got a good layout of our anatomy. So she's engaged the wire in the drivetrain. So Spencer's going to push down, look down and push disable all. Spencer's one of our interventional fellows. He's done about 25 robotic cases. He's been in the cockpit for about half and at the table side for about half. So he's now going to drive the guide wire to the tip of the guide with turbo. So the guide wire control is the middle control. So you've got fluoro control. Yep, enable all. Good, drive the guide wire. Push turbo. Good. Spencer, you're going to push the rotate on retract button. Okay, rotate on retract is an automated wire function that tells the robot to rotate the wire in a particular arc about 205 degrees every time you pull back. So now all we have to do to wire a lesion is push forward, and if you want it to rotate, click back. So go ahead and wire the circumflex, Spencer. You can already see that it's in the wrong orientation to get into the circumflex. Keep going forward, keep going forward. Test. Good. Send it on out. Back up. Okay, good. Tina, load up the second wire for him.
Okay. Can you step on for just a second so I can make sure? I'm sure I know we're close. All right. So our main driving wire, I'm going to put the clamp down. I'm going to put the main drive wire in the drive.
So the OM wire is going to be in the parking port.
Correct.
The circumflex wire is going to be driven, and then we're going to flip those out for ballooning and stenting. There you go. See how it flipped right over for you? Too much of a hook on there for you. That's just... Go ahead. You're good. Go ahead. Send it. You're in. Okay. Keep going. Good. So that's good. Tina, let's load up a 2520 RX balloon. So we'll need you to switch the wire in the parking port to the drive port and the wire in the drive port to the parking port. So Spencer's going to just leave all of the options open for device manipulation. So the device control, the guide wire control, and the guide cath control are on. You can selectively turn each one of those off. As you're learning, that helps you to not grab the wrong one. After 5 to 10 cases, it's just intuitive and you don't really need it. So he's going to drive that in. Go. That's good right there. Let's do our first inflation there, Tina, up to 12.
Okay. Going up.
So it's just a 2520 balloon for pre-dilation. Check.
I'm at 12.
Take it down.
Down 12.
I'm going to have you balloon all the way back to the bifurcation. So Spencer, come back and balloon to the bifurcation. That's good. Let's take that up.
Going up.
Go to 12 again. You have to realize that the robot never lets go of the
12.
balloon catheter, and so it'll store some energy, and the balloon will continue. See how it's come back well past the bifurcation, proximal to the bifurcation, down. Okay,
down
Spencer,
12.
take the balloon back in, and we're going to do a measurement. Tina, will you need a test there? Come back. Now, you want to go past the lesion and then back a couple of clicks. So back it up a couple. Stop there. That's about where we want it. We're going to let it sit for just a minute. Let's get a test now, Tina.
Okay, I'm ready.
That looks well into our distal landing zone. That's perfect. Now Spencer's going to back it up to the bifurcation. And first push reset on the device. Okay, so push reset on device, and we'll take that distal dot all the way back to the bifurcation. Okay, stop there. Remember, it's going to come a little bit more now. Click the millimeter by millimeter control and back it up one right there. Okay, so that tells us 27 millimeters. So this is often where guide catheter control gets really handy. This is a bit of an angulated, diffusely diseased segment. Sometimes we need to enhance guide catheter control to get a stent delivered. So we'll see how it goes. Stop there. Okay, advance your guide a little bit and pull back on the stent at the same time. Okay, and that'll seat your guide. Advance and pull back at the same time. Pull back more on your stent. Good, okay, now advance your stent.
और पेशेंट आ रहा है ना एक और
Good, stop there.
नहीं,
Let's take a
तीन
test, please.
All right.
मैंने दो देखे
I kind of like that. I would go in one dot. Just click it forward 1 millimeter there.
Huh?
And let's go up.
All right, we're going up.
And this may
I'm at 6.
12.
12.
Give me a little test, please. I
Okay.
think we may be back into the circ, but nope, it looks perfect. 16.
Going to 16.
And down.
16.
Okay. We'll let the balloon come down, take the balloon back into the guide, and we'll take a picture. Here's where you may need to pull back on the guide catheter because it's going to get sucked in as your balloon comes out of this. Yep, there you go. So you can actually push forward on the balloon and back on the guide catheter simultaneously to really get some guide catheter movement. Keep going until your guide comes out into the aorta. There's a, good, okay, let's come back on the balloon now. And be ready to go forward on your guide if your guide begins to slip way out as the balloon releases. That's deep seating the guide, but that's okay, it's a pretty normal vessel. Okay, now start sliding the guide forward and pulling the balloon backwards. Keep coming, you're good. Perfect, balloon out. Awesome, good. Okay, let's leave the balloon right there. Stop, leave the balloon right there, and let's take a picture. Oh, that's fine. That was that disease when we started, so that's perfect. You just absolutely nailed the ostium of that OM. Good job, Spencer.
So that was a wonderful demonstration of multi-vessel PCI, and I think, Dr. Buske, you would agree with me, this is a wonderful technology, both in coronary and endovascular field. And I'd like to have your comments, and maybe in future, maybe the next APVIC, we may be able to show some endovascular cases on this device because we are in a process of procuring this.
Dr. Khanna, do you hear me?
Yes, we hear you very well.
First, I would like, as course director, I would like to thank you for the work you did during 3 days with much volunteer, ability, and resistance to show us these marvelous 3 days of innovating slides and presentation from over the world. Thank you very much. Second thing, as ambassador of the International Society of Endovascular Specialists, which is supporting you, I would like to be present as ambassador for the society next year in person. It's what I would like to honor you this very good meeting this year, opening the way to next year. Now, I've been very interested by these novelties. Siemens is doing a very good job. We did together 6 months ago a Zoom with Singapore and the US. I think it will be the future, and the future is present. If you got a robotic system in your cath lab, Dr. Khanna, I would like you to train me as soon as possible, if you accept me during a weekend or something. This control is very accurate, very safe. Oh, the problem I see, and I don't want to be a bad player, but it's the cost. The cost is very important in terms of the system, the disposable catheter, and also the maintenance. So this could be reserved to academic center, which have a good budget, and devoted to the younger generation in order to be safer regarding the radiation, safer about the final result, and safer about the learning curve, as it was described by Ryan, who is a good speaker and a good promoter of the system. I've been impressed by Dr. Aaron, and I really express my thanks to all these people, including you, Dr. Khanna.
Thank you. And it will be an honor to host you in the coming year. If everything is fine, we'll probably have APVIC back to its physical form. And I really thank you and ISEVS for a joint collaborative meeting for last 12 years, and the meeting has really grown. And I've been just told that up till now we have crossed 10,000 registrations and people who have watched this 3 days of proceedings, and we have another 4 or 5 hours of the meeting left. And tomorrow, I must thank Siemens Corindus for bringing in their simulator for training. We have about 25 interventional cardiologists of good standing coming tomorrow to learn hands-on robotic PCI on their system at our center. So with this, I thank you again very much, and we move on to the next session. And Dr. Busquet, you would be happy to hear that APVIC has grown, and now this year we have 3 international sessions or chapters of APVIC. We have the Middle East chapter, we have the African and Nigerian chapter, and Southeast Asian chapter. And we have also started a new course, which is the International Nephrology, Interventional Nephrology International course, which we call the APNIC. And this, we have 4, the next session is devoted and conducted by APNIC, which will be the Nephrology Interventional course of APVIC. And we have Dr. Martin Merish from Bahrain, Dr. Rajnikant Rajagopal from Brunei, Dr. Oladimiji from Nigeria, who's been my fellow, and he is one of the rare cardiologists who is also a board-certified nephrologist. So he moved on from nephrology to interventional cardiology, and he's practicing in Africa, and Satish Babu from United Kingdom. So we have these 4 international moderators to moderate this session. And this session we have important and very eminent speakers, Dr. Rajnikant Rajagopal, who has got excellent work on AV fistula interventions. And I was fortunate to go and work in his lab a few years back. Dr. Martin Merish from Bahrain, who is an excellent vascular surgeon who does a lot of endovascular nephrology-related work. Myself and Dr. Gaurav Sagar, who is a very dear colleague and interventional nephrologist from our center. Dr. Sudhakar Rao, who is from India, he's going to be talking about transradial angioplasties in dialysis excess. And Satish Babu, who is a very famous nephrologist practicing in United Kingdom. So if you agree, we'll just start with the first talk by Dr. Rajnikant Rajagopal from Brunei.
Thank you, Dr. Khanna.
Thank you so much.
You are the most famous.
Yeah. Thank you.
Hello, my name is Rajnikant Rajagopal. Before I start my talk, I would like to thank Dr. Khanna and the organizers for inviting me to be a part of this meeting. It's always a pleasure to be a part of APVIC, be it in person in beautiful Delhi or online, as it's been last year and this year. My topic today is AV fistula intervention. What's new from the cardiologists? So I'm an interventional cardiologist. I work in a clinical JPMC cardiac center in Brunei. I specialize in complex coronary intervention with an interest in imaging and physiology. I first developed interest in AV fistula intervention about 5 years ago. I was visiting this hospital in Korea with my vascular surgeon colleague who sat down in the middle with me. We worked with these 2 interventional radiologists who were doing a wide variety of peripheral interventions, including fistula intervention. They had an excellent service where they fixed fistulas the same day from the dialysis center and sent them back so that they could resume their dialysis without needing any perm cath or any delays in their treatments. So we learned a lot from them, and we came back and set up a service in Brunei. It's been well established now for a few years, and we've done a few hundred interventions. What I've learned over the last few years is there are several skills and knowledge which, as a cardiologist, we are able to transfer to the field of fistula intervention. and today I would like to talk about one of them, the distal transradial access for AV fistula intervention. Now, traditionally, when we try to do fistula intervention, we have a few access options. We could go in from the cephalic vein, going antegrade up into the cephalic veins and the central veins. We could use the cephalic vein in a retrograde fashion, and that allows us access to the juxtaanastomotic region as well as into the artery. We can also go in from the radial artery, and this gives us access to both the arterial and the venous limbs of the fistula, and we can reach all the way to the central veins with this access. As an interventional cardiologist, this is my normal access of choice whenever the radial artery is available. Now, the distal transradial access was made popular in about 2017 by Dr. Kemeny from Amsterdam, who recorded his experience and published this article. He explained the technique of the left distal transradial access, explained the advantages of the procedures, and he also predicted development in the technique. Now, in the distal transradial access, we access the artery in the anatomical snuff box, which you can see on the top right picture. And that's, you can see the comparison of the anatomy on the left side. So when you put a sheath in the anatomical snuff box, the tip ends up somewhere near where your normal puncture would be. And that is usually the area where you tend to have the anastomosis of a radiocephalic fistula. There are several advantages of using the distal transradial access. It is a comfortable arm position for the patient because they don't have to keep their arm up with the palm facing up. If you are doing intervention from the left distal transradial access, the operator can still work from the right side without having to bend over. This is not much of an issue with fistula intervention because we will just stay on the other side. There is a low rate of radial artery occlusion. There is lower risk of bleeding because we have easy hemostasis. You have the option of saving the radial artery for potential future grafting. And in fact, the distal transradial access can be used to recanalize a radial artery that's been occluded from a previous procedure. Thanks to all this, there has been good uptake of this technique, not just in cardiology, but also in other fields such as interventional neuroradiology. This table shows you different publications where they have used distal transradial access for cerebral angiography and intervention. Now today I would like to talk about a couple of cases where we used distal transradial access for fistula intervention. These are fairly straightforward cases technically, and the focus really is on how we use the distal transradial access. So one of my favorite songs, "The Thrill Is Gone" by B.B. King, always a good reference to fistula intervention. Right, so our first patient was a 39-year-old lady who's been on dialysis for about 6 years, history of hypertension, asthma, and TB in the past. She had a right radiocephalic fistula for about 3 years. Recently she had poor blood flow and it was occluded, and she had no thrill for about 3 days. Examination showed just absence of thrill but no swelling or erythema. We did an ultrasound that showed that there were 2 areas in the venous limb filled with clot with narrowed segments in between. So this is a picture of the patient's fistula. The arrow points at the anastomosis of the radiocephalic fistula, and you can see it's pretty close to the rest, and therefore a normal radial artery access would not be possible here. Since we decided to go for a distal transradial on the right hand as it was. So we gave sedation as we normally do with midazolam 1 milligram. We injected local anesthetic, and then we used a 5 French pediatric 10 millimeter sheet. It's important to point out that when using the distal transradial access, we need to use open needles and not the closed needles which go through and through. So with an open needle, we got access and put in this short pediatric sheet. We then took a Burr-2 catheter along with Terumo 035 wire and made our way up. So the first picture is from the sheath, and you can see that it's filling the artery. And from there, we were able to use the Terumo wire or the Berthoud catheter to manipulate our way into the fistula. And you see the first picture on the right side, where there are two aneurysmal segments with a lot of thrombus in them, and the venous limb is very narrowed. We then proceeded to intervene. So using the Berthoud catheter, we were able to maneuver the Terumo 3-4 wire, followed by the Berthoud catheter. We then started our angioplasty. We did balloon dilatation with a Mustang 4x40 mm balloon. We saw better flow after that, but there's a lot of thrombus. We then inserted a Craig McNamara infusion catheter. We injected 2 lots of TPA into the venous limb, and that improved the flow, and some of the thrombus was resolved. So that is us checking the position of the Craig McNamara catheter. We did further dilatation with a 5 mm balloon, and the venous limb looked a lot better, and that was the final result. So at the end of the procedure, we had an excellent thrill back in the fistula. The sheath was removed. We deployed a compression device. We find the Nichiban Skep-T to be the most suitable device in this situation rather than a TR band. Patient was commenced at hemodialysis the next day. This is a picture of the same patient having dialysis subsequently. We did 9 months follow-up of the patient just clinically, and just measurements, and the patient had good flow in the fistula and had no issues. So the key points from this case is the fact that we used the left distal radial axis. A single puncture got us access into the artery and the vein. We were able to do successful angioplasty as well as thrombolysis, and we got easy hemostasis. The next patient was a 62-year-old man with a left radiocephalic fistula created about a year ago. He had poor flow for a few weeks. That's a picture of at the beginning of the procedure, where we placed once again a short 6-French sheath into the distal radial artery, and our very first picture showed severe stenosis in the juxtacomotic region. We passed a 035 Terumo wire. We dilated with a 3 mm balloon, and then with a 5 mm balloon. You can see a bit of wasting there. So we completed the angiograms first by passing the Berthoud catheter. We did our completion angiograms and came back to complete the angioplasty. We exchanged the 035 for a 018 wire. We tried a 5 mm scoring balloon, which didn't really work. Then we swapped for a 5 mm cutting balloon. The picture in the middle is an angiogram through the sheath to confirm the position of the cutting balloon to make sure it's not in the artery. Then we inflated the cutting balloon, which and the constriction finally gave way, and we got good expansion. And we had a good final result. We secured hemostasis using a Nichiban Skep-T device, and we were able to resume dialysis the next day. The points are again very similar. The use of the left radial axis in this occasion. Single puncture, we were able to use 035 and the 018 system, including a cutting balloon, to get a good final result. So that's our experience, and we've done maybe a handful of procedures in between then and now. To be honest, there's a team of us, that's me and the vascular surgeon. The vascular surgeon still prefers to use the cephalic vein approach. If I do the brachiocephalic fistulas, I tend to go from the radial artery. But if I'm treating a radiocephalic fistula, I do try the distal radial axis, which makes, and if you get through, it makes the procedure quite simple and elegant. So while looking through the literature before this talk, I found this article from the US, so where they had reported their experience with the snuff box distal radial artery axis. They compared this with direct fistula axis. They used ultrasound guidance for all their punctures, and I think that is a good idea. They only used hand pressure for hemostasis. I'm not sure if that's a good idea. They used it in about 17 out of the 68 patients with radiocephalic fistula, a quarter of them, and all of them are successful. They found that the main procedure types are similar, and they had minor hematoma in about 12%, which is compared to just 2% of the direct fistula axis. I do wonder if compression device would have been better. There were no major complications though. I think that's quite useful, showing the feasibility of this axis. for fistula intention. So to conclude, distal transradial access is well established now in coronary intervention, and it could be an option for treating AV fistulas, especially radiocephalic fistula. A single puncture could give access to the artery and the vein. It is suitable for treatment of fistula and central veins, including adjunctive techniques, as long as they all fit into a 6-vein sheath. Hemostasis is easy, and there is a low risk of complications. I would like to...
Thank you, Rajni. That was great. And I do remember the times when I came to your hospital to do some cases, and you've been to our meeting many times. Now let's move to Martin Merish. Is Dr. Merish there? Yeah, I see him. So he's a very, very close friend from Bahrain, who is a terrific vascular surgeon and also specializes in endovascular management. One of his interests is central vein recanalization and SVC interventions for SVC syndromes. So I've asked him to give 2 talks. One is on SVC syndrome management, and the other one is on complex chronic venous recanalization. They are pretty similar topics, overlapping each other. And Martin, if you're okay, we can give both the talks back to back.
All right. Thank you very much, Dr. Khanna. Thank you for an invitation. It's a great honor to be a part of this platform, and I have to tell you, it's incredible work what you are doing the last 3 days. Let me just go ahead. When we are referring to central venous occlusions, we are referring to superior vena cava. The obstructions are usually of malignant character or post-dialysis and central venous catheters, fibrin sheets and thrombosis. So we'll be discussing both. According to the data, there was recently published studies showing 100% of composition of this fibrin sheet around the catheter. So it's always there. It's not only the thrombosis we are dealing with, it's always this fibrin lesion and strictures, and this make these venous interventions very specific. And whatever you have learned from the arterial work doesn't work really here. This is how the venogram is looking, identifying the fibrin sheet, and this is where it can go. You know, the superior vena cava is quite huge, and the pressure and the velocity is quite low, so it's forgiving. But when it's completely occluding, then you can see this kind of picture with shortness of breath and the feeling of suffocation, and it's very traumatizing for the patient. It's defined as increase of the pressure over 20 millimeters of the mercury, and in this setting you can consider the internal jugular pressure, the SVC pressure as well. This is the classification according to the clinical status of the patients. On the venogram, we usually classify the occlusion according to the presence of the collaterals. Sometimes we measure the gradients, but it's not really, informative because it's very low pressure anyway. Then you can measure the area of stenosis, but in veins, especially in a chest, it's very tricky to really measure it precisely. I personally prefer the IVUS intravascular ultrasound in all the cases in this region. In regard of the procedures, these are quite long procedures, usually needs much more than one access, 2 or 3, always the femoral, sometimes popliteal, depends on these patients are usually elderly, very complicated, post multiple access before, so you might expect some iliac venous stenosis as well, and you need a big sheets because for the stenting you need 10 French sheets. So the general rules, all the procedures have to be planned precisely in advance. It's good to have a good anesthetist around, and majority of these cases we do on the general anesthesia. It's much more comfortable for the patient and the operator, and using Atlas high pressure balloon is very often painful, so don't get frustrated. the very untraditional techniques are often needed in these cases. You know, very often we go for sharp recanalization techniques. There's nowhere else, and unfortunately, the balloon angioplasty alone is very rarely effective. So the stenting is usually needed. We still don't have a dedicated, really like ideal venous stent. There are dedicated stents, but not ideal. They're quite rigid. They need to be very big. So with high radial force, it's very difficult to manufacture ideal stent. This is our setup with the IVUS all the time around the angiojet to deal with the perioperative complications. We do the CT or MRV in indicated cases, going for venography and the IVUS. In these cases, the venography itself might be very misleading. You don't see the channel, you see just a network of collaterals, and also the rupture is a possibility. This is how it looks like. The IVUS is mandatory. In cases that the patient is still not on dialysis, we use the CO2. These are the techniques of stenting, because the stenting is often unavoidable. The complications are quite rare, and I have to say in our cohort of the patient, and we have plenty of patients on dialysis, what we are dealing with it's very safe procedure. And I have done perhaps like 2 open procedures within last year. So if there is a big difference between the endovascular and open procedure, which needs sternotomy and very often cardiac surgeon to be around, and the patency is very similar anyway. This is an example of the simple reconstruction and stenting. This is much more difficult case, which is showing very short occlusion at this level, but unfortunately, you know, very often it's not as easy as it looks like. This is a complex reconstruction of the SVC. You can see still the perm cut which is there, because still we get these veins open. I kept the perm cut and then just insert the wire over the perm cut and then removed it. You can see the very short distance, but it took 1 hour to get the wire into each other. Then we did the ballooning from one side, another side, kissing balloon in the SVC, and the reconstruction with the double barrel stents. A very nice flow with no collaterals, which gives you the idea about the result. So in conclusion, the symptomatic occlusions, they need to be open to decrease the pressure in the upper half of the body and the head itself. Endovascular approach is definitely now the treatment of choice. You have to be very familiar with the venous pathologies and the anatomy itself. So very often it needs CT venography before. And it's good if it is done in a specialized center, and it's good if the cardiac surgeon is around as well. But on the other hand, these are very gratifying procedures with immediate relief of the symptoms. This patient suddenly can breathe freely. The edema is subsided within first 6-12 hours. So these patients are very, very thankful after the procedures. So I'm happy to take the questions, perhaps after the second talk. Dr. Hanna?
Yeah, so Martin, that was perfect. Can we have your second lecture together? We'll have the discussion in the end.
All right. Can you see the lecture?
No, not yet.
Okay, just give me a second. I'm sharing this one. It's supposed to come up.
Yeah, now we see complex endovascular revascular.
All right. So the second presentation, I personally, I just love it because it illustrates the rapid evolution of our specialty, coming from the knife to the wires and the balloons. And especially in the venous procedures, where for many decades was removing the varicose veins, basically the only procedures we used to do, and the deep venous thrombosis for years and decades was basically medical diagnosis for anticoagulation. But this has changed dramatically. So let me just go through the couple of my cases. This was a lady who came with the left leg swelling and pain. Ultrasound confirmed acute iliofemoral deep venous thrombosis, and the eye was revealed chronic occlusion, which was basically the cause of her acute DVT. So we started this catheter-directed thrombolysis combined with angiojet thrombectomy. And then we did the angioplasty and the stenting with immediate relief of the symptoms. Here you can see the run of the IVUS. Without the IVUS, it would be very difficult to identify the chronic lesion. You can see the complete occlusion at the level of the May-Turner syndrome, May-Turner point. So the IVUS is mandatory again, and this is the base of the balloon and the stenting. And the nice flow afterwards. You can see the post-procedural IVUS, which we always do, showing nicely open iliac vein. This is the stent, fully open, a little bit compressed, which is always there, the May-Turner compression point. And this is the femoral ultrasound, which we do after each procedure, and it's extremely important because the inflow is the key in these procedures. Second case, it's also the young gentleman. Very often these are young patients. And he was having neglected 3 years DVT linked to trauma, and he developed massive post-thrombotic syndrome with open ulcers. And unfortunately, in his case, the occlusion went all the way up to the renals. So it was very difficult case, very difficult recanalization, stenting. It was a case which was complicated with on-table partial thrombosis of the IVC, the upper stent, which we deployed in the IVC, despite the full heparinization and ACT control all the time. We dealt with this successfully with the angiojet thrombectomy immediately, and at the end he was having the great result afterwards. You can see the venous ulcer here, massive collaterals developed after 3 years. This is the IVC. This is the run of the IVUS from all the way up. This is the IVC. You can see the chronic fibrotic changes in the IVC. Basically, no lumen at all. It took like two hours to get the wires all the way up with looping and different techniques with glide wires and sharp recanalization combined with a hydrophilic catheters as well. You can see the base at the level of the IVC, at the level of the pelvis. This is the thrombus, which was there immediately afterwards. It was dealt with the angiojet. Angiojet is amazing in this case. You could see the thrombus there. Angiojet is amazing because you can direct the suction. This is the result at the very end with a good flow and augmentation and Valsalva. Patient was very happy after the procedure. The last case, it was a lady with acute DVT, but unfortunately she came very late to our clinic, which was like more than 6 weeks. So we left her for 6 more months for the acute inflammatory period to just go away. And unfortunately she has developed severe post-thrombotic syndrome. She was unable to walk. When she came to me, she was wheelchair dependent with the whole family. She was crying, and this is how she looked like after 6 months post the massive DVT. This is the initial venogram. You can see the base of the balloon and the anatomical variation. And she came immediately afterwards, walking, smiling. It's very gratifying, the procedures like this. This is a gentleman. This is the last case. Young fellow who was unable to get married because of post-thrombotic syndrome, post-trauma in childhood. Unfortunately, the fibrotic lesions were going all the way down to the groin in his case. So I was unable to get a good inflow despite pushing, my catheters into the profundal vein. I was unable to get the deep femoral vein, and deep femoral vein in this case is the crucial to get the good inflow. So I was not happy with the inflow, and I opened it up and I did the endophlebectomy, which is like endarterectomy, kind of in the venous bed. So let's go through the images. You can see the chronic venous ulcer, which was coming and going on and off. This is the femoral part, and you can see that it was impossible to identify the deep femoral vein. This is the vein in the iliac, and the initial venography, and this is the open part of this hybrid procedure. You can see this fibrotic mass which was in the femoral vein. We opened a couple of, there were 3 deep femoral veins here, and I closed it up with the contralateral great saphenous vein page, and this is the sheet into the pitch, and we finished the stenting all the way down. And this is the good iliofemoral flow afterwards. And here you can appreciate how fast is the improvement. The patient is still having the dressing, so it means it's like 2 weeks maximum. And look at the venous ulcer already getting smaller and smaller. So the chronic venous obstructions can cause the severe morbidity and with a high recurrence. The treatment is to provide unobstructed venous drainage. The complications, early instant thrombosis, you have to have the IVUS on side all the time. If you open the groin, very often there is a wound complication, sometimes bleeding because of the high heparinization, massively giving heparin. We are starting with 10,000 units, checking ACT every 2 hours. But in conclusion, it's the endovascular treatment with venous stenting is first-line treatment for this obstructive venous disease. It's recommended by all society, and the surgery only in case of the failure. Intravascular ultrasound is a mandatory tool to get you out of the trouble. Venous stenting unavoidable very often because of fibrotic lesions. Very often very long segments. There is still no ideal venous stent on the market. Treatment of choice that reduces post-thrombotic morbidity, and it works immediately, and you can really change the quality of life of our patients. So thank you very much for your invitation again. It's a great pleasure to be with you. I'm happy to take questions. I cannot hear anything now.
Professor Khanna, if you don't, can I start with the question?
I can hear you.
Yeah, Dr. Maresh, can you hear me?
Yeah, I can hear you very well.
Yeah, wonderful presentation. I mean, it's very innovative, chronic venous occlusion recanalization. Just a quick question. Is there a role for the similar role for acute venous occlusion? Is it going to change the landscape of the way we treat DVTs?
Yeah, I believe within the last 10, 12 years, it has changed dramatically. And at least in our institution, we opened a special venous program collecting all the cases of DVT all around the region. And as long as the DVT is involving the femoral vein and above, so iliofemoral vein, we always go ahead with thrombectomy or thrombolysis. Depends on the situation, depends what is the cause of the DVT, but we don't go for the proximal DVT. I don't think so the anticoagulation is a treatment of choice anymore.
Yeah, I would agree with Dr. Martin. You know, this is what we do, and this is what we teach our colleagues and our interventional friends and the emergency doctors. If you have a proximal, you know, if you have a iliofemoral DVT and patient comes in time, don't waste time on heparin, and you know, go inside. If the patient can afford, go inside with a catheter, lyse, or take out the clot, or do a, you know, thrombectomy with a dedicated device. You're actually going to save this patient of a lot of problems later on. The patient is going to preserve the valvular function, and the patient is not going to, the chances of getting into recurrent DVT would be very less if you completely take care of the DVT in the first go. And you would many a times uncover either a May-Thurner, or you may find some prothrombotic state. If you can take care of that subsequently, these patients are going to do well in future. So we may have some questions later on. Let's move on to the next speaker. It will be my very dear colleague, Dr. Gaurav Sagar. Is Dr. Sagar there? Yeah, I see him there. So he is a very popular nephrologist who works in the same hospital, and he specializes into tunnel catheters and has a lot of interest in interventional nephrology. So Dr. Gaurav, you have another 8 minutes. We can see your slide. You just have to go to the presentation mode. Yeah, now it's there.
Good evening, sir. At the onset, I would like to thank you for this invitation, and it's a matter of pride and honor for me to be part of this APVIC as usual. And I would really thank Dr. Khanna, who has been my mentor as far as interventions are concerned. So I'll be presenting two cases in which I'll be telling about the insertion of tunnel chronic dialysis catheters, the perm cath. This is the first case is about a 45-year-old gentleman who was on peritoneal dialysis and who had multiple failed vascular accesses in the past. He was being worked up for renal transplant at a different center, and he came to us for basically transplant. And when he came to us, we found that he had pain, abdominal hypertension, and had fungal peritonitis, and the CAPD catheter through which he was getting dialysis had to be removed. So he received 2 sessions of hemodialysis through the right femoral vein access. On the left side, we couldn't see the vein through Doppler also, and since the right femoral vein had to be preserved for transplant, we decided that we should do an angio and see which veins are patent. Clinically, he had all the features of central venous stenosis. So the right femoral vein was patent, and here, as we can see, there was complete right-sided SVC, the central venous stenosis was there. And on the left side also, the brachiocephalic was obliterated. And similarly, on the right side also, there were multiple collaterals on the chest, and we couldn't cross the vein. But fortunately for us, we could access the vein on the left side of the neck, and we then introduced the wire. And here, when we did an angiogram, we could see that there were multiple collaterals, and on further reviewing the angiogram, we could see that we were into a very big collateral, and we could see that it was going all the way down, and then it was coming up.
Before I told you, will happen something, you know, when he...
So even in the lateral view, we could see that we are in a main collateral, and we were not actually into the internal jugular as it was looking like. And here again, this angiogram confirmed that we were in a collateral. So we were in a difficult situation because his CAPD, we couldn't do the peritoneal dialysis. And since he had central venous stenosis, the right femoral vein had to be preserved. So what was the option with us? Since he was being worked up for transplant, and we were thinking that after about 4 to 6 weeks, we could give him a transplant, we decided that let's try to do the tunnel dialysis catheter in this collateral itself. So this is the tunnel dialysis catheter in the collateral, but you can see there are some kinks over here. So we just pulled the catheter slightly backwards, and finally we could get good flows in this catheter. So this is the final position of the catheter on X-ray, and fortunately for us, we could use this catheter, the tunnel catheter, for about 4 to 6 weeks before he could go for a transplant. So to summarize, this was just a desperate measure, but definitely not a recommendation. And we reviewed the literature also, and we found that there have been few case reports where abdominal collaterals have been used as vascular access. So there's one more case which I would like to present. This is about a female, 24-year-old female who had undergone renal transplant about 7 years back, and who had now revisited end-stage kidney disease and was started on hemodialysis through a left radiocephalic AV fistula. Before getting transplant 7 years back, she had received hemodialysis for about 8 weeks through a temporary dialysis catheter in the neck. And this time she came with moderate left-sided pleural effusion and uncontrolled blood pressure. She was started on antitubercular medicines after pleural fluid analysis, and she came to us with progressively worsening paraparesis with frequent falls, and her father had to literally lift her up and bring to us. So this, we could see she had features of central venous stenosis and had some collaterals on the neck. And this was the chest X-ray with which she came to us. So in view of paraparesis, neurological consultation was sought. A detailed evaluation was done, which was not contributory. And since she has paraparesis, INH and later microbital was stopped, hoping that her paraparesis would improve, but there was no improvement in her symptoms. And since she had refractory hypertension also, we decided to do a CT scan, and that showed that the brachiocephalic on the left side was obliterated. So we decided to attempt angiography and try to open the vein on the left side, but unfortunately we could not cross the wire. And since she was getting dialysis through a left radiocephalic fistula, and this is the angiogram of the left side where there are multiple collaterals. And now, since we couldn't cross the wire on the left side, we decided to close the fistula on the left side. And for future, we decided that let's check the vein on the right side. The right subclavian was checked, which also had stenosis, which was stented. This procedure was done by Dr. Khanna. And 4 days later, surprisingly, this is what we got. Our chest X-ray had improved completely. This is the stent on the right side. The left side effusions had all disappeared. So we discussed with the neurologist also. So his take was probably that she was having dilated vertebral channels and congestive venous myelopathy, and the high AV fistula on the left side was contributing to it. So for this girl, we did a right radiocephalic AV fistula, and meanwhile she got dialysis through a femoral perm cath, and after 4 to 6 weeks, she was able to get dialysis through the right radiocephalic AV fistula. And after 6 weeks, she came walking to our clinic, which was very, very gratifying. So as a nephrologist, what are the lessons which I learned from these 2 cases are that in patients who have chronic kidney disease, it's really important to respect the central veins and avoid them as much as possible. In our practice, we try to convince our patients that whenever they are in CKD stage 4, when they have not started dialysis, we try to convince them to get the fistula. In any dialysis unit, there would be about 5 to 10% of patients who would have difficulties in their access. And many times it's the central vein which is the culprit. This is what I had to share. And I would like to thank again Dr. Khanna for this invitation and for the honor. Thank you, sir.
Thank you, Dr. Gaurav. That was wonderful. And I do remember doing both these cases with you, and we did a lot of brainstorming to actually know in the second case to actually understand what's happening. And it was very dramatic to see this patient who could not even, lie flat walking after a few weeks. So that was one of our good cases, and to learn a lot, we learned together. So then we have another speaker, Dr. Sudhakar Rao. He's going to be speaking about transradial angioplasty for dialysis excess. Another young cardiologist from Manipal, and he's an associate professor in the Department of Cardiology at KMC Manipal. And he specializes also into the fistula angioplasties, and like Dr. Rajnikant, he has an interest in using radial arteries and distal radial arteries to actually do this fistuloplasty, which has a lot of advantage to my understanding, and whenever we get a chance, we try to go through the radial artery.
Am I audible, sir?
Yes, you are audible, and your slides are visible.
Thank you, Dr. Anand Khanna, sir, for giving me an opportunity to present in this APNIC. So my topic will be a transradial angioplasty for thrombosed hemodialysis excess. So we all know the renal replacement therapies can be via the AV fistula and graft, the central vein catheters, the pump catheters, the peritoneal, and the renal transplant. However, I am going to talk on the AV fistulas and graft, which presents to us via most oftenly in an occluded state. So there are various methods described, like the retrograde puncture, the direct antegrade puncture, that is the transradial and the distal radius or the snuff box puncture, the fistula puncture, which can be both on the arterial and venous side of the fistula. Then we can have a thrombolysis followed by thrombectomy, and then the balloon angioplasty, which is my area of talk today. In very rare instances, the DEB, which is the newest article published in the NEJM, have described the use of DEB in a stenotic lesion, but not the thrombotic. And whether to stent in a case of a dissected vein is the question. So I'll go via a few of the cases. So the most commonly we encounter the case of in our center is the most commonly the brachiocephalic fistula, which is the most common, and we can see the site of occlusion in this case. That is the right brachiocephalic fistula. Our approach is to take the termo and then cross with a microcatheter, stiff wire, and then take the balloon. Usually in a brachiocephalic, we usually use a 6 balloon, and at the outflow side, we usually use a 7 to 8 mm balloon. So you can see after a 6 balloon, it's mostly the thrombus, and which usually has cleared after doing a balloon angioplasty to most of the full segment. So how did we decide on which balloons should we use? So initially in our 20 of our cases, we did a surveillance IVUS, and we realized that the outflow site in most of the cases is around 7 to 8 mm, and the inflow site is usually 6 mm. Sometimes it can be some 5 mm, but so out the first 20 cases, we did a surveillance and decided that our further cases, we use this balloon for our angioplasty. Now, this is another case where we can see a radiocephalic fistula complete occlusion. In most of the radiocephalic complete occlusion, our approach is usually the distal radius or the anatomical snuff box, unless it is little distal in the arm, where we use the distal most part of the radial artery. So the approach is again the same. We usually do a cross with a termo wire and put a microcatheter stiff wire, and then dilate the entire length, usually a 3 to 4 mm balloon. So this again, you can see a good opening of the fistula. And this again, we have done the initial surveillance of our few cases where we saw that the fistula was usually 3 to 4 mm at the outflow site, and the inflow, the anastomotic site is usually, sometime it can take even up to the 5 mm balloon. Now, in many cases where we are not able to balloon to cross the fistula, or where the nib of the fistula is not seen, we have tried using the transfemoral puncture and then going via this site, as you can see, and then we usually take both the side, and then we usually use a snare. So usually you can see here from the arterial side, we cross from the venous side, and then usually take a snare, gooseneck snare, and then usually complete our work. This we have done in few of our cases, the snare technique, and then take the catheter to the SVC, exchange it with a stiff wire, and then again using a 6 and 7 mm balloon, finish the procedure. The next we usually encounter in our case is a fibrotic lesions. These are usually we see in 20% of our cases, very hard lesions these are, and we usually use initially the normal balloons, which are Cook balloon or the Armida balloon, the 680 or the 640 balloon. But usually we can see a significant waste at the fistula, which we then open with a Mustang or a Bard balloon. The Bard usually goes up to the 30 atmosphere, and the Mustang, the burst pressure is around 24 atmosphere. So you see there is a good opening with the Mustang, and then we have a good flowing fistula. So the stenosis, if it is well dealt, the fistulas run for quite long. Now there are two cases which we had encountered till now, which are very highly fibrotic. So even you see, we usually tried a 640 Cook balloon and then a 540 barred balloon. None of them were able to yield the lesion. Then we used a 640 Mustang and 840 Mustang after doing the IVAS, which showed that the inflow site was around 8 mm. This was still not able to yield the lesion, very significant stenosis. Then I took a 4 NC balloon, still there was no, and then I had to use a OPN NC, a 3.510 OPN NC on the self, which actually without making a dog boning, it had opened the lesion. And after that of 840 at its burst pressure, you can see that there is significant dog boning, and that with around 30 to 60 seconds of the lesion opened, and then there is a good flowing fistula. So this patient is still following up 2 of our cases where we used OPN NC to open such a highly fibrotic lesion. It worked, and the patients are still following up with without a recurrence of the lesion. Now, there were cases where we had difficulty in crossing with a turmo, and here I'm sorry that there was no video available. There was a significant brachiocephalic fistula, complete occlusion with a significant stenosis of the brachial artery prior to that. We had to use a Gaia 1 to cross the lesion, after which we exchanged it with a turmo and then used a 540 Cook balloon at the inflow entire length. What happened is, after opening that, the radial artery had completely gone off, and the brachial artery, there was complete occlusion because there was a significant residue at its origin. We had to use a 4 NC which opened that, and then we had to use a bifurcation using a coronary hardware, a 6 French guiding kite with 2 wires and a 3 balloon each. After which we can see that there was opening of the brachial artery. So this, sometime if we had a thrombus in the brachial artery or a significant stenosis just prior to the AV fistula, there will be a dislodgement of the thrombus in the brachial artery, and which can cause the occlusion. So overall, this was our recent publication with a transradial percutaneous intervention. We had around 150 patients over last 3 years, and the clinical success rate was around 82%. The primary patency rate was 90.25% at 3 months, 82.93 at 6 months, and 73.18% at 1 year, with a great secondary patency rate of 94% at 1 year. So the take-home messages are the transradial approach, including the distal radial and snuff box, have lesser complication rate, faster recovery, and early mobilization. They have a good primary and secondary patency rates. However, is there a role of routine surveillance of AV fistula and graft so that we can do this at an earlier stage, maybe at a stenotic stage and not the completely thrombose stage? And if fails, the other options would always be standby. As I told, we can take both the transfemoral and we can do a snaring or other options, or even the direct fistula puncture. Most of the time, which we have tried fistula puncture, there was very difficulty in doing it. And the role of high pressure balloons in the highly fibrotic lesion, as in this case. I would also like to then, till now we have done around 400 cases of fistuloplasty in the last 7 years with the good success via the transradial and the balloon angioplasty. And hardly 2 patients needed a short stenting at the anastomotic site. We cannot put long stents because of the problem of needling at the fistula to gain access. So I'd like to conclude here. Thank you.
Thank you. That was a wonderful talk. And then let me invite Dr. Suresh Babu, who is a nephrologist from United Kingdom, to actually show his case, because that would really, it's a good case to actually discuss. And it's like a case that what we need to do after that, after presenting this case. So jointly we will be discussing it after the last talk. So he would be speaking for the next 8 minutes. And then after that, I will be presenting a case, and then we'll have a joint discussion. So over to you, Dr. Suresh Babu, who is a consultant nephrologist at the Royal...
Satish Babu, Dr.
I'm sorry, Satish Babu, I'm so sorry.
No, it's all right.
Who is a senior nephrologist at the Royal Wolverhampton Hospital NHS Trust in United Kingdom.
Thank you, Dr. Khanna. It's a great pleasure to be among such wonderful people, and I really wish I mean, people in Delhi are very lucky because of such a wonderful service, interventional nephrology service. And in the UK, all interventions for fistulas are done by interventional radiologists and the vascular surgeons. Nephrologists, as such, we do the tunnel lines, biopsies, and the temporary lines for our patients. All tunnel lines in our center are done by us. But anything more than that, it's up to the interventionalist. So I'm going to share this very interesting case, which we got into trouble very early in the dialysis life. Patient is a 32-year-old female. She's type 1 diabetic since the age of 10. She has all micro and macrovascular complications of diabetes with retinopathy and neuropathy. She had extensive laser treatment for the eyes. She's blind in one eye and partially sighted in the other eye. She had diabetic nephropathy, and a baseline GFR was around 35 mils per minute. So CKD was progressing. We anticipated that maybe she might need dialysis in the next 2 to 3 years, but unfortunately she had admitted with sepsis in another hospital nearby. She went to visit the relatives and got admitted with sepsis. She spent 4 to 5 weeks in intensive care, at which she developed AKI on the background of CKD and never recovered her renal function since then. The dialysis, obviously, in the ITU was done with the perm care, with the temporary line. And then when she came to our center, because as she was local to us, first thing we did is we did a right-sided tunnel dialysis catheter, and we referred our patient to the vascular surgeons for a permanent vascular access. The bilateral Doppler showed small-sized radial veins, and there was a good brachial vein, and they decided to do left brachiobasilic AV fistula with good flows. Was going on smoothly. In between, until she got the fistula done, she had to have multiple lines in both femorals and right-sided neck. Left side neck, we didn't touch it, but she had catheters in all other 3 central veins. Even though we tend to avoid and get the fistula first, but this patient, there was a long delay because multiple cancellations. She was not turning up to the surgical vascular clinic, and sometimes even canceled the theater, had to be cancelled the theater list. And so since the time of fistula, dialysis was taken care of, access was not an issue, but she had multiple hospital admissions with both hypoglycemia and DKAs, which did, and also the COVID pandemic was thing, and that delayed some of her work up for transplantation. Finally, when we worked up for transplantation, she had a very low ejection fraction and was not suitable candidate for transplant listing, they said. And then we always wanted to look for other options. What if this fistula, if she gets into trouble? And we did counsel about peritoneal dialysis. She also had some diverticulosis and diabetic gastropathy, and patient was not keen for PD, so hence she was not a candidate for peritoneal dialysis. In April this year, left arm started swelling, and the Doppler showed left subclavian vein stenosis. She had 1 angioplasty with good results, but the stenosis recurred, and second time when they tried to do the angioplasty, it failed because the patient could not tolerate it. It was very painful. She screamed, and we had to get her out of the room. We thought under sedation, we will attempt a further angioplasty. But within that time, fistula clotted, not surprising, and we couldn't declot the fistula. This happened on a Saturday. We couldn't dialyze at all. And Sunday, we got her admitted. We treated with potassium binders, made the potassium safe. And on Monday, she had a central venogram which showed bilateral external iliac veins were occluded. Right IJ was narrow. We could not put a tunnel catheter in the right IJ. And the right subclavian vein was patent. And we know the left subclavian anyway is stenosed. So what we decided, usually we have a vascular MDT on a Monday morning, but we called this urgent MDT after this venogram and then decided what's the best way to proceed. And our vascular surgeons, a couple of them, after discussions, they decided the best way to do is left to right necklace graft. We've had this done in the past, but not for such a young patient. Within 3 years of dialysis, we had to get to this stage of using a necklace graft. And she had the graft on Friday, but for that we had to put a temporary, because she was not safe to go to theater, we had to put a right IJ line, dialyze for 2 consecutive days and take the line out. And Friday she had this procedure. And so far the dialysis is going on quite well. Now we are really concerned about the vascular access, and we are talking with the transplant team again with further cardiac investigations to see, yes, she's a borderline, but whether we can somehow look at the transplantation again. I just want to show this picture of the necklace graft from left to right. This is one of our recent dialysis session. We took this picture. So I think what I would, in the UK, we always go for fistulas and not the grafts. I was wondering the experience from other parts of the world, whether in this particular situation or in select individuals, whether graft can be a preferred option instead of fistulas. And also now, yes, we've got this necklace graft, but there is always chance that it might stop working. And if it does, what are the options do you think the team might suggest? So I'll open the floor for discussion.
So Dr. Gaurav is there. So we have Dr. Gaurav and Dr. Martin. So Martin, what would your approach be?
These are all interesting cases. You know, we also prefer here to go for native fistula as much as possible. That's why we are opening so much the central venous occlusions and trying to keep them open, because you know the one thing is to cross the lesion then put a stent, but the other is to provide long-term patency as well. So there is also discussion about like how what is the medication you keep the patient on post venous stenting, you know, if either to just keep them on lifelong anticoagulation or combining with antiplatelets. That's one thing. Anyhow, if this is gone, or all native fistula options are gone, then you have to go for some kind of bypass. And as alternative, I can just propose perhaps to use the hero graft. I'm just getting it. I don't have my own experience. I'm just getting it this week. 2 pieces. We have candidates for the procedure, so this might be an option. You know, because the inflow is usually easier to find than the outflow. So the hero graft with the catheter, which you can insert even through the occluded central veins, might be an option for these cases.
Dr. Gaurav, how would you manage such a patient? And you see a lot of these issues in your practice.
So I would like to answer the first question before, whether grafts are more suitable for a certain subset of patients. I think a lot of elderly who have poor veins, our center would prefer doing an AV graft. The risk of infections is definitely higher in our centers, but if proper care is taken, in the sense you educate the dialysis technicians how to keep on rotating the site, I think graft is also a good viable option for these patients. And endovascular interventions, I believe Dr. Khanna would be able to answer this better, are easier for patients with graft compared to access, the native fistula. And I fully agree with Dr. Martin that yes, for a patient with the patient you presented, hero graft is an option, although in our country also we have very limited experience in that. There are certain centers who have been doing it, but the experience is quite limited. But temporary catheters, there are few centers who are doing transhepatic, translumbar, and down south, there are certain centers who are doing the IVC catheters also, the translumbar catheter also. But I think the hero graft is a good option for this patient.
Sure. Thank you very much, Gaurav. I think, yeah, we've kept that. We've never used Eurograft. That's something which I will discuss with our surgeons. But yeah, translumbar and IVC catheters is an option. I mean, yes, we're thinking, but again, these catheters are temporary, isn't it? I mean, we need to look for
these are just, I would say, a bridge for transplant. Ultimately, you have to, for a young patient like her, you have to look for transplant.
Absolutely. Thank you very much.
Unfortunately, these patients are so complicated. These patients are usually not the candidates for transplant, you know, rejected from many other reasons, usually full of comorbidities or unable, you know, to find the location of donor. That's the problem.
That's absolutely true. And in any dialysis unit, there would be at least 4 to 5% of patients who would behave like this, who would have difficult vascular access, not good candidates for transplant also.
Yeah, I think we've had over the years many patients in this situation, but the tricky thing with this patient is it's only she's very young, she's only 32 now, and it's only 3 years of dialysis life she's gone into such severe complications. And my next worry is if the transplant, the external iliac veins are occluded, so the surgeons will question where we're gonna get the vein, I mean, transplant into. That's another challenge.
Can I just the last question, gentlemen, for both of you? What is your tactic for the medical treatment after this kind of procedure, so complicated, access? Do you keep this patient on anticoagulation, or you just keep going with antiplatelets or nothing?
Yes. So for my patient who has difficult vascular accesses like this and who's thrombosing multiple times, I would keep them on a small dose of acetrom or maybe warfarin, small dose. Antiplatelets generally don't help, but I've seen, although there's no literature, but this does help these patients. Acetrom 1 milligram or warfarin maybe 1 milligram, that does help these patients.
Regardless of INR, yeah? You don't even check INR.
Yes, regardless of the INR.
Now, we use warfarin regularly in all patients who has grafts, and we maintain the INR between 2 to 2.5.
Can I ask, hi, it's Raj here from Brunei, in Singapore now. Can I ask everyone in the panel, hi, Dr. Khanna, a simple question. I saw Dr. Sudhakar Rao present the beautiful cases, radial access interventions, and he used angiogram, fluoroscopy, and panning across from the arm to the shoulder, which was very good. We always use DSA in our practice. Can I ask, some of you are very experienced in this, is there an advantage of DSA over this angiograms? Because, I'm mostly comfortable with angiograms. That's what we do for the heart. But when I started doing fistula intervention with the vascular surgeons, they taught us to do DSA. And we are sort of stuck with that habit. And then I saw all these cases. And so are we wasting radiation and time and effort in doing DSAs? And should I just be doing angiograms and just panning across one view? What's your practice and what do you recommend?
It's a great question. It's very obvious. You have a lot of cases as well. Sometimes we are looking like crazy dancers, dancing around the patient, because as I mentioned, when you do these complex cases, I usually go with like jugular, brachial or radial and the femoral, because I always put the stent from the femoral and trying to snare the wire, and because it's the safest as well. It's the stenting is sometimes very tricky, and if you have a wire from the brachial all the way to the femoral, then it's the safest stenting you can possibly have. So anesthetist is very often just laughing what I'm doing, because I'm dancing around the patient, doing this and that, and I'm using the angiograph because you can move the table. Sometimes you need to see the flow in the long segments, so I move the table, and this you can do only with angio. You cannot do this with DSA. So I'm combining, both of these. I'm trying to stay away. It's also difficult because the radiation load is amazing in these cases. So you have to keep protecting the team, yourself, and the patient as well. So I'm trying to combine it in regard of the situation and specific patient and the location as well.
Okay, so that was good, and I think we are running late, and we have Dr. John Eichelboom, who has been a primary investigator for the COMPASS trial. He's going to be giving an oration after this, so I'll quickly end this session after my talk, and this is something unusual from the nephrology side. We work closely with our nephrologists, one of them are here, and ours being one of the largest volume renal transplant center also has a very high load of dialysis, and there are a lot of patients with, a central vein catheter for dialysis, and then many of these would land up with clots related to, the catheter, and some of them are really big, and they actually give us a very potentially catastrophic situation. So I'm going to be speaking on this. Let me just give you an example of a case, 35 years old male with end-stage renal failure on hemodialysis. He was a transplant, he had a transplant rejection and was on maintenance hemodialysis and was a prospective patient for renal transplant. Again, the second transplant, there was history of pulmonary embolism in the recent past, and the recent workup actually showed there was 6 centimeter thrombus in the right atrium attached to the right atrial wall and to the internal jugular vein. This is the CT angiogram. You can actually see a big thrombus in the right atrium. Again, this is the same CT showing that there is a catheter, and below the catheter there's a huge thrombus in the right atrium, which has very high potential for embolization. Now again, this is the echo, which is showing a right atrial thrombus like a ball, and the size of this is almost twice the size of the main pulmonary artery and RBOT. So you can imagine any intervention at this stage can just make this thrombus fly up and obstruct the RBOT, and it will act like a ball wall and get a patient to immediate cardiac arrest. But the situation here was that the patient refused surgery. The patient was advised surgery and open surgical removal, but he refused surgery, and then we had no other option but to go ahead and treat it. Now, this was one of our first case, and we were pondering what to do, and suddenly, we were looking at options, and a thought came to my mind that every thrombus has an acute component and a chronic component. So what if we go and lyse this clot and put the lytic agent near the clot? We may actually reduce the size. We can take care of the active, a large thrombus and make it a smaller thrombus, and then think about possibilities how we can take it out with endovascular technique. So with this thought in mind, we actually went ahead and did a lysis through the jugular catheter for almost 24 hours. And what you see now is that the clot actually reduced in size, and this made us more excited to that now we can remove, but we had no other, we had no device to actually remove it. And while we were thinking, a thought again came to my mind that, if we can use the capturing device of an IVC filter to the retrieving device for an IVC filter, probably we can take this clot out. But the issue is the clot is not in one direction. While you are putting in a retrieval device, you will only go in one axis. How to make that coaxial and how to catch it in that direction. So post-lysis, what we thought, let's go and take the help of imaging from echocardiography also, and and then try to get into a bicaval view and try to make it coaxial. So before that, we did a bench test, and this is a bench test, whether we can actually retrieve this clot without fragmenting this clot and causing pulmonary embolism, and actually we were able to do it. And this made us more excited that probably, yes, this is the way we can take it out. So we use this hardware. This is the hardware for retrieval device of IVC filter, and this is only one company makes this, because it has a net and a mesh around it, which is non-porous, so it can catch. It's a cone which can actually catch the thrombus without embolizing or crushing the thrombus. So we went ahead and did the procedure in a bicaval view in the cath lab with the help of echocardiography and also with the help of a fluoroscopy. And once we had this and we were aligned coaxially, we actually went ahead and docked our retrieval catheter onto the clot. You can see the retrieval catheter here. And once we did that, you can see that the device actually opens and retrieves the clot. We captured this in the fluoroscopy also as in echo, and you can actually see we are coaxial, and we can catch the thrombus and then take it out coaxially. And while we got this coaxiality in that view and also passing in a wire and retrieving it and having a good veno-venal loop. This is the post-operative, immediate post-operative echocardiography, which shows complete removal of the clot. And this is the immediate post-angio, shows the complete removal of the clot. This is the clot which we removed. So the CT confirmed the finding. There's another case of similar variety. I'm going to skip this. And subsequently, we have done many more cases, and I'm going to be skipping this. And then we published this result and this technique, which this was widely accepted. And now this is one of the ways we can go ahead and treat and take out RA clot in difficult situations where surgery is either contraindicated or it is refused by the surgeon. So just to give you half a minute on potentially embolic RA thrombus, there are two varieties. One are catheter related and one are RA thrombus in transit. RA thrombus in transit means that you have an DVT or an IVC thrombus which actually moves to RA and RV and to pulmonary artery. It can, in that transition, it can go and get stuck in the RA for some time, and you have a situation where there is a patient is potentially to have a large or massive pulmonary embolism, and you can do something to take it out. Now the incidence varies from 2 to 29%, and the mortality in hemodynamic patient is 18% unless we don't treat it, and mortality in non-hemodialysis patient is about 40%. There are different ways to manage it. One is a catheter-based management, which I told you. The smaller ones can be just treated by anticoagulation or thrombolysis, but sometimes we have to opt for surgical thrombectomy or percutaneous thrombectomies. So I'm not going to be discussing this, but this technique was described and published, and now it's accepted as one of the very important techniques for taking out the RA thrombus related to the catheter, especially the RA thrombus, which are quite big. So I'll stop my slide here and open this for discussion. And also to Ujjwal, can we have the, also that, we have, with the help of International Society of Endovascular Specialists and the APVIC, we have actually created a society which is known as the Asia Pacific Nephrology Interventional Course. And this is a course which is being launched in this meeting, and this will be an Asia Pacific course on interventional nephrology. We also have a logo. Ujjwal, can we have a logo? And I'll open this to a discussion. And then this is the logo of our Asia Pacific Nephrology Interventional Course, which we'll be having in different parts of Asia Pacific region on a yearly basis. So we stop here and we take one or two questions before we move to the next session.
Dr. Khanna, you didn't share the screen, so it was not very clear what kind of device have you used for the removal. Can we see the device again?
1 second.
The mesh.
Give me a second. I close this. 1 second. Okay. I can show you. Okay, so can you see the device now?
But this we can see it only in a very small window. Cannot you put it?
This is being shown as a, actually somebody has directed a YouTube to you, this is being shown as what the people are seeing on the website, this is how the people, except the panelist, everybody is seeing this in this view.
I see.
So this is a, auditorium view in our website, and that's where the entire streaming is going. So this is a retrieval device of temporary IVC filter, which goes from the jugular vein. It sort of docks into the hook of the IVC filter, and then once it docks there, and it crimps the IVC filter when we push in the sheath, it takes the filter in and takes it out. There are many devices like this to retrieve, but this device has a unique thing. This is from Cook's, that you have a membrane and which was to our advantage because this membrane, to take out the clot will not, there would be some fragments which will be crushed or embolized, so this membrane is going to hold them in and take entire thing in one scoop without embolizing. So this is an out of IFU use, but this was something which was innovative and which worked in this case.
Very nice.
So, Marty, can we go to the next session? Oh.
Yes.
Dr. Rajnikant, can we move on to the next session?
Yeah, sure. Thank you.
Thank you, Dr. Khanna. Thank you once again. Wonderful session. And I would love to be part of this interventional nephrology course in person when it happens next year.
Thank you. You're most welcome. We'll keep you informed, and also we'll have Rajni. So the next session is a very prestigious session, the Gopi Devi oration, and today we have none other than John W. Eichelboom, who is the primary investigator for the COMPASS trial. And to preside over the function, we have Dr. Mrinal Kanti Das, who is the ex-president of the Cardiological Society of India. He's one of the senior most cardiologists in the country and also a mentor to many cardiologists, and he specializes always into the new frontiers of cardiology. We also have Dr. P.S. Banerjee, who is the current president of the Cardiological Society of India, Dr. Bahulyan and Dr. G.S. Wonder to chair this session. And let me invite Dr. Eichelboom, and I would request Dr. M.K. Das to introduce Dr. Eichelboom and then take over the proceedings of this session.
Dr. Khanna, do you have any slide for Dr. Eichelboom?
No.
Okay. Dr. Eichelboom is a very, very senior scientist who has specialized in population health research, and he is the key person to have the inputs from the COMPASS trial, that is with rivaroxaban, which is a 10A inhibitor. As you know, that 10A inhibitors have got two modes of action, dual mode of action. One is the antiplatelet action, and the other is the anticoagulation action. So far, we have known that the anticoagulation action was more in favor of rivaroxaban, especially in the higher dose, but in the lower dose, it has been found, as in COMPASS trial, that the dual mode of action could be activated, and we can have series of beneficial events with this molecule along with the aspirin, as has been highlighted in COMPASS CAD, COMPASS peripheral vascular disease, COMPASS heart failure, and so on and so forth. And John Eichelboom is the right person to enlighten us about this particular issue in a greater detail, and really will be very much benefited after his deliberation. Now the podium is Dr. Eichelboom's.
Thank you very much, Dr. Mrinal Kanti Das. Ladies and gentlemen, it's really my pleasure and privilege to address you in this Gopi Devi oration. I have been asked to address the question, how has rivaroxaban changed cardiology practice? And listening to the former session, learning about the interventions being employed, I think what we have in low-dose rivaroxaban is vascular protection delivered via an antithrombotic approach. And this treatment will become the standard of care for long-term secondary prevention across a broad spectrum of vascular patients, thereby changing cardiology practice around the world. My disclosures are here. I want to start by reminding ourselves of where we've come from over the years. And the first anticoagulants that we had, particularly unfractionated heparin and warfarin, were detected by serendipity and used for many years. And I heard the speakers at the earlier session tell us that they still use low-dose warfarin. I fear more out of desperation than out of evidence, because low-dose warfarin has not been shown to provide vascular protection. We went from the serendipity phase into the designer parenteral drug phase. And today we have available a series of designer oral drugs, of which rivaroxaban distinguishes itself by the extensive nature of the development program. In atrial fibrillation plus, I don't have time to address all of the indications, VTE prevention, VTE treatment, and the focus of my talk, low-dose rivaroxaban plus low-dose aspirin for vascular protection in cardiology. I will address two issues. Firstly, I will review with you very briefly the overwhelming evidence from randomized trials that using low-dose aspirin in combination with low-dose rivaroxaban in vascular patients prevents vascular events and saves lives. I will then turn to address this challenging issue. Well, where do we apply this treatment? How do we get the biggest benefit for the buck, so to speak? Who is at highest risk and who should be treated with this therapy? Well, let's start with the randomized trials. And in truth, even to discuss these trials, time does not allow, because we have trials, the ATLAS trial in coronary disease, the Voyager trial in peripheral artery disease, and the COMPASS trial, chronic treatment, long-term treatment in coronary or peripheral artery disease, more than 50,000 patients in randomized trials. In the COMPASS trial alone, we've published over 50 papers detailing the benefits of the COMPASS regimen across a very broad spectrum of vascular patients. In parallel with this, we also have large registries, so an overwhelming body of evidence. I'm going to focus primarily on the chronic management of coronary or peripheral artery disease. The design of the COMPASS trial is interesting because it was a 3-arm study in which low-dose aspirin was the control and 2 different strategies involving rivaroxaban were tested. We expected to continue for 3 to 4 years in this trial, but halfway through the trial, the DSMB indicated that we must discontinue because of overwhelming evidence of superior efficacy of rivaroxaban and aspirin. Indeed, the benefits were deemed to be so large that there was an ethical imperative to stop randomized evaluation to make this treatment available as soon as possible for patients with coronary or peripheral artery disease. The main outcomes are shown here. And when you look at the relative risk reduction, a 24% relative risk reduction, it seems rather modest when seen on a bar graph. But I'll remind you that the relative risk reduction of adding rivaroxaban to aspirin is of the same magnitude as a statin or blood pressure lowering. These are very substantial benefits, particularly when applied across a large number of patients. There were consistent reductions in cardiovascular death, in stroke, and in myocardial infarction. One of the most striking results was a very large reduction in stroke. As cardiologists and vascular specialists, I do not fault you for focusing your attention on coronary risk. But we have to remember that for every 3 myocardial infarctions in this coronary or peripheral artery disease population, there are 2 strokes. and our patients fear strokes at least as much as they fear myocardial infarction. And if they can avoid a stroke, a 49% reduction in ischemic stroke, this is going to be an extremely attractive option for them. The reduction in ischemic stroke was not accompanied by an excess of hemorrhagic stroke, which was very reassuring. We reduced stroke by a large amount. We also reduced major adverse limb events by a large amount. And this is a fascinating story. It deserves a separate discussion, but I will hit the highlights. Small number of people experience these events, but if you add low-dose rivaroxaban to aspirin, you reduce the risk of major adverse limb events or need for amputation by 1/2. That's the second big result from COMPASS. And the third, as I've mentioned, this treatment saves lives. And we saw this central line here is the estimate of effect on mortality. The upper line is the upper 95% confidence interval. The lower line is the lower 95% confidence interval. We saw a mortality benefit emerge very early and persist throughout the study. The only thing that changes is that the confidence intervals become narrower as we get more data. So a trifecta of less stroke, less amputation, and saving lives. I've put this one slide in here to remind the interventional cardiologists who may be viewing this presentation that the treatment effects of low-dose rivaroxaban in combination with aspirin are not only of at least similar magnitude as dual antiplatelet therapy, but unlike antiplatelet therapy, it saves lives. A 1/4 reduction in mortality in people randomized anywhere between 1 and 10 years post-PCI. So even if your only mission in life is to revascularize coronaries, this result should impact your practice in high-risk long-term management. Now, there was a price to pay. As with all effective treatments, we pay the price in some way or another, whether that be financial, whether that be side effects, or here, whether that be bleeding. You will notice on the left-hand side of the slide, our primary outcome, which was a modification of the standard ISTH definition, one that was indeed more liberal, so we had higher event rates than the conventional definition. With aspirin alone, after 3 years, 3.5% of patients had a major bleed. With rivaroxaban plus aspirin, the new treatment, 4.5% of people had a major bleed. An absolute increase, which in actual fact is only about 1 and a little %. So a very modest excess of bleeding. The bleeding in almost all patients was very readily manageable. Here is the bleeding with aspirin. 1/3 or 30 with rivaroxaban plus aspirin, 30% required a transfusion, 26% required it with aspirin. And if you look at the other types of treatments that were used, they were used the same in both groups. Because bleeding occurred mainly in the first year, the net benefit, that is the ischemic events prevented in the first year, already outweigh the bleeding. In the second year, they greatly outweigh the bleeding. In the third year, because we're not seeing more bleeding, the net benefit gets bigger and bigger and bigger. This is shown here also. For CV death, the curves continue to diverge. For stroke, the curves continue to diverge. For MI, the curves continue to diverge. For symptomatic bleeding into a critical organ, there is an increase in the first year, but then the curves are parallel. There is no further excess. and there is no increase in fatal or intracranial bleeding. If we put this into perspective with other long-term antithrombotics, rivaroxaban added to aspirin is the first therapy since aspirin alone to significantly reduce mortality. This is why rivaroxaban plus aspirin has become one of the prime treatments for long-term secondary prevention in chronic coronary or peripheral artery disease. In all other cases, there was perhaps a favorable trend for mortality, but in no case does antiplatelet therapy alone, other than aspirin, reduce mortality when used long-term. I want to spend the last few minutes to address the issue of applying these results in clinical practice. We have an overwhelming body of evidence. We're sitting in our clinic and we need to decide who to treat with this new therapy. Do I treat everyone? Do I treat a select few with certain clinical characteristics? Where do I start? What do I do? Well, up front, I want to say that as clinicians, we're always trying to tailor the therapy for those who get the biggest benefit of the treatment. And for this, COMPASS is very clear. I think the key considerations are as follows. The COMPASS regimen with low-dose rivaroxaban and aspirin demonstrated a clear net benefit of treatment. The net benefit got bigger over time. The relative benefits were consistent in people in low, medium, and high-risk groups. I'll show you that data in a moment. And therefore, the absolute benefits are greatest in those at highest baseline risk. A very simple formula. We know the benefits are biggest in those at highest baseline risk. Therefore, they are the ones we should target. Who is at highest baseline risk? And I'm going to suggest to you there are three possible approaches. Many experienced clinicians can tell instinctively. They can tell by their sense, their clinical sense, who is at high risk. And you don't need a scoring system to know that someone with diabetes, who's young, who's got complications of coronary disease and peripheral artery disease is a super high risk. They should be included and treated with this regimen. So one is to use gestalt or clinical judgment. The second is to remember certain clinical characteristics. For example, if you have polyvascular disease, disease involving more than one vascular bed, you're very high risk and an ideal candidate for this therapy. If you have coronary or peripheral artery disease and mild or moderate heart failure, chronic kidney disease, or diabetes, you are at high risk and derive the greatest benefits from this regimen. There is perhaps the most compelling evidence of what I've just said comes from this paper, which we published earlier this year, where we looked at the mortality benefit of low-dose rivaroxaban in people who had one of these high-risk features, two of these high-risk features, or three or four of these high-risk features, compared with those who had no high-risk features. Now, when we split the data like this, the individual parts are not statistically significant, but we look at the consistency of the treatment effect. And the p-value for interaction is not significant. Therefore, statistically, these are the same. Therefore, the greatest benefit is in those at highest risk. We prevent 53.9 lives for every 1,000 patients treated for 30 months. That is an extraordinary benefit of a long-term antithrombotic. So this highlights the patient clinically at highest risk benefits. Here are the data looking at polyvascular versus single vascular bed, heart failure versus no heart failure. And in the gray column is the absolute benefit at 30 months, and the orange is the absolute benefit at 24 months, and blue is the absolute benefit at 12 months. So across the board, there is benefit. It accrues over time. It's greatest in the highest risk categories by vascular disease, heart failure, chronic kidney disease, and diabetes. There is a third way to detect or to identify the patients at highest risk. You could simply count the number of cardiovascular risk factors at baseline. You could simply count the number of medications at baseline, or even calculate a CHADS-2 score. We use it for atrial fibrillation, but the higher the score, the higher the baseline risk. Here you count risk factors. The more risk factors, the greater the benefit. Here you count how many pills the patient is when they walk into your office. The more pills they're on for cardiovascular disease, the greater the absolute benefit of treatment. Here you do a CHADS-2 score. You simply count your atrial fibrillation risk factors. In people without atrial fibrillation, the higher the score, the greater the benefit of this treatment. I'm going to end by saying not everyone should be treated. There are certain people who should not be treated. Clearly, if you already need full dose anticoagulation, you should not be treating these people. Clearly, if you have an unacceptable risk of bleeding, note that I'm not saying high risk, because people at high ischemic risk are at high bleeding risk. And we have to change our thinking, and we need to identify people with unacceptable risk of bleeding and not treat those and treat the rest. I'll show you what I mean by that in a moment. We should not treat people with contraindications. And clearly some people can't access the drug or be followed. Now, what do I mean by unacceptable risk? Here is an example from atrial fibrillation. As stroke risk goes up, bleeding risk also goes up. But the stroke risk goes up more steeply than bleeding, and therefore the absolute benefits of anticoagulation in AF is in people at highest risk of bleeding. But we should not treat the unacceptable risk of bleeding. For example, prior history of life-threatening bleeding when the underlying cause has not been identified or remains untreated. People who have recurrent major bleeding where the underlying cause has not been identified or remains untreated. People with spontaneous subdural hematoma. People with a lobar intracranial hemorrhage due to amyloid angiopathy. And another example, people with moderately severe thrombocytopenia. This is the type of patients who we should not treat. And then, of course, people with contraindications. If your GFR is less than 15, we're doing a trial at the moment, but it hasn't yet been completed in those people. People who have liver disease at baseline with an elevated INR, people with certain drug-drug interactions, and people who are allergic. Mr. Chairman, gentlemen, ladies, in summary, I've given you a short overview of the role of rivaroxaban at low dose for vascular protection. This is going to be your new tool of the 2020s for vascular protection across the range of patients with coronary or peripheral artery disease. Rivaroxaban is the first oral anticoagulant that's now been shown to save lives when added to antiplatelet therapy in both acute and chronic coronary artery disease. The highest risk patient derives the greatest benefit. And I leave you with a challenge, because leaving the pills in the pharmacy or on the shelf is not going to prevent MACE and save lives. We need to start treating our patient. And I'm aware that in India and in many other places, this treatment is now generic. So it's become more affordable than ever. I thank you very much for your attention.
Thank you very much. That was indeed a very, very good, presentation and very informative one. This is a part of the oration. This is one of the most prestigious oration of our society. It is one of the orations which we gave last year to Dr. Farid Murad and earlier to Dr. Alain Tribier. And this is on, it's a Gopi Devi oration, which I will just read out the citation. Gopi Devi oration for the year 2021 has been conferred to Professor John W. Eichelboom from Canada, Faculty of Health Sciences, McMaster University, for the topic of COMPASS trial, how rivaroxaban has changed cardiology practice. At the 13th Asia Pacific Vascular Interventional Course held virtually at New Delhi, India from 19th to 21st December 2021 for his distinguished contribution to the field. Asia Pacific Vascular Society wishes him many more years of good health and academic excellence, dated this 21st day of December 2021. And I will request Professor Mrinal Kanti Das, who is the ex-president and mentor of Cardiological Society of India, to actually present it to you virtually, and we will make sure that we will send it to you personally through the post or through a courier. Dr. Das, please.
Yeah, it's a great pleasure to hand over the citation, and it was a fantastic oration. At least myself has been benefited because of the fact that if new facet he has analyzed and he has described, that is the higher risk of patients are more benefited with the low dose rivaroxaban along with the aspirin, and that's a very important key message that should be received by everyone who is listening today. And with that note, I congratulate Dr. Eichelboom for his erudite deliberation on rivaroxaban, and please accept our this oration award. Thank you very much.
Thank you very much. I'm very much honored to receive this award from you. Thank you very much.
Thank you.
Thank you very much, Dr. Eichelboom and Dr. M.K. Das. And now we move on to the next section of our presentations. And there are 3 sessions of Asia Pacific Vascular Society. It has now 3 chapters which has gone beyond India. So we have the Southeast Asian section of APVIC. We have the Nigerian and the South African chapter of APVIC, and we have the Middle East chapter of APVIC. And also we have a new session this year, which is on the session on Women Crusaders of APVIC. We cannot stop and not to recognize the contribution of the lady cardiologist and our own comrades who have actually helped for APVIC to grow and brought to this stage, and they are doing phenomenal work all over the world. So we'll have their session today. We also have a session on congestive heart failure, which will follow their session. So let's move quickly to the Southeast Asian section of APVIC. And let me welcome Dr. Ramesh Singh Arjun Singh from Malaysia, and Dr. Jayakanthan from Malaysia, Dr. Rini Pramesti from Indonesia, Dr. Reza from Indonesia, Dr. Sriram Narayan from Singapore, Dr. Wulan Agrihani from Indonesia, and Dr. Rajnikant Rajagopal from Brunei for this session. So let's invite first Dr. Rini. She's going to be speaking on May-Thurner syndrome when the vein becomes too fragile. Dr. Rini has had worked in Indraprastha Apollo Hospital. She was one of our fellows. She has done phenomenal work in Indonesia to develop interventional cardiology and also vascular interventions in Indonesia. So over to you, Dr. Rini.
Okay, good evening, everyone. First, thank you for Prof. Kana for inviting me to join the great meetings. And I missed the Delhi or Apollo Hospital also, the meeting, of course. because for the last 2 years only online we can meet at the meeting. Today I have present my case about my Turner syndrome when the vein become too fragile, a case report. I have no conflict of interest in this case presentations. As introductions, that incidence of first is symptomatic DVT in the adult is about 50 until 100 per 10,000 population per year. And my Turner syndrome is, or MTS is referred to chronic compression of the left iliac vein against the lumbar spine by the overlying right common iliac artery. MTS is anatomical risk factor for lower extremity vein thrombosis, especially left lower limb. This is a case report about Mrs. LMN, 63 years old, a Chinese lady. From the anamnesis, the patient have a chief complaint of recurrent leg swelling, dominantly in the left leg, more than 1 year. And 2 years, she already gone to many doctors, but not improved. And 2 weeks back, went to the cardiologist and received rivaroxaban and diosmin, but also there is no improvement. In this patient, no history of trauma, malignancy, or prior clotting problem herself or on her family. For a physical examination, blood pressure otherwise is normal, with only swelling dominantly on the left leg with hyperpigmentation in these patients. From laboratory finding, we found that the D-dimer is about 12,000 and fibrinogen, hemoglobin is normal, chest X-ray normal. Echocardiography only find that diastolic dysfunction as the woman is already 60 years old. From US ultrasound Doppler, we found that the patient have left femoropopliteal DVT with normal arterial flow, and CT venography is iliofemoropopliteal DVT in the left legs. So the patient have working diagnosed with iliofemoropopliteal or proximal DVT of the lower limbs. At the times, I gave the patients with enoxaparin, diosmin, atorvastatin, elastic compression for Barnard stocking with leg elevation. At the time, I still thinking about the conservative therapy. But after 1 week, there is no improvement. So I planning the patient to undergo a catheter direct thrombolytic therapy. So patient on the prone position, I put at 5 French seat and also GR, chest skin right for 5, and I underwent the venography. There is total occlusion from femoral vein, and I advanced the catheter and also thrombus along the iliac artery. So the patient get alteplase bolus for 10 milligram followed by continuous infusions and unfractionated heparin 200 units through the sheet. And patient transferred to ICU for close monitoring. The following day, I saw that the left iliac vein is compressed with the spur. So this patient is with May-Turner syndrome. And then I am predilated. I plan to put the stent. So I predilate with the balloon 60 million balloon gradually for up to 10 ATM. But from venography evaluation revealed a perforation on the left common iliac vein. So I put the distal left common iliac. I know that there's a perforation, so I put the 5 French catheter to the right iliac vein to know the length between the bifurcations and the healthy, and I evaluate where is the location of the perforation. And then I put, instead of self-expandable stent as I planned, I put the covered stent 40 millimeter to maintain the patency of the left common iliac vein and to close the perforation due to complication of the procedure. Here I put the covered stent. And this is the final result. As we discussed a bit about MTS's definition, isolated left lower extremity swelling secondary to left iliac vein compressions, first described by Mike Morris and defined anatomically by Meyer and Turner in 1975. And the left iliac vein is usually located posterior to the right iliac artery and can be compressed between the artery and the 5 lumbar vertebrae. Most the patient present with left lower extremity DVT, like in my patients with symptom with left lower extremity swelling, pain, venous claudication, ulcerations. And the clinical stage of MTS is the first stage is asymptomatic with left in compression, and the second stage formation of the venous spur, and the third is left lower extremity DVT, like in my patient. Modality for the MTS is CDTT without or without stent placement, balloon angioplasty, pharmacomechanical catheter, direct thrombolysis with stent placement, and anticoagulations. Venous stenting indication for the chronic obstruction, like in this patient with contraindication, is uncorrectable coagulopathy and local or systemic infection. As the complications is early thrombosis, less than 30 days is about 1.5 until percent, late thrombosis is 5%, extension stent into IVC is about 1%. Rare complications is venous or perforation, like in this patient, is or injury adjacent arteries and fracture and stent dislocations. As a take-home message, when encountering unexplained proximal DVT, Turner syndrome should be considered, and those diagnosis and treatment must be performed to prevent the recurrence of thrombosis. The optimal treatment of MTS include CDTT to relieve the symptom and followed by stenting placement to relieve the stenosis. Perforation as a complication could happen and should be treated properly during endovascular treatment in MTS. Thank you.
Thank you, Dr. Rini. That was wonderful. So we'll have the discussion in the end. And let's move on to the next presenter. I would request Dr. Reza again from Indonesia. Again, we had Dr. Reza in India and Delhi for about a year. So Dr. Reza, please continue with your presentation on aortoiliac interventions.
Recording stopped.
Thank you, Prof. Kana.
Recording in progress.
Thank you, Prof. Kana. Good evening for everyone. I will to presentation. The short time I will to move the presentation, the pearls and pitfall for aortoiliac intervention. This is my outline. We know the more 90% etiology of infrarenal aortic obstruction are atherosclerosis. And many wide spectrum signs and symptoms for acute and chronic aortoiliac, and we can manage the surgical, endovascular, and hybrid to improve the quality life, relieve symptom, and patency rate. This is my classification. Aortoiliac disease, TAS E onto TAS D, and TAS D is still recommendation for surgery. And appropriateness, the lesion more 50% in abdominal aorta, common iliac, external iliac, and internal iliac, we must to manage the intervention of surgery. This is outcome of endovascular intervention. Many study head-to-head surgical endovascular, the same technical success. The primary patency is more 70% in 1 year. And the ST guideline, endovascular strategy is recommended for short occlusion patient class 1. And ST guideline also show the procedure hybrid endovascular and open surgery for our aortoiliac lesion. This is indication mild symptom, claudication, critical limb ischemia, appropriate go to intervention. And if the novel stenosis, we can manage the stent with bare metal stent. In the lesion diffuse or CTO or focal, we can manage with the bare metal stent. But if the indication ESR, we can manage the cover stent with the BMS the focal lesion. And heavy calcification we must to manage with the cover stent. And the different setting in autoiliaca in acute and chronic is very different. In acute, uncommon, very different. This is the process associated with the high morbidity and mortality. And chronic have progressively impaired indirect inflow to pelvis and the lower extremity. This is many complication in surgical from early until late morbidity. And endovascular intervention have many good advantage in low mortality, low morbidity, and very high success rate. And this is how about pre-procedural imaging. The imaging CTA and MRI is strategy before to management. The good quality CTA to assess inflow and outflow, to mix to see the flow limiting to distal bifurcation, iliac and femoral, and the access imaging about calcification, the lesion, potential risk rupture, tortuous thrombus, we can manage this lesion. And the first selection, we must do about the stand, how the patency rate, freedom from target lesion revascularization, and multifactorial like location, calcification, length, tortuous, sizing, outflow and inflow, and then selection. And we must do technical approach intraluminal, subintimal, and access femoral and brachial, and combined surgical or endovascular. This is the slide intraluminal and subintimal recanalization. And subintimal technique is postcurrence is high technical success rate and high limb safety rate in critical ischemia. But we must need the advanced interventional skill. For intraluminal technique, it's easy, but the consequence very difficult to know if wire remains to lumen along in entire CTO course. This is selection device. BS and SS, this many study show target lesion is primary patency more 80%. And self-expandable, balloon expandable, cover stand show this advantage. Like if increase radial strength, we must do balloon expandable. In cover stand, if autoiliaca TASD. How about the access? The successful recanalization is based on the anatomy and the extent disease. This is ASIS fusion technology. The fusion technology is to combine the CT scan and fluoroscopy in one image. The name is fusion. This is my case. The Lehigh syndrome with the ankle brachial index is 0.4 and 0.5 is no re-entry. We go to manage with the CT fusion left and right, and see the outline view, volume view, and predilatation. And after predilatation, we go to standing with the cover stand. The successful procedure endovascular with the CT fusion is more 98%. This is many journal and many research. CT fusion in complex lesion is made easy by technology, less radiation, less complication, and give more successful procedure. And future trial are advanced autoiliac occlusion led manifestation of atherosclerosis. Gold standard is still bypass, but now with the CT fusion, we can do intervention is make easy. Maybe with the hybrid, the trial aims decrease the length hospital, major complication, and patency. In Corbus trial, so cover stand is more superior than bare metal stand for good short and long-term outcome and high patency rate. This is many trial. Cover stand is great safer and better patency in autoiliaca TASD. This is syrup trial. The final kissing balloon, give the good
Dr. Reza, you only have a minute left.
Okay, this is my case. Triple E with autoiliaca TASD. So is we go to hybrid. to the cut down right femoral artery, left femoral artery, and puncture left brachial artery. And C, EVA and bypass and CT angio follow-up in 3 years is good patency. This is my case COVID. So the autoiliac disease, the combined procedure, hybrid endovascular and surgery. So the post 1 month is go patency. And the case 3 is post-vaccination 2 weeks ago in history COVID-19, 4 months ago. This autoiliac disease diffustration antidistal and hybrid also. We see the PTA and embolectomy, the same procedure, so the thrombus, many thrombus. And angio of sensoric motoric is still good after 1 month, is primary patency is good. And evaluation, drug, CT angio, management critical ill, and pitfall valve, CTA, improve preoperative planning, calcification lesion, iliac ostium, and cover stent, more durability and safe than BMS. CT fusion is more successful procedure if only fluoroscopy, less radiation, less complication. Hybrid technique is one technique, compact extensive autoiliac lesion. Serrat technique is future gold standard technique. Avoid cover stent in iliac internal artery. Avoid extension put to distal aorta, and avoid spot stenting, and do not hesitate to obtain vascular access from multiple sites. Thank you.
Dr. Reza, that was very good and comprehensive. We have the next speaker, Dr. Woolen. Dr. Woolen is going to be speaking on interventions for chronic pulmonary arterial hypertension, CETPH. In fact, it makes me very proud that all the 3 speakers have actually been to Delhi and worked with me. And it gives me a very proud feeling, and all of them are leaders in their own country. So Dr. Woolen, please carry on with your talk. And I believe Dr. Ramesh Singh, Arjun Singh is on the panel. I will want him to actually lead the proceedings.
Thank you. You can see my slide, right? So thank you, Dr. Khanna, and thank you all the attendants and panelists this evening. So some interventions in chronic pulmonary hypertension, we just specifically will describe a little bit about CTAP. Here we have a male with 24 years old of age, and in 2014, when he was working, when he worked in Taiwan, he had a right-sided leg swelling, and he was given oral medication, and it recovered for about 2 weeks, or even later about 4 weeks. And since then, he never complained anything. And in 2016, he returned back to Indonesia in one of the district hospital. He came with the complaint of hemoptysis and diagnosed with and treated as pulmonary tuberculosis, as this is rather common in our country, that people with hemoptysis, they would rather diagnose it with tuberculosis in district hospital. And eventually the patient developed right heart failure, and they provide him with medication for the congestions and continue with the treatment of pulmonary tuberculosis. In 2020, he was referred to our hospital with quite severe right heart failure with class functional of 3. And we from the echocardiography, and it showed typical signs of pulmonary hypertension, and we found a thrombus in the just septal leaflet of the tricuspid valve. Even in the TEE, we found thrombus in the RVOT, so we highly suspect him is having thrombus as well in the pulmonary artery, but he didn't show any signs of acute massive pulmonary embolism at that time. So we performed a duplex ultrasound in both of his leg, and we found the partial thrombus in the right femoral and popliteal vein, and it quite answered our question that this might be the cause of his symptoms since 2014 or 2016. In 2020, in that time, our team did a peripheral vein angiography, and we found an occluded left iliac vein and partially occluded right-sided femoral popliteal vein, and the patient underwent successful blunt angioplasty and had quite a good flow for the bilateral lower extremity of the vein. And then for the next 1 year, we provide him with an oral anticoagulation with in 2020, again, we did a CT scan and we found quite a large thrombus in the ostial of the left pulmonary artery. And since it's quite large thrombus up to the mid and distal of the left pulmonary artery, we couldn't see any flow, so we provide him with oral anticoagulation, sildenafil, as he showed any sign of pulmonary hypertension, diuretics, and digoxin. We also tried to refer him to the surgery for the pulmonary endarterectomy, but the surgeon shows some reluctancy. And since then, he was 3 times hospitalized due to the recurrency of the right heart failure with a high functional class. So just briefly that DVT may come up to acute pulmonary emboly or just not treated well as for this patient, and he came with a symptomatic signs of right heart failure, which we suspect him either as having chronic thromboembolic disease or chronic thromboembolic pulmonary hypertension. So as for the final diagnosis, actually we have to perform right heart catheterization to exclude if the mean PAP is more than 20 and PVR more than 3 Woods unit with the persistence of thrombus after 3 months of anticoagulation, then the patient will definitely having a CTAP. So the treatment decision-making process in this patient is quite difficult, actually. So once we establish the diagnosis of CTAP in this patient, actually based on the morphologic characteristic of the thrombus itself, this patient is indicated for surgical pulmonary atherectomy because the thrombus is quite large. It's in the osteoproximal of the left pulmonary artery, and it's kind of totally occluded or subtotally occluded of the lesion. But anyhow, when we see that the patient is operable, we have to determine the risk to benefit ratio for the surgical PEA, whether it's favorable or it's unfavorable. And if it's unfavorable, and we have to see whether the lesion is favorable for the BPA or not. Otherwise, we only what we can do is only giving the patient vasodilator therapy as we give initially to this patient, because in our hospital, PA is the surgeon has not familiar with the PA, and the patient is having a very high risk due to the high functional class. So if it's inoperable, so we have to evaluate actually if the patient is having a high risk of operation, like in this patient, so we have to evaluate whether it's favorable to BPA or not. But in the initial days, we thought since the patient is having high risk and the surgeon is not having a good experience in PEA, and then the lesion based on CT scan is not favorable for PEA, we thought that, okay, we initiate him with vasodilator therapy and quite a good control of anticoagulation orally. And then we evaluate the patient, but eventually in the 1 year of the follow-up, the patient has a readmission of 3 times. So 40% of CTAP patients are ineligible for PEA because the technical accessibility of the thrombus itself, like what we have in this patient, and the poor surgical candidacy. So, yeah, some of the recommendation for performing BPAs, first, the selection of the target lesion is very important. So we have to define which kind of lesion of the thrombus in the pulmonary, distal pulmonary artery. And angiographically, if you have a ring-like stenosis or the web lesion or subtotal lesion, that we might be able to perform it. But if you have totally occluded lesion like what we have in this patient or tutors, and it might be high risk for the failure. And yeah, it should be done in multiple stage, and then we have to assess pulmonary gate flow scores afterwards. And then it's also, we have to define the endpoints of target lesion every time we did the BPA and define the endpoints and also the risk for having a complication pulmonary edema. So back to our patient, actually, finally, after he admitted for the third time, and he had a very severe condition and bad shape, and even he had a very high carbon PCO2 in the blood gas analysis, and we have to put him in non-invasive ventilation. So we tried to think whether what we can do for this patient. And yeah, if you see the left pulmonary artery flow is very small, and it's just similar to what we had in the CT scan.
Dr. Woolen, kindly complete the slides, please.
I'll be fast. So we try to do the wiring using just the workhorse BMW wire, and we can go into the anterior branch of the left pulmonary artery. And then we try to do the sequential ballooning using a non-compliance balloon, but it was very difficult. So we changed the balloon into a non-compliance balloon. And then we first did it in the proximal, and then we do it sequentially to the distal. And yeah, apparently we can have just quite a better flow. And once we open the proximal, then we have a little bit better flow for the posterior branch of the left pulmonary artery, but still the size is very small. And then because we want to try to put the wire into the posterior branch of this branch, and it's a bit difficult to engage the wire, so we do the double wiring and anchoring the other wire to the superior branch. And yeah, after that we just do the sequential ballooning, and then just finally, if you see here, there's still a stenotic lesion, so we try to just do the ballooning in that part. So basically, what we can do is just opening that part of the posterior branch and also the anterior superior branch, but unfortunately the other occluded part is very difficult to do the wiring because the thrombus is quite hard. So up to this stage, it was done like 3 weeks ago. This is what we can do so far, and we just wish that we can do more to the patient sequentially. And we have an MPAP of 83 millimeter mercury, and after that just have a slight reduction about 6 or 7. So as a conclusion, the treatment options for CTAP are evolving, including endovascular therapy, and even now they are trying to find the good technique for the chronic total occlusion. And PPA might be an important therapeutic option for patients with CTAP who are not amenable for pulmonary aneuploidy. Thank you very much.
Dr. Woolen, that was great. Can I have Dr. Ramesh Singh?
Thank you, Dr. Chana.
Sorry about that.
Yeah, so you're there.
Minutes delay.
Okay, right. So now I can see you. So I would leave this to you for discussion. I think Dr. Sriram Narayanan is not here, and we will have the discussion so that we are not late for the next session. So you can start the proceedings. And
so Dr. Raj is not presenting, is it, Dr. Khanna?
Dr.
Rajnikant.
No, Dr. Rajnikant, I don't find him here. He was there in the previous session.
Okay, because his name is next.
Yeah.
Okay. Yeah. So we've actually had 3 very interesting talks, and maybe I'll just ask the first speaker, Dr. Rini. So I've never seen this condition before, actually. How common is it or how often do you see such cases? Number 1. Number 2, what is your choice or indicated anticoagulation, and what's the duration of your anticoagulation?
Okay. The cases about the Turner syndrome is the second case I have, but unfortunately, when I do something, when I open the left iliac veins, there is a perforation. That is my second case of Turner. But the anticoagulants, after the patients, I put the cover stents. The patient is under good conditions, and still I gave the patients with rivaroxaban for about 3 months, but because of the finance problems, he chose to go to the warfarin after 3 months.
So it's lifelong.
Up to now, he's still with the anticoagulant.
Yeah.
For about less than years. This patient is about early on during the pandemic case. I did the cases during the pandemic. So this the patient, the second evaluation, when the first evaluation, I still a bit thrombus on the left femoral. So I gave the anticoagulant, but I changed to the warfarin. But for the second evaluation, the patient hasn't come back to my clinic.
Yeah. So I think anticoagulation is also a very important mainstay of treatment here, apart from your intervention, because this is recurrent. So that's one.
Yep,
And my last question actually will be directed to Dr. Wulan. While CTAP is actually evolving, from your experience, what is your success rate? How often do you have to take these patients back for repeat intervention?
Okay, thanks. So actually, it's not easy to have a diagnosis of CTAP, and the challenge in my hospital is we don't see them. Maybe this is the first. Oh no, it was the second case of CTAP, but this is with the apparent thrombus. But actually, there's so many type of CTAP which has in the distal branch of the pulmonary artery, and the shape of it's not the thrombus, the apparent thrombus, but rather it's like a web ring or a stenotic lesion of a very distal pulmonary branch, or some total occlusion, but in the very distal part of the branch of the pulmonary arteries, then you will not be able to see it even in the CT scan, unless you perform the VQ scan as before. So unfortunately in our hospital, we don't have any VQ scan, but if you do have it, it will be very nice, because actually the incidence will be higher as what we expected, because once patient that you see any signs of pulmonary hypertension by echocardiography, and the age is like around middle age or 40 years old above, then you cannot find any other cause of pulmonary hypertension, then it might be one of the thing that we have to think, because in the chart of the diagnosis, once you have the pH sign in the echo, then VQ scan is one of the tools that we need to elucidate whether they have a mixed match perfusion defect. Then we will suspect a CTAP. And the next is, what was your question? Oh, the sequential intervention for CTAP. We cannot do it at once, because most of the time patients with previously suffered from DVT or post PEA with a residual pulmonary hypertension, then they will have a very small or quite a lot of area of the branch that may have some lesions. So once you do it all once together, then they will have a more complication than it shouldn't be there. So what we have to do is do it sequentially, like every 2 weeks or 4 weeks. Then some patient will need 3 to 5 times a series of the pulmonary angioplasty.
Thank you. Thank you so much. I've got no more questions, actually, Professor Khanna. We'd like to extend our thanks to the 3 speakers.
Okay, thank you so much, and thank you for being here. It means a lot that it's very late. I understand in your country it's pretty late,
Yes.
but all of you are here, and what gives me a lot of pleasure is all 3 of them have actually been trained by me, and they are doing so well in their country. So that gives me a real pleasure.
And this time, I want to thank you for you, Prof. Khanna, for accepted me as a fellow in your hospital.
All right. Thank you then. Good night.
Good night. Bye.
Bye. Selamat malam.
Selamat malam. Namaste.
Terima kasih. Bye-bye.
Bye. See you next time.
Can you hear me? Ujjwal?
Yes, we can. We can. Hello.
Okay, so now we thank you all very much. We move to the next session, and there has been a little change. The next session, because we have Dr. O.P. Yadav, who is a very eminent cardiac surgeon, and Dr. Vijay Kher, who is a very eminent nephrologist. We have a small case-based discussion on cardiac remodeling, and following this, we will have the session on women crusaders for APVIC. So if there's no problem, we'll go to the next session first, the congestive heart failure session. And I would invite Dr. Vijay Kher and Dr. O.P. Yadav to join in as panelists, and we can start with this session. Can I have, is Dr. Kher?
Yes, I am here. I am here, Dr. Khanna.
Okay, I couldn't see you, so I'm sorry, and Dr. Yadav will be joining. So we have, we are running a little late, so we have stopped the sessions, and we have requested the women crusaders to just stand by for 20 minutes. So this session is very interesting, and we have it's a panel discussion on cardiac remodeling, and this will be a good panel discussion between cardiologist, cardiac surgeon, and nephrologist. So let's start with cardiac remodeling. Let me set the whole, the ball rolling. There's a central pathophysiology to heart failure. Whenever there is a heart failure or a heart damage, actually what happens is the myocardium starts remodeling. It is defined as a group of molecular, cellular, and interstitial changes that manifest clinically as change in the size of the LV, the mass of LV, geometry, and function of the heart after the injury to heart. And this injury could be because of inflammation, because of ischemia, or because of chemicals and drugs. Whenever we talk about this injury, we have the heart goes into remodeling, which could be early remodeling and a late remodeling, which ultimately leads to neurohormonal activation of the sympathetic nervous system and RAS, and also dilatation of LV wall and thinning of the LV wall, and also scar formation. This all results in poor prognosis because of the association of left ventricular dysfunction, and it is known for a long time that a poor LV begets more deteriorating LV dysfunction. So let's go on to the case-based discussion. This is a case scenario on heart failure patient showing changes in echocardiographic parameters. Seema, 68 years old female, a known patient of HFrEF since 3 years. She underwent revascularization 8 months back. She was on optimized dose of ACE inhibitors and ARBs, beta blockers, and MRAs. But lately she complained of difficulty in breathing and difficulty in doing day-to-day course. On investigation, we found that the LV function EF was 32%. The NT-proBNP was 1782, which was markedly raised. The LV end diastolic volume index was 82 ml per meter square, and LV end systolic volume index was 44 ml per meter square. The clinical investigations definitely indicated that there are changes in the echocardiographic parameters, and there is a progression of LV remodeling. And the question came, how does a cardiac remodeling impact the progression of heart failure in this patient? So as we see, cardiac remodeling is the culprit for heart failure progression. This has been known for a long time. And what we see, that patient with only a mild symptoms, like in this patient, does not mean that the heart is only mildly affected. What happens is, it's like a tip of the iceberg. The main problem is happening, subclinically, and there is a huge amount of cardiac remodeling which is happening, and there is a continuously reduced pumping of the LV, and the LV functions actually keep deteriorating in the background, and the patient suddenly, if you do not control and arrest this process or retard this process, the patient would come with burnt out disease and severe heart failure. So be very careful. Even mild deterioration of symptoms and early rise in NT-proBNP or LV falling of LV functions post revascularization means that this patient is remodeling in the wrong way, and this will actually create a long-term bad prognosis in the long term. Now, this remodeling further worsens heart failure, and then there are many sites of many things which are happening. What is happening clinically? There's a prolonged LV relaxation time, increased diastolic stiffness, slow LV filling, and elevated end diastolic pressures, which are picked up on biomarkers as raised NT-proBNP. In terms of pathophysiology, there is eccentric hypertrophy, extracellular matrix remodeling, necrosis, apoptosis, autophagy, oxidative stress, and energetic abnormalities. And this leads to, in HFrEF patient, leads to cardiac changes in cardiac structure, myocardial composition, myocyte deformation, and multiple biochemical and molecular alteration, which all have a very negative impact on heart functions and cardiac reserve. So the understanding the features of cardiac remodeling has become a major objective for limiting or reversing its progression. That is where the crux of the discussion is. If we can intervene at this stage, we can actually prevent rapid progression of cardiac function and also prevent a burnt out stage requiring LVADs or cardiac transplants or a lot of things in that direction, or CRTD. Now, if you have to understand, that there could be physiological and pathological stimuli which affect multiple tissues. It could be directly cardiac myocyte, interstitial matrix, or vascular smooth muscles and endothelium. And there could also be myocardial injury, which could be direct necrosis, scarring, thinning, or hypocontractility. And in the non-infarcted zone, it could be hypertrophy, dilatation, and hypocontractility. There could also be altered cellular pathways, pathway signaling in terms of which can lead to apoptosis, beta, dysregulation of beta adrenergic receptors, excitation of and contraction coupling, and also lead to changes in the myocardial oxidative mechanism and leading to myocardial stress. And there could also be changes in myocardial mass and volume. This is detected by echocardiography, as in this case, or it could also be detected very early by cardiac MRI and radionuclide ventriculography. We had a similar case discussion on cardiac imaging a few hours back. And it could also be seen grossly in terms of fall in ejection fraction or changes in LV and systolic volume and diastolic volumes. So what happens once we know this, a decrease in LVEF in a revascularized patient significantly increases the risk of cardiovascular death and future hospitalization. If this is the data from CHARM study, which enrolled almost 7,599 patients. And what was seen is there was 45% increase in cardiovascular death and chronic heart failure hospitalization. And a fall of 10% of ejection fraction actually led to 57% increase in cardiac mortality or MACE. An increase in LV end diastolic volume or end systolic volume significantly increases the risk of patients for further hospitalization for heart failure or death. And this is the data from Valiant study, which enrolled 610 patients. And what was seen here is the death, cardiac mortality, and heart failure hospitalization actually increased by 15% if the end systolic volume went up by more than 10 ml, and it was increased by more than 9% if end diastolic volume went up by 10 ml. So with this background, and I have sort of given you a background of what happens in cardiac remodeling, how it affects the cardiac functions, the rehospitalizations, and further CHF and death in these patients. There is also a a very strong correlation between the cardiac remodeling and the renal dysfunction. And I will direct the talk to and discussion to Dr. Vijay Kher, who is a very accomplished and one of the senior most nephrologists of the city. So, Dr. Kher, if you want, I can move your slides, or if you want, you can move your slides yourself. Dr. Kher, are you there?
Dr. Kher, you are muted.
Yes, yes, I am here, Dr. Khanna. Thank you very much for the invitation, and I would request you to move my slides because then it becomes a continuity.
Okay.
Otherwise, it would break often because
Fine.
I'll have to come 2 or 3 questions which are there
Okay,
for
so
me.
I'll keep moving the slide.
Yes,
and,
yes. You
Dr.
can
Yadav,
start.
do you want me to move your slides as well, or you want to do it yourself?
Please go ahead, Dr. Khanna.
Okay, fine. So these are your slides, and the point of discussion would be relation between cardiac remodeling and renal dysfunction.
Yeah, I think there is a crosstalk between the kidney and the heart, and it's a very, very close kind of an interaction which happens even in health, and it gets aggravated in disease process. Acute dysfunction of heart can lead to acute dysfunction of kidney, and chronic dysfunction of heart can lead to chronic dysfunction of kidney or an acute dysfunction of kidney. So there's a vice versa kind of an relationship between acute heart failure and kidney dysfunction. And this is mediated predominantly by common mechanisms like sympathetic activation, renin-angiotensin system activation, oxidative stress, as well as. So there is a significant connection, a decline in kidney function aggravating the heart failure, and a declining heart function producing progressive decrease in the perfusion to the kidney and causing not only acute kidney injury as well as chronic kidney disease. Next slide, please, Dr. Khanna. Yeah, the heart failure coexists with kidney failure, and there is in fact 20 to 40% heart failure patients have serum creatinines of more than 0.3 milligrams per deciliter. About 50% patients of heart failure have some form of chronic kidney disease. And in this study, about less than 60 ml of GFR, about 50 to 66% of patients of heart failure had some form of kidney disease. And in addition, 20 to 30% of patients of heart failure, especially in acute heart failure, will have acute worsening of kidney function, either as a part of the heart failure or as a part of the treatment of acute heart failure. Vice versa, patients of chronic kidney disease, again, 30 to 40% of patients will have some form of heart failure. And in advanced kidney disease on dialysis or stage 4, stage 5 kidney disease, almost 50% of patients have heart failure. And this remains partly underdiagnosed because volume overload and heart failure distinction in patients of advanced kidney disease may not happen very easily. Next one, please. And you can see that the mechanisms which are important for causing this cardio-renal interaction and this combined heart failure and kidney failure is related to the common risk factors which are very common for both heart disease as well as for kidney disease: diabetes, hypertension, obesity, smoking, dyslipidemia, and other factors being malnutrition and immune-mediated diseases like or elevated augmented sympathetic nervous system or renin-angiotensin system, and other factors are like inflammation, endothelial dysfunction. These are fairly common both in patients of kidney disease as well as there is also in addition other toxic agents that treat under treatment of diseases of heart failure, which Dr. Khanna was talking about just now, and as well as under treatment of kidney disease. And then there are certain organ specific factors which are common between heart and the kidney. And these are decreased cardiac output, renal perfusion is decreased in these patients. There is increased blood pressure in these patients, volume overload occurring in these patients. And then in addition, there is leading to electrolyte and metabolic disturbances which occur in these patients. Next one, please. So I think you can see that renal dysfunction not only is affecting the function of the heart, but there is alterations in the structure of the heart also. And the cardiac remodeling which occurs in patients of heart failure is aggravated in patients who have associated chronic kidney disease. And this is related predominantly to increased atherosclerosis, which occurs in patients, diabetes mellitus being a common cardiovascular, as well as renal dysfunction, arterial hypertension, and wasting of protein energy, malnutrition, and cachexia, which are common in patients of heart failure, as well as in patients of kidney disease. And these factors, in addition to chronic kidney disease as anemia, which is common in patients, and this aggravates heart dysfunction, as well as structural alterations in patients of chronic kidney disease who have significant anemia get altered. And these are related to many metabolic factors or changes which can happen in these patients. So there is increase in cardiac hypertrophy in patients of chronic kidney disease, as well as increased fibrosis in these patients. The endothelial dysfunction is again much more aggravated in patients who have combined kidney failure as well as heart failure. And the vascular stiffness and vascular calcification, one of the most common causes of calcification of valves, as well as arterial and valvular and vascular calcification, is in patients of calcium phosphorus metabolism led by the progressive kidney failure in these patients. So this is how the cardiac remodeling, both in function and structure, happens in patients of combined kidney disease and heart failure. I think it's over to you, Dr. Khanna. I think that's probably the last slide for this. Dr. Khanna, you muted.
That was very well explained, and now we move on to Dr. Yadav. Does cardiac remodeling impact outcomes in HFrEF patients post-revascularization? I'm talking particularly in this context after bypass, because this is one of the very common situation we feel we face sometime. You have a good surgery or you have a good revascularization, but in the post-op period, over a few months, you see the LV is getting down and the patient is having early symptoms of heart failure. So I'll ask Dr. Yadav to discuss this point.
Thanks, Dr. Khanna. I mean, the short answer to your question is yes. Can I have the slide, please?
Yeah, it's there.
Yeah. So, if you look at when you have initially to start with primordial risk factors, that's the hypertension, dyslipidemia, smoking, and those kind of things, insulin resistance, it causes endothelial dysfunction, and ultimately it produces a milieu of atherosclerosis, producing myocardial ischemia. Now, till such point, no structural damage occurs in the heart, and all of these are producing symptoms, maybe stable angina, but there is no myocardial necrosis. But once the plaque ruptures for some reason and coronary thrombosis takes place, that's the time when myocardial infarction sets in, and it leads to a spiral of cardiac remodeling, which involves ventricular dilatation, ventricular hypertrophy to maintain the cardiac output, and formation of scars. And ultimately, if not interrupted and corrected, it leads to heart failure. Next slide, please. Now, if you look at the results from the EXCEL trial, when you have a normal ejection fraction and even mild derangement of ejection fraction, the primary endpoints after revascularization are nearly the same. But once you cross that tipping point, which is roughly 35 to 40% ejection fraction, see, there is virtually a doubling of the primary endpoints, and these primary endpoints I'm referring to are the all-cause mortality, the stroke, and the myocardial infarction. So virtually twice as much mortality and heart failure revascularization and MI if you have severe LV dysfunction as compared to mild LV dysfunction. Next slide, please. Now, if you look at these individual endpoints, they are affected both in short term as well as in long term. You look at death, look at heart failure hospitalization, and they are partially more affected in PCI as compared to CABG, but both of them are adversely affected. So heart failure is extremely important, and in fact is more important. Next slide, please. I sent some slides which have not been received. So if I can just add in, Dr. Khanna here, that we have been only talking of ejection fraction. There have been articles which have shown that ejection fraction is important, but probably more important is presence of heart failure. And it has been demonstrated in a very recent study, a very important study by Sun et al., that if a patient has preserved ejection fraction, but heart failure, they do much worse than patients who have reduced ejection fraction, but no heart failure. So it is extremely important that though the ejection fraction and heart failure may go hand in hand, but there may be occasions when the ejection fraction is preserved, but there is heart failure, and that is a very, very, what shall I say, a bad set of patients. Thank you. Over to you.
So that was very well explained. And now let's see what is the impact of sacubitril/valsartan combination on cardiac reverse modeling in hospital patients. So this is a very new concept. We know that the remodeling happens, and at some stage before the tipping point, we can actually reverse this remodeling and correct this pathophysiology of remodeling at multiple levels. And whether we had many drugs which were there, ACE inhibitors, what happened to my slides? Okay, so we had a lot of drugs which were classical drugs like ACE inhibitors, diuretics, MRS, but the new drugs which have come to our armamentarium are, sacubitril/valsartan combination and also SGLT2 inhibitors. These are the two game changers which can actually reverse this remodeling effect. And I'm going to be talking about sacubitril/valsartan in these patients. Not only that this combination improves cardiac remodeling by inhibiting myocardial cell death and hypertrophy, it also sort of increases the longevity of these patients and somehow also increases the LV ejection fraction. Now, what happens here is the sacubitril increases the cardiac myocyte decreases the cardiac myocyte contractility and decreases the cardiac myocyte death, while valsartan leads to cardiac myocyte hypertrophy and also LV extracellular matrix remodeling, but reduction in these two. And this leads to cardiac remodeling in a way, in a reverse remodeling, which actually improves the LV functions. The beneficial reverse cardiac remodeling effects with sacubitril and valsartan have been demonstrated in multiple studies in HFrEF patients, not only one but many studies. And what we have seen that this benefit actually starts very early, and it's a long-lasting benefit. And LVEF almost improves by 5% in most of the studies, and we know that this 5% improvement in LVEF in hospitalized patient actually translates to a much bigger improvement in the survival of these patients. The data from prospective open-label single-center trial, which included 68 patients of acute decompensated heart failure, it was seen that this combination improved ejection fraction by 8%, and there was no improvement in EFs by ACE inhibitors and ARB. We are talking of a subgroup of hospitalized patients with ADHF. It improved the echocardiographic parameters of in-hospital patients, and this is the data from prospective open-label single-center trial, and again enrolling 68 patients of ADHF. And what we see here is there has been improvement in the indices from and parameters of echocardiographic, both in terms of end diastolic decrease in end diastolic volume, decrease in end systolic volume, and also improvement in E to E prime, which is an indicator of diastolic dysfunction. Again, this study showed that there was 42% relative improvement in with this combination compared to only 1% improvement with ACE inhibitors and ARB. And it is recommended by ACC and ACC in 2021 that for all hospitalized patients with HFrEF, this combination should be the first line of treatment, along with other decongestive therapy in patients with HFrEF who have been admitted with acute decompensated heart failure in the hospital. The ESC guidelines of 2021 recommends ARNI as a first-line therapy in HFrEF patients, and we know why it's recommended. It is a cornerstone therapy for HFrEF patients, and this has been proved beyond doubt by different studies, by different guidelines, be it European, American, or WHO guidelines, and also the Indian guidelines, and this is what we have seen even in our day-to-day practice. So now we come back to Dr. Kher and to discuss whether this combination improves heart function in HFrEF patients and CKD patients.
Thank you, Dr. Khanna. As you can see in this slide, actually, sacubitril valsartan significantly improves heart function in real-world HFrEF patients with chronic kidney disease. This is real-world data, 54 patients. On the left-hand side, what you see is the historical controls, and this is at baseline in gray, and then darker yellow is about 6 months and 1 year of treatment. So you can see that there is improvement with the standard of care. This is the historical controls which were available prior to availability of sacubitril valsartan. And with the availability of sacubitril valsartan in these patients, you can see that there is an increased improvement in the percentage of people who improve their left ventricular ejection fraction in patients with chronic kidney disease. These are difficult group of patients who have chronic kidney disease. Heart failure alone, and then in addition, chronic kidney disease obviously makes these patients extremely difficult to show improvement. So improvements have not been very easy in this group of patients, and sacubitril valsartan showing a significant improvement is definitely a good impact of this drug in patients of chronic kidney disease. These are worse patients. Next one. And you can see that actually sacubitril valsartan, and this is a sub-study of the paradigm heart failure study, which included about 2,745 patients. These are patients who had an GFR less than 60 ml. Paradigm heart failure had included patients up to about a GFR of 30 ml or so. They did not go below 30 ml. So these are group of patients who had GFRs between 60 to 30 ml. And you can see that this is in comparison to enalapril. And you can see that there is a 21% reduction in cardiovascular death or hospitalization for heart failure. There is again a 24% reduction in cardiovascular death, 21% reduction in hospitalization for heart failure, and all-cause mortality, again a 21% reduction, and 30% reduction in the development of end-stage kidney disease. So you can see that not only there is improvement in the mortality in patients with either heart failure admission or cardiovascular death, all-cause mortality, development of end-stage kidney disease. So these parameters are significantly improved in patients with the kind of standard of care. You can see that the ACE and ARBs in heart failure have already improved the mortality rates by about 18% or so. You are about 34% increase in the survival of these patients. And in patients with heart disease and kidney disease, this is a significant kind of a paradigm shift in the management of these difficult patients. Next one, please. And not only you can see what is significant in this patient, which is extremely important for nephrologists, and look at the impact on the decline in the GFR. With enalapril, you would, starting say at a GFR of 63 ml, you'll see that in 1 year time, there would be a decline in GFR to about 56 ml or so. So 7 ml decline in GFR. But with sacubitril valsartan, you start almost with the same similar kind of a GFR, but the GFR improves by about 7 ml. So in fact, there is an improvement of about 14 ml of preservation of kidney function in these patients who otherwise would have progressively progressed to advanced kidney failure. So sacubitril and valsartan definitely brings a huge advantage to patients who have significantly severe disease with very, very high mortality and very, very high morbidity in these patients. These people get admitted very, very frequently to the hospital. So sacubitril valsartan, a great, great addition in the management of these patients, difficult patients. Over to you, Dr. Khanna.
So we see this drug has a potential not only to increase the cardiac function and the ejection fraction, we also see that it has the potential to increase the kidney functions and the GFR, and probably this happens because it's acting in that loop of cardiorenal syndrome, and better LV functions actually lead to better renal perfusion and better kidney functions. Now, what is the impact of this combination on HFrEF patient with after revascularization? Again, we come back to Dr. Yadav. And
well, the effect, carries on. It is not just limited, as Dr. Vijay K said. The benefits occur in the kidneys, they do occur in the heart and the entire vascular system, and they do remain even post-revascularization. In fact, if you look at the same study that Dr. K was referring to, and we're going to refer to over and over again, the paradigm heart failure study, even in this patient who did not have any coronary revascularization, there was a roughly 17% improvement in or reduction in cardiovascular death and heart failure, the composite endpoints. But if the patient had undergone coronary revascularization, this benefit got exaggerated to 26%. So there was a 26% reduction in the composite endpoints. Next slide, please. And if you look at the breakup, now this occurs both early as well as late, and it is irrespective, as I told you, of the revascularization status, and there is 20% reduction in cardiovascular death. So the composite endpoint was driven mainly with hard endpoint of mortality, and that is very important. Reduction of MI, strokes, and those are important, but not as hard endpoints as mortality. Next slide, please. We also see that the composite outcomes, and these composite outcomes included, things like MI, stroke, resuscitated cardiac death, as well as cardiac arrest, as well as cardiac mortality and all-cause mortality. And there was a reduction from 20% to 17%, which is a kind of a 17% relative risk reduction in the composite endpoints. So it's important to realize that post-revascularization remodeling is extremely important for satisfactory results of a revascularization. Otherwise, no matter what great a job you have done, the patient may have functional graft, but his ventricle fails, then the problem, in fact, not only remains, it worsens. Is that all, I suppose? And, I've already spoken this. This is reduction both in cardiovascular death and heart failure hospitalization. Even if you look at the individual components and you look at early as well as late, this reduction is compared to the use of just ACE inhibitors And in the paradigm heart failure, as Dr. Vijay Kher had already told, the comparison was made with enalapril versus the ARNI inhibition. Thanks. Next slide, please.
Okay, so once we are clear about this fact that, ARNI is important both in improving LV functions and also improving renal functions, it is a must post revascularization if the LV is poor. It could mainly in HFrEF patients, but also in HFpEF patients, as told by Dr. Yadav. Does NT-proBNP play a significant role in cardiac remodeling in HFrEF patients? Now, it is NT-proBNP, which is one of the most common biomarkers which we use in our clinical practice, is a prognostic biomarker in HFrEF patients. And most of the studies and the trials which we have seen now, actually, one of the endpoints is a change in the NT-proBNP level. And this is released from the myocardium in response to hemodynamic stress. It provides prognostic information in HFrEF patient, and decrease in its concentration shows that there is an increase or increase in the improvement in the heart failure or LV ejection fraction or the LV stress. Its level independently predicts clinical outcome post-discharge in hospital patients. And if NT-proBNP did not decrease by 72 hours, the patient are at a risk of, there's a 75% increase in the risk of death or hospitalization within 30 days, and fourfold increase in the risk of death at about 6 months. So ADHF patients without a significant fall in NT-proBNP levels merits closer surveillance post-discharge. And obviously what it means is these patients have not been adequately treated in hospital or before discharge. And these are the patients who are going to come back again with repeated hospitalization and repeated heart failures. And we need to know every repeated heart failure hospitalization is an independent predictor of a worse prognosis in terms of mortality and MACE. So what are the impact of change in NT-proBNP on cardiac remodeling parameters? Numerous heart failure therapies like sacubitril or valsartan are associated with reduction in NT-proBNP in parallel with reverse remodeling. So what happens here is not only that the NT-proBNP levels have linear correlation with improvement in LV ejection fraction, also they have a linear correlation with decrease in LV end diastolic volume and LV end systolic volume, and also the clinical condition of the patient and the NYHA class. ARNI reduces death and heart failure hospitalization by reducing NT-proBNP. It is not by reducing NT-proBNP, it is by adequately decongesting the patients and improving the heart failure and improving the cardiac remodeling. And this NT-proBNP is an indirect biomarker suggesting that this improvement is happening. So it's not because of NT-proBNP, but NT-proBNP is a marker. Fall in this NT-proBNP is a marker of improvement in cardiac functions. Now, what is the impact of ARNI on cardiac reverse remodeling in HFrEF patients with FMR? I'm going to direct this discussion again to Dr. O.P. Yadav.
Well, cardiac remodeling obviously is extremely important, and what it does to the ventricle is that the ventricle dilates. It also changes its shape. So from an typical elliptical left ventricle, it becomes spherical. And when it becomes spherical, what happens is that the mitral valve gets tethered. That is, the chordae are pulled laterally instead of longitudinally, and the closing forces of the mitral valve and the tethering forces of the mitral valve start competing. As long as the closing forces are strong, the mitral valve remains competent, but the moment the tethering forces take over, the mitral valve becomes incompetent, and left ventricular remodeling as well as left atrial remodeling, that increases the mitral regurgitation whenever it is a functional MR. So in that way, it is extremely important that we control the ventricular remodeling, and that is why we say functional mitral regurgitation is a ventricular problem. It is not a valvular problem. Next slide, please. So the first and foremost is guideline-directed medical therapy. You know, European Society of Cardiology and Cardiovascular Surgery just a couple of weeks back or 10 days back have released their valvular heart guidelines, 2021, just 10 days back. And they've given class 1 recommendation for guideline-directed medical therapy. And it is not only ARNI, but it is also, you know, SGLT2 inhibitors and ivabradine. And they must replace ACE inhibitors and ARBs, even if the patient is so-called stable. In fact, the word used is, there is nothing like a stable heart failure. So we must, even in patients who do not have symptoms, we must transition to ARNI oblique, the SGLT2 inhibitors as the need may be. Next slide, please. Now, it has been shown in the PRIME study that systolic and systolic volume and diastolic volume, as well as index volumes, they reduce by more than 2 times with ARNI as compared to the ACE inhibitors. Next slide, please. And if you look at effective regurgitant orifice area, there is a reduction of almost 3 times. Next slide, please. And regurgitant volume of the mitral valve also, reduces by almost 3 times or 2.5 times. So there is a gross remodeling benefit in these patients, and surgery or any form of intervention must only be considered if a patient has been adequately treated with guideline-directed medical therapy, and which includes ARNI and SGLT2 inhibitors. I think I'm finished. Thanks.
That's a very important learning, that even in functional mitral regurgitation, because of LV dilatation and ARNI is a very important and a first-line drug, and it's now recommended by the European guidelines. Now, what is the safety profile of this drug in hospital HFrEF patients, in terms of the nephrologist point of view? Dr. Kher, I'll direct this discussion to you.
Yes, Dr. Khanna, as is evident in this slide, actually worsening renal function is very well known to cardiologists as they start treating patients with heart failure. There is worsening of renal function as the heart failure progresses, and there is also worsening sometimes in patients when you start treating and removing the fluids with diuretics, and there is a diuretic induced increase in the serum creatinine and the urea. And when you look at sacubitril valsartan in patients of acute heart failure, and this is from the PIONEER heart failure study, you can see that there is an 11% reduction in the incidence of worsening renal function. And worsening renal function, you must realize, is associated with increased morbidity and mortality in patients of heart failure. So in comparison to enalapril, there is a 11% reduction in the incidence of worsening renal function when you switch patients on to sacubitril valsartan from enalapril. Next one, please. And the incidence of hyperkalemia, also hypotension, is also reduced in these patients. Hypotension is a significant adverse effect in the treatment of heart failure patients, and with sacubitril valsartan in the PIONEER heart failure study, you can see that there was a 27% reduction. The incidence of hypertension in enalapril was about 4.6%, and it was 3.4% of patients on sacubitril valsartan. So 27% risk reduction of hypotension with sacubitril valsartan in comparison to enalapril. And next one, the incidence of hyperkalemia. Next one. The incidence of hyperkalemia in the hospitalized patients. When you look at enalapril, one of the common complications of treating with enalapril would be incidence of hyperkalemia and sometimes severe hyperkalemia in patients of heart failure. And in patients associated with kidney dysfunction, the incidence of hyperkalemia becomes much higher. The overall incidence of hypertension, hyperkalemia was reduced in the Pioneer heart failure study by about 41% once you moved patients from enalapril to sacubitril valsartan. So significant improvement in the adverse effects related to sacubitril valsartan in comparison to enalapril. Next one, please. So I hand it back to you, Dr. Khanna, for you to summarize this whole case discussion.
This was a really good discussion discussing about the entire spectrum of heart failure in a revascularized patient with renal dysfunction, and how this new drug helps in different ways, and what are the different mechanisms it works on, and also what are the clinical scenario where ARNI is important. So let me just summarize what we discussed. In a HFrEF patient showing changes in echocardiographic parameters like this patient Seema, time is very essential. So one has to be very, very critical that you need to initiate these therapies and get the patient better before you discharge the patient. And so to initiate ARNI as a first-line therapy in heart failure, we must have the confidence, not only because it improves the heart function and the remodeling in the in-hospitalized patients, it improves clinical outcomes in HFrEF patients post-revascularization, and it is also a very safe and well-tolerated drug for in-hospital HFrEF patients. And what we need to understand that there are a lot of people who are worried that it may cause symptomatic hypotension. As we saw, the risk of hypotension as compared to other ACE inhibitors is much lower. And even if the patients do have a fall of blood pressure, they actually feel much better. They are better in terms of NYHA functional class, and they improve in terms of parameters of heart failure, whether they are the echocardiographic parameters or they are biomarker parameters. So with this take-home message, I'll probably stop here. And I thank my co-discussants, Dr. O.P. Yadav and Dr. Vijay Kher, for making this discussion very fruitful and with a very clear-cut, take-home messages. Thank you very much for staying back for attending this APVIC. It means a lot to us.
Thank you.
Thank you. Appreciate it.
Thank you.
So now let's move to the session, Women Crusaders of APVIC. I'm sorry to to keep you delayed because of this swapping of these two sessions. Let me invite the Women Crusaders, Dr. Amira Benjelon, who has been there with APVIC from day one. She's also one of the post directors. She is the president of the Moroccan Society of Vascular Surgery. Dr. Aarti Lalchandani, who is a very famous cardiologist who practices in Kanpur. She was also the principal of for GSVM Medical College in Kanpur. And Dr. Geeta Subramaniam, who was the ex-HOD of Department of Cardiology at Banaras Hindu University Institute of Medical Sciences. Dr. Jane Ajaluchukwu, who is the mother figure of cardiology in Nigeria. And I was privileged to actually train her son, Dr. Obiora, whom I have a very fond memories, and subsequently a chain of cardiologists from Nigeria have been sent to my center, and they have been excellent fellows, and now they are all excelling as excellent consultant cardiologists in Nigeria. We also have Dr. Vijayalakshmi, Dr. Monica Kher. I think Monica is traveling right now, so she probably is not joined. Dr. Preeti Gupta, Dr. Rupa Salwan, who has been a colleague for last 20 years in interventional cardiology. Dr. Rini Permestri from Indonesia, who's leading the Indonesian vascular intervention. Dr. Suparna Rao, who's heading hospital in Vrindavan, and she has been my associate and a very, very academic doctor, and Dr. Ulan Agrineni, who you have heard speaking on almost every day. Now, let me also invite the people who are going to present, Dr. Poonam Mehrotra, who is the head of the Department of Cardiac Anesthesia in All India Institute of Medical Sciences. She's also, she has a tremendous role in actually promoting and propagating use of ECMO in our country. Dr. Sarita Rao, who has excelled in interventional cardiology and is one of our colleagues at Apollo Indore. Dr. Shrikala Padmanabhan, who has been associated with APVIC and is a leading interventional cardiologist in Kerala. Dr. Anumit Bagga, who is a cardiac surgeon, trained in vascular interventions, and she's been a regular member of the APVIC family. And Dr. Tanya Pereira, who is an interventional cardiologist from Sri Lanka, and she is known for her skills in vascular intervention. So with this, let me invite the panelists to come on board and put their camera on, and let me invite Dr. Poonam Mehrotra to talk about recent advances in ECMO.
Thank you, Dr. Khanna, for giving this opportunity. In fact, it's always a pleasure to be a part and parcel of the APVIC programs over the years. The APVIC programs have done wonderfully well, and it's really a proud privilege to be a part of this time, even though it is not physical, but to be here is enough to speak about the state of ECMO as it exists in the country today. We were very lucky in the last couple of years to be doing some ECMO in COVID with disastrous results. But what we learned is a lot more to improve our patients in the post-COVID era. So I bring you greetings from my alma mater, AIMS, where ECMO came in 2002. We had very bad results with a mortality of nearly 70% till 2010, when we started doing what was known as integrated ECMO. And integrated ECMO paved the way in a very big way. We are primarily a pediatric center where a lot of tertiary complex congenital cardiac surgery is done. And if you see the patients that come to us, whether it is a truncus or a arterial switch operation or a obstructed TAPVC intracardiac, the initiation of a CPB or an ECMO brings about hemodilution. It brings about a hypothermia with dilutional coagulopathy, contact factor pathway activation, and all of this leads to an inflammatory process with the generation of thrombin. Now, thrombin generation is something that is disastrous and worsens the inflammatory process. And at the center of all this is nothing but the platelet. Platelet is the universe which brings about all the contact factor, tissue factor pathway activation. And from it begins the factor 10, factor 10A activation, which is also very, very bad in an ECMO patient. But if you put this patient on an ECMO beforehand, and this is what we did from 2010 onwards at AIMS, we started to put our patients with the surgeon putting the cannulas preemptively as if you're coming off not on CPB after the surgery, all elective surgeries, but you're coming off after the CPB on the ECMO circuit. This ECMO circuit was similar. We were at that time in 2010 onto the roller ECMO pumps, but today we have the CPB pumps. Our 10-year experience is wonderful on integrated ECMO. The mortality of 70% is reduced to a mortality of 27% today. And the circuit after surgery is just the way we wanted the circuit to be on a veno-arterial ECMO for these pediatric neonates as well as infants. So integrated ECMO circuit, the CPB incorporated, increase the preparedness and the availability. It cut down the assembly time. What were we doing before? The patient would come off on a low cardiac output and we would juggle for the ECMO machinery. But here we were prepared. We were coming off on the ECMO. It reduced the possibility of CPR resuscitation. It is very, very cost effective because you're not using duplication of cannulas. And the pump today is a good centrifugal pump. And we were extending the boundaries of creating a historic win over using the integrated ECMO circuit for a DTGA with an intact ventricular septum, even in bigger babies who were more than 3 years of age. So when we did this, the concept and design of the integrated ECMO became very, very paramount to our circuit. And along with it, from high flow ECMO, the recent advances towards a low flow ECMO. Why? Because the low flow ECMO, because of technical advancements in the ECMO machinery that we are seeing today, we use the CardioHelp. The clinical management available for short-term as well as long-term ECMO applications became much, much better. And today you have, from the roller pumps, those centrifugal pumps, or the cones as we call them, which cause less hemolysis, which cause less platelet dysfunction and thrombocytopenia. And we can evaluate the level of perfusion at low flows with less hemolysis than at high flows. So if we need central cannulation, which brings us better drainage, oxygenated blood, post-cardiotomy, especially in cardiogenic shock, the peripheral vascular disease also entails a central cannulation over a peripheral cannulation. But one of the most recent advances in the use of ECMO, particularly the veno-venous type of ECMO, is the percutaneous treatment of using the peripheral limbs for cannulating. Why? Because the availability of the peripheral cannulas became much, much better than what it was before. So if we use the semi-open technique or the open technique or the semi-Seldinger technique, the risk of vascular complications became less with these very, very naive and very new enriched siliconized ECMO percutaneous cannulas for both veno-venous as well as veno-arterial, where the femoral vessels could be cannulated or the right internal jugular vein could be cannulated with a dual lumen cannula like the Avalon. And if the Avalon was causing a lot of thrombosis, today we have the Crescent cannula, which is even better than the Avalon. What came in was the pumpless ECMO, the use of end-tidal carbon dioxide removal in a very, very smooth way. And if you use ECCO2R with peripheral cannulation, you just need a small pump which is put between the groin or the two legs of the patient, and contralateral two femoral vessels, whether veno-arterial or both the femoral veins in a veno-venous, are connected, and there is removal of carbon dioxide, which brings about absolutely good results, because CO2 retention with PCO2 being very high was causing a lot of acidosis and giving bad results on ECMO. So AV shunt kind of a picture was put in. A very major recent advancement has been the use of lung protective ventilation. The lung rest, which we use as ventilation therapies, better ventilators, APRV, inverse ratio ventilation, with the use of high frequency oxygenation ventilation, has brought about very good adequate gas exchange, keeping a PIP about 30 to 35, keeping the PEEP between 6 to 7 or less than 8, with a rate which is less than 35 and an FiO2 less than 50%, and a tidal volume in the ultra protective is as low as 3 ml per kg body weight. This brings about fantastic results, especially on the veno-arterial cardiac ECMO. Another very, very useful part was the use of echo during ECMO. And if you use echo, the patient selection, if there was a aneurysm of the aorta, or there was a PFO, or there was a small obstruction in the RA, because RA is the area where most of the cannulas are going to lie, then we would not use central ECMO in this patient. But as we talked about the acute decompensated heart failure, where we want something temporary to give us some results before we use it as a bridge to transplant, or a bridge to bridge, or a bridge to VAD, or a bridge to recovery, or destination therapy, where clinical judgment, echo variables, and hemodynamic parameters are not enough, we started to use better anticoagulation. And when we started to use better anticoagulation, moving from heparin, which was a culprit, from high dose to low dose, and during the pandemic, a heparin-free period. This is where we are today, giving bouts of 2 to 3 days of heparin-free period. Most of the COVID patients were on low molecular weight heparin, so we did not add heparin. And to our results and to our happiness, the ACT, the APTT, and all the anticoagulation parameters remained within normal limits. Today, what we need are not just heparin bonded circuits. We need a biofilm or a biosurface which has added nitric oxide, which gives a good intact endothelium kind of a result. Probably that's where the research is, and that's where we're going to be going. But something that if can be added along with an echo to an ECMO machine is the use of a point of care analyzer. A sonoclot, a TEG, or a rotum, if you add it and implement protocolized algorithm-based rotum studies or TEG studies, where you use the RTEG at parameter or as well as you use a APTT, then one test would tell you which blood component to give. It is very easy to monitor because the turnaround time is 5 to 10 minutes. And using low molecular weight heparin, the anti-10A, if that was the monitoring technique that we needed, the RTEG gave as good a result for anti-10A, because getting anti-10A in even a city like Delhi became difficult during the COVID time. And what did we develop at AIMS? We developed algorithms for these point of care tests, where we use platelet function tests on the rotum or on the sonoclot, where a PF SON on the sonoclot of less than 0.9 told us that there is thrombocytopenia and you don't need to give whole blood or cryo or FFP, but your patient needs just single donor platelets. So research was done by a lot of people in Germany, a lot of people in Europe, and point of care algorithms became a norm on ECMO patients. This is where we are today. We pick up these, we give the right component. It is never always whole blood. Why? Because we are in a restrictive transfusion phase, and that's what the patient blood management therapy and the guidelines from European Society also tell us. The advantages of ECMO in a acute decompensated heart failure patient cannot be overlooked. You need an IABP, but IABP alone is never enough. With big cannulas being put in, an IABP with ECMO can exist today, and a lot of guidelines coming up from all over the world in the West today is on how to judiciously use ECMO with the IABP. And using ECMO as an LVAD therapy, just bridging it before an LVAD, particularly before a lung transplant, you need a veno-venous ECMO. So ECMO as a bridge to transplant came up, ECMO as a bridge to VAD or destination therapy came up. And ECMO with IABP and ECMO with VAD together can be put for 3 to 4 days on a patient. And these are some of the most recent components of the use of ECMO.
Dr. Poonam, please conclude.
Okay, I'll just wind up. So if we categorize the ECMO centers in the country, from 8 to 9 have today picked up to more than 59 centers. We formed the SWAC ELSO, the Southwest Asian ELSO, with the ELSO of Dr. Robert Bartlett from Michigan. And we came up with anticoagulants and blood product usage in a very, very good way, so that the 3-pillar component, multidisciplinary, multimodal therapy of patient blood management could be maintained. Anticoagulation is where we are. It's an enigma. Using the right anticoagulant is not just heparin, but doing away with heparin because it's the only agent which can be neutralized is also not one. So we need direct thrombin inhibitors and alternatives to heparin. Another thing, and that this is my last recent advance, is the use of cytosorb, particularly in ECMO with sepsis. Cytosorb removes the cytokines, the plasma kallikrein pathway, and this takes away all the inflammatory markers and has shown that patients on whom a cytosorb was kept with ECMO, the ECMO removal and weaning off and trial off was much faster, as you can see in this slide, and the use of ECMO with cytosorb is on the rise. I would like to end by saying that whether it is COVID or whether it is any inflammatory marker, using expensive therapies may not be there, but cytosorb as a bridge is there. What we need is nitric oxide. Inhaled nitric oxide is also added on to the ECMO therapy, and advances in ECMO management may help complications compared with inception, but we need antithrombin 3 with heparin, which is the prodrug, as the cornerstone of anticoagulation to be done away with, and urgent need for more research in this field is what is warranted. Learning from each other, taking out academic portfolios and taking out books and journals on ECMO is need of the hour. And ECMO today stands tall in every ICU because of learned behavior post-pandemic. Thank you so much for giving me this opportunity. Thank you, Dr. Khanna.
Wonderful, and I would request you to be in the panel. We'll have the next speaker, Dr. Srikala Padmanabhan, who is a very good interventional cardiologist and also a vascular interventionalist practicing in Kerala. So, Dr. Srikala, Can you put your slides up? Yeah, we can see your slides, but not on the presentation mode.
Good evening, sir. Is my slides visible?
Yes, they are. They are.
Yes, yes, yes,
Okay.
we can see this.
Okay, so good evening, respected chairpersons, all panelists, and my dear friends, my dear colleagues. At the outset, I would like to thank Professor Khanna for giving me opportunity to present my case before this august audience. So today I would like to share a case of critical limb ischemia in
I cannot hear you, Dr. Srikala.
You cannot hear me?
Yeah. Yeah, no, I can. Okay.
Sorry, my slides are not moving. So this is the story of a 92-year-old lady. Is my slides visible now?
Yep.
Sorry.
Yes.
Question. Yes, we can read it. We can show it.
But it's sorry, it's not moving in my computer. So it's a story of a 92-year-old lady who presented with critical limb ischemia of lower limb. She had okay, so she presented with gangrene and ulcer of her big and second toes. She was 92 years and she had history of coronary heart disease with the left bundle branch block pattern and chronic atrial fibrillation. And she is on regular treatment for that. And when she presented, she had history of rest claudication symptoms for the past 1 month. And she also had gangrenous, pre-gangrenous changes of the first and second toes. So she was taken after the preliminary workup. She also had diabetes mellitus, and she had no previous history of POVD. And after the preliminary workup, she was taken up for a peripheral and coronary angiogram. Her peripheral angiogram revealed a flush occlusion of left superficial femoral artery, as you can see from this picture. The profunda is filling, and we cannot see the stump of femoral artery. And the distal SFA can be seen filling from collaterals. So we tried multiple views so as to see the ostium, and we were planning for the crossover approach from above, since already we have put a sheet from above, and she also had a difficult iliacs. So from the opposite side, that is from the right femoral side, the different views were taken, and with the multi-purpose guiding catheter, I was able to view the ostium of the superficial femoral artery in this view. So it was a diffusely diseased and totally occluded superficial femoral artery. And with the multi-purpose catheter, we tried the thermo wire, and the lesion was crossed with the thermo wire, with the hard end of thermo wire, and the lesion was crossed and placed in the anterior tibial artery. So after passage of the wire, a trickle of flow was established in the SFA, and you can see there is only faint flow, and multiple balloon dilatations were done using initially coronary and then peripheral balloons, and a good flow was established in the entire superficial femoral artery and also in the infrapopliteal vessels, because we are not able to see the ATA and PTA in the initial angiogram. So once the flow was established, we decided to stent the osteoproximal SFA with a 6x120 millimeter silver stent from Cook, with the final good flow up to the toes. and she also had a relief of this claudication pain, and the ulcer also healed totally within a span of 1 month. And intervention in this lady, even though she was 92 years, the bystanders and all the others were willing for all sort of intervention. And actually, she was the grandmother of one of our orthopedicians. And successful intervention saved the limb from amputation. And SFA intervention was very crucial in this lady for this ulcer healing process. Because of this, because of the background of atrial fibrillation, a cardioembolic source was considered, and the patient was started and discharged on NOACs. Thank you. Thank you for the patient listening.
Hello.
Yeah, hello.
Who is the next speaker?
While the next speaker is preparing, can I ask a question? Whether you can use a long balloon or drug balloon in this patient, or always we have to stent the...
No, it's we can use a long drug-eluting balloon. Actually, this case, I have done this case around 3 years back when the peripheral drug-eluting balloons were not much available in India. So, and moreover, in this lady, I have not included all the videos. There was dissection in the osteoproximal part of superficial femoral artery, because initially there was we could not see the ostium, but I think by repeated attempts only I was able to establish the flow in the SFA. So we decided to stent the SFA because of the dissection.
Okay.
Thank you.
So is Dr. Anumit Bagga ready with her presentation?
Yes, I am ready. Should I share my screen?
Yes, you should.
Okay.
I think you are one of the rare surgeons who are specialized into endovascular right from the beginning.
All
of your
thanks to
career.
you, sir. I've been attending this APVIC for the past 4 years now. So, just a second.
We can see your slide. You
Okay.
just have to go to, yeah, now it's on the full screen.
Right. How do
You're going backwards.
okay, right. Okay, good evening, everyone. And thanks, Dr. N.N. Khanna, for letting me be part of this APVIC. And it's a very great honor. So, I start with my presentation. So, I have been doing a lot of interventions here at my institute, which is Government Medical College at Patiala. But I have been doing open procedures also. So the critical limb ischemia, which is characterized by chronicity, which is more than 2 weeks of duration, with ischemic rest pain, non-healing wound, ulcers or gangrene in one or both of the legs, which is objectively proven arterial occlusive disease. The diagnosis is both the constellation of signs and symptoms, and for making the diagnosis of CLI, which is more on the duration. So that is the main focus. So according to task classification, the task lesions are amenable for endovascular therapy. For the type B lesions, we prefer the endovascular. For type C, the preferred treatment is the surgery. But for type D, the open surgical procedures are recommended. But as the interventionists are we going for the endovascular therapies, and they're becoming more advanced. So, but still, there are many cases in which the endovascular therapy is not possible. So the open surgical procedures can be classified as either the direct anatomic, which includes the aortobiofemoral bypass, aortoiliac endarterectomies, descending thoracic aorta to femoral bypass, iliofemoral bypass. The extra anatomic bypass are axillofemoral bypass, femoral bypass. The femorotibial artery bypasses with prosthetic graft materials should not be used for the treatment of CLI because they have very high rates of graft failure and amputations. The bypass to the popliteal artery with autogenous vein is recommended, which is in preference to the prosthetic graft material. So I'll be discussing a few cases. This was a 50-year-old male with the history of intermittent claudication in bilateral lower limbs, right more than the left, for the past 8 months. And he also had ischemic ulcers over the right leg and foot for the past 6 months. He had a history of CVA in 2010, and he's also known case of CAD. He's a non-smoker and he is a non-hypertensive and a non-diabetic. So this was the case. He presented with the ischemic ulcers on the right foot, and this is post-open surgical procedure. These are the CT angiofilms, which shows complete block of right external iliac, CFA, SFA, popliteal, and there was partial filling of the right profunda. So when I opened the external iliac, the right groin incision was made, and right iliacs were exposed. The right common iliac was healthy. The right external iliac was hard and cord-like. The right CFA, SFA, and profunda were completely occluding the lumen, and thromboendarterectomy was done. And then right iliofemoral bypass was done using 7 mm EPTFE graft, and femoropopliteal PTI bypass graft was done using the reverse saphenous vein graft. So the inflow was from the right common iliac, and the outflow was into the right common femoral artery. There was another case who presented with complaint of left toe gangrene for the past 20-25 days, and had also history of intermittent claudication for the past 3-4 months. This patient was a diabetic and a chronic smoker. And this is the CT angiofilm, which shows complete complete opacification of the left external iliac from its origin, and the reformation of the left SFA and profunda by the collaterals. A hybrid procedure was performed using a femorofemoral bypass graft with 8 mm EPTFE and balloon angioplasty of the left distal SFA and popliteal artery. So, and another case, this is a 90-year-old male who presented with the bilateral intermittent lower limb claudication for the past 4-5 months and left foot gangrene for 1 month, which was progressively increasing. There was no history of smoking, diabetes, or hypertension, but when he presented, he was in AF. The 2D echo was normal. So this is the case. I attempted an endovascular procedure going from a crossover right femoral approach, and while doing the procedure, this somehow at the aortic bifurcation, the O14 guide wire got stuck in the crossover sheath. So it could not be extracted out from the right femoral puncture. So I had to open up the left femoral groin, and then the wire had to be extracted from there. So I don't know how it came, but it did, and it was a complication that I had to deal immediately with. So this was done. This was another case who presented with history of bilateral intermittent lower limb claudication of 2 years duration. This case I've been planning for axillobifemoral bypass graft. So I would just thank you at the end that these are the cases that I've done as open procedures, which was I wanted to share. So thank you very much. I think I'm done with my presentation.
Waiting for Dr. Khanna to tell us the next speaker.
Doctor, just for my interest, can you tell us which patients you decide to go for surgery in similar situation, and when you take, because you have got both advantages of interventionalist and a surgeon. So how you decide where to go for surgery and where to go with intervention?
This is basically, sir, based on the comorbidities. If the patient is, I said, as the patient was a 90-year-old male, so I could not go for an open procedure. So I went for the intervention, and involving long lesions, which the lesions involving the iliacs and the femorals, the open procedures are preferred. The CTOs, obviously, they can go in for endovascular, but I am obviously prepared for the open procedure as well, as the complication occurred, I said, as I mentioned. So I had to open up the left groin and extract the wire. So, but then, yes, we had the facility to do it. So I did that immediately.
So you have an advantage of being a surgeon,
Right.
and I would say you have a disadvantage that because you will not try very hard to do a difficult lesion, like a cardiologist or somebody like Dr. Srilata, she would be continuing to pursue further for finding ways to cross that lesion and to do it. And many times, like in cardiology, we do it, CTO, it takes much longer and we manage to do it. So I think for you, it might be easier, just you can find a way.
No, I'll just sorry, I would just want to just say something. I have been trying to do very difficult lesions also. I had for this patient, I actually did anterior tibial and posterior tibial. I crossed over and we did good revascularization. But during extraction of the wire, it got stuck. So yes, I do it very patiently, and I've been trying to do as much crossing the lesions. But so it's well, I'm a cardiothoracic surgeon, so I've got a lot of patients do those things. So that's it, sir.
Thank you. That was really very nice acceptance of the things which you have in your hand and giving and sharing your experience.
Right. Thank you, sir.
So, is Dr. Tanya there, or is Dr. Tanya there, or she's? I saw her in the panel, but I don't see her now.
She's offline right now.
Okay, so if that is the case, then we will open this for discussion, and may I request Dr. Rini and Dr. Rajiv Lochan to take over these proceedings of discussion and initiate the discussion. May I also invite Dr. Jain Ajalochukwu, who is the senior most and the mother figure of cardiology in Nigeria, to join in the discussion, and also if Dr. Woolen is around and Dr. Suparna is around, they can also join for discussion.
Dr. Anumit, for your lesions or the first case on the SFA case, the long case, you don't think about put like a supra or the mimic artery stent for this case?
Dr. Bagga, you are on mute.
Sorry, this case, actually I did 18 months back. So the picture I showed was on 18 months follow-up. So the first case, yes, the first case I did was, and that time my cath lab, I had not started working in the cath lab that time. So I had just joined as the assistant professor. So what I had in my hand was the open procedure. So that is what I did. And the patient has good results. On 18 months follow-up also, he's doing pretty well. So he comes and the ulcers healed. He has minimal pain on walking. And that too, he complains on walking long distances. And earlier he could not walk 10 steps or 20 steps. That time he had to sit down. So that was the level of the pain he had that time. So, and the ulcers, and otherwise he would have gone into tissue loss. So I managed it that ways.
Okay.
Yeah.
While you're there, Dr. Rini, can I ask you a question from your presentation when you're talking about anterior May Turner syndrome? So is there any particular role for this angiojet and other catheter, thrombus removal devices?
Yeah, actually the ideal treatment is if we have angiojet, so with the thrombus burden so along the vein, angiojet will be very useful. But at the times in my hospital, the angiojet is not available, and the price is because of also the economic
reasons. Okay.
yeah. But it's ideally also the penumbra, also if the DVT is still soft, it's ideal. But for the recurrent and these patients, the DVT is recurrent for more than 2 years. So I think it's difficult. It's not easy to just remove the thrombus.
Yeah, I just want to share one of my colleague who was doing the other week in our hospital, very similar case. So what he did, he put a IVC filter, and then he put a stent in the artery just to, stent in the vein. And he, before putting the stent, he had also cleared this with the angiojet, and he had fantastic results. So I was just trying to ask whether how it has happened in your center. Thank you.
What I learned from this perforations, the complication is, I think I started the balloon. It's better if I do the escalating balloon. I'm direct with the big balloon. So patient have already received the alteplase, so prone to bleeding, and I put the balloon directly out the size is the bigger size. Actually, for the patients with MPS, especially with the spore, all the collapse, and for the long time, this is all closed. It's better as we do with the escalating balloon, start with the small balloon and then bigger and bigger.
Just another question from Dr. Poonam. Doctor, you're doing ECMO, and I saw that you have been doing for a long time, establishing in India. Dr. Khanna mentions me. So is there a large number of patients in India, they are going for destination therapy, and before that they have used ECMO? So using LVAD as a destination therapy rather than a heart transplant. So are there a number of patients we have been treating like this?
No. LVAD and RVAD came up in a big way in 2005, 2006, 7, up to 2010. We were using Thoratec, we were using HeartMate 1, and recently from 2017 onwards, HeartMate 2. But see, what happens is the Western world has moved way ahead of us. HeartMate 3 as well as Impella are the norms. We need VAD, and VAD is always done at a tertiary referral center. I can name only 5-6 centers which are putting in VADs in a very, very big way. So for ventricular assist devices, somehow we at AIMS lagged behind, but we did not lag behind ECMO. We put in RVADs, we put in biventricular VADs. HeartMate 2, we put 2 to 3 last year itself, 3 of them. The results are very good. You put the patient on ECMO and then you take the patient the next day or within a few hours for a VAD. In Chennai, probably there are 3 centers which are doing great ventricular assist devices. So also in Bombay, so also in Bangalore. Many centers, 8-9 of them have picked up for ventricular assist devices in the country. But I would say more than VADs, it is ECMO that has picked up more. VAD is a very expensive proposition. Not many can afford it. And centers which are well equipped like Narayan Hridyalaya or like MGM, I was just there yesterday, they're putting VADs over and above when the heart or the lung is not available. Oh. If you don't have an organ, and especially organ donation still in the country is less. Maybe one center can do 350 heart transplants in maybe 4 years. But of us, we've just done about 80-85 heart transplants in India so far at AIMS. So many centers are now putting onto VADs, but we are awaiting the FDA approval for Impella to come up in a big way. Using ECMO and Impella along with what we use as the cone. The cone is the centripetal centrifugal valve that is available to us, CentriMag, by the name of CentriMag. Now, CentriMag using is excellent for RVAD, and that is where patients with pulmonary artery hypertension, with right-sided failures, CentriMag along with veno-venous ECMO gives wonderful results before a heart-lung transplant or a pure lung transplant. That's where we are today. But VAD therapy alone has not picked up as much as ECMO and the way that we do transplant.
Thank you very much, Dr. Khanna. You can go ahead.
Dr.
Thank you, Dr. Lochan. I also see Dr. Preeti Gupta and Dr. Aarti Lalchandani and Dr. J.N. Ojalachuku there. If I would definitely want their comments on this session, and this is a new session which we have started, and it's very heartening to see how much of work is happening in India, and what we are seeing is a surge of women cardiologists who are taking the lead and doing excellent work in all sections of cardiology, whether it's pediatric, EP, clinical cardiology, non-invasive, vascular, or coronary. So this is and also structural. This is a great revolution which is happening, and we wanted to acknowledge this and have this session of APVIC, Women Crusaders in APVIC. So Dr. Aarti, would you like to comment on this? And
I congratulate you, Dr. N.N. Khanna, for your consistency, regularity with which, in spite of Corona, you have been organizing APVIC so regularly and in such a grand way. Really, it is an academic bonanza, non-stop. And thanks to Vinkars, that all the women cardiologists of the world, or women in actually cardiac sciences of the world, international, we all got together thanks to people like Poonam, Dr. Jyotsna Madhuri, Dr. Asha, and so many, Dr. Shiba. So there are so many ladies who drove this Vinkars, and it has become a very prominent name. It gave us a platform for all the women cardiologists, but thanks to you for giving the women a big platform in one of the biggest conferences, biggest organizations and courses, a true academic course in the world. Thank you, Dr. N.N. Khanna.
Thank you, Dr. Aarti. Dr. Preeti, you have something to say before we wind up?
So we have cases of critical limb ischemia we commonly seen in emergency, and the timely use of catheter-directed thrombolysis or the peripheral arterioplasty is very much needed to tackle these cases and prevent these cases from amputation. Thank you so much, sir.
Thank you. So, Dr. Rini, can we wind up this session?
Yep.
Thank you very much for coming and attending this. I know it's very late in your country, but thanks again. Thanks a lot. And we still remember when you were here and how much of work you were doing, and it was a very good level of academic and clinical and interventional work which you did, and actually set an example for Woolen and other international fellows who came in.
I'm humble, sir. Thank you.
So thank you very much. Now let's move on to the next session. As we know that APVIC has moved out, has now some sessions, international sessions, and we are having a Middle East session of APVIC. We are having a Southeast Asian session of APVIC, and also African and Nigerian session of APVIC. Today, we have almost 5,300 attendees. In all 3 days, we have surpassed 11,000 attendees in our online APVIC this year, and we had more than 60 international faculty. Now, moving on to the next section, I would invite Dr. Rajiv Lochan, who is one of the senior most cardiologists, interventional cardiologists of India, then moved to Middle East, and I am sure he must be the senior most interventional cardiologist of UAE as well. He's been a wonderful teacher, a real good academician, also a researcher. He has a very novel and ideas, and he has an out-of-box thinking. He's very good in his skills. And I was impressed in interventional cardiology and vascular work. Even when I was a fellow and I was doing my DM, I used to see him operating, and see him speaking in the meetings, always with a new thought and a a thought which actually came in a lot of, at least 2 decades later. I remember one of his case, putting, multi-layered, putting 2 wall stents in aortic aneurysms and putting in coils, and that actually later on was the concept which the world accepted in multi-layer flow modulators. So let me ask him to chair this session and carry on with the proceedings. I would also request Dr. Omar Halak. He was traveling to United States. I don't know whether he has joined in. Dr. Brijesh Mittal, who also is a very dear colleague and works in UAE. He heads a department and a hospital there. Dr. Ajay Kanodia, again from UAE. Dr. Sachin Upadhyaya, who's been a very close and a very fond colleague of mine, and he's been instrumental in starting APVIC right from this place. From the first APVIC, he was there. And Dr. Abdul Rauf Malik, who was also my associate and a very good cardiologist and a good researcher who's also practicing in UAE. So I'll hand it over to you, Dr. Rajiv Lochan, and I know you have a talk, the first talk on ultrasound-assisted thrombolytic therapy in high-risk pulmonary embolism, and you are using some real new novel devices which we do not have in India. And it will be followed by a talk of Dr. Brijesh Mittal on aggressive therapy for secondary prevention of atherosclerotic cardiovascular disease, and Dr. Ajay Kanodia and Dr. Rauf Malik on update on NOACs in VT. So I'll hand it over to you, Dr. Lochan, and for you to carry on the proceedings of this session.
Thank you, Dr. Khanna. And I think I'm so impressed that you remember that case, which was done about 25 years ago. And if I remember correctly, Brijesh Mittal was with me in Apollo Hospital when we did this case. And it has been a really innovative journey of the new procedures we have done. And many times it has been a question whether it was safe to do it. It's the only thing that question I asked, whether it is safe for the patient. And only then we tried new therapies when they were not very established. So with that, I will share my screen and see whether you can see my slides. Can you see my slides?
No, we can't see your slides. Yeah, just.
You can't see?
No.
Let me share it again. So let me.
Ujjwal, do you have Dr. Lochan's slide? One second, we'll take it out from, I think you had transferred it, we'll just get it out. 1 second.
But I actually...
Yeah, now we can see it.
Okay. Good. So I will make a full screen and then it should be okay then. Can you see it now?
Yes. Yeah, we can see it, full screen.
Okay, so this is the ultrasound-assisted thrombolytic therapy in high-risk pulmonary embolism. This is not a very common scenario, but we do get these patients time to time. Organizer, can you unmute? Can you mute the other mics, please? There are some background noise. So, thrombolytic therapy for pulmonary embolism, is it a real or is it justified? There are lots of questions before we go ahead with this kind of therapy. And it appears logical to remove the offending cause of the massive thrombus and immediate improvement in the failing right heart. Thrombolytic therapy immensely successful in dissolving clot in MI, but the same has not been translated into the pulmonary artery thrombus. Why? We don't know the dose, how long it should be continued, which agent should be used. Is there any mortality, morbidity benefit at the cost of either bleeding or stroke? So these are the major concerns which we have. So catheter-directed therapy has local delivery close to the thrombus. That's the logic, and it appears better than IV thrombolytic. So probably the dose is less. Other techniques are thrombus removal or thrombolysis. Which one is better? We have to still decide which patients we can use that. And ultrasound defragmentation of thrombin and fibrin has been useful. And this is the approach which has been recently come across. I came across an interesting case, and this is a 40-year-old man. He presented with dyspnea and chest pain on minimal exertion, like climbing upstairs in his villa, and severe chest pain or sweating was absent. Obese, gastric bypass done 6 years ago, no history of prolonged immobilization, long flight recently, family history of DVT in father. So he had some anterior wall T wave changes, came with chest pain with minimal ST elevation, no RVH, no LVH, cardiac markers, troponin raised, CKMB raised, NT-proNP raised, and echo showed normal EF. However, there was an enlarged RV. So this was the ECG showing some ST elevation. So if you was considered a non-STEMI, angiogram was normal. So we started thinking of other causes, and you can see that there is a massive saddle embolus sitting across both the pulmonary arteries, and right pulmonary artery was almost totally blocked, and the lower and middle zone perfusion was decreased. Right ventricle is enlarged. So we did an angiogram, which showed again similar findings, that right, middle, and lower zone finding was less. And when we did a pulmonary angiogram, left field was also partially occluded. So catheter-directed therapy, ultrasonic sound-supported thrombolysis was attempted. And what it did, so that is the way it is placed. Both pulmonary arteries were cannulated from the right femoral artery. And if you can see those tiny dots, these are the ultrasonic ports on this catheter. And there are multiple perfusion holes for the perfusion of thrombolytic therapy. So this is the pre, and you can see the post on the lower slide on the left. The pulmonary field is filling up, and same on the full, you can see when selective injection was given. So there has been an improvement in echo, which is the D-shaped LV, which is a hallmark of high right ventricular dilatation, which presses the LV, and that is was changed. And this was the pressure. If you look at it, pressure was more than 96, and which decreased to next day were continued thrombolysis with the bolus, followed by infusion for 24 hours, and PA pressure come to around less than 50, which was almost 100% reduction, which is drastic reduction in terms of this. And look at the CT also showed significant improvement. And the bottom left, you see the pulmonary arteries are clear. And the top, you can see the saddle embolus, but there was some residual thrombus in the right coronary artery. So after this, he was continued on oral anticoagulant. Vitamin K antagonists were chosen because he had a gastric bypass, so we were not aware that NOACs, without knowing what is the degree of anticoagulation, at least in vitamin K, we could see what is the warfarin can do the PT INR level. Clinical improvement was continued, and this is the general schema which has been described. There is an increased pulmonary vascular resistance, which increases the RV pressure and RV overload. Dilatation of RV compresses left ventricular by pushing the IV septum to the left, diastolic dysfunction, and decreased LV cardiac output at later stage because RP is compressing the LV, and eventually RV failure, and that's how the patient succumbs in this situation. So there are various thrombolytic therapies have been given. MOPED-3 trial used 100 milligram in 100 patients, and they showed significant positive result. TNK was used in 50 patients, where the bleeding was significant. However, there was a reduction in terms of PA pressures. And MOPED-3 tried to reduce the lower dose of alteplase, and it was very effective without any increase in the bleeding. TOPCAT trial in 2014 shows TNK low dose was effective, and PETHICO trial with TNK is used in 1,000 patients. There was still significant bleeding and stroke, so it was plus minus trial. In 2014, European guidelines recommend alteplase 100 milligram is superior. At least it has got better effects if it is given within 48 hours. Streptokinase, urokinase should be avoided, or the first generation, what we used to call them. So recently, these guidelines, they have tried to, European and American, differentiated from massive, submassive, and low risk. And that's how it depends on the abnormal RV imaging or elevated troponins or both, that is the massive and nothing in non-massive. They can be treated conventionally by anticoagulants or local or orally subsequently. But these two groups, in European, they subdivided middle group, intermediate, high risk, where the high risk, intermediate, or high risk, they are closer to the therapy where thrombolytics has got better role. So what justification for thrombolysis? Clot selective thrombolysis are useful in massive, high risk, submassive pulmonary embolism. Long-term mortality benefit is not proven in intermediate risk patients. Low risk patients have no benefit. Lower dose has shown lower stroke and bleeding and cost effectivity. Sorry, I have difficulty moving. So various systems have been developed, like the suction catheters. These are basically to remove the catheters from pulmonary system, and these catheters have different results. And recent, there is a FDA warning for the angiojet system, which is not a black warning that this should not be used because there's more complications. Flow retriever has been a very impressive device, which has shown significant reduction in RV-LV ratio, and it has got disadvantages, got a 20 French cannula. German group, this is interesting data which shows more than 40,000 patients, and they used in different subgroup of patients, and the summary of the results shows whether it is a subgroup hemodynamically stable, hemodynamically unstable, or the patient who had a CPR. So obviously CPR patients are worse patients. They have not much hope, but still they showed improvement. But other two groups, stable or hemodynamically stable, they also showed significant improvement with thrombolytic therapy and further improvement with the cath-directed therapy. So ultrasound-assisted thrombolytic therapy experience has been still limited. I would say about 800 patients in various studies, and they have used in high risk or high intermediate risk patients. What they did, it reduced pulmonary artery pressure significantly, less than 10 or 20 millimeters. It changed the RV-LV ratio, which improved significantly. To bring you some old memories, I had this case about 30 years ago. It was 92 when we had this case. And intrapulmonary thrombolytic therapy I used with the balloon dilatation in recurrent pulmonary edema, pulmonary hypertension. So this was published in Indian Journal of Chest Diseases in 94. This was a 52 years old man had a recurrent pulmonary thromboembolism following fractured tibia and subsequent deep vein thrombosis. One episode of massive pulmonary embolism with hemodynamic compromise was managed successfully by balloon compression. And this was our own thought process. We used the balloon with throat compression, and then used thrombolysis with urokinase, which was continued for 2 days or 48 hours. And after that, his PA angiogram was done, PA pressure was monitored every day, and it showed a gradual progressive decrease from 90 plus to about 50. So this was, you can have advanced devices and you can use, when you don't have it, you have to think of your own and you have to make an alternative, and this was done. And now it has got much superior devices we have. There are still some unknown territories. Is there a time window of systemic or catheter-directed therapy? Is it from the onset of the system? Like in MI, it's clear-cut indications are available, but in pulmonary embolism, onset of disease is not so clear. Is the dose of lytic varies from acute to subacute state of pulmonary embolism. Like our patient had their symptoms for 2 weeks, but for 2 days, he became so short of breath, he could not walk up to the car, from his car park, and he felt dizzy. So that's why then he came to the hospital. A longer infusion with a higher dose, more effective with a lower bleeding complications. So if it instead of a large big dose, it gives an opportunity. Are clot selective agents are truly selective? If so, why we have a stroke, higher stroke and bleeding complications? Because if it is working on the strokes. So there is some generalized thrombolytic state established, which needs to be still known.
Dr. Lochan, kindly conclude your slide. We are running very behind.
This is the last but one slide. Knockout PE trial. It is the largest prospective interventional pulmonary embolism study of nearly 500 patients, including intermediate and high risk. And it showed RV-LV ratio reduction by 20% with no intracranial hemorrhage. This was a drastic change, and it was done with the help of a ECOS, and it is to be effective in lowering therapy treatment in this particular subgroup. In conclusion, encouraging results have been shown with newer suction embolectomy devices, which only have minor limitations. Evidence-based ultrasonic facilitated catheter directed thrombolysis system ECOS is a sleeker. Additionally, has shown quicker improvement in RV function with low rate of adverse effects. Catheter-directed therapy has surpassed surgical embolectomy, systemic thrombolysis, and will be the preferred mode of treatment, both high and intermediate risk patients with availability of more data or information. Thank you very much. Sorry for the delay.
Thank you. Thank you very much, Dr. Lochan. That was very, very good. I mean, again, it just puts out the same point. You have been doing these procedures. This is a very new device which is not available in India. I would not say very new, but maybe it's new to Dubai. I mean, it was being used in US and Europe earlier. But again, I would go back to what I said earlier. You have always been very intuitive and think out of the box. I mean, 30 years back, you could think of a balloon angioplasty and crushing the thrombus and lysing the patient. And today there is a big rationale of, macerating the clot and then giving intra-arterial lysis just to increase the surface area and decrease the lytic dose, and to suck out the clot as early as possible. So this is the way things are moving in terms of DVT and acute pulmonary embolism, especially the massive and submassive ones. And many a times when you have situations where surgery is contraindicated, where anticoagulation therapy or thrombolytic is contraindicated, these are the only therapies which work. And if they work so well there, why not to use them in high-risk patients preemptively and by choice? I think Sachin is there, and Sachin was there in one of the cases. Like for last 5-6 years, what we are doing is in patients who come with massive PE and absolute contraindications to thrombolytic therapy or heparin, like road traffic accidents, immediate post-op, we actually go in with a suction catheter and suck out the clot. And the suction catheters are not very advanced or sophisticated ones. We actually just take wide bore guiding catheters or sheaths and go over the wire and try to take out the clot. And that itself starts the antegrade flow. It improves the hemodynamics on the table and brings down the PA pressure and increases the saturation. And then we put in 2 pigtail catheters and give just lytic TPA at a dose of 2 to 4 milligram per hour, and that actually takes care of a lot of pulmonary thrombolysis without causing enough bleeding. And now we have data of about 50 patients. Sachin was, and both Rauf Malik, both were a part of this study when we were here, and I think one of the papers was also presented in TCT or EuroPCR. So let me ask Dr. Sachin also to come on the panel, Dr. Rauf Malik and Tamkeen Kina to come on panel, and we'll have the second talk by Dr. Abdul Rauf Malik on updates on NOAC in VTE. Dr. Brijesh was here, but he just left because he had another engagement. He's going to send his talk, record his talk and send it over to us.
Good evening. At the outset, I would like to express my profound thanks to Professor Khanna for organizing this educational platform and providing me the opportunity for this event. The topic of my presentation today is the role of NOACs in the management of venous thromboembolism. So should I share my screen now?
Yes, you should share your screen. We can see you. You can see your slides now.
Are you able to see my slides?
Yes, very clearly.
These are my disclosures. And today I will be focusing my talk on these outlines. At the outset, we'll talk about the general principles of anticoagulation in venous thromboembolism. Today's talk, as in general, is essentially includes patients with deep vein thrombosis or pulmonary embolism. We will later move to the selection of anticoagulation in different situations and specifically focus on the role of NOACs both in the acute management and the long-term prophylaxis of thrombosis. In the end, we will talk about certain specific situations in this field. So why do we use anticoagulation for patients with venous thromboembolism? The most important rationale for treating patients with DVT is obviously the recanalization of the veins so that we prevent the occurrence of pulmonary embolism as well as minimize the chances of compartment syndrome as well as the long-term the post-thrombotic syndrome. Similarly, for management of established pulmonary embolism, the first rationale is to obtain the hemodynamic benefit, which helps in the management of acute heart failure that develops, and subsequently to reduce the development of chronic thromboembolic condition. Anticoagulant is also used to reduce the recurrence of DVTP in patients, which is very high, almost 25% at 5 years. And finally,
Dr. Malik, so can you please sit closer to the laptop, please? Your voice is fading away sometimes.
Okay. Is it better now?
Yes, sir.
And anticoagulants are finally used for preventing, in the first place, venous thromboembolic events in patients who are at high risk, like those who are hospitalized or have other immobilization or other conditions. The minimum requirement, some patients of venous thromboembolism can, of course, be managed on a ambulatory or outpatient basis, but they have to be ambulatory, hemodynamically stable, have a low bleeding risk, and do not have severe chronic kidney disease. And there has to be a practical system in place for administration as well as monitoring of the anticoagulant agents, as well as surveillance and timely treatment of any recurrent VT events or bleeding events. So there are 3 groups of agents currently available for the treatment of venous thromboembolism. The classical ones are the parenteral anticoagulants, heparin and low molecular weight heparin. And now later on, the fondaparinux was also added. Among the classical oral anticoagulants, we have the vitamin K antagonists, known as the warfarin-like agents. And finally, we have the novel oral anticoagulants, in which we have factor Xa inhibitors and direct thrombin inhibitors. We'll be discussing these in detail. The selection of an anticoagulant for VTE is predominantly dictated by its efficacy, safety, availability, and the need for the reversal of anticoagulant. The other factors which are important in this context include the presence of other comorbidities, the clinician's experience, and there are some special clinical situations. Of course, the values and preferences of the patients are also to be kept in respect. An ideal anticoagulant should be efficacious, safe, including during pregnancy and in children, easy to administer, have rapid onset and offset of action, have a predictable therapeutic half-life, and immediate reversibility if needed, and no need for or minimal need for monitoring, and few diet or drug interactions, and be affordable. But currently, none of the available anticoagulants fits all these criteria. There are relative merits for all the agents. This is a busy slide. We can be referring to it later on. Both the parenteral and the oral agents have their own merits and demerits, which will eventually play into the selection of an individual agent, of the anticoagulant agent for individual patients. The novel oral anticoagulants, which is the topic for today's discussion, in this term, the N stands for the novel, but it has been also defined as standing for non-vitamin K oral anticoagulants. In the latest CHESS guidelines of 2016, it was proposed to stand for the non-vitamin K antagonists. There are other acronyms which are also used for this, especially the direct oral anticoagulant or DOACs, sometimes which is now even preferred. Other terms like TSOX, ODI, SODA, also being variously used from time to time, but they are unlikely to become familiar in the near future. The available NOACs include the factor Xa inhibitors like rivaroxaban, APVIC, edoxaban, and late matrixaban, well as the thrombin inhibitors are the dabigatran and the zigalogatran. Why these NOACs came into front is based on the central role of factor Xa as a gatekeeper in the coagulation cascade. You can see it is positioned at the start of the common pathway of coagulation, and therefore interfering in the activity of factor Xa is going to be, of course, theoretically going to be very helpful in managing the coagulation cascade. The direct factor Xa inhibitors exactly do the same job. They engage the active site of the factor Xa molecule activity and inhibit both the free factor Xa in the plasma and that attached to the prothrombinase complex. These agents are orally administered and have many of the properties of an ideal anticoagulant that we discussed before, like they are convenient, do not need monitoring, effective, they have been shown to be non-inferior or even superior to the conventional warfarin therapy. They are safe and they are used in fixed doses and have rapid onset and offset action and have a predictable pharmacokinetics and dynamics. However, they have certain limitations like the antidote, which was not available. Although antidotes have been available recently, but they are not available in for most of the patients. They are costly and cannot be used in poor patients with severe renal disease and kidney disease and liver disease. And there is limited data on their use in children and therefore in pregnancy and oncology patients. So they are NOACs, although having many of the properties of an ideal anticoagulant, still are not ideal and have their own limitations. The rivaroxaban was the first and one of the first among the NOACs. It is used in the prophylactic use in VT was established in the record group of trials in the hip and knee, later in the knee arthroplasty, and in the medically ill patients in the Magellan study. It was approved by FDA in 2012 for the treatment of DVTP and for the reduction of recurrent DVTP after initial treatment. A pooled analysis of the Einstein DVT and Einstein P trials has shown that rivaroxaban is as effective in preventing VT recurrence and as enoxaparin followed by VK therapy with less bleeding device. APVIC, its role was in prevention of DVTP was established in the advanced group of trials and in the hip and knee replacement cohorts and in the medically ill patients in the ADOPT trial. It was approved by FDA in 2014. The Amplify study established that in comparison with standard anticoagulation regimen, APVIC resulted in a 16% lower risk of composite endpoint of recurrent symptomatic VT or VT associated death. Edoxaban was approved by FDA in January 2015 for the treatment of DVT and P in patients who have been initially treated with a parenteral anticoagulant for 5 to 10 days. The Hokusai VT study showed that among patients with DVT and P, edoxaban not only was non-inferior to high-quality standard warfarin therapy, but also caused significantly less bleeding in a broad spectrum of patients, including those with severe pulmonary embolism. About the betrixaban, it was approved in 2017 by FDA for prophylaxis of VT in adult hospitalized medically ill patients. Its role was established in the phase 3 APEX studies. Betrixaban group showed significant decrease in VT events compared with the enoxaparin group in the study. That was about the direct 10 inhibitors. About the direct thrombin inhibitor, which is currently available, is the dabigatran. It is a competitive reversible thrombin inhibitor, inhibits both the free and fibrin-bound thrombin. It is already administered as the prodrug dabigatran etexilate. It was approved by FDA in 2014 for the treatment of DVT and PE in patients who had been priorly treated for 5 to 10 days with a parenteral therapy. And it was approved later for secondary prevention of DVT and PE in patients who had been previously treated for the acute. Other agents in this class of direct thrombin inhibitors are the argabatran, melanogatran, and zamilagatran. Their development was stopped by AstraZeneca because of reported hepatotoxicity.
Dr. Malik, please conclude your slide. Your time is over.
Okay. I will be moving quickly through my slides now. This is a summary of the different trials which established the role of NOACs versus warfarin for acute treatment of DVT. You can see that they had similar efficacy, while as the bleeding was significantly less in the NOAC group of patients. Not only that, NOACs were also shown to decrease the resource utilization in treated patients compared to low molecular weight. So to conclude about this, for general population of VT patients, oral agents are preferable to parenteral agents, and NOACs are preferable to the agents, and they should be the first choice for most hemodynamically stable non-pregnant patients who do not have severe renal disease or cancer. Rivaroxaban and ibexaban are administered as monotherapy, whereas edoxaban and dabigatran are administered only after prior 5 to 10 days of parenteral therapy. An ideal patient for NOAC, as I said before, should have good renal function and hepatic function and should be adherent, whereas patients who have these issues or have active cancer are not ideal patients for NOAC therapy. There are certain clinical factors that would influence the agent selection for anticoagulation, like cancer patients are better treated with low molecular heparin, liver disease, again low molecular heparin, and GI bleed on the APEX-7. This is a busy slide, we can refer to it in some other detail. There, in cancer patients, lately there have been several studies which have studied the role of NOACs among the oncology patients, like the Canvas Pragmatic, the SELECT-T, the ADAM-VT trial, and the Hoxsite cancer component. And they all concluded that they offer NOACs offer a simple oral treatment regimen alternative to the low molecular heparin. However, the risk of GI bleeding has to be considered significantly. These two trials, the AVOT and Cassini trial, were recently published, which studied the effect of NOACs in primary prevention in high-risk oncology patients. So clinical considerations, optimal patient for an oncology patient would be patient without a GI malignancy and who doesn't have a major bleeding risk, and when the patient prefers the easy treatment and there are no drug-drug reactions with the chemotherapy. In the long-term prophylaxis of DVT, again, clinical scores, there are two competing concerns, like risk of recurrence versus risk of bleeding. The risk of recurrence is about 10 to 40% at 12 years, 20% at 5 years. And there, for the bleeding risk, there are several scores to predict the recurrence risk, but for the risk of bleeding, there are currently no well-validated tools to stratify, but these are the risk factors which would increase the risk of bleeding on anticoagulants in the VT settings. So how long we treat, this is a summary of how long we should treat a patient with, depending upon the clinical situation, whether it's a proximal or a provoked first or second event. And accordingly, we selected the duration of therapy. And this is we will see what is the role of NOACs in the extensive treatment. Both rivaroxaban as well as APVIC have been found to be useful in the long term in reducing the recurrent against the placebo group, although there has been a slight increase in the bleeding risk in these trials. The Einstein choice trial it compared the effectiveness and safety of rivaroxaban versus aspirin for the long term prevention of venous thromboembolism in patients who had already been treated for 6 to 12 months. Among these patients, the risk of VT recurrence was significantly reduced by rivaroxaban both at 20 and 10 milligram doses compared with aspirin. So this is a summary of the trials which has studied the long-term use of secondary prevention role of NOACs. For the dabigatran, we have Remedy and Resonate trials. For the rivaroxaban, we have Einstein group extension study, and for the APVIC, we have Amplify extension study. All these studies showed a significant superiority compared to placebo in the prevention of recurrent VT. However, in the rivaroxaban and dabigatran group, the risk of bleeding was higher in the long and extension trials. This slide is sometimes we need to switch between the anticoagulants, so we have a different protocols have been developed for switching between VK to NOAC and as well as NOAC or a NOAC to VK. NOAC reversal agents have recently been developed, including the adrasuzumab and the lately developed indexinate alpha. Indexinate alpha was recently approved by FDA for the reversal of NOAC anticoagulation. There are some other newer anticoagulants being developed, including the allosterotic thrombin inhibitors, which appear to be promising. And there are some more studies being conducted, including those in the COVID-19 thrombosis prevention trial. And these should tell us more about the role of NOAC and any limitations and other unanswered questions about the NOAC therapy in venous thromboembolism. So to summarize, VT is a common disease with high risk of mortality, morbidity, and recurrence. Anticoagulants are the mainstay of treatment for VT, and NOACs are generally preferred for acute and subsequent treatment of VT. NOACs should not be used in severe renal failure and those with severe renal liver disease. If used in patients with mild CKD, we should check the renal function at least twice a year. NOACs may facilitate outpatient treatment of acute DVT and low-risk PE and facilitate a shorter hospital stay. The recent availability of NOAC antidotes may further broaden the scope and usage of NOACs in venous thromboembolism. The minimum effective duration of therapy with NOACs is about 3 months. Select patients may benefit from extended anticoagulation, and we should consider individual risk-benefit ratio for extended therapy. Sometimes D-dimer, ultrasound, and clinical scores can help in this direction. Thank you very much. Hello.
Thank you, Dr. Malik. It was a wonderful talk and a lot of information available. And I think we are waiting for Dr. Sachin Upadhyay to give further information or any information on this topic.
Sachin, you're muted.
Hello. So are you able to hear me?
We can hear you. We can't hear Sachin. You can hear you.
Sachin, I think he's trying to unmute. It becomes muted time to time.
I'm sorry, sir. I had to rush through some of the slides in the interest of time. So, but you can ask me. You can carry the discussion further.
Sure. This is the DVT as you given it duration. So which are the conditions when you give indefinitely anticoagulation? Are there any condition where one has to give indefinitely?
Yes, there are certain situations in which there should be no scheduled stop date. In other words, an indefinite therapy, like patients who have non-reversible risk factors for DVT, like those who have inherited thrombophilias, or who have malignancy which is not curable and it is metastatic and active. So in such situations, we may have to continue anticoagulant therapy indefinitely.
Thank you, Dr. Malik. Dr. Khanna, you can proceed for the proceedings.
I think because of the paucity of time, we would like to have final comments from Sachin and Dr. Tamkeen. And I also see Dr. Kaushal. Sachin, you are muted. So, Dr. Kaushal, what would we'd like your comments because we have the last session, the Nigerian and South African session after that. You need to unmute yourself.
Dr. Kaushal, I've sent you a request on your screen, must be flashing. So just click on that.
Okay, so if they are muted, and I thank all of you for being a part of this session, for being with APVIC, and next year maybe we'll have more robust society sessions and intercontinental sessions.
Dr. Khanna, am I?
Yeah, you are audible now and visible as well.
Congratulations for such a great effort, marathon effort by you. Hats off. May you cross 100. And I enjoyed all these talks, even Dr. Rajiv Lochan's and Dr. Malik. Congratulations to you too. It was wonderful having you all here, and amazing efforts by you, Dr. Khanna. Hats off.
Thank you so much. Is Dr. Tamkeen around? He isn't there. Okay.
No.
I saw him. So thank you all so much. And right now it's almost 11:15 in India. It must be afternoon in Nigeria. So that's why we kept this Nigerian session in the end. And till now, still we have about 1,200 people hooked up. We have crossed 11,000 attendees in this conference over 3 days. And that gives us a confidence that, that the conference is doing well, and all of you are so acclaimed physicians all across the world that people are interested to come and join this conference. It's our effort to get in newer technologies, newer ideas, and to debate a lot of controversial issues. So thank you all very much. I thank special thanks to Dr. Lochan. And now let's move to the Nigerian and South African session. I see Dr. Emmanuel clearly. Let me invite Dr. Jayan Ajalochukwu from Nigeria, Dr. B.S. Garko, Dr. Oladimiji to be on the panel. We also have Dr. Chukudi presenting here, Dr. Peter presenting here, Dr. Bashir Garba, Dr. Oladimiji, and Dr. Francis. I have a special privilege and I feel very honored and fulfilled that we have excellent interventional cardiologists now in Nigeria, and many of them are trained under me, one by one as a chain. Dr. Idafi actually leads the show, and we have Dr. Chukudi, Dr. Peter, Dr. Bashir, Dr. Oladumiji, Dr. Francis, all of whom have actually done their fellowships, interventional fellowships here under me. And it is a very fulfilling experience to know their progress and their growth in Nigeria. So without any delay, let me invite Dr. Idafi Emmanuel to talk about endovascular management of heart and vessel foreign bodies. So foreign bodies in heart and blood vessels. So he's going to be talking about it for the next 5 minutes, followed by Dr. Chukudi.
Okay, thank you very much, Professor Enekana, for the privilege to be part of APVIC 2021. We are grateful from Nigeria. So let me share my slides.
Okay, you can see your slides. Just go to the presentation mode.
Okay, can you see my slide?
Yes, we can see your slides, but you have to go to full screen or presentation mode.
Okay, good.
There you are, yeah.
Yeah, thank you very much, Professor Enekana. It's a privilege to be with you again. Not just training, but also mentoring us day by day. If we run into difficult cases, we do call you. So I just take a 3-year review of foreign bodies in the heart and vessel as we see them in the country. Foreign bodies in the heart and vessels are rare. They are usually iatrogenic. Embolism and arrhythmias may be part of the complications when they present, and they are usually diagnosed with an X-ray, CT, chest, or even on echocardiogram. They can be easily picked up, and they can be managed by either conservative. Can you hear me? They can be managed by conservative or
yes, sorry about that. You can continue.
Endovascular, percutaneous, or surgical method. So the objective of this review was to describe what we have been seeing at the Bayelsa Specialty Hospital and the Cardiocare multi-specialist hospital in Abuja, where we have a lot of referral. So the method here we used was a retrospective cross-sectional study. We searched through the cardiac catheterization of these two hospitals from January 2018 to 30th of April 2021, and we have 11 foreign bodies. So we look at the site, theology, and the clinical presentations and the data we analyze. So the results, we have about 58. The mean age was about 58, and we have more of men than women. So the most common foreign body was seen in the superior vena cava, the right atrium, and the inferior vena cava. Then also we also noticed that those that are above the age of 60, we have about 6 of them. We are above the age of 60. As we said, we have guide wires because of central line placements by the anesthetists. Some of these guide wire fall into the veins, and they are lost in the veins, so we'll be called upon to come and take them out. Then also radial intervention is also increasing in the country. So we have one case of guide wire loss during radial puncture. Then IV cannula was also to the pulmonary circulation, tolerance, and you can see the rest of them there. So how many of them were symptomatic? We saw that 4 of them were symptomatic, and the symptoms they presented, some of them were this atrial atopics, ventricular atopics, and non-sustained ventricular tachycardias. So we have a total of 81% presented within 24 hours. My time is almost up. So the time of presentation, we see that a number of them presented faster because of when you are told that you have a foreign body in your body, it always causes anxiety and panic among them. So the complications, as you said, we have a few of them that presented with some of the ventricular atopy because some of them went into the right atriums and were causing intermittent and not sustained VT. Mortality, we had no mortality during the treatment, and they all had this. Among them, about the 11, 9 of them had endovascular treatment. So you can see one of the case here. Hope you can see here that this was a tunnel catheter for a port for hemodialysis, and after that, the surgeon was about to take it out, and he got broken and went into the right atrium, extend into the right ventricle. So the first thing we did here was we can see that I got the catheters and we pull it out, then into the SVC. From the SVC, we got a locally made a snare. Then you took it out, and this was the final stage of taking it out. And when it was taken out, we measured it, and it was around 27 centimeters. So this was another guide wires. Also, the anesthesis was actually to set a central line, and before you know, the guide wire slip out and enter into the SVC, migrated to IVC, and this was the time it was shown to us. The same day, we took it out, and this is when, after it was taken out, the final fluoro. So the management of foreign body in the heart should be individualized. Symptomatic foreign body should be removed. Asymptomatic foreign body can also be removed, but if they are like it's a very small fragment of a broken cannula, because and are migrated to the distal end of the pulmonary artery, you may not bother to take any such things out. So foreign bodies in the heart and a vessel may be symptomatic or asymptomatic. They are usually iatrogenic, and they can be managed appropriately when referred to the specialist. Thank you very much for the privilege to present. Hello? Are you still with me?
Very much. You are enjoying your talk very much. And every day we feel so good hearing your good work. Now, I think Dr. Chukudi would be the next person to speak. He would be speaking on IVC filter indication with case report. And I also saw Dr. Ola and Dr. Peter, but I don't see them online. If you can just give them a ring and ask them to join again.
Okay, sir. Then Dr. Bashir.
Yeah, Dr. Bashir and Dr. Ola. And Dr. Peter, I think, is online. So, Dr. Peter, you can put your slides on.
So
is Dr. Peter ready?
No, only Dr. Chukuri is available, but he's not responding to the requests.
Okay. And what about Dr. Chukudi? Dr. Chukudi is going to be speaking about IVC filter indications with case report. Dr. Chukudi, can you put on your slides and put on your camera as well?
Bashir, join the meeting. Your time of presentation has started. Please, I'll finish presenting. We are waiting for you. Okay.
Where is Dr. Peter? Dr. Chukudi? He's online, but we can't see his slides.
He's online, but he's not unmuting himself or turning on the video. I've sent multiple requests.
Let me call him.
Yeah. And what about Dr. Bashir?
Bashir, I've called him. He's joining.
And Ola?
Dr. Chukudi, please, you are the next to present. Please, we are waiting for you. Time. Yes, join and take your presentation. We are waiting for you. So Dr. Chukudi is just a second. He will take his presentation, sir.
So, Dr. Emmanuel, what should we do? Should we carry on, or we should just discuss with you and close the session?
I think Chukudi Peter's number and the last number are not going, but Chukudi will take his presentation because he said he's joining now.
Okay. Dr. Chukudi has always been a big boss, you know. And I'm waiting to see his chain of medical centers. I'm sure he would do that.
He will.
Yeah, he would. He has a management mind, you know.
Yes, sir. Chukudi, join, please. We are waiting for you. You are the one we are waiting for. The past 5 minutes we have been waiting for you.
I will join a minute time.
No, not a minute time. Now. Okay. Now, please open your slides and present. Peter's number and we can be talking, sir, because Peter's number is not going, or last number is not going. Bashir, I've called him to join. Chukudi, I'm sure he will join.
Okay, so let's discuss. In the meantime, when they are joining, let's discuss about the practice of interventional cardiology in Nigeria. I know that you are doing very well now. You, I think, probably joined a center, and you partly own a center of interventional cardiology, and you're doing a great work there. I see that on the international group we have, and I just want to know what is the practice pattern, how many cath labs are there in Nigeria, what are the problems there, and how is the government supporting this interventional cardiology revolution?
Oh, very good. Well, there are cath labs are springing up in the country, and it's becoming very, very robust. Like in Abuja, Abuja is the capital territory, is the capital of Nigeria, just like you have New Delhi as the capital of India. So Abuja, we have more cath labs that are coming up there. Like the hospital that I serve as their interventional cardiology, that is the cardio care multi-specialty hospital. We do like 15 to 20 cases every week, and it's like the busiest hospital in the country currently in terms of interventional work. Is the busiest because we have a number of cases coming from the northern part of the country, because Abuja is like center of Nigeria. So people come from the north. There are many states in the north that they come from to come and join us. And we are doing well. Then the south, we also have a cath lab in Port Harcourt where I reside. It's like the cath lab is also getting busier day and day. But in terms, all these cath labs are more of private cath labs. They are not government-owned cath labs. They are private cath labs. So it's the main challenge here is getting the consumables. Those are the main challenge, because we have to get from India, from US, from Europe. That is where we get the consumables. So that is the major challenge that we have currently in the country. When Professor Angela Shuku will commence, I'm sure she will say something more on the issue, because I've called her. She will soon join the panelists. I think Chukudi is ready, sir.
Hello, sir. Good evening, sir. Yeah, Dr. Chukudi, I see the future MD of a chain of hospitals in Nigeria. So, Chukudi, can you hear me? I think you need to...
Hello, boss. Good evening, boss.
Yeah, we can hear you, so you can start your presentation on IVC filters, indications with the case report.
Yeah, 31 years female medical doctor presented with a history of recurrent day venous thrombosis, an episode of pulmonary embolism.
Where are you, sir? Yes, sir.
She was evaluated and started on Evaroxaban 20 milligram daily. the patient developed another episode of pulmonary embolism while on optimal dose of rivaroxaban. Within 3 weeks on treatment, she developed another episode of pulmonary embolism. Because of the recurrent pulmonary embolism while on optimal anticoagulation, diagnosis of first anticoagulation was made, and she was advised for IVC filter. IVC filter was inserted, and the patient was also started on rivaroxaban 20 mg daily. And after 4 months post-IVC, she has remained free of symptoms, no more pulmonary embolism. And also, the IVC filter was planned to remove after 1 year of insertion. And also, the patient is advised to continue on top rivaroxaban 20 mg daily. This is the video of the procedure, the IVC filter that was inserted through the femoral vein to the IV inferior vena cava. Also, this is the image. In conclusion, IVC filter is indicated in cases of recurrent pulmonary embolism due to distal proximal DVT, and also in a situation of free-floating proximal DVT. Thank you. This is the end of my presentation.
Dr. Chugudi, that you're absolutely right. You know, if you have a free-floating thrombus in the proximal IVC or you know, at the confluence of two iliac veins, definitely that's an indication to put in a filter. Or if you have a failure of anticoagulant therapy and patient has pulmonary embolism, or there is a contraindication to you know, anticoagulant therapy, definitely these are the cases for putting in IVC filters. And if you really want to put a filter, it's much better to put a temporary filter and take it out as early as possible when you have managed the DVT and the risk of pulmonary embolism, because these patients the filter itself is a nidus for recurrent DVT, and it's not a good idea to leave it for long or lifelong in these patients. I believe one of you who are all my esteemed fellows must have seen 1 or 2 cases where we have taken out the IVC filters, and also a case where it was a lot of problem taking out the filter because the filter really got stuck into the IVC walls and almost was protruding out of the IVC wall. But I totally agree with your indication, and I feel very proud that all of you are doing so well. And I was telling Dr. Emmanuel that I'm waiting for the day when Dr. Chugudi is going to be managing many chains of hospital in Nigeria. I'm sure you have that managerial skills, and one day you will do it. You have that entrepreneur skill in you.
Thank you, boss.
And
thank you, bro.
Now it's an esteemed pleasure to welcome Dr. Peter. Dr. Peter is a very busy clinician, as I understand, very busy cardiologist. and he's an academic cardiologist. And I remember Dr. Peter, when he was here, he also won, I think, the best paper award in the clinical Indian College of Cardiology, you know, the competition, abstract competition. So let's hear Dr. Peter on management of hypertension in Black population.
Thank you, Prof, my mentor, my teacher. Thank you very much, sir. Let me share my slide. Okay. Can you see my slide?
No, still not.
Not visible?
No, I don't think it. No,
No.
it's not visible.
They're coming up.
Okay.
They would come up. I think there is some lag. They would come. Yeah, now it's there.
Yes, we are seeing it.
Okay, I've seen it. Okay. Sir, I wish to congratulate you, sir, for organizing a very wonderful conference. And also thank you, sir, for the mentorship. I really appreciate that, sir. Well, I'll be presenting this evening, on the management of hypertension in Black populations. Hypertension, I'm using your ESC definition of hypertension, 2018 definition of hypertension. Office blood pressure of up to 140/90, or ambulatory blood pressure of up to 130/80, or home blood pressure monitoring of up to 135/85.
Hello.
Hello.
Yes. How are you?
Hello.
Yeah, Dr. Peter, we can hear you and see you. You continue.
Hypertension affects 1 billion people worldwide in 2014. That comprises 22% of the world population at that time. Africa have the highest prevalence of hypertension, even at that time. The Black population generally have the highest number of hypertension worldwide. Both Africans and the African Americans, as you can see in this. However, in my country, about 1/3 of our patients with hypertension are not even aware they are hypertensive. And this is the world prevalence of hypertension. From this map, you can see that the red marks, what the males and females are in sub-Saharan Africa. Most of them are in Africa, and particularly in sub-Saharan Africa, have the highest prevalence of hypertension. And that constitutes the majority of the Black population worldwide. And I mean to say that my country have one of every 6 Black men is a Nigerian. So when we talk about management of hypertension in Black population, we are talking about management of hypertension in Nigerian population indirectly. Oh, sorry, I'm having problem with my. Oh my God. I have an issue with my computer here, please. Okay. This is also a UK study that shows that Afro-Caribbeans have the highest prevalence of hypertension in UK population. So hypertension is a Black man's problem. Affect Black man more than all. Oh my God. I'm having a problem with my computer here. Please. And the hypertension have been found to be the highest cause of mortality, far above obesity, alcohol, cigarette smoking, and all other risk factors. Hypertension found to be higher than all other risk factors. In my country, a study was done by OGI in Abuja. It found that about 75% of hypertension present for the first time with complications. Okay. Now, what are the peculiarities of hypertensive patient in Nigeria, in Black generally? One, Black population have higher prevalence of hypertension. We have earlier onset of hypertension. Also, our patients have the higher prevalence of non-dippers, and non-dippers have been found to have higher complications. Hypertension in our population has also been found to be associated with higher non-medical beliefs in our populations, and that affects our adherence greatly. Now we have salt-sensitive patients that are low renal hypertensive. Now the Black population generally have higher reactivity to a number of physical and mental stressors, e.g. like video game challenge. In fact, study was done among children playing video games. Their blood pressure was taken before, pre and post, and during the video game challenge. And it was found that the African children have higher blood pressure rise during the during the video game challenge when compared to their white counterparts. Black population also have higher risks of, I went to Mayo Clinic report. Blood pressure is more difficult to control in Black population than the other races. Now, how do we treat hypertensive patients. First of all, we evaluate the patients. And evaluating the patient, the history should be taken. And in taking history of patient with hypertension, we have to look for history of duration with hypertension and also ask for history of other cardiovascular risk factors and complications of hypertension. A patient that presents hypertension provides opportunity for further evaluation of that patient. Now, because hypertension is a disease that has multifactorials, so treatment also involves multidisciplinary approach. Patient has to be counseled, dietary approach to hypertension. Then Nigerian guideline too we have a guideline for treatment of hypertension that involves low salt diet, avoiding processed foods, and then more intake of boiled or grilled foods instead of fried foods. Also, other non-medical, other lifestyle measures in measuring hypertension in blacks that we employ in our country is using the WHO exercise regime, aerobic exercise of at least 150 meters in a week. Now, because the prevalence of hypertension, because the mechanism of hypertension is multi-dimensional, there are no single drug mechanisms can treat hypertension in most of our populations. Oh my God. In most of our populations. So therefore, most of our patients will benefit from combination therapy because they usually present with higher blood pressures than required. Now, this is just a guideline. This is not a statement from the guideline of Nigerian guideline in managing hypertension. This guideline shows it stated that diuretic and calcium blocker are the most effective for black population everywhere in the world. And this is mainly because black population are have low renin hypertension, and therefore they benefit more from it. Beta blockers, RAS blockers, and alpha blockers are less effective and so not advisable as monotherapy for hypertension in blacks. The South African guideline also support this by saying that in a black hypertensive patient, ACE inhibitors and ARB are not effective. However, if combined with a diuretic or a calcium channel blocker, they are as effective as the non-black population. Now, this is just a summary of different guidelines. All of them supported the use of calcium channel blocker or a diuretic or combined as a first-line therapy for black population, especially those that are not diabetic and those that do not have renal diseases. So, in conclusion, hypertension in black population is a multidisciplinary approach. It's not a doctor take all. We involve the nurses, sometimes the clinical psychologists, the dietitians, and other health workers in managing hypertension. And in managing hypertension, it's important for us to know that it's a teamwork and we should manage the patient holistically and not the number of the blood pressure. Thank you very much, sir. Thank you.
Thank you, Dr. Peter. That was very good and very well presented and very well studied. And as usual, I told you, you are an academician. You have the knack of
Thank you very much, Professor.
reading and understanding the journals well and the studies well and doing good research. Is Dr. Ajulutuku, has she joined?
Yes, I'm here. Good evening.
Yeah, good evening. We've been trying to see you and have your presence in the women section also, the Women Crusaders. And we are missing Obiora. I think he's got his examinations. That's what he told me. And I would like you to conclude the session and with a message. And all your boys are doing very well. It's very proud moment for me to see how a chain of interventional cardiologists have been trained by me, and it all started with your efforts, and Obi was the one to lead the show, and he passed on the baton to a chain of doctors.
Thank you so much. Well, thank you, Professor Kana. It's exciting, and everybody who has spoken before me, they have all alluded to the fact of your tenacity and your spirit of not giving up. Even 2020, when the world was being ravaged by COVID, we had one of the best. I really enjoyed the 12th APVIC. It was very rich. And this year, the 13th one has come, and it's still at that very high level. We've gotten all the sections, the orations, the Iron Man, and everything. And this year we were quite excited. I was excited when I saw the Women Crusaders. So the whole world is looking at women in a particular way, and I was really happy. In a minute, I even thought it was talking about the role of women in cardiology, but I later saw that it was the work of women. So I am very proud that APVIC is following the what is happening all over the world. Women are being women and underrepresented groups, underrepresented groups, ethnicity-wise, and other reasons for being underrepresented are being singled out for for in-depth even outside work or inside work. There are psychological issues, there are issues of mentoring, of leadership, and then I was quite happy that APVIC has remembered the women. And I'm very proud also that many more women are presenting and getting into interventional cardiology. That is not the trend in Nigeria. The interventional cardiologists are still very much men, but I'm happy to report that in South Africa we have, and in Nigeria we have some few cardiothoracic surgeons. And but the cardiologists, the non-invasive cardiologists, they are growing, and then the interventional cardiologist, Dr. Dafe, is holding up the torch very much and very busy. The important and interesting thing is that we were even of the opinion at the time that the conditions were not there. But when the investigations became available, and then when the treatment options were available, referrals started coming from here and there. So the interventional cardiologists are very, very busy. And one of the problems we have in Nigeria is the electricity, cardiac cath availability, high cost of the procedures. But the important thing is availability. The options are available now, and patients are benefiting. So many more people looking towards India. They've seen those who have come ahead of them. They've seen Dafe, Peter, and Chukudi, and they want to get into that type of training. But because of the COVID and travel restrictions and governmental policies, that is a little bit on the hold. But I know that many people are interested, and I'm very proud that we have this African section, and I'm also more proud that we have the Women Crusaders. So I think that the Women Crusaders will be expanded in such a way that there will be more mentoring, and more mentoring and more leadership training and more interrelationships. That would be what I would like to see. Thank you very, very much.
Yeah,
And
definitely. That is what we are looking at, not only, praising and acknowledging the contribution of women in cardiac interventions, cardiovascular interventions, and in APVIC, but also to help each other and promote training across the world. And that is what our aim is, and we would definitely want you to sort of advise us on this and lead the whole movement.
Thank you so much. So, and thank you for your tenacity and for your interest and for the growth and development you have invested on a lot of the young ones. Your shoulders are very, very wide. The shoulders that they stand on so that they can see. So we pray for you, and your energy, your indefatigable spirit is very, very encouraging. And we are so proud of you. Thank you so much for all that you are doing.
It also encourages and fulfills me, and sort of gives me immense satisfaction to see all our fellows and young cardiologists. Now, they're not only budding, but they are very well established cardiologists in their own countries and field, whether it is Nigeria or Southeast Asia or Middle East. All of them are doing so well, and they are all consultants. I have Dr. Sachin. I can see him.
Sir, Dr. Garba is online as well.
Oh, Dr. Garko is there? Yeah, if Dr. Garko is there, definitely we would like to welcome him. Dr. Garko, please, you are welcome. I don't see you on screen, and we would like to listen from you and your words.
Thank you.
Is Dr. Garko there? Can you unmute yourself?
Yes, he's unmuted. Dr. Garba?
Dr. Bashir is waiting for his presentation, sir.
Yeah, so let's go ahead with Dr. Bashir. Okay, now I can see him. Dr. Bashir, can you go ahead on your presentation of critical limb ischemia case report and review of literature?
Hello, sir. Good evening, sir.
How are you? Good to see you.
Hello, sir. Can you hear me, sir?
Yeah, I can hear you. Very good to
Good
see
evening,
you.
sir.
So you can upload your slide.
Should I share a slide from my end?
Yeah, if you have, you can. Dr. Bashir, is it okay that we play the slides from our end if yours is not working? Or we see your slide? Yeah, we can see it. Good.
Okay, sir. Good evening, sir. Good evening, Prof. Good evening, other panelists. Greeting from Kano, Northern Nigeria. How many minutes? Okay, 5 minutes. Okay. It's a small talk on critical limb ischemia with some case report. But actually, the case report was largely done by Dr. Edape. So I'm just going to go over it. He will have more explanation for it later. I will go a bit into the literature and see what we have. The case is that Mr. Edi, 68-year-old Nigerian with a non-diabetic hypertension for 20 and 10 years respectively, has been on metformin 1 gram daily, glimepiride and amlodipine, as shown on the screen. Luckily, situation of his foot, left foot for 3 weeks. Has been on aspirin, Celebrex, and Ketanox, but no much improvement. He has no family of similarity in the past, and he was referred for possible intervention. When he was examined, he was noted to be an elderly man in painful distress. He was not pale, he wasn't cyanosed, and he has a hyperpigmented blackish left tooth and poor foot. His pulse rate was normal, 96 beats per minute, but he has absent left posterior tibial and dorsalis pedis pulsations. The pulses are also diminished on the right foot. So test clear, CNS okay. The results came out Doppler confirmed peripheral arterial disease, posterior tibial and dorsalis occlusions. Other investigation were largely normal, first was normal. So an assessment of peripheral arterial disease was made. We had intervention, revascularization in Abuja, new hospital. This is a presentation before the intervention. This is the day 1 after, day 2 after revascularization, and then this is 4 days after. So the limb has cleared. So by literature review, I will go over it very briefly. Time may not be allow me, but as you're all aware, it's a common condition worldwide. And when we say critical ischemia, I mean it's a life-threatening complication of peripheral arterial disease that typically manifests with breast pain and tissue loss. It's common, up to 1 in 10 patients with PAD has CLI, and it has an estimated cost of about $2 billion annually in US, just Medicare alone. So with increasing population, aging population, and increasing tobacco use, other complications, CLI is bound to increase sources. And it's also termed as a chronic limb-threatening ischemia, which is in contrast to the acute limb ischemia. Chronic critical ischemia is like a chronic progressive thing, not condition I would say in acute airline. Atherosclerosis that's progressive over time. Hyperlipidemia, diabetes, tobacco smoking, family history, and chronic kidney disease. Other etiologies are shown. Presentation largely is ischemic rest pain, which relieves by limb elevation, and then patients that are diabetic may have other complications, neuropathy and other things. They may have non-healing wounds in this activities. Findings generally showed diminished absent pulses. The Doppler signals may be monophasic, especially the tibial, prolonged capillary refill time, brittle nails, etc. There is superimposed cellulitis or osteomyelitis in the affected limb. The major diagnosis is using ABI, ankle brachial index, which is mostly widely adopted, available, affordable, and can be done in many outpatient clinics. Patients with DD and OCKD may exhibit pulsely elevated ankle pressures due to calcified blood vessels. And pulse volume recordings also can be used to confirm the ischemia and predict wound healing potential. Diagnosis, basically, as I mentioned, if you have the ABI of less than 4, confirms it. Ankle pressures also, as shown, can be useful. Transosseous pressure also less than 20 to 40 suggests CLI. So there are many classifications done. Those are for one time will not allow me to go into it. There's also a YP classification as shown correlate with the risk of amputation and treatment outcomes. Prognosis variable depending on the severity and other comorbidities, but here it's about 50%. And many patients may have a concomitant coronary artery disease. So it's multidisciplinary care. I don't have time, sir, but I think I can continue aloud. The treatment is actually a multidisciplinary approach: vascular surgeons, cardiovascular medicine specialists, interventional cardiologists, radiologists, pediatrics, wound care nurses, and physical. But the key component treatment include symptom control, wound care, and revascularization, so that to aim of salvaging the limb and improving survival and quality of life. Actually, when we say term control, the most important thing is to keep the limb in independent position, and then you only take analgesics when necessary if the pain is severe. Drugs like lidocaine, gabapentin, ketamine may also be used to optimize patients that have concomitant neuropathic pain. Home management basically is uploading, good nutrition, using non-adherent dressings, and then removal of fibrinous tissues using either sharp or enzymatic approaches. Associated cellulitis usually is caused by polymicrobial agents and warrants broad-spectrum antibiotics as appropriate. I&D, incision and drainage of abscesses, and to open to output amputation may be necessary in wet gangrene to control the source control the source of the sepsis. This slide looks bulky. We're just trying to highlight the steps for medical optimization. Main thing is to reduce cardiovascular outcomes and adverse limb events. Typically, you use antiplatelet immunotherapy with aspirin or clopidogrel. That tends to reduce cardiovascular limb-related events. DAPT has a role, although the risk is not clear because of the increased hemorrhagic tendencies when using them. However, drugs like ACE inhibitors for BP control all been advocated. Use of statins also be important to increase survival and improve the efficiency of hospitalization. Importantly, also the patient advised stop smoking, which has been shown to improve limb survival, reduce mortality, and then generate overall cardiovascular adverse events. In terms of counseling for people to stop smoking using other drug supplements like nicotine patches, varenicline, and bupropion, all of them tends to help in smoking cessation. Exercise role is controversial, not very clear. Some guidelines support, some are against it, but generally it should be prescribed with caution. Imaging preoperatively is basically done using Doppler as in this case. However, there's also a clear role for CT angiography, magnetic resonance angiography, all in order to have clear lesion delineation so that for proper and appropriate treatment, selection of right approach for intervention. So patients with renal insufficiency may benefit from prehydration, in order to prevent the risk of contrast nephropathy, which is somehow common in the intervention. So diagnostic angiography is the gold standard. You require less contrast than CT angiography. It gives you optimal resolution for distinguishing distal lesions and facilitate immediate endovascular treatment. Patients who are candidate to perform as soon as possible PCB post-identified lesion. The Vascular Society of Great Britain and Ireland advocates intervention less than 14 days after diagnosis in all 7 patients, and a short period as possible, less than 5 days in patients that are hospitalized. So there's no need for delay. Delays create more problem and tends to reduce the chances of good outcome. When there's no facility for hospitalization, amputation risks are higher, up to 20% in some studies. Main step for CLA is, of course, I mentioned, is a rehospitalization, either surgical or using endovascular approaches. Sometimes there is a room for hybrid approach, where you combine the surgery, open surgery, and endovascular treatment. We call it hybrid approach in some situations. However, open techniques for hospitalization comprise arterial bypass and atherectomy, while endovascular approach mainly is incorporated use of angioplasty, stenting, and/or atherectomy. So the main thing in the vascular hospitalization is minimally, at least less invasive, unlike open surgery, and it's very good for lower extremity. Has replaced lower extremity bypass in recent days. Even the surgeons are learning and adopting it in most centers. So percutaneous transluminal balloon angioplasty mainly replace plaque, and sometimes you do atherectomy to debulk atherosclerotic material as are the major techniques that are usually employed in the vascular approaches. However, newer technologies have emerged. They include cutting scoring balloons with abrasive surfaces to assist dissection of heavily calcified lesions. There's also room for cryotherapy and laser atherectomy to facilitate reconstruction during angioplasty, disease arteries, and then subintimal angioplasty, which is used across long occlusions through subintimal space. There's also drug-coated balloons, using, of course, sirolimus and paclitaxel, commonly the common ones used. The vessel wall to prevent neo hyperplasia and stenosis globally now. Many providers take on the vascular hospitalization as first treatment option with the high technical and clinical success rates and low morbidity and mortality, and procedures that can be performed even as a patient without necessarily going for a GA or admissions. So in the vascular therapy, outcomes have been evaluated in many cohorts, but the general conclusion is they are safe, they are reliable, and they are kind of both safe to the doctor and treatment for the radiation and the patient and take less time. Femoral angioplasty and bare metal stenosis occlusions in the setting of CLI ranging from as high as 58 to 71% up to and then 7 to 7% respectively. So hybrid vascularization, if you have multiple lesions, hybrid approaches have been adopted, where you use endovascular surgical approaches, hand to hand. Usually, endovascular approaches are reserved for the inflow lesions, so that while the open surgery used to correct the distal outflow lesions, usually it's femoropopliteal bypass, whereas the inflow lesions out of iliac are usually managed by endovascular approaches, the inflow lesions. However, limb salvage rates are consistently greater than 8% in 3 years. So, depending on the lesion location, the lesion type, the clinical classification, one can decide to approach the hybrid method, which is because not all the lesions are amenable to a particular approach. Sometimes we have to consider different approaches for different lesions based on their individual characteristics. So basically, after the revascularization, there's clinical surveillance, follow-up, using clinical examinations, repeated ABIs, Doppler ultrasounds, so that at least 3 to 6 and 12 month intervals to be able to appreciate and then early diagnose risk stenosis where appropriate. The product symptoms, diminished ocular pulses, decreased ABIs, always increase the chance that the lesion, the vessel has been re-occluded, so there's need for another intervention. So there are also medical adjuncts that have been used aside to the revascularization. Those like antithrombotics, which tend to improve the long-term patency and reduce adverse cardiovascular outcomes. Combined antiplatelet and anticoagulant therapy does not really appear to improve patency compared with aspirin alone because of the increased bleeding risk and side effects. And anticoagulation is equally reserved for graft thrombosis mainly, or patients with hypercoagulability. Dual antiplatelet therapy with clopidogrel reduces the need for intervention at 6 months. The optimal duration for clopidogrel ranges from 1 to 3 months or longer, depending on the case, patient in question. Also, possible combinations include high-dose aspirin and diflunisal. Also, cilostazol and aspirin have been combined with different results. So these are my few slides. Thank you for listening. I wanted to show this slide, but it's like something will not allow me. Memorable picture in Ahmedabad, the boss.
Thank you very much. This was indeed very good presentation and covering entire aspects of CLI. And I won't agree more, Dr. Bashir, that as you have seen here, CLI is not only a leg disease, it's a multi-systemic, multi-vessel disease. It not only, gets you to amputation or lose your leg, it also leads to, if untreated properly, it will, and not treated properly, it's going to lead to loss of life, loss of kidney, loss of leg, loss of, and quality of life. So this has to be taken as a systemic disease, and as you have shown, the way we diagnose, the way we manage, and you've given an entire picture of CLI. Thank you very much, and very good to know again that you're doing very well. And I would like to Dr. Sachin has been acknowledge his role, that Dr. Sachin has been there right from the first APVIC. He's been, he's walked with me in the journey of APVIC every step. And now we are missing him because he's far away in Middle East and because of COVID times, he couldn't make it. So I would leave the last comments to Dr. Sachin for his view of APVIC 13 and APVIC ahead. And probably these are the people who are going to, all of you are going to take it forward after a few years when I retire.
Thank you very much, sir, for those kind words. And it's your passion, hard work, sincerity, and a lot of things to learn from you besides the medical science. and I'm sure the fellows across the world share my thoughts that it is indeed a privilege and an honor to have worked with you, to have learned with you, not only the medical science, but also how to be into academics and research, and how to be passionate about the academic work. And congratulations, sir, to have organized this wonderful conference. This is the 13th successful year, and Corona times in which the things have stopped across the world, but APVIC have moved on, and last year also you successfully organized it, and this year also you have successfully organized it, and in fact it has crossed the boundaries of India now. And this year it was very heartening to see the sessions coming in from Middle East and the Africa and South Africa and from Southeast Asia. Congratulations, sir, and it has been an honor and privilege to be the part of this August gathering, and amidst the so much of academicians that you are able to gather, and such a stalwarts and such a big people and big names to hear on one platform. It's a really a delight to see and be part of it. Congratulations very much, sir, and thank you for making us part of this. Thank you.
Thank you very much, Sachin, and all of you. Are my very favorite and esteemed fellows and colleagues, and it's very good to see everybody prospering and budding and blooming in their own countries and in their own hospitals. So we'll see you soon. Maybe if things are fine after 6 to 7 months in Delhi, and if things are not fine, maybe we'll do it physically a little later in the year, coming year, or maybe again, if things are bad, we will be forced to do it in a better way. But good to know that APVIC is moving ahead. Last year, it was one of the first online meeting in the world in cardiology, and it was in June. And so it was very well attended. We had unexpectedly more than 10,000 attendees and delegates who joined, including Nobel laureates and our own chairman, who sat for about 2 hours. But this year, because of the webinar fatigue and online conferences fatigue, we were thinking that we were expecting only 2,000, 3,000, 4,000 attendees over 3 days. But it was very heartening to know that we have already crossed 11,000 delegates in the 3 days. So things are moving ahead. It only speaks of the passion of all of you, and that is what drives us. And thank you all very much. So I would end the session here and the conference here. And in the end, I would like to acknowledge the contributions made by my team, my organizing secretaries, Dr. Suparna Rao, Dr. Gaurav Gupta, and also Dr. Sachin, who could not make it physically. And then we have a host of audiovisual inputs and help, and especially I would like to acknowledge the role of JTech, who has done a wonderful job on the transmission and audiovisual. Also, we would like to acknowledge Mr. Vikas, who's been here from morning to night every day, and my organizing team, the global conference committee, especially Mrs. Shruti Sinha, Jyotsna Gurung, and Akshay, who have done very well, and my secretaries, Rajiv and Shruti and Sapna. So they have all done a great job. Also, we would like to acknowledge the help of Indraprasth Apollo Hospital in providing the platform, the auditorium, the necessary help for live cases, and also the F&B department and the library, Mr. Harminder Shah, and also Mr. Kuldeep. Special thanks to our MD, Mr. Shiv Kumar, Dr. Karan Thakur, and everybody who has contributed in their own way and helped us and encouraged us to do this meeting. Thank you all very much. And we are going to, I don't know whether Sachin was a part of the ICE programs also. I think you were
I was there.
First ICE. So we are going to have ICE from tomorrow. We have 20, we restrict the number of attendees. So we have 25 attendees in the auditorium coming from different parts of the country. We have divided in 5 zones, so 5 intermediate level cardiologists with 5 to 10 years of experience post-DM are coming. And we are going to have the first time in India, the simulator for robotic PCI, which we have got from Germany. Soon we are going to start robotic PCIs here, and also have simulators for other peripheral vascular interventions. And we'll have a didactic course from tomorrow, and we are also adding live case transmissions in ICE. So I hope this is going to be a good meeting and good workshop. And all my Nigerian colleagues have already attended ICE, and ICE has been growing consistently. And not only me, but there will be other doctors and international faculty which will also be teaching in online format, and I would be teaching in physical format and from the cath lab. So this is going to be more and more regular, and there have been a long list. Now you have a waiting list of 50 doctors wanting to attend ICE. So we have planned it to do 3 times a year, as we were doing 2 times a year earlier. So we are making it 3 times a year, and we will sort of take more inputs, and I hope that ICE will become a very important physical teaching course to transform interventional cardiologists of middle order to from coronary to structural and peripheral vascular interventions. The other thing which we started, Sachin, you would be happy to know, apart from these 3 geographical and intercontinental sections, we also started this Women Crusaders, because we need to acknowledge their efforts and also help them. And also we started a new section and a new course called the Asia Pacific Nephrology Interventional Course, which is the interventional nephrology course of APVIC. And you saw that we have got international directors there. And this course hopefully would become one of the leading courses and certified courses for interventional nephrology in the times to come. So with this, I do understand, and remember your vision and how your